morning, Akash. morning.
Hello.
Yeah, good morning, everyone.
गुड
यार
मॉर्निंग।
सुबह वो भाई
हाँ
सुबह सुबह उठाया रे,
हाँ,
और वो भी संडे के दिन पे।
correct. Zamrud, you are in Hall B, right?
Yes, sir. I just logged in here just to say hello to everyone.
Yes.
Hi.
We are ready, sir.
Yeah, and you are MOC there.
Yes, sir. Yes.
Correct.
Yeah. Chalo.
Alan
See you all
Zamrud
bye.
has been the main force. मेरे को बहुत help हुआ उसकी वजह से सब हो रहा है.
Very good. I'm happy.
Yeah.
Thanks,
Thank you,
Zamrud.
sir.
She's done really well.
Thank you, sir, so much.
All the best to you,
Let
Zamrud.
us join the other hall. Thank you.
Yeah, please. Okay.
Bye.
I saw Ajay.
यस सर, गुड मॉर्निंग सर।
Hi, good morning. Hi, Kalpana.
Where's
Ajay, क्या हाल
Rasika?
है?
Rasika.
सर एवरीथिंग गुड।
Good.
यस
How's your new hospital cruising along?
सर, वही कंस्ट्रक्शन टेक्स टाइम, न्यू सरप्राइजेस एवरी डे।
Yes. So there is a field beyond nephrology which you need to learn,
यस
which you are learning. And COVID has taught us many things, which makes it easier for us to learn and, adapt. Correct.
Morning, Akash.
Good morning, sir. Good morning, sir. How are you, sir?
I'm okay. How's Ankit?
He's
Ankit,
doing well.
Yeah. I mean, his fever has come down,
Uh-huh.
but
He's had a cocktail.
and I'm not sure he had. Akash, did he have? No, his parents had.
No, parents had. He did not.
He did not.
अच्छा. So he's a teetotaler.
teetotaler. अभी तो चाय भी पीता है कि नहीं मालूम नहीं.
Yeah.
So is this the earliest you have got up, Alan, in the last 1 week or 10
अरे
days?
नहीं, आजकल तो late riser, late
sleeper, early riser.
Early riser.
Okay.
Excepting yesterday. Yesterday I slept. I could not get up basically. 9 o'clock in the morning I'm surfaced.
So the only time you get up late is when you cannot get up.
Absolutely.
So Ajay, tentative opening of the hospital, couple of months.
सर, we've started OPDs, ground floor हो गया है।
Okay.
So inpatients probably November।
300 bedded?
नहीं सर, सर 70।
70. Okay. Hemat and nephro or
नेफ्रो एंड यूरो।
nephro euro? What happened to hemat-onc?
सर अभी नहीं।
अच्छा, the place is there for you to.
नहीं। This place is a small place, इसमें जगह बढ़ेगी नहीं। This is going to be 70-80 नेफ्रो यूरो।
Okay.
फिर देखते हैं सर, ये चले तो फिर बाकी कुछ और बना।
ये तो चलेगा, उसमें कुछ मैं लिख के दूं एक कागज पे ऊपर?
नहीं सर।
if मेरा कागज has any value. I think we are approaching 27 seconds remaining. Akash, will you take over?
Where is this one? Rasika is not joined?
New Friends Colony, Delhi.
Okay. I think you have Rasika and Eileen. I saw Eileen Candy.
Eileen is there.
Yeah,
Good morning.
Very good morning.
Rasika.
Very good morning.
Can't see you, Rasika.
Rasika is there.
I'm there.
Yes.
Okay, great.
So I think the quorum is complete and it shows 0000. Akash, take over.
Good morning, everyone. After a successful first day. It's the IPL season, sir.
Yeah. And I think we are
Good.
behaving like Americans. We are ourselves saying it was a successful first day. I thought people will have to say, but doesn't matter, Akash. The Americans do it, so why can't we? You have to tom-tom about it if it's no problem.
No, it wasn't without the contribution from chairperson and speakers who supported the sessions really well.
Yes,
and
honestly.
the congratulations go to them actually.
Absolutely.
So for conducting the sessions beautifully, and in the same spirit, I hope today also we'll be able to kind of complete on time. And for the first session, which is on fluid, and we have none other than can you bring up the slides, please? Yeah, the first session is Fluid and Electrolyte Symposium, and I would want to invite the first three chairpersons, Dr. Alan Almeida, Dr. Rasika Sirsat and Eileen Candid, all three of them don't require any introduction, but Dr. Almeida is consultant nephrologist and transplant physician at PD Hinduja Hospital, Mumbai. Dr. Sirsat is a consultant nephrologist at PD Hinduja, Mumbai again. Eileen Candy is head dietitian at H and Reliance Foundation, Mumbai. Welcome, sir, and I would let you introduce Dr. K.
Thanks, Akash and Umesh. And it's as Akash said, let's start on time. Let's get the work done. Yesterday was a successful day. Now we have none other than Ajay Kher, who's director and senior consultant at the Epitome Kidney Urology Institute, who has a lot of credits, but he's very modestly said just listed one. Now I'm sure that Ajay would be giving us an expose on hyponatremia and all its consequences, management, etc. Ajay, if I have the permission of Rasika and Eileen to have Ajay start his talk. Yeah, Ajay, you're on.
Thank you so much, sir, for the kind introduction. And let me get my screen on board. I hope you can see my screen.
Yeah, Bonnie, put it in presentation full screen.
Sure, sir.
Yeah, that's done.
So for today, what I'll talk about is pathophysiology, the diagnostic algorithm and treatment. I'll try and combine it together as we go along with the cases with a focus on nutrition and diet as the primary part of the treatment modality. So I'll try and finish in the 20-25 minutes. So we have some time for questions at the end. So we'll start with the kidney and how amazing and flexible and adaptable it is. And so the minimum concentration or urine osmolarity that the kidney can get to is anywhere between 50 to 100 milliosms per liter. And the maximum is 1200 milliosms per liter. Normal intake in a normal diet is about 600 to 700 osms. And so at the minimum concentration of 50, the body can put out up to 12 liters. And at the maximum concentration of 1200, the urine volume can be 500 ml. So based on how much water we drink, the brain and then the kidney in response to that will adapt the osmolarity to excrete the volume that we have taken in terms of water and the osmolarity that we have taken in terms of solute. And hyponatremia is a water retention issue, and ADH is the main defense against hyponatremia. So let's talk a little bit about how osmolarity is sensed and regulated. So on the left side is osmoregulation, which is measured by sodium concentration. We sense the plasma osmolarity by the sensors which are in the hypothalamus. And then these hypothalamus receptors will either secrete ADH or generate thirst. In response to ADH, we have water reabsorption. And in response to thirst, we have water intake. And so that will increase water in the body. And if the osmolarity is low, then both of those get shut off, ADH and thirst, and we have water excretion. If there is any problem in this system, then you can have hyponatremia or hypernatremia. So unfortunately, the name has sodium in it, but the body senses and regulates it through water. And so hyponatremia and hypernatremia are water problems. In contrast, volume regulation, which is measured as total sodium or is effective total sodium in the body, is sensed as effective circulating volume by the carotid sinus, afferent arteriole, and atria. Based on whether the volume is high or low, you will have activation of the renin-angio-aldo system or switching it off, natriuretic peptide, sympathetics, and as a last ditch, ADH. The predominant mechanism by which these work is urinary sodium excretion or urinary sodium retention. And if there are problems in this system, you will have volume depletion. If the volume is low, or edema and volume overload if the volume is high. Again, because the body is regulating it through sodium, volume is actually a sodium issue, and osmolarity, because the body is regulating it through water, is actually a hyponatremia are water issues. So now just looking at ADH, so the white circles are ADH and changes in osmolarity. So it's a very tight linear relationship between osmolarity and ADH. Osmolarity goes up, ADH goes up. Osmolarity goes down, ADH goes down. In comparison, the black circles are volume changes. As your volume goes down, for the first 5-10% of your volume decrease, you are reliant on renin, angio, aldo, sympathetics, and the natriuretic peptide being turned off, while the renin, angio, aldo, and the sympathetics go up. And so for the first 7%, ADH does not do anything. Once your body loses more than 7% of volume, as a last ditch effort, ADH is now being secreted in response to volume. And this can then overwhelm what the regulation is happening through osmolarity. And this is a last ditch effort to save the organism. So now let's come to cases and kind of how we diagnose and what algorithm we can use. So we have a 24-year-old male who is an alcoholic and presents to the emergency department after being found down by his family. His blood pressure is 120/80 and he appears euvolemic. His serum sodium is 128, serum osmolarity is 265, urine osmolarity is 60, and urine sodium is 15. What's his cause of hyponatremia? Is it 1, pseudohyponatremia, 2, beer potomania, 3, volume depletion, or SIADH? So I'll kind of share you my algorithm for hyponatremia. There's lots of different algorithms out there. All of them use the same basic structure, and so you can use any of them. The first thing that I look at is the serum osmolarity in the setting of hyponatremia to see if it is serum osmolarity is actually low. So that means that this is true hypoosmolar hyponatremia. If the serum osmolarity is normal or high, then I would look at pseudo hyponatremia and hyperglycemia to assess which of those is the etiology for the hyponatremia that has been diagnosed. And then if in this patient it is 265, so this is true hypoosmolar hyponatremia. The next step I look at is urine osmolarity. In the setting of hyponatremia, which is hypoosmolar, the brain should shut down ADH. In response to brain shutting down ADH, the urine osmolarity should be between 50 to 100. So it should be less than 100. If it is less than 100, then the brain and the kidney are doing what they're supposed to. And what is actually happening is that this person is overwhelming the body's ability or adaptability of the kidney. And so that is primary polydipsia or beer potomania. So that is what this patient has. And so this is beer potomania. The take home message is that the low urine sodium that we saw was due to the low osmolarity of the urine. Now let's look at what the body does and how does it adapt. So let's take a normal person who has a normal 600 milliosm intake and 1 liter water intake. So the kidney and the brain will adapt the ADH level, and the kidney will excrete 600 milliosm per liter with 1 liter urine, and the body will be in balance. Next, let's say the same person next day drinks 2 liters of water. So now he has 2 liter water intake. The body will adapt the osmolarity of the urine through ADH. And now it will secrete 300 milliosms per liter and then have 2 liter output and again be in balance. Let's say that he drinks 6 liters of water, or in that case, the ADH will be almost completely shut off and the urine osmolarity will be 100 and they will excrete 6 liters of water, again be in balance. However, if someone has beer potomania, what happens is that their solute intake is low, and dominantly solute is from salt and protein. And in case of beer potomania, it only has calories and doesn't have any salt or protein in it. So let's say that their water intake was 4 liters even with a urine osmolarity of 100, with only 200 milliosms, the body can only excrete 2 liters of fluid or urine. And so the extra 2 liters is going to be retained in the body. And if this person continues to do it every day, his sodium is going to continue to come down because of this retained water on a daily basis. In case of primary polydipsia, the solute intake is same, but the water intake will have to be massively high, somewhere in the 14-liter range. The urine osmolarity would be in the 50 to 100 range. If it is 50, the person would be able to excrete 12 liters. If it is 100, they'll be able to excrete 6 liters. So based on how low the kidney can go, you will have a positive balance of 2 to 8 liters. And this is what primary polydipsia patient will have to do every day for him to remain hyponatremic. Otherwise, the kidney will be able to excrete the additional water and the sodium will come up. So again, so beer potomania and tea and toast or primary polydipsia is too much water intake for the amount of solutes that the person is taking. So now let's go to case 2. So this is a 55-year-old male with cirrhosis from alcohol and presents for a scheduled endoscopy as part of his liver transplant workup and is noted to have an asymptomatic serum sodium of 128, the serum osmolarity of 260, urine osmolarity of 450, and urine sodium of 80, and he's not on any diuretics. What's the cause of his hyponatremia? Is that cirrhosis, which causes effective circulating volume depletion, beer potomania, SIADH, or true volume depletion? So again, we'll go back to the algorithm, and serum osmolarity is low, urine osmolarity is high at 450. So that means that ADH is present in the system and the kidney is responding to that ADH. Now we look at urine sodium, and if the urine sodium is low, less than 20, so what that tells you that the renin-angio-aldo system is active and the ADH is in response to this volume issue. So then that would mean that it is either volume depletion or effective volume depletion in terms of heart failure, nephrotic syndrome, or cirrhosis. So the exam would be easily able to identify, is this someone with true volume depletion due to either GI loss or some other loss? Is this someone with effective volume depletion in terms of cirrhosis or heart failure? This patient, the urine sodium is 80. So this patient has SIADH. Before you label someone with SIADH, you should also assess them for hypothyroidism and hypocortisolism. And so that would be something that you would do. In this case, the patient had actually started a recent SSRI or serotonin reuptake inhibitors, and that was the cause of his SIADH. We stopped the drug, SIADH went away. So another patient, 70-year-old male with lung cancer, presents in the clinic with asymptomatic sodium of 125 with a serum osm of 260, urine osmolarity is 900, and urine sodium is 150. So all of these criteria meet SIADH. The questions now in terms of management, how would you manage him? With just fluid restriction of 1 liter per day, fluid restriction plus salt tabs, 1 gram 3 times a day, fluid restriction of 1 liter and furosemide 10 milligrams twice a day, or normal saline 100 ml per hour for 2 liters. So let's look at how the answer is going to be fluid restriction with furosemide, but let's look at how we approach this. And we'll come back to the balance in terms of water intake and solute intake that we had looked at. So in SIADH, the predominant driver is not the body's ability to change the ADH level and the kidney's adaptation to it, because that is being driven by the ADH coming from whether it's the cancer or nausea, vomiting, or lung disease, whatever is the driver of the ADH, that's going to control the ADH level. So the main driver of how much urine is going to come out is going to be dependent on the solute that we take. So let's say the solute intake of 600 milliosm, and let's say that the urine osmolarity for this person based on his ADH level is at 200. So then they will excrete 3 liters. If they started with hyponatremia, they'll get better because water intake is only 2 liters. And so they have a negative balance of 1 liter. The extra water is coming out. Hyponatremia, if they would get better. In contrast, if you have someone whose ADH is at a higher level with a urine osmolarity of 400, and they also eat 600 osms and drink 2 liters, they'll excrete this 600 osms in 1.5 liter. And so there'll be a positive balance of 0.5. And so their hyponatremia is getting worse on a daily basis. But if you put this person on a 1 liter fluid restriction, they keep eating their 600 osms. Now this 400 osmolarity is going to get the 600 milliosms that they eat at 400 osms per liter will get excreted in 1.5 liters. And so they'll be in a negative balance of 0.5 liters. And so the hyponatremia is getting better every day, 0.5 liter a day. In comparison, if you have a higher ADH level, once you get to 600, now, even if you, and you take 2 liters, you're at positive 1 liter. If you fluid restrict them to 1 liter, what ends up happening is the 600 milliosm per liter will get excreted in 1 liter. And so your net balance is equal. So even if you fluid restrict someone, but their urine osmolarity is at 600 milliosm per liter, they will be in a net water balance and their hyponatremia won't correct, but it will be stable. So now you have two options. One option is to add Lasix or furosemide. And what that will do is bring the urine osmolarity down from 600 to close to isoosmolar around 250 to 350. So we've taken 300 as an example. Now this person will excrete the 600 milliosm in 2 liters. If they're fluid restricted to 1 liter as well, they'll be negative 1 liter. And that will allow the hyponatremia to get better every day with this extra free water excretion. If in addition to that, you increase their salt, urea, or protein intake and get them to a 900 milliosm per day diet, then on a 300 milliosm fixed osmolarity, they'll excrete 3 liters. And so they will correct quicker than the person above, and they will be negative by 2 liters a day. In comparison, if you have a patient like the case that we're describing here, who has a 600 milliosm intake, 2 liter water intake, but urine osmolarity is 900, they're going to excrete the 600 milliosms in 0.7 liters, they'll be positive 1.3. To make them negative in terms of water balance, you would need to increase their osmolar intake, restrict them to 1 liter, and give them furosemide, drop their osmolarity from 900 to at least 450. If you can get them to 300, even better. And then they will put out 2 liters and be negative. So take-home message is, if the urine osmolarity is more than 600, diet in terms of fluid restriction won't be enough. And even with salt tabs or increasing protein intake, it will be hard to get them to correct their hyponatremia. In these situations, you will need furosemide to lower the urine osmolarity to help correct the hyponatremia. Now we'll take another patient, 30-year-old female with lab cholecystectomy. And post-op, she's been receiving D5 with half normal saline at 100 an hour. Post-extubation, she has significant pain and nausea and is not eating much. So she just continues on the maintenance IV fluid. Next day morning, she's found to be altered and incoherent. Labs reveal a serum sodium of 115 with a weight of 60 kgs. What treatment would you prescribe? Free water restriction, change the IV fluids to NS at 100 an hour, 3% hypertonic saline at 100 ml bolus, free water restriction, and 3 gram salt tabs. So the answer is 3% hypertonic saline at 100 ml bolus. Another option would be to do it on a drip. So we'll go over the drip, and then we'll talk a little bit about the bolus as well. In terms of treatment, the two basic principles for hyponatremia are: you want to raise the sodium at a safe rate, and you want to treat the underlying condition. But the biggest question is the patient symptomatic or not? If they are symptomatic, then you need aggressive correction at 1.5 to 2 MEQs per liter per hour for the first 3 to 4 hours, and then less than in the first 24 hours. The rate of correction is 48 hours. So it's not that 10 to 12 every 24 hours to continue. It's only 10 to 12 in the first 24 hours. And then after that, you do it at a slower rate. So let's calculate the sodium deficit. So if you want to calculate the sodium deficit, it's 0.5 into the lean body weight multiplied by 140 minus the current sodium. So for this patient, 0.5 into lean body weight, correction sodium would be 0.5 into lean body weight was multiplied by the target minus the current sodium. For this 60 kilogram female with a sodium of 115, our goal is to raise the sodium by 4 to 6 in 4 hours, and 10 in 24 hours. So 4-hour correction would be 4 millicoulombs per for the 4 hours, 4 into 60, which is her weight, into 0.5. So that's 120 MEQs. 3% has 512 MEQs per liter. That's 2 ml per MEQ. And so 120 MEQs would be in 240 ml. And so if you want to correct 240 ml over 4 hours, that's 60 ml per hour. You could start this person on a bolus of 100 ml, repeat the sodium in 3 to 4 hours, and then give additional boluses. Or you could put them on 3% at 60 ml per hour, and then monitor the sodium and adjust the rate based on their actual correction. For the next 20 hours, you would want to do a slower correction. So if they were following what your math is saying, then for the next 20 hours, you would want to correct by an additional 6, get them to around 10. And so that would be 0.5 into 60 into 6, that would be 180 MEQs. And that would be in 360 ml of 3%. And to give this over 20 hours, you would drop the rate to 18 ml per hour. So you would start at 60 ml per hour for 4 hours. If the math is working correctly and they're correcting as you've calculated, then you would decrease the rate to 18 ml per hour for the remaining 20 hours and then reassess over every 4 hours. So another shortcut would be to do 0.5 into weight into ml per hour. So that would be about 30 ml per hour, and you could start that. Another version, as I discussed, is 100 ml 3% bolus and repeat every 3 to 6 hours based on the sodium correction. The caveats for the sodium deficit calculation and its correction are that it only applies to administration of salt without water. So salt tablets, hypertonic saline, and not normal saline. It's only an estimate, and so serial measurements are needed. And it doesn't take into account ongoing losses or isoosmotic losses that the person may also have, which may need additional correction or separate correction. So now we'll take a look at a couple more sicker patients. A 30-year-old female with severe diarrhea with 5 to 6 days of diarrhea and presents to the emergency with hypotension. Again, serum sodium is 115 with no neurological symptoms. So she receives 5 liters of normal saline over 6 hours, and she's already corrected to 125 and now is putting out copious amount of dilute urine every hour. What would be your next step? Stop the IV fluid, monitor clinically for osmotic demyelination, give D5 and DDAVP, or monitor labs and only intervene after she reaches a serum sodium of 130. So the answer is that you would want to start D5 and DDAVP and do something called re-lowering for someone who has had rapid correction. So let's talk about osmotic demyelination. So that's rapid correction leading to central demyelinating lesions. And this is due to osmotic shrinkage. The symptoms are typically 2 to 6 days after correction and can include paraparesis, quadriparesis, dysarthria, dysphagia. And high clinical suspicion is required for confirmation by CT or MRI, though the lesions may not be detectable even up to 4 weeks after. The risk factors are more than 12 correction in 24 hours and correction to more than 140 in the first 2 days. Hypercatabolic people, malnourished, and alcoholics are at a higher risk. The treatment is none after you've gotten it. If you get them before symptoms or even early on in symptoms, you can reverse it by giving free water and DDAVP, re-lower the sodium, and then bring it up slowly over time. And this is based on case reports and animal studies. Some of them are dominantly done by Dr. Supart from France. And they've shown in elegant animal studies that this is something that you can do, and the neurological damage is prevented or reversed. So the last case that we'll talk about is a 70-year-old female with lung cancer who presents with change in mentation and has a weight of 60 kgs. Serum sodium is 115, potassium is 2.5, urine osmolality is 600, urine sodium 75. You follow the algorithm. The serum osmolality is low, urine osmolality is high, urine sodium is high. So this is a side EH, likely due to the lung cancer. you do your calculations of sodium deficit, and you want to give 300 MEQs of sodium over 24 hours. You plan your 3%, but you also have to give potassium. So if you're giving potassium, how should you adjust your sodium? So option number A is you don't adjust the sodium, you give both. Option number 2 is 220 of sodium, so you reduce it by the amount of potassium you give. 380 MEQs, option 3 is you add the potassium as well and give additional sodium. And then D is you only give sodium and you don't mess with potassium at all. So let's look at what would happen. So when you give potassium, it will first go into the extracellular fluid, and then it will go into the intracellular compartment, and the intracellular potassium concentration will go up. Then water will move from the extracellular fluid into the intracellular fluid, and compensation wise, sodium will go up as well. So giving potassium to someone who is hyponatremic is the same as giving sodium. And so the answer is B. So you would reduce the 300 to 220 of sodium and 80 of potassium, because giving potassium is same as sodium. So I'll stop here, and if someone wants to hear more from my side on hyponatremia, my talk is already on Dr. Vic Cha's YouTube channel, so they can look at that here, and I'm happy to take any questions if there are any at present.
Thank you, Ajay. That was an excellent expose, illustrated so beautifully by cases. Rasika, you would like to take it on?
Yeah, it was really good. You've taken it case by case and elaborated, and I've also heard your talks on the YouTube. Excellent. I was just wondering, how would you manage a chronic SIDH?
So, ma'am, the chronic SIDH one would be if there is something that we can fix and correct, you would want to correct that. My assumption is that that's not possible. That's why they have chronic SIDH. In those situations, I would focus on the diet and intake. If they have nothing contradicting taking a high salt diet, I would do high salt, high protein, and fluid restriction. And usually with that combination, unless their SIADH is a really high ADH state, in which their ADH is in the 600 to 900 range, if they're in the 200 to 300 range, high salt, high protein, fluid restriction would be able to manage them and get them to a normal sodium. The only problem is they have to do it on a daily basis and continue and make this a part of lifestyle. If their osmolarity is 600 or higher, even this salt, protein intake and fluid restriction won't be enough. So usually in those situations, we will need to put them on furosemide. They don't need much. They usually need 10 milligrams twice a day, kind of knock out the loop, knock out their concentrating capacity. And then the other things that we talked about, the salt, protein, and the fluid restriction, in combination with the furosemide, would manage these patients in the long run.
Do you ever have to use tolvaptan in low doses?
Ma'am, usually I try and avoid using tolvaptan. And that's because most of the time I'm able to manage my SIADH with this combination. And the other reason that I try and avoid tolvaptan is one, they will only maintain the sodium as long as they're taking it. So now I'm giving this medicine to someone for the rest of their lives. So that's one. Two, when we start tolvaptan, even especially in SIADH patients, they are at the highest risk in the first 24-48 hours of overly rapid correction. And even Takeda, that is made tolvaptan, they did a trial of their own, and they started with 7.5 milligrams and even 3.75, meaning a quarter of the 15 milligram pill. And 1 in 10 patients that they gave to their SIADH patients had overly rapid correction in that. And so in my mind, usually I manage with medicine, with the diet, fluid, and Lasix, and try and avoid tolvaptan if I can. I know occasionally we may need to use it. In those cases in SIADH, I would start with like a crushed low dose and slowly see the response, because the main problem is going to be in the first 24-48 hours.
Eileen?
Yes, we are out of time already. I just want to tell Dr. Ajay that when the patients come to us in our nutrition clinic, what is the one advice we should be giving to the patients who come with hyponatremia?
So, ma'am, again, I would focus on three things: high salt, high protein, and fluid restriction. Those three things together would be what I would focus on. The problem in India predominantly is if you have a hypertensive or cirrhotic or heart failure, then you can't give them the salt. And protein in an Indian vegetarian diet is very hard to push up. So you really need to ask them to take supplements. You can't ask them to just do dal, dahi, paneer, soya bean. You can't get their protein up. So usually for Indian vegetarians, I am pushing them for additional protein biscuits, protein powders, and asking them to take it as dawai or medicine, because otherwise you can't get their solute. Getting to 600 to some, most of the people who have hyponatremia have some component of low solute intake. So you really need to push their solute intake high. And with low blood pressure or heart failure or cirrhotics, salts out. So then you get stuck, and then you really need to push their protein. And so that's something which I routinely do. I push and push and push on protein.
Thank you, Dr. Ajay. It was indeed a very good lecture.
Thank you so much, ma'am.
Thank you,
Thank you,
Ajay.
sir.
Excellent.
So one last question, if I can. What are your thoughts on Urena and when is it expected to come to India?
Ooh, that would be something that the drug companies would answer. I think there are some sodium pills. Instead of putting salt into our Bicasol capsules and putting it in patients' mouths, I've seen sodium as capsules are already available. Urea, there's a very good, elegant study by Dr. Supat that compared satavaptan and tolvaptan versus urea. And 1 year of urea tablets was equally good to satavaptan and tolvaptan, and probably with less likelihood of overcorrection in comparison to those. So if we can get urea tablets, that would be awesome.
Perfect. So, sorry, sir. Yeah. So, excellent session, sir. Dr. Almeida, if you would like to close the session.
Thanks, Akash. I thought you'd take over now because it's already exceeded. I know the questions could go on, and with Ajay answering those questions, you always hanging on to every word that he says. Over to you, Akash.
Thank you, sir. Yeah.
Thank you, sir. He's been nicknamed Salt Whisperer very rightly. He's a student favorite, actually. I've been a student in Delhi, and we've always looked forward to his talks. Thank you once again, Dr. K. I would like to invite the next set of chairpersons, Dr. Kalpana Mehta, Professor and Head Nephrology, Nair Hospital, Mumbai. Dr. Ketan Mehta, Consultant Physician at Asian Heart, Suchak and Nama Hospitals and Lifeline Medicare Hospitals. And Ms. Priti Shukla, Director, NutriNeeds Health Consultancy, Indore. She is the National Executive Member of Indian Dietetic Association. Welcome, sir. Over to you, ma'am.
Kalpana, you can introduce Dr. Sribhushan Raju.
Hello, good morning, everybody. After the first nice session on sodium by Dr. Ajay K, now we move on to the next session of hyperkalemia. And it is a pleasure to introduce Dr. Sribhushan Raju. He is a professor and head Department of Nephrology at Nizam Institute of Medical Science, Hyderabad. He has been awarded Meritorious Teacher Award by Government of Telangana, and he has chapters written in long-term complications of CAPD and as well as ischemic nephropathy. Over to you, Dr. Sribhushan Raju, for the hyperkalemia talk.
Sir, please unmute.
Hope I am able to.
We can't hear you, Dr.
Yes. It's okay now?
Yeah.
Yes, sir. Good morning, everyone. And I would like to thank the organizers for giving this opportunity to me to speak on this very interesting topic of hyperkalemia, which is very, very important and significant in our day-to-day management of patients with a chronic kidney disease. And This I would like to talk briefly about how the kidney handles potassium and what is the need of necessity of newer antihyperkalemic agents, and what are the existing agents and what are the shortcomings of them, what are the newer drugs available, and how to plan therapy for hyperkalemia. This is only one slide regarding how the potassium is being handled by the kidneys, and you know that the potassium will be freely filtered by the glomeruli, and 70% of that will be reabsorbed, reclaimed by the kidney in the proximal tubule, and 30% by the distal tubule, and it will be initially in the proximal convoluted tubule. It is just a free flow, and it is reabsorbed by the free renal tubule through the renal tubular epithelial cells, and it is not governed by any other drug or the substance or the hormone. And in the thin loop, it will be slightly leaked into the interstitium, but it will be reclaimed again by the thick ascending limb again, and it will be reabsorbed by the thick ascending limb and the distal convoluted tubule. Most of the hormones, especially the receptors, would be governing the entry and exit of this particular thing in association with the sodium to maintain electroneutrality between the sodium and the potassium. As the sodium is actually excreted into the tubule, the potassium will be reabsorbed and governed by the ENaC and also the Romke channels. And the distal collecting duct also, it will be the same. Mostly, almost 2 to nearly sometimes 100% of the potassium will be excreted into the urine. Many times, it all depends on the dietary potassium intake and the presence of several metabolic abnormalities like hypometabolic acidosis, metabolic alkalosis, and the hormones like aldosterone, which acts on the ENaC cell, and also sometimes vasopressin, which acts on the Romke cells. So most of the times it also depends on the flow of fluid and also the flow of sodium into the distal convoluted tubule that determines how much potassium should be there in that. Especially when the kidney damage takes place, all these things will be deranged. Not only the hormones, but also the channels which actually govern the movement of potassium across the renal tubular epithelial cells. So that's why the handling hyperkalemia or hypokalemia in association with a chronic kidney disease is very, very difficult. Not that we see only hyperkalemia, many times we see hypokalemia also. But managing hyperkalemia is very, very difficult. You know that most of the patients would get into cardiac complications and other complications, and it would be one of the reasons for the early or emergency start of hemodialysis in those patients with a chronic kidney disease. Not just the kidney, but also the gut also involves in the management of potassium, and it's also gets reabsorbed by the small intestine and passively secreted into the colon, and but predominantly it is the kidney that manages the show, and many attempts the potassium also will be lost through the stools by almost nearly 10% of it. And a significant number of our patients would be having a chronic kidney disease alone as the etiology, but some of these associated features also can lead to hyperkalemia, the pseudo-hyperkalemia, the cellular redistribution of the potassium, especially in the presence of metabolic acidosis, which is an existing and part and parcel of chronic kidney disease, hypertonicity, insulin deficiency. Some of the drugs like beta blockers and alpha agonists can lead to, and some of our patients had hyperkalemic periodic paralysis on maintenance hemodialysis, and that is a recurrent periodic paralysis secondary to hyperkalemia we happen to see, and a massive tissue dissection secondary to rhabdomyolysis and the conditions also can lead to sudden occurrence of hyperkalemia, which should be managed very, very clearly. And many of our patients would not be able to restrict their potassium in their diet, and excess intake of potassium also would be one of the major reasons. And as we know that the decreased renal excretion, especially the oliguric renal failure, and some of the associated features with the kidney disease, mineralocorticoid deficiency, and the defects in the cortical collecting tubules also can lead to hyperkalemia. These are basically the etiology of hyperkalemia. In renal failure, many of these would really exist. And it is actually the basic understanding how to make a diagnosis of hyperkalemia or confirm the hyperkalemia and to manage or not depending on the ECG abnormalities, which we frequently follow, because many times it is actually the pseudo-hyperkalemia. Sometimes we might see when the patient is actually flexing the hand again and again with some exercise, and some of the dietary intake immediately makes a difference for him to increase the potassium in the levels in the blood. So, but many times we tend to take ECG and see whether the ECG changes are also there in association with the blood levels of hyperkalemia. So, mild, moderate, severe changes in the ECG, and we get to see the tall tented T waves and the prolonged P and QRS complexes as the potassium increases to more than 8. You can see almost ventricular fibrillation, asystole, and bundle branch blocks and fascicular blocks, etc. but we don't really allow the patient to go till then. And we rarely see a patient who comes to us. And nowadays, with the drug therapies and all, we are able to control the potassium, and more awareness by the people to receive the potassium also is making the difference. And these are the drugs which are classically available for our therapeutic armamentarium of hyperkalemia management. These are the things which are known to every medical student seated in the chair in emergency medicine department. And these are the classically that should be given to all the patients. Many times it works and sometimes it doesn't work. And the nephrology resident will be called to do emergency dialysis also many times. But the calcium gluconate should be administered in the 10% of it in 10 ml in IV infusion or IV route and slowly. And that can really reverse the blockade at the heart level. But it will not be useful again and again when you give it for more frequently. And the dextrose insulin has to be given with the 10 units of insulin in a 25% dextrose to be given over 10 to 15 minutes. And that also can reverse the changes of ECG. And the salbutamol inhalations, albuterol inhalation should be given, but the amount needed to control the hyperkalemia by the salbutamol inhalation is excess in such a way that the patient gets into complications like tremors and tremulousness. Very, very difficult. The furosemide can act temporarily. If the patient is on furosemide therapy for a long time, it can slowly and gradually control the potassium levels in the blood. The another resin available is the sodium polystyrene sulfate, the so-called kexalate, and which is available in sorbitol free and in association with the sorbitol also to be given. But this is a huge amount of has to be given, which probably can produce it'll work like a laxative, but many times it fails to control, and not more than 1 to 2 grams it removes, and sometimes the marginal decrease in the potassium level can take place rather than a significant and a therapeutically valuable decrease in the potassium in the blood. So it will be always a difficult situation for us, and though we don't really go to the hemodialysis immediately to control the potassium in the blood, rarely, hyperkalemia alone may not be an immediate and the most important indication for initiating the dialysis, unless it is associated with some other complications like metabolic acidosis and refractory metabolic acidosis and uncontrollable pulmonary edema. But mostly we try to treat them with all this. So there is definitely a need for newer agents, and it is as the CKD stage advances from 3% in the initial 3 to 4% in the initial CKD 1 to 2 stages, but almost 15 to 20% of the patients with the chronic kidney disease in stage 4 5 would develop hyperkalemia. Interestingly, many of our dialysis patients would tolerate hyperkalemia when you take a first blood sample of the week and the pre-dialysis sample showing a hyperkalemia of more than 5.5 to around 6, but patients would be asymptomatic. But we cannot really leave them like that, because you know that the sudden cardiac death is seen in almost 20 to 25% of the patients on maintenance hemodialysis. That probably could be attributed to an increase in the potassium level in the blood. So so we are supposed to treat the patients and maintain the potassium levels to less than 5 in all the patients of CKD as well as than dialysis therapy. And moreover, as the patients are getting into chronic kidney disease progression, we are supposed to add ACE inhibitor, ARB, or nowadays even mineralocorticoid receptor antagonists also, like spironolactone and other drug therapy, where the potassium would be a problem for us to manage them. And in fact, initially when we were writing the ACE inhibitors or ARB, we used to tell the patients to get the potassium done once a week or 10 days later, and to get back to us again with the potassium levels. But nowadays, with the patients staying in distant, faraway places, it is very difficult to monitor the potassium also. It is not so easy. But the potassium level would be a problem in giving a very important and wonderful drugs called ACE inhibitors and ARB in the prevention of progression of chronic kidney disease in our patients. So it is very important for us to get the newer drug therapies. And unfortunately, all these drugs, whatever are available, can only temporarily deal with the transmembrane shift of potassium. And in fact, I personally do not really advise very frequently the resin sodium polystyrene sulfonate, and also never felt that it is so efficacious in controlling the hyperkalemia. And also, this particular thing has to be given orally along with the sorbitol, and that was known to produce some kind of a colonic necrosis in some of the cases reported. So hence, we require some newer drugs, and luckily we have few newer drugs which are supposed to be seen in our country. And the patiromer, which was approved by FDA in 2015, not yet available in India. It's an organic, non-absorbable polymer, and which increases the fecal potassium excretion. It acts predominantly on the colon, and in exchange for the calcium, and the potassium will be excreted into the distal colon, and it works well as far as the literature is concerned. It is basically a free-flowing insoluble powder, and which has got a small spherical beads with a low viscosity, and which, when it is in the intestines, it tries to take out the potassium through that, and it is a tasteless, odorless powder and not metabolized or reabsorbed into the through the GI tract. And there is a significant reduction statistically of potassium at after taking it, ingesting it for around 7 hours later. And as the dose increases, the potassium excretion also increases. Is basically dose dependent increase in that. And it is to be given 8.4 grams initially to start with once a day, and maximum of 25.2 grams once a day can be given, and it should be administered routinely along with the 40 to 50 ml of water, and sometimes if required it can be given twice a day also. But no major adverse effects were documented with this particular pathogen drug therapy, but there are some GI disturbances like constipation, diarrhea, nausea, vomiting, and excess flatulence have been reported in patients who received pathogen. And a small percentage of group of people had a significant hypokalemia also. Along with that, the hypomagnesemia was also documented in this patient, and some patients probably had worsening hypertension, which I would like to tell you later. And the warnings, it binds not only with potassium and other things, but it also binds to several drugs which are concurrently given to the patients with a chronic kidney disease. And keep a gap of 6 hours whenever you are giving the pathogen in association with other drugs. But no robust data is yet available whether it can be used in those patients with acute life-threatening hyperkalemia. The Pearl HF study shows that when you compare to the placebo and other drugs, in those patients who are receiving spironolactone, the pathogen was given 15 grams twice a day plus spironolactone and the placebo therapy. This is a 28-day study which is monitoring the potassium, and spironolactone was concurrently increased. It is only to see the change of potassium from the baseline to the end of study. This particular study showed a statistically significant improvement in the potassium compared to the baseline level, but hypokalemia was also significantly, along with the hypomagnesemia, was also significantly seen in these patients who received pathogen in association with spironolactone. And another study, Amethyst DN trial, also showed the long-term safety and efficacy of pathogen in outpatient patients with hyperkalemia. And we know that we have to treat hyperkalemia in the outpatient department only. This can be seen with a four-week drug trial with a starting dose of 4.2 grams, maximum up to 16.8 grams taken twice a day, resulted in a significant decrease at the end of 4 weeks. And this also is supposed to be very important to see that the hyperkalemia can be managed on outpatient basis with the pathogen. And another study, Opal HK, the phase 3 pivotal study design, also showed that the pathogen in association with the RAS inhibition and placebo versus the placebo alone with the RAS inhibition at the end of 8 weeks showed 76% of the patients had reached the target potassium of less than 5 at the end of 4 weeks. And the recurrence of hyperkalemia occurred in almost nearly 60% of the placebo group compared to only 15% of the patients who received pathogen. That shows that recurrent hyperkalemia is also important. We should be able to give this particular drug for a very, very long time. And as I stated earlier, the constipation and a significant number of patients having hypokalemia, of course, it is reversible, was seen in a good number of the patients with the pathogen. And time to first recurrent hyperkalemia was also documented in this randomized control trial after withdrawal, and that shows that 94% in pathogen group continued to receive RAS inhibition, whereas only 44% could receive placebo therapy. 62% of the placebo group needed an intervention to manage hyperkalemia, whereas only 60% of patients on pathogen who require some other intervention to control the potassium when it is a recurrence of hyperkalemia after withdrawing the drug therapy. So that shows that it's very important molecule that should be really checked in the future, especially when it comes to our country. Another important molecule which is there in the hyperkalemia management is the sodium zirconium cyclosilicate, and which is an inorganic polymer. It selectively attracts the potassium ion, its negatively charged crystalline lattice structure, and exchanges them for sodium and proton. And it is a free-flowing, again, an insoluble powder, which is sodium-potassium cation exchange agent. And this is also not systemically absorbed, and it should be given 10 grams orally, and it decreases potassium almost in an hour. It is a very quick in action, it has a 25-fold selectivity for potassium as compared to the calcium and magnesium, and it works throughout the GI tract. And the best results almost can be given when it is given 5 grams and 10 grams, and it should be administered along with the full meal, and it should be dissolved in 240 ml of water, and thrice a day with meals, and once a day if it is a chronic and outpatient management of hyperkalemia. As such, there are no major adverse effects have been reported or documented other than some simple GI disturbances and edema. And hypokalemia was also documented, which is again reversible compared to pyrethromer. It was actually less. And the urinary tract infections and prolonged QT interval were actually documented, and also the worsening of hypertension was also documented. This trial, this harmonized trial, is a study where the sodium zirconium trisilicate was tested. It's a 48-hour open label phase with 9 to 10 grams 3 times a day, and a 28-day randomized phase. And primary endpoint was to see the change in the potassium compared to the baseline. And this particular study showed that the median time for the potassium normalization occurred in 2.2 hours only. And 84% of the patients normalized by almost nearly in 24 hours. And by 48 hours, almost nearly 100% of the patients got their potassium getting normalized. But some of these patients had GI disturbances. And hypokalemia was also documented. Compared to the placebo, hypokalemia was documented significantly in these people. And the edema, which is important to be noted, the numerically higher rate of edema was documented when the 15 grams dose of this particular drug is being given. The sub-study of this particular harmonized SF study in those patients with the heart failure, with the mean serum potassium over a time was checked, and these patients were on RAS inhibition and who achieved normokalemia in a significant way compared to the placebo therapy, as the doses were increased to 5 to 10 to 15 grams per day, and the efficacy also has increased further. And the normokalemia was maintained when 5 grams or 10 milligrams were given, and potassium levels increased to hyperkalemia levels in placebo group, but not in the particular ZS9 therapy. And when it is discontinued after 15 days, the hyperkalemia redeveloped within 1 week. That shows that it acts as long as it is being taken. And maintaining a normokalemia is very equally important, especially in those patients who have been taking RAS inhibition on outpatient basis. And compared to the placebo therapy, the maintenance of normokalemia was significant in these patients who received this particular drug therapy. And very important to know that this particular table almost summarizes what exactly is each drug, which is compared to the old one, which is the resin which is available to us. And the resin, all of them act predominantly in the GI tract, and they don't get systemically absorbed, and usually they get excreted into the feces. And as far as the selectivity of potassium is concerned, the sodium zirconium cyclosilicate is the one which has got the highest selectivity, and almost it binds 9 times potassium compared to the other drugs. And probably like pyrethromer, the magnesium binding is not associated in the sodium zirconium. And another important thing which you should remember is the edema and aggravation of hypertension in these patients who received hyperkalemia therapy. This is the sodium content of this particular drug therapy is 15 milligrams for sodium for 15 grams of resin, the sodium polystyrene sulfonate. Whereas the pyrethromer doesn't have any sodium content of it, but to remind you all that edema, the hypertension worsened in some small group of these patients who received pyrethromer, and the sodium zirconium almost approximately 1000 milligrams of sodium per 10 grams of dose of sodium zirconium. So that could be the reason why the significant number of these patients, almost 7 to 8% of the patients had edema and worsening of hypertension. And the sorbitol has to be given in those patients with the kexalate and pyrethromer, and which doesn't require to be given in sodium zirconium. You know that the sorbitol can really produce intestinal necrosis. And the onset of action is earlier with the sodium zirconium compared to the other drugs, and it also can sustain for a long time. But unfortunately, we don't have a clear-cut idea about the duration of effect. But actually, it acts almost for a longer duration. But the moment you stop it, almost 4 to 12 hours later, it can probably, the hyperkalemia can reappear. The doses, as I stated, it has to be given 2 to 3 times along with the meals and has to be followed up. And if it is, it can be given once a day, especially when you are giving the patient on outpatient basis. And all of these two powders are tasteless and odorless powder. It has to be mixed with water, and it has to be given orally. But though hyperkalemia is a significant problem in our patients with a chronic kidney disease, but unfortunately we don't have a wonderful therapy to manage these patients, and still an emergency management, something like a hyperkalemic periodic paralysis we have been seeing. And hyperkalemia as a number also will frighten the nephrologist when we see the potassium of 6.2 without much evidence of ECG changes. And we require to have wonderful drug therapies with the long-term safety and efficacy proven. And at the same time, these drugs have to be given orally, and there may be some drug-to-drug interactions, and there can be less efficacy of other drugs concurrently given along with these drug therapies. And we don't have the efficacy trials done in those patients with a post-renal transplant, where multiple immunosuppressive drug therapies will be given, and with a decrease in the kidney function gradually over a period of time, metabolic acidosis sets in these patients, and simultaneously the potassium goes up, and taking care of them would be a difficult thing. And as I heard that the cost effectiveness is also very, very important. And in these patients, and these two molecules which are not yet available in India are supposed to be very, very expensive, and we need to weigh the risk and benefit ratio simultaneously when we are treating with multiple drug therapies on outpatient basis. And most important is the dietary restriction of potassium, which is easily said than done and difficult to manage the patients at home. And we should advocate the potassium restriction, especially from stage 3 to 4 onwards, to all the patients, where the significant number of these patients would be having hyperkalemia. And thank you very much for the kind attention and the patient hearing.
Thank you, Dr. Sribhushan Raju, for that extensive elaboration on management of hyperkalemia and the new drug armamentarium which we have. And so often all of us have faced hyperkalemia presenting to cardiologists with heart block and continuous CKD. My one question before handing over to others is, what is the effect of this pachyderma on calcium? Because it is in calcium exchange regime. So is it been known?
No, it did not really make any difference as far as the calcium content of the blood is concerned. Hypocalcemia and the hypercalcemia were not reported with that, except magnesium. It is known to bind the magnesium, and hypomagnesemia would be a problem, and very difficult also to correct during the therapy. So we need to see, once we get experience individually with these particular drug therapies, how to titrate the doses and to according to excuse me, to the requirement of the patients individually.
Thank you. We still have 5 minutes, so I go over to Dr. Ketan Mehta.
Yeah, thank you, Kalpana madam. First of all, let me congratulate Dr. Sribhushan for such a fantastic, in a snapshot of hyperkalemia in such a short time. I would like to mention 1 or 2 points over here, or rather things what you have mentioned about usage of beta agonist, which is used as an inhalation therapy for hyperkalemia. So how much is the role of beta blocker as an etiol or as a causative factor for hyperkalemia? Because we as a clinician, lot of come across cases of heart failure where RAS blockade therapy, aldosterone, along with beta blockers, which has been used. So, and when they present with cardiorenal syndrome with hyperkalemia, obviously our nephrology friend will come and start omitting one after the other drug. And then the question comes about the beta blocker. So can you just throw some light on that?
Yes. Beta blockers are known to produce, if you really see all the textbooks of internal medicine and nephrology, every table will have hyperkalemia. One of the reasons is the beta blockers. But maybe the initial drug therapies like propranolol and other drugs might have had a significant number of patients having hyperkalemia. But the newer drug therapies, carvedilol and metoprolol, these drugs are not shown to have any kind of a impact on the potassium. Something similar to the bronchial asthma, which is being aggravated by beta blockers, which was documented in the early literature, but not in the recent times. But we are more comfortable in using this. But definitely, ACE inhibitors and ARBs are known to produce hyperkalemia. We have seen good number of these patients having hyperkalemia as a manifestation, which forced us frequently to stop the drug therapy, at least for temporarily for some time, till the potassium gets corrected. But would be difficult also to send the patient out with hyperkalemia unless we give some management. But unfortunately, none of these reasons or any kind of this drug therapy would come to our rescue. But only thing is that we frequently prescribe the drug called sodium bicarbonate in patients with the chronic kidney disease. And probably we would see less number of potassium hyperkalemia patients, as the patients are on sodium bicarbonate therapy, and it corrects the metabolic acidosis frequently. But we don't write that in patients with a congestive heart failure frequently. But hyperkalemia would not be a problem when we give a beta blocker, especially when we give a bicarbidilol and other drugs in patients with a congestive heart failure. But ACE inhibitor ARB in association definitely would be a problem. Interestingly, many of the studies done, especially the spironolactone and other studies given, so they were used in patients with a congestive heart failure only in association with the heart failure. So we are supposed to be careful in giving ACE inhibitor ARB, but beta blocker definitely would not be a much problem for hyperkalemia.
Right. So because that was also a very, very important point over here. And the issue comes over patients with heart failure, and then the cardiologists pushing so much on ARNI. And now with the SGLT2 inhibitors which are introduced. So I just wanted to know, because ARNI, you are always concerned about both the aspect about the EGFR creatinine as well as potassium. Whereas with SGLT2 inhibitors, at least you are safe in terms of your potassium. You are worried about only your EGFR and creatinine. So would you agree with that?
Yes, yes. ARNI, we have used a good number of the patients, both in pre-dialysis and dialysis patients also, with with the ejection fraction of less than 30% and around. And we have been using it, and we never faced a problem with the hyperkalemia. Maybe in pre-dialysis patients, invariably they'll be on diuretic therapy, and the dialysis patients would be on dialysis therapy. So that would actually counteract the effect of this particular drug therapy, which probably can increase the potassium otherwise. So we never faced much problem of hyperkalemia in these patients who received the ARNI therapy.
I think Preeti Shukla is with us, and I think she is going to play a very important role. So we should have some comments from her. Sri Bhushan already said that diet would play a very important role. Is Preeti around?
Yes, sir.
Yeah, it's all over to you.
Yeah, diet plays a very important role in reducing the hyperkalemic elements. And for that, we need to focus upon the interventions and actually
Hello. I think we lost her.
Yeah, we lost her. Somebody can take it over. Yeah.
Yeah. So
Kalpana, you can add. Yeah.
So dietic part is that it's very difficult to make patients control their potassium intake, because normally they don't take potassium with fruits so high, but the moment they are told CKD, they want to say which fruit I want to take, which fruit I can take. So all our dietitian usually talk about all those fruits with peach. Yeah, she's back again.
Yeah, she's back.
Yeah.
Preeti, take over.
Yeah, sorry, sir. I lost the connection. So in this, we reduce the potassium intake by asking them to not to consume coconut waters and high potassium fruits, as well as we avoid them having any kind of juices. Leaching is only prescribed once we know that the patient is consuming very high green leafy vegetable. So there is a increased intake, or the patient is lover for green leafy vegetables, only then it is allowed to leach. Otherwise, only limiting the fruit intake and the juices intake and the coconut water intake, we can limit the potassium intake. Unnecessarily doing say potassium restrictions in the form of leaching each and every vegetable, it is not recommended nowadays.
Okay.
Yes, ma'am. Yes, actually, it is very important to advocate leaching right from the beginning. And but many times it is a very frequent question by the patients when I should take the fruits while on dialysis. So one of the social media few years back, there was a question by someone, and people were asking, and as a routinely I told that you should take the fruit just before initiation of dialysis, or during the first 1 hour of dialysis. But many of the patients retaliated, saying that no, we have been doing the same thing, but still we had a problem. Our doctors scolded us for taking the fruits during the dialysis.
But that actually helps. Yeah, that actually helps. Pre-dialysis, you can give them fruit, and whichever fruit they are fond of can be given on the dialysis machine.
Yes, I always advocate this.
For the nice session of hyperkalemia, which is at times can be life-threatening. Thank you very much. I hand over to Dr. Akash.
Thank you so much. Thank you so much, ma'am, for conducting the session and finishing on time. We would invite the next set of chairpersons to help us through the next talk, which is an important one. Dr. Mayur Prabhu, Associate Professor, Kasturba Medical College at Mangalore. Dr. Rajiva Lochana Parthasarthi, Consultant, Madras Medical Mission, Chennai. She's an ERA EDTA Fellow. Dr. Meenakshi Bajaj, Dietitian, Tamil Nadu Government, Multi-Speciality, Super Speciality Hospital at Chennai.
Thank you, Akash. Am I audible, Akash?
Yes, perfect.
Thank you. Thank you, Akash and Dr. Umesh Khanna and the organizing team of Srnmcon for putting together such a wonderful and an excellent academic program. So the next talk we are having right now will be by a very eminent faculty, Dr. Sanjay Pandya from Rajkot. Dr. Sanjay Pandya is DNB Nephrology from IKDRC in Ahmedabad. And he is very well known for his Kidney Education Foundation and his series of books, which have been translated in up to 39 languages. And he has a global team of about 100 plus nephrologists. He is an author on several books on the related topics, and therefore he is probably the right person to be invited as a speaker for this session on fluid therapy, electrolytes and acid-base balance. So he will be speaking about metabolic acidosis. So I think we can start the presentation, please.
Good morning, friends. First and foremost, I would like to congratulate Dr. Khanna and team for having such an excellent conference on this subject, very well needed. Now, today I'm going to talk on metabolic acidosis. Am I audible?
Yes, sir.
Very clearly, sir. Very clearly.
Yes. Okay, fine. So basically, this topic I am going to have some of the brief outline, and first we will start with the basic understanding that what metabolic acidosis is. See, when we talk about metabolic acidosis, the first question that what acidosis and what pH is. Now the pH is determined by two things. Number one, it is bicarbonate, and second is PCO2. So when bicarbonate is normal 24, PCO2 is normal 40, then pH will be 7.4. So this is how it is actually calculated. When pH is less than 7.35, it is acidosis, and when pH is greater than 7.45, then it is alkalosis. Now the question arises that what are the primary disorders? Because metabolic acidosis is one out of that. So primary change in bicarbonate leads to metabolic acidosis and metabolic alkalosis. Primary change in PCO2 leads to respiratory acidosis and respiratory alkalosis. But today we are going to talk only on metabolic acidosis, where primary change is low bicarbonate, which gives rise to low pH, and secondary change will be PCO2. So it's a balance that when bicarbonate is low, pH will reduce, and that's how metabolic acidosis will be characterized by acidosis that is low pH and low bicarbonate. But we need to keep in mind that low bicarbonate can be as a primary change because of metabolic acidosis, and even in respiratory alkalosis, when PCO2 reduces, the compensatory change will be reduction in bicarbonate, and therefore bicarb can reduce because of two reasons. So if the bicarb is low with low pH, our diagnosis is metabolic acidosis. If bicarb is low but pH is high, our diagnosis is respiratory alkalosis. So it is either because of bicarb loss or because of the acid is added, or kidney is unable to excrete bicarbonate. Now, when we look at the metabolic acidosis, always check NIN gap. NIN gap is sodium minus total of chloride plus bicarbonate, and normal value is 12 plus or minus 2. If anion gap is high, we can say that yes, metabolic acidosis is of high anion gap. So on basis of anion gap, metabolic acidosis is divided into two parts: normal anion gap and high anion gap. The cause of normal anion gap metabolic acidosis is like severe diarrhea, renal tubular acidosis. High anion gap is like ketoacidosis, lactic acidosis, and renal failure and others. Now, when we talk about etiology, basically either there is increased acid excretion or bicarbonate is lost, or there is diminished renal acid excretion. So these are some of the important causes which we have summarized here. We will not go in depth of everyone. Now, what are the symptoms of metabolic acidosis? The symptoms of patient varies. First, that it may be manifestation of underlying disease like patient with diarrhea, decay, shock, patient CKD. There will be symptoms of associated problem, basic symptoms of metabolic acidosis, which we will cover just now. And sometimes patient may be asymptomatic and it is accidentally diagnosed. Now, when we talk about symptoms of metabolic acidosis, respiratory symptoms as a compensation, that is hyperventilation or Kussmaul's breathing, is something which is common, and that tells us that yes, there is underlying metabolic acidosis. Because of metabolic acidosis, it can lead to cardiovascular effects like tachycardia, susceptibility to develop cardiac arrhythmia. They are more prone to develop hypotension, and if they are hypotensive, acidosis is present, there is decreased response to inotropes. Neurological problem like headache, confusion, lethargy can occur, and there is possibility that because of metabolic acidosis, these patients are more prone to develop hyperkalemia. So if patient is metabolic acidosis, we need to keep in mind that hyperkalemia is a possible thing. Now, coming to how do we manage metabolic acidosis? It's a broad topic, but very, very important to remember that look at the underlying disorder, and treatment of underlying problem is the most important measure to manage metabolic acidosis. And we need to provide bicarb, we need to provide, we directly need to treat metabolic acidosis in some of the patient. But if patient is having mild to moderate acidosis, treatment of underlying problem may be enough. Alkali therapy should be reserved for selective patient with severe acidosis. The treatment of all acidosis with sodium bicarbonate is not only unnecessary, but it can also be detrimental. Now, the question arises that why we should treat patient with metabolic acidosis? Answer is that it's because of its detrimental side effect like Kussmaul's breathing, risk of arrhythmia, myocardial depression causing hypotension, impaired response to vasopressors, and possible risk of the hyperkalemia. Now, if it is so much useful, why we should be cautious and why we are concerned about using bicarbonate judiciously? Because it has many side effects. It's rich in sodium, so can cause hypernatremia, volume overload, CNS acidosis, hypokalemia, hypocalcemia, overshoot or rebound alkalosis in patient with organic acidosis. And because of this reason, it's very important that we should use this molecule, sodium bicarbonate, meticulously. Important to remember that 100 ml of bicarb, which we are using, contains 90 milliequivalent of sodium. And therefore, amongst all available agents, as compared to 3% NaCl or others, it has almost, as compared to 3% NaCl, it has a almost double concentration of sodium, and therefore they are at risk of developing hypernatremia and volume overload, should be used cautiously. Now, when to treat metabolic acidosis? See, there are many indications, and its use depends upon for what problem are we using bicarb therapy. In patient with high anion gap metabolic acidosis, the basic principle is that not recommended routinely. Use judiciously, and whenever you are using it, use it only for partial collection. Our aim should not be that we bring a pH to 7.4 or we try to bring bicarbonate to 24. No. In such case, bicarbonate therapy can be harmful. Mild to moderate acidosis may be beneficial in high anion gap metabolic acidosis, and therefore try to provide only when it is pH is low, and try to bring pH to little greater than 7.2 and then leave it as it is. So this is what is important. See, lactic acidosis, which is common, it's high anion gap metabolic acidosis. So use of bicarbonate is controversial, but should be given when it is severe, life-threatening, pH is less than 7.1. Start with late, discontinue early, discontinue when pH is greater than 7.2. Now, normal anion gap metabolic acidosis, like patient with diarrhea, indicated early and should be discontinued late, should be started even with little lower pH or even bicarbonate is less than 16 to 80. Replacement of bicarbonate is very important, it's beneficial and hastens the recovery. In diabetic ketoacidosis, when we talk about, it's rarely used and usually avoided. And in diabetic ketoacidosis, the role of bicarbonate therapy is only when it is extremely severe, like pH less than 6.9, otherwise it is not required. In patient with metabolic acidosis and hyperkalemia, along with my learned friend Dr. Raju has already narrated all aspects of hyperkalemia, but bicarbonate therapy shifts potassium intracellularly and corrects hyperkalemia, and therefore in acute management of the hyperkalemia, if patient is acidotic, correction of the bicarbonate with bicarbonate with sodium bicarbonate may be helpful. Now, if patient is having hypokalemia, then it's very important that, see, we have two problems. One is acidosis and second is hypokalemia. So if hypokalemia is severe, correct hypokalemia before correcting acidosis. See, if acidosis is corrected, that is going to aggravate hypokalemia, and in severe hypokalemia, it may precipitate respiratory failure, and therefore it's very important that when you are treating metabolic acidosis, look at the potassium. If it is hypokalemia, treat potassium first, bring it to little comfortable safe zone, more than 3.5, and then continue potassium supplementation and simultaneously treat metabolic acidosis. This is something which is important. Now, coming to the last part, and the most important for all of us is CKD. Now, say in chronic kidney disease, especially when it is of chronic tubulointerstitial disease, metabolic acidosis is very common, and this metabolic acidosis is going to be harmful. Different ways by which it can cause the harm is it increases the risk of CKD progression, it leads to bone demineralization, so weakens the bone, and even the muscular weakness is going to be, skeletal-muscular weakness is going to be very important, and that increases the risk of even death when pH is less. Even high pH is going to be harmful, and therefore try to keep bicarbonate level between 24 to 26, which is the ideal as per the current recommendation. It's very important that metabolic acidosis is one of the important risk factor for CKD progression, and the correction of metabolic acidosis in CKD can slow down the CKD progression. In some of the patients with severe acidosis, when we start bicarbonate therapy, all of us have observed that creatinine, which is higher, will come down to little lower level, and we can settle it down in lower value of serum creatinine. and it improves outcome. It decreases the overall weakness, skeletal weakness. And because of all this reason, it is very important that metabolic acidosis should be looked for in every patient of chronic kidney disease and should be meticulously treated with oral bicarb therapy, which is easily available, and with the aim to bring pH, doing bicarbonate between 24 to 26. So this is something which is very important. I think it is a short time to discuss metabolic acidosis. So with this, I would like to end and would like to thank all of you for supporting this fluid therapy book and supporting our kidney education mission, where book is available in 39 languages. This is received World Record Award. It's available in 27 international languages and 12 Indian languages. So it's a popular book, and it's because of the efforts of more than 100 nephrologists across the world. We are supported and blessed by many and all. Thank you. Thank you very much.
Thank you very much, Dr. Pandya, for a very lucid presentation, and especially for including a lot of practice pearls, which will be very useful for our postgraduates especially. I invite Dr. Rajiva Loshana and Dr. Meenakshi Bajaj, my co-chairpersons, to take the discussion forward.
Yeah. Fortunately, we have 5 minutes, so I think we can take a good number of questions.
Yes.
Thank you, sir, for the very lucid presentation. So firstly, in 3 settings, that is pre-dialysis CKD, in hemodialysis and peritoneal dialysis patients, and in transplant patients, what is our approach to metabolic acidosis? And Meenakshi ma'am, what is the dietary regulations we can do in these 3 sets of patients in order to prevent and improve metabolic acidosis?
Thank you so much, sir. I think Dr. Sanjay sir did an excellent presentation, whether it's the postgraduates or the practicing nephrologists or even the dietitians, to understand the thin line between hyper and hypokalemia correction prior to correction of metabolic acidosis. Now, recently, a recent publication in Nutrients 2021 gave a very different understanding of correction of metabolic acidosis in CKD stage 1 as well as CKD stage 3 and 5. So in which they have explained the importance of a normal protein omnivorous Mediterranean diet, point number 1. Point number 2, as an alkaline diet. So these 2 diets help to reduce the PRAL as well as the NEAT value. This is the first understanding when it comes to CKD stage 1 and 3 for correction of metabolic acidosis as against sodium bicarbonate therapy. And secondly, the talk of low protein diet and a vegan low protein diet, which also helps in the improvement and management of metabolic acidosis, wherein they talk of protein between 0.6 to 0.7 grams, as well as, replacing the animal-based meat, fish, and cheese with fruit and fruit juices, as well as vegetarian sources of protein. But as sir very beautifully said, we need to keep in mind the potassium values before we start the correction, whether it's hypo or hyperkalemia. So this is my take when it comes to the dietary management of metabolic acidosis, but I would like to hear more from Dr. Pandya sir because of the world of experience sir has.
See, basically amongst all therapy which is available in management of CKD, I am talking about pre-dialysis, pre-transplant phase. The two most effective therapy which can control or slow down the rate of progression is number 1, control of blood pressure, and number 2, control of metabolic acidosis. I mean, this is all about chronic therapy. I'm not going to talk about hypovolemia or sepsis or drug-induced, whatever happened. But on the long term, when we manage such patient, control their hypertension and meticulously control their metabolic acidosis, try to keep bicarbonate at 24, then we can slow down the rate of progression. The need of dialysis, stage of dialysis transplant can be avoided, and therefore even it is very cheaper as compared to many of the other newer therapies which are available in market. If proper care is taken for these 2 points, then it's going to be very rewarding. And therefore, although this is a different topic, but this is very, very important topic for clinical practice in management of the patient with CKD. Regarding dialysis, as they are on regular dialysis, the need of the bicarbonate therapy will reduce because dialysis itself will take care of the metabolic acidosis. However, if the acidosis persists, then we may have to provide bicarbonate. And post-transplant, usually acidosis is very uncommon because kidney function becomes normal and it's take care of the rest of the things.
Sir, how do we approach patients with metabolic acidosis in terms of management? Because many of our patients, when we give them a high number of tablets of sodium bicarbonate, so they do, default on it, and it is difficult to take. Are there any tips to kind of resolve this issue as well?
Basically, because they, as already discussed, when they are on vegetarian food, the need will reduce. But bicarbonate tablet is available even in 1 gram. Now, even some of the companies have come with the 2 gram sachet. That's number one. Some of the patients who may not be comfortable, even the bicarbonate solution syrup is also available, but there is no other shortcut. And one more thing which we need to keep in mind, that along with bicarbonate, even we are supplementing sodium. And therefore, we need to increase the dose of diuretics. We need to take care of the blood pressure, which is likely to increase when bicarbonate therapy is given. But treating bicarbonate with metabolic acidosis is very rewarding in terms of protecting kidney function.
Usually patients do complain and say that, madam, you have told us to restrict sodium and you are giving us sodium bicarbonate tablets. So that time it's a little tricky to explain to them.
Yes, but then it has a great protective
Obviously.
effect and therefore should be really followed well.
Ma'am, in terms of the 2 diets that you spoke about, quickly, can you just tell us how we can modify that in an Indian setting and in an Indian diet?
So when we talk of a Mediterranean omnivorous normal protein diet, is basically we talk of, bringing down the saturated fat and stepping up the mono and the poly. So basically, in CKD early stages, it's not difficult for us. So we can rely more on legumes, more on nuts, obviously the healthy nuts, the almonds and the walnuts, and plant-based protein sources in the form of whole grams and legumes. So that comes to the normal protein omnivorous Mediterranean diet. And second is, there is some comment of extra virgin olive oil, though I'm not a very hardcore fan of it. But recently, after having read this paper, it had given me some interest to understand that it has got mini polar compounds and bioactive molecules, which not only help to, improve metabolic acidosis, but also helps to improve lipids, which is also a slight problem where there is some amount of lipid metabolism which is impaired in CKD. So that's when it comes to the Mediterranean diet. Second is the alkaline ash diet, in which we talk of more consumption of cucumbers, zucchini, radish, as well as bell peppers, which is easy in an Indian diet, which is not hard on, money or even availability. So easily available, whether it's radish, onion or capsicum, all these are easily available, including some of them, they do talk of broccoli and kale, which I would still say, it's a Western sort of a thought, but these other vegetables are very, very convenient. And third thing is, when it comes to the low protein and a very low protein vegan diet, it's not difficult. In fact, a quite number of population has been moving to a vegan diet right now. And the only little crunch where they talk of is they want us to ensure that the calorie is adequate. If you're going to reduce the calories to below 30 calories and reduce the protein also, the milieu of PU is going to worsen. So we do not want PEW in the patients. We want them to improve as well as correct metabolic acidosis. So basically, moving from animal-based diet to a plant-based diet plays a very, very major role. And obviously keep away from ultra-processed foods. So that's about these 4 diets, ma'am. And the protein is 0.6 to 0.7 grams.
Great. I think I think the time,
Rajiva is talking, but she's muted.
Yeah, so I think the time is up, and if we are going to cover up all the aspects or all the points which our Cam Kalantar is going to talk, which is in fact an extension of what is going on, then we would all also want to hear from him, our star speaker. And so thanks everybody for this wonderful session. It was really an eye-opener and a great workshop which we had. Akash, please.
Thank you, sir. Thank you, chairpersons, for this excellent session. Thank you, Dr. Pandya. Always a pleasure to hear your thoughts. We now move on to the most important session of the morning today. It is a celebrity speaker, and we all know him, but we will invite the chairpersons, Dr. K.S. Nayak and Dr. Jagmeet Madan, to take the proceedings forward and introduce our speaker. Dr. K.S. Nayak is the Chief Nephrologist at Department of Nephrology, Virinchi Hospital, Hyderabad, and Dr. Jagmeet Madan. We've been lucky to have her with her yesterday and throughout this conference. She's Principal and Professor, Department of Food, Nutrition and Dietetics at Vithaldas Thakarse College of Home Science and SNDT Women's University, Mumbai. I welcome you to take over the session, sir and ma'am.
Yeah, Jagdeep, it's a pleasure to chair the session with the dietitian. This is the first time I'm doing that, and I think I cannot overstress the fact that the dietitian should be involved in these conferences, and their inputs are very crucial in patient management. So, Jagdeep, are you there, Mr. Jagdeep?
I will join because she's in a parallel session also,
Yes,
which is
sir.
not yet ended, so she will join.
Okay, so it's my pleasure to invite my long-standing friend of more than probably about 2 decades, Cam, as we call him, Kamer Kalandazade, is probably the latest statistic shows that he's the most published nephrologist in the world. And ever since he shifted to UC Irvine, he's been doing even more work. He's teaching nutrition to the world, actually. That's what I can. And he's a strong proponent of the Plateau diet, which is the plant-dominant diet. He's professor in chief of division, as I said, of hypertension and kidney transplantation department of medicine, the UCI School of Medicine that's the Urban School of Medicine, and the past president of the International Society of Renal Nutrition and Metabolism. He was the president of the International Congress of Renal Nutrition in Hawaii, NIH Career Development Award 2001 to 2006, Joel Koppel Award 2006, which is the highest award in nutrition, NIH Mid-Career Mentoring Award, UCI Mentor of the Year Award 2017. Always a pleasure to welcome you, my friend. He is, by the way, a very big fan of Indian food. That's something that the nutritionist should know that, and is also a great fan of India. India is probably his most favorite country. Welcome, Cam. Good morning and welcome.
Thank you very much. Such a great pleasure and honor for me to be back in India. Last time I was in the incredible India was 2019 in Chennai and then Hyderabad. And I think that was a few months before COVID started. So hopefully, once again, the world starts being relatively normal so that we can start traveling and interacting. With that in mind, I don't have much to contribute to what the richness of dietary management is coming from Indian experts, especially nephrologists and dietitians in India. I'll try my best to put together what I have had here, and also some amounts of it I have learned, good significant amounts of it I have learned from colleagues in India, including Dr. Nayak. So World Kidney Day is important since I have privilege to be in the steering committee of the World Kidney Day, and especially since this year is about World Kidney Day's theme is about living well with kidney disease, and next year is Kidney Health for All. So please remember, in March 2022, celebrate Kidney Health for All, and in the upcoming 3 months of 2021, living well with kidney disease. That means if you have a kidney disease, you need to be able to live well and long. So I'm using some of these papers and textbooks to present today's presentation. And now, living well with kidney disease is about some of the statements here. Patients' priorities, values, and goals. After being a nephrologist for over 2 decades, I've come to believe that if everything is done in a good amount, what I learned, for example, from India, less dialysis in earlier stages, more dialysis in later stages. And to advance research practice policy, there is increasing recognition of the need to identify patients' priorities. So everything is about our patients because we serve patients. We are there because of the patients. And patients need hope, a feeling of trust. And hope can be aggravated when there are choices. If you look at our traditional approach, we tell the patients that dialysis needs to start. Patient needs dialysis. If you don't want dialysis, then go to the path of no dialysis. And in the US, it's called hospice medicine and essentially path of end of life. But what we would like to emphasize is that there is no dichotomy. Somewhere in between, we should be able to help patients instead of saying either supportive care or full dialysis life-saving care, that we are here to expand the choices. And the choices come from nutritional and lifestyle modifications. So I would like to emphasize again that patients appreciate ability to be free dialysis freedom as long as possible. Now, I am in charge of 2 large dialysis centers, so I'm a very pro-dialysis person. Like an oncologist who's a pro-chemotherapy, but in the right dose and in the appropriate timing. So going back to hope can be expanded and enforced by choice. And choice is not a dichotomy. That means I have to expand this. I have to be able to tell a patient that, hey, I can help you to preserve kidney function longer. That's conservative management that's associated with even longer survival if it's done correctly. And when you need help, I can help you with your symptom management. And when you need to start dialysis, I can help you to start dialysis gradually, not abruptly and frequently and intensely. And then at the end, when you need adjustment for dialysis, I can help you. So these are things plus more we should offer to our patients. And for now, if there is a patient with CKD, I have to say that, hey, I can help you to delay and defer dialysis. And that's what I learned. And we nephrology in the US, we need to learn from India, among others. And it's not just for the old patients. They think in the US that this is for the old patients. This is for all patients. So if we focus on the first one, conservative and preservative management, kidney preserving therapy by diet and lifestyle modifications. And this is essentially to highlight the green area here. That means allowing slower progression, delaying dialysis, deferring dialysis, and yet making patients live long and be healthier. So in this Lancet paper, I was privileged to contribute, which was published last month. It's a comprehensive review of CKD. Here we define preservative management or kidney preserving therapy means prolonging dialysis-free time, achieving the greatest survival. So because some people say that avoiding dialysis means to go to the path of end of life, as I said, no, that's not the case. It is combining non-pharmacologic strategies on top of ACE, ARB, and SGLT2 inhibitors, no matter how impressed we are with these medications. And once again, let me just put this in the middle of the kidney care chart, kidney preserving care, plus symptom management when it's needed, hospice. But a main part of kidney preserving care, as you can see here, is diet and lifestyle modification. And this was also highlighted last year in 2020 about secondary and tertiary prevention of CKD, which, as you see, is all about, among others, of course, diet and lifestyle, lower protein, more plant dominant, and allowing us to slow progression. So in the United States, fortunately, this is becoming something more important nowadays. We have a long way to go, especially after the problems that the challenges of the MDRD study of 25 years ago. at that time, and even now, the low protein diet is considered 0.6 to 0.8 grams of protein per kilogram per day, not kilogram. Is it ideal body weight? Is it real body weight? That discussion continues. Even Keidoki didn't end that discussion. If anything, add to more, and then lower protein. That means less than 0.4, 0.3, which is very low protein diet. Now, this is what Keidoki says. If you don't have diabetes, 0.55 to 0.6 grams of protein per kilogram per day. And if you have diabetes, 0.6 to 0.8, Keidoki did not specify the amount of the source of protein. Should it be from plants or from meat? They didn't specify that. That was one of the areas they did not say a lot. They did not say much, actually. And looking at the MDRD study of 1994, if you look at here, the problem was that they said the study was negative. The study was negative, but then I would like to remind colleagues, anybody who talks about the modification of diet in renal disease, you should always remind colleagues that diabetes was excluded. In 1990s, at that time, they said diabetes is a rare disease. We don't even need to include this in the MDRD study. Now in India and US, a large proportion of patients have diabetes, and polycystic kidneys was overrepresented, and yet the study was positive. Why? Because while ACE and ARBs, they work on the efferent arteriole, low protein diet and SGLT2 inhibitors, they work on the afferent part of the arteriole, of the glomeruli. That is the afferent arteriole of the glomeruli. If you look at here, let me just highlight again. As you can see, vasoconstriction that happens with low protein diet and with plant-based diet is important. Now, I would like to try with your help to revive the concept of hyperfiltration of glomeruli. This is a very important concept, which was highlighted 30 years ago. And look at here, diabetes, high dietary protein intake, especially animal protein, leads to glomerular hyperfiltration. And if you look at the history, look, if you find here in 1982, Brenner and Tim Meyer and Hosseter, they wrote a landmark review paper that put together all this data. And they said 30 years ago, which makes it 70 years ago from now, our science already found glomerular hyperfiltration due to high protein intake. It is something that was so established at that time, and we forgot. We completely said goodbye to this, and our effort is to bring this back to the front line, to the prime time. If you look at here, animals who eat meat, they double to triple their GFR within 30 minutes of eating meat. Why? Because they need that. This was an evolutionary adaptation based on what these animals needed, animals that are based on meat. Now, are we human based on meat? We are not like them, right? Look at here again. This is a dog who just ate chicken and is sleeping, and his GFR has doubled. Now, and triple, look at here, GFR rise by several 100% within 2 to 3 hours of heavy blood eating in these bats and vampire bats. So these animals, usually like a dog, doesn't live more than 15 years. A bat is also life is restricted to a few years. And for us, for mankind, maybe in the past, where life expectancy 40 to 50 years, for those societies that were based on eating meat, that was something that was not important. And even in us, in human, amino acid surge leads to increased GFR. If you look at here again, once again, let me highlight another paper from 1991, but this is pure research. Kathy Tutel, who is in the Seattle area, she at that time found that in volunteer diabetic patients versus non-diabetic patients, when you infuse amino acids, look at here, GFR goes from 95 to 160s within half an hour to an hour. And in people who don't have diabetes, it also goes up. But in diabetic patients, it goes even higher. So hyperfiltration is even more burdensome in people with diabetes. And imagine now, some people, some dietitians tell the diabetic patients eat more protein to lose weight. So by lowering the amount of protein, especially the meat part, there is a decline or adapted decline in GFR. Now, again, we try to highlight this in figure 2 of the Lancet paper of last month. And once again, I wanted also to highlight here that diet and medications together, they work, not one versus the other. So we're not saying that, hey, either you are pro pharmacology or pro diet. We need to really highlight what, for instance, cardiologists do. Cardiologists never give statin and says, don't go and eat whatever you want. They have a combination of diet and pharmacotherapy. So if you look at, again, MDRD study, if MDRD study has started 3 months later, the study would have been declared positive, despite the fact that majority of patients, or a large number of patients with polycystic kidney patients, whose progression is extremely slow. Yet there was positive signal here. And the reason that initially GFR was worse in the first 3 months in the low protein diet patients is what we see in SGLT2 inhibitors or ACE and ARB. We don't even question that, but when it was about this MDRD study, people use this to discredit the results. Now, let me highlight the second, the other question, which is, can lowering protein intake or not eating meat cause protein energy wasting or malnutrition? So there are a good number of research based data suggesting that the amount of protein that is required as the basic and to maintain or to avoid catabolic rate is 0.46 to 0.5, not even 0.6 or 0.7 or 0.8, 0.46, assuming there is adequate essential amino acids. So the Institute of Medicine, or the American Academy of Medicine, which is the new name now, has recommended through its food and the food section that the recommended dietary allowance of protein is 0.8, which is 35% higher than the 0.6. So therefore, 0.6 to 0.8 is considered safe. And 0.6 to 0.8 is what also considered as what should be recommended to patients with CKD stage 1 through stage 5, not on dialysis, and including those on dialysis who still make urine. Now, in the past, again, 25 years ago, they used to say that if you lower protein, half of it should be high biologic value protein. But this is now being replaced by half of it should be from plant-based protein, and it's plant dominant. Now, are there data about that? And then some colleagues say that if you're worried about very low inadequate amino acids, or if you give very low protein diet, then supplement this with essential amino acids or ketones of amino acids, which is yet another discussion. We, in our center, we invariably ask patients every 3 to 6 months to help to collect 24-hour urine. We look at accuracy of 24-hour urine and all the data related to that. And we calculate based on urinary nitrogen and estimate the amount of protein that patient is taking. Now we use potassium, not to lower potassium, but we use it to see if patient is eating adequate vegetables. If the potassium in the urine is less than 3 grams or 4 grams, I say, hey, you're not eating enough fruits and vegetables. So that's, now juxtapose this to the traditional approach that potassium is high. So if I could highlight here, what is recommended, some of us, including myself, we take issue with the low potassium, and we say that potassium should be 4.7 grams per day coming from fibers, fiber-based diet. It must be natural potassium. Why? Because if it comes from fruits and vegetables and plant-based diet, then it helps with gastrointestinal transition and helps avoiding or preventing or lowering the likelihood of constipation, which is the cause. Constipation is usually the cause of hyperkalemia. Now, another contribution of our group under Dr. Ree and Dr. Narasaki, few months ago in the journal, American Journal of Clinical Nutrition, is that in people with GFR below 60, high protein diet is actually associated with worse outcomes, above 1.4 grams per kilogram per day. Now, it's very interesting. And then the question about high biologic value, which essentially means meat. High biologic value means mostly meat. And as you can see here, in people with eGFR below 60, high biologic value, that means second and third tertile, was associated with unfavorable outcomes. So therefore, the old notion that high biologic value is something important and useful, especially in low protein diets, is here seriously questioned. Now, data from France, for example, as this one says, the lower is the protein, the better. So, but how low can we go if the lower is the better in terms of CKD outcomes? So, initially, if colleagues remember 10 minutes ago, I mentioned that I reminded colleagues that 0.3, around 0.3, is very low protein diet. It needs traditionally to be supplemented with essential amino acids or keto analogs of amino acids. There's a review paper about this in AJKD by colleagues, Dr. Koppel, myself, and Dr. Anuja Shah at Harvard UCLA. And here, the reminder that keto analogs of amino acids are generated inside your liver. That means these are not synthetics. The amination of amino acid leads to an ongoing process of having keto analogs inside your liver right now. And then studies from Italy, such as Brunori studies from 13 years ago, suggesting that deferring diets with very low protein diet keto analogs helps without without compromising survival. Now, when colleagues ask me, are there pure research data that more plant-based helps? I say, yes, there are some good data. One is from a colleague in Greece who went to UK, who did this study. And I copied and pasted this amazing presentation by Dr. Naik, as you can see here. And he showed that it's not just quantity of protein, but quality. That means if the protein source is vegetable-based, then you see similar impact as if you have lowered the amount of protein. That means the glomerular hyperfiltration goes down, subsides. GFR goes down, which is essentially what SGLT2 inhibitor people are very proud. They say, hey, we lowered GFR. And here also epidemiologic data from Dr. Srini Bedu in Salt Lake City showing the same thing again. Across the population, when there is more than 50% source of protein coming from plants, also the hazard ratio of mortality in CKD patient goes down. So altogether, based on this data, we suggested that the plant dominant is a compromise for those who don't want 100% vegetarian. We say that at least try 50%, and then plant dominant level 1 and level 2, that means 50 to 75% being from plants, and 75 above up to 100% being from plants, essentially becoming vegan. And try essentially plant dominant means PLA, plant dominant means DO, vegan, vegetarian, pescatarian, pesco-vegetarian, lacto-vegetarian, and the favorable things that colleagues have discussed probably the entire time when I joined, I noticed such a great and rich discussion was ongoing about so many different aspects of plant-based diet, from avoiding acidosis to hyperphosphatemia, to improving, increasing fiber intake, to favorable impact on microbiome, and so many other things. And data are essentially overwhelming nowadays. Actually, I would still say we need much more data. We need actually more studies, translational studies, to look at this. And there are pilot data, such as this one. There are data that corroborate to the concept, and also consistent with the culture in many nations, including in India, where you guys should be very proud and should really capitalize on this. Now, in the last few minutes, let me just go over another part, but when I said that we expand choices, one is also You do all these great things and patient still is going eventually. I mean, the more you prolong life of CKD patient, the more likely that they still are around and at some point need dialysis. And when that's the case, the more that I learned in 2012 in India, that means in South India, actually, since I was there for a few weeks, in Bangalore and Chennai, is gradual transition to dialysis. And this is what now we perform relatively widely in Southern California. So if we look at here, I'm highlighting two areas: incremental transition to dialysis and preservation of residual kidney function. Patients who start dialysis, they still have, many of them, they make urine, and it's about incremental transition to dialysis, or what we learned from Indian colleagues. Indian colleagues, they were not, some of them at least, were not very proud of that. And I said, hey, you should be very proud what you're doing. If you do it correctly during the correct phase, that means initial first few months, then there is a lot of reasons to believe and that is something favorable. So instead of starting everybody on thrice weekly, start once a week, twice a week, and then gradually, if patient residual kidney function subsides, then go to thrice weekly and maybe daily dialysis, and then at the end palliative dialysis. But we look at here the model that also comes from South Italy and Japan is to do 1 day or 2 days a week dialysis, and on non-dialysis day to continue low or very low protein diet. And the question as to whether this is where plant-based diet can continue on non-dialysis days, or on dialysis days, you can liberalize protein intake. This is the concept. There are some data, but we don't have a lot. We need a lot more data to be supportive of this dialysis and nutrition-based initiation transition. So at the end, I would like to acknowledge here World Kidney Day. Once again, we're here living well with kidney disease. If a person has kidney disease, he or she needs to live well and long. And in conclusion, I'm going to highlight what this incredible culture told us 30 centuries ago. 300 centuries, I'm sorry, it's 3000 BC, sorry about that. So when diet is wrong, medicine is of no use. And this one is even more accurate and relevant now, 3,000 years later. And we in the International Society of Renal Nutrition Metabolism are working on world kidney recipes to make a multicultural approach. And I apologize that one or two of this is based on meat because we want it to be inclusive. And I would like to encourage all colleagues, especially when we're going to meet in 2 years, hopefully in 2.5 years in Hyderabad for the International Congress on Nutrition Metabolism under leadership of Dr. Nayak. We're going to have a larger collection of world kidney recipes, especially based on what we learned from South India, North India, from Gujarat, from so many amazing cultures, from Bengali, who also have Bengali colleagues and colleagues in Kochi who also have some touch of fish, for example. All these things together, which is all about conservative and preservative management. We diversify things, but with more emphasis on plant-dominant components. That means low and very low protein diet. So it's not just any plant-based or vegetarian. The amount of protein should be on the low to very low side. The more and it has to be more plant dominant. That means at least 50% of the source should be from plant, if not even more. And incremental dialysis for those who need to start dialysis, but also less dialysis and more emphasis on low protein diet and plant dominant diet on non-dialysis days. And in summary, there is an urgent need to pursue more conservative and kidney preserving therapy for CKD using nutrition and diet in order to prolong and preserve kidneys and patients. Acknowledging colleagues from University of California in UCLA, UC Irvine, and also appreciation and acknowledgement of International Federation of Kidney Foundation, World Kidney Alliance, and World Kidney Day. And this is my Twitter, Facebook, LinkedIn at Cam Kallenthal. Thank you very much.
Thank you.
Thank you. Thank you, Dr. Cam, for an outstanding comprehensive deliberation on Plado diets in CKD. I think it was such a joy to hear your journey towards Plado diet. And I only wish to add 2 points here. One is that you spoke about preservation, slow down and prevent complication. I want to add one more word: prior to preserve, prevent. And that's precisely what we discussed in our previous session with Dr. Meyer. And preventing a patient from entering into CKD by early detection of microalbuminuria is something I think which should also come in the radar of our CKD management, because there is a lot which we can contribute by intervening early and preventing a patient from a microalbuminuria state to macro. That was point one. The second is, sir, I think Plado diets are very, very relevant in a country like India, wherein we are a plant-based population. And, if we are looking at plant-based diets in CKD management, I think it's a very, very welcome step. And if you look at the Eat Right India movement, which we are engaged in the last couple of years, we are talking about eat right, eat safe, and eat sustainable. So I think somewhere that sustainability and plant proteins go together. And you very rightly said that we need more Indian-specific data, which can be developed, which can be documented, published. And on behalf of Indian Dietetic Association, we extend our full cooperation to the entire team of Srnmcon to work in this space. And we are already having flagship master's program where students are specializing in renal nutrition. And I think we are doing some credible work with Dr. Bharat Shah. So what I'm saying is that this is a space where we need to generate Indian-specific data, especially in the role of plant proteins in the management of CKD. Thank you very much for wonderful session and wonderful deliberation.
Can I say something first of all, thank you. This is such a great honor and pleasure for me to be again connected with colleagues in India. I wish I were there in person. Now, since I've been frequently in South India and also in a few times in North and in Calcutta, it's not quite. Many, based on which part of India you go, there is a more dominating or more vegan, vegetarian dominating culture, but not everywhere. For example, Dr. Nayak kindly invited us in Hyderabad, and this famous Paradise Biryani restaurant, which was amazing. It wasn't easy to say that, hey, I want one without meat and chicken, if you remember Dr. Nayak. So that means it's good not to take it for granted that everywhere in India that culture exists. Also, the other question is, what is the best type of plant-based diet? That means this is now the job of Indian college to tell us which one we should use based on the research coming from colleagues in India that could help with which type of kidney disease. For instance, IgA nephropathy, people who have IgA nephropathy ask me, we are trying to come up with a gluten-free plant-based diet, right? Or for polycystic kidney disease, now some colleagues have data about ketogenic diet, but we are working with them on a plant-based ketogenic diet, right? So there's so many great things we can do and so many opportunities.
Yeah, Cam, I think I need to put the KDOKI guidelines, which came up recently. They did not give a very high level of evidence that plant-based diets are good for retarding progression of kidney disease. But I should put in a caveat here that their data had a hard stop in 2016. Anything published after 2016 by the KDOKI guidelines did not take into consideration. And CAM, along with the International Society of Renal Nutrition came up with a rejoinder to that, because most of the studies which have confirmed that Plado diet works for CKD came after 2016. And if you remember, even the vegetarian diet study by Liliana Garnieta came end of 2016. These were not factored in. So I think CAM led the movement against the low recommendation for vegetarian diet or Plado diet. And that is one thing that has to be very seriously considered, and a renewed guidelines should come out which recommends Plado diet. And I think we as Indians should use this as the fulcrum of what you call retarding progression of CKD. We are a plant-based country, so we have to do that. And the third important point was hyperkalemia, which was the session just before Cam entered into the meeting. He has addressed it partly. So I think these are three important issues I wanted to make, where hyperkalemia is not a big issue with Plado diet because it increases gut motility and it does not allow the intestines to absorb the potassium in the diet in a Plado diet. Whereas in a meat-based diet, the transit time is about 50 to 60 hours. A lot of time for potassium to be absorbed. So there's more hyperkalemia possibility there because of that. So these are three important issues. And I think we have some questions. Jagmeet, thank you for joining. Yeah,
I'll just take these questions which are here. So there is a question, Dr. Cam. It says, what are the long-term outcomes of Plado? And should Plado be made universal diet for people of all ages? Do outcomes of Plado differ in growing children and aging adults? Not limiting Plado to CKD alone?
Yeah, very good question, because now I'm going to add even more to the challenge. Sometimes I have seen in Los Angeles, you have bodyguards, Hollywood bodyguard people, and these are muscular people who some of them, they have been taking 150 to 250 grams of protein a day. That means this is their business. They have a career out of this. And sadly, they come to see me because they have proteinuria, increased creatinine, FSGS, and it breaks my heart. Middle-aged men, highly muscular, some of them sadly are on dialysis. We are now referring to that as high protein nephropathy. And for these people, I can't just, sometimes when I tell them you need to go to 0.6 to 0.8, they think I'm crazy. So I have to calculate and adjust for them. So instead of 300 grams of protein, I say that, hey, I need to adjust how much, I need to calculate how much protein you make, how much protein you require. And for you, it's not 0.6 to 0.8. Maybe for this person, for a muscle building professional athlete, is maybe 1 to 1.2, 1.2, 1.4, right? So you individualize. Now, your question about children is the same. Based on a child being at which phase? Is it during puberty or during the excess important growth so that we don't cause any problem for them? So this is room now for precision medicine. And same also with Play-Doh. As I said, right now we say Play-Doh 1, which is 50% to 75% plant, and Play-Doh 2, which is about 75%. And then the gluten-free Play-Doh, maybe if it's useful for IgA nephropathy based on gluten-free data, right? Or more vegetarian oil-based Play-Doh for polycystic kidney disease. So these are all opportunities for us to come up, but and to also, this is the answer to colleagues who say that, look, you're coming up with one size fit all. We're going to say, no, this is a base for a lot of precision medicine related adjustments.
Right. I think there is another question that are there any clinical trials comparing various diets like Mediterranean diet, Plado, DASH, VLPD on GFR?
Yeah, I wish there were. Actually, even for hypertension. I mean, DASH was created by amazing colleague, Dr. Larry Appel in Baltimore Hopkins some 30 years ago. and he's retiring. And most of the DASH data are in hypertension, if you remember, and some of them by secondarily coming also related to CKD. So we don't have a lot of data. We don't even have, there are some head-to-head comparisons of DASH versus others for hypertension. For CKD, sadly, it's been now 25, 30 years ever since MDRSA was negative, that essentially they told us diet doesn't work and just start them on dialysis early, and that's all we need to do. So therefore, India and some Southeast Asian countries were the last resorts, and where you guys harbored this culture of lifestyle, and now it's coming back to the Western countries. So we don't have data. This is where, as Dr. Naik says, it's just has been only 3 to 4 years that it's a return of those data back to nephrology literature. So a long way to go, but we're going to try our best.
Yeah, I think Cam, let me say that our dietitians should take the initiative, Jagmeet, and because we are ideally placed. If you know, keto analogs are still not FDA approved in America, and that is because of the MDRD study, which has still the damage is ongoing. But we are ideally placed to compare all the Mediterranean diet, the Plateau diet, the DASH, BLPD, and all of them. I think we should present this data at the 2024 International Society of Renal Nutrition, ICRNM, which is happening in Hyderabad. We should come up with the data. And I think CAM is going to help us in every which way possible so that we come up with very constructive data, which is very pro-Indian population. The world is waiting to come to Hyderabad for this meeting because they want to learn a lot about Indian diet. I think, and I think I would exhort the dietitians of India, the renal dietitians, to take the initiative and do this study.
Thank you.
One quick question, Cam. We were talking of reducing dialysis or managing with twice a week, and dialysis population, we always talk of high protein diet. So how do you kind of reconcile with the idea of managing with less dialysis and high protein diet in a dialysis population?
Yeah, actually, that's a good question. That means should we liberalize more protein on dialysis days, right? Immediately before dialysis and after dialysis, during dialysis, eating during dialysis, which I saw, for example, in Chennai, a nice dialysis center, it even had its own kitchen with good food. So the answer is yes. On dialysis days, these patients need more. And also similar to that, when a CKD patient has AKI, this is where I say that, hey, we're going to, for now, suspend for a few days or weeks, maybe, low protein diet until the AKI and CKD goes away. So these are all great questions, and we look forward to more data and research until we meet again in Hyderabad in 2024.
24. But anyway, we can go on and on with Dr. Cam Kalantar. Time is running out and I have to be on time. And therefore, we must thank Dr. Cam from the bottom of our heart. And I must put it on record, my co-chairman, Dr. Arun Shah, has been kind enough to talk to Cam and get him here today. And I really thank Arun for giving us such a wonderful session. And thanks, Cam, and thanks the chairperson.
Thank you very much. Thank you, Dr. Shah. Have a nice day.
Thank you. It was a wonderful opportunity to hear you.
Thank you.
Over to Akash. Yeah.
Thank you, sir. It was an honor to hear Dr. Kalantar talk, and thank you to the chairperson for their amazing inputs. As much as we would have wanted to continue, we now have to move on and to our next session. Again, there'll be two parallel sessions, one in Hall A and Hall B. Both these sessions are pretty amazing. The first one in Hall A deals with obesity, and Hall B deals with negotiating issues in post-kidney transplant. And moving on, in Hall A, I would invite the next set of chairpersons, Dr. Krishna Penmatsa. He's consultant nephrologist at Indus Hospital, Vishakhapatnam. Dr. Arpita Roy Chaudhary, professor, Department of Nephrology, Institute of Postgraduate Medical Education and Research at Kolkata. And Dr. Niti Desai, consultant nutritionist practicing in South Mumbai, attached to Kambala Hill Hospital. I welcome you all, and I please request you to invite and introduce the speaker. Thank you.
Sir, please unmute, sir. You're muted.
Thank you, Akash. Thank you for your kind introduction. So now we have a $1 million, if not a $1 billion question of as to why do we actually get fat? So there are so many things which are dependent on this question. So let us ask Dr. Siddharth to just give his insights on this topic. It's quite interesting. Thank you.
Yeah. May I offer a single sentence? Yeah.
Please, ma'am. Please,
Good evening.
please.
Good evening. Good morning. And Kolkata greets with a nice autumn morning today. And I'm inviting all to the happy happenings in the coming Durga Puja. And thank you, Srnmcon organizers, for inviting us in a virtual session. At least virtually enjoy Durga Puja. I'm inviting all on a nice autumn morning. And special thanks to Dr. Khanna and Akash for organizing such a good conference. And I'm so happy to see the obesity session, the chronic lifestyle diseases we are acquiring, the cardiometabolic renal continuum is nicely connected to obesity, and we need to address it from the very childhood. We were doing a school children survey and found alarming obesity even in the early age, which you all, I agree, will be putting a lot of problem to the upsurging metabolic diseases. Now we'll be happy to listen to the session talks and enjoy it.
Can you introduce the speaker?
He's Dr. Krishna is already.
Of course, I find, okay.
Yes.
Okay, Krishna, take please.
No, he's already introduced us. Siddharth, if you can.
Okay, Siddharth, you can start.
Hello, everyone. I'm Dr. Siddharth Warrior. I'm a neurologist from Mumbai, and it is an honor and a privilege to be part of this conference. I would like to thank Dr. Khanna for inviting me and Akash for conducting a wonderful conference so far. Everything has been on time, and I hope that my talk continues that tradition. Obesity is the current pandemic that we have been facing for quite a while, and no specialty is spared. From nephrology perspective, we've been hearing about how obesity can affect kidney diseases, and from the brain's perspective, all of my neurological problems have been associated with obesity, including migraine, stroke, even Parkinson's patients. In every area, obesity plays a role. Our understanding of obesity has been continuously evolving, and the science of obesity involves many subspecialties. It involves diet, it involves metabolism, it involves nutrition. But one primary aspect of obesity is human behavior. So that is what I'm going to do today. I'm going to use neuroscience to explore human behavior and the role that it plays in obesity. If I can just share my screen, I'll just start the presentation. Right. I hope that the screen is visible to everybody, and we can begin. Obesity starts with human behavior, and then it involves all the other specialties that I mentioned. So let's start with this. Let's start with an image of something that can trigger certain changes in your brain. If you imagine this cake in front of you, what is going on through your brain? What are the changes occurring through your nervous system right now that will eventually lead you to wanting to eat this cake? If you are not into cakes, perhaps this might be something more to your taste. Imagine biting into this pani puri and imagine the feeling that you might get. There are already chemical changes happening in your brain between a conversation between your brain and your stomach that will ultimately lead you to eating this. So the question that we have to ask is, to eat or not to eat? Who decides this action? I want to introduce you to the first main player of today's conversation, which is the hypothalamus. The hypothalamus is in the central driving seat in the brain that decides all your primary actions, whether it is eating, whether it is sleeping. Hypothalamus has the ultimate say in all your primary human behaviors. It is located in the center. It is located right below the cerebrum. It is located right above the pituitary gland, which is the master gland for all hormones. and right below the thalamus, which contains all the sensory inputs. The hypothalamus is closely connected to every part of the brain, and every single connection tells us a different story about our relationship with food. So if you go a little deeper, with the hypothalamus being highlighted by the red circle, every connection that the hypothalamus has talks about a different aspect. The orbitofrontal cortex, it is part of the frontal lobe. And this is the area that is responsible for telling us if this is the right time or place to do something. So if I were to give you a cake, is this the right time or place to eat this cake? The insula tells you about your own body's physiological state. If you are very hungry, you might feel that the cake should be eaten. If you've just had a 7-course meal, that cake might not be so appealing to you. The insula is responsible for telling you about your own body's physiological state. The cingulate cortex has a very interesting job. It has the job of resolving any conflict. So you might be somebody who loves to eat cake, but unfortunately, your wife or your husband is insisting that you diet. Now there is a conflict here. The cingulate cortex has to resolve this conflict. The thalamus has all the sensory inputs. So the thalamus is the part of the brain that tells the hypothalamus what it is seeing, what it is feeling, what it is hearing. So if you hear the description of a cake, if you see the cake, all that sensory input is reaching the hypothalamus through the thalamus. The temporal lobe has the job of storing memories, and it also has the job of controlling the emotions through something called as the limbic system. So the emotions that you feel when you think of a cake, the last time you had the cake, maybe it was at your birthday, maybe you were feeling very happy at that time. All those memories will come back through the temporal lobe. And finally, the brainstem is where your primary basic control of your body is taking place. So your heartbeat, your breathing, all of that is controlled by the brainstem, and the hypothalamus has a direct connection to this. Another role that the brainstem plays is in the autonomic nervous system, and an important nerve called as vagus nerve. So this is the overview of how the hypothalamus is connected to every part of the brain in context with eating. Now, we have to go a little deeper into the hypothalamus to truly understand the neuroscience of obesity. The hypothalamus contains different nuclei. We are not going to talk about all of them, but there are some nuclei which are important, which is the ventromedial nucleus and an arcuate nucleus. What is the role of this? The arcuate nucleus is in the absolute center. Right lateral to it is the ventromedial, and further lateral to it is the lateral hypothalamic area. These are the 3 areas in the hypothalamus that has the maximum role in deciding whether you eat or not. So finally, to eat or not to eat. The arcuate nucleus contains orexigenic and anorexigenic neurons. Orexis is Latin for appetite or Greek for desire. So orexigenic neurons will encourage you to eat. Anorexigenic neurons will tell you don't eat. In the hypothalamus, the ventromedial hypothalamus is the part that tells you you are full, you don't need to eat anymore. The lateral hypothalamus tells you eat more. These 2 areas will come together to decide your eating behaviors. So this is how the brain decides whether to eat or not. Does the gut have a vote? Absolutely. That is where gut hormones come into the picture. The gut hormones is what your tummy is telling your brain. So it is a conversation between your brain and your gut. The first hormone that we will talk about is ghrelin. Ghrelin is released by the cells in the stomach. Ghrelin also causes the stomach to prepare for food. So when the stomach is empty, ghrelin is released. It goes up to the brain. It tells the brain that, listen, my stomach is empty. You need to start getting hungry. You have to seek food. This is a very primitive impulse way before human beings evolved. Even in animals, this primitive response has been designed for food seeking behavior. If an animal doesn't seek food, it will die. So ghrelin has a primary evolutionary role to play. And as soon as you start eating, so suppose there's a burger in your tummy right now, the stomach stretches. The stretching of the stomach because of food stops the release of ghrelin. Also, why people say that drink a lot of water if you're hungry, because sometimes that hunger is just because of ghrelin, and water will stretch the stomach, stop the release of ghrelin, and you will find that, hey, you're not that hungry anymore. The other hormone to talk about is leptin. Leptin is released by the adipose tissues in the brain, and leptin suggests to the brain that now we are okay. Now there is enough of energy stored in the body, and now you can stop eating. So this seesaw between ghrelin and leptin will decide whether you are hungry or you are satiated. So when you're hungry, there is more ghrelin, less leptin. When you're satisfied, there is less ghrelin, more leptin. This is the basic connection between ghrelin and leptin, and how these two combine to talk to the brain about eating habits. The overview is, of course, much more complicated. All of these hormones will go and talk to nucleus tractus solitarius, which is part of your brainstem, that is part of your vagus nerve neurons. We spoke about ghrelin, which talks to the brainstem through vagus nerve. We spoke about leptin, which comes from your adipose tissue. The other important hormones that come out is from the pancreas, which is pancreatic polypeptide, amylin, and insulin. And from your GI tract, which is peptide YY, cholecystokinin, GLP-1, and oxyntomodulin. All these different hormones go up to the brain and talk to the brain to decide appetitive behavior. Leptin reduces hunger, PPY, CCK, GLP reduces food intake, ghrelin increases food intake. The end result of the brain-gut conversation is that you are hungry. Now, neuroscience of hunger is essentially trying to answer the question, are we eating to live or are we living to eat? What is the difference? There are two main pathways of eating behavior. One is the homeostatic pathway and one is the reward pathway or the hedonic pathway. The homeostatic pathway is easy to understand. We eat to live. We eat so that we have enough energy to perform our tasks. Our body decides what is our energy storage and what is the energy requirement that we have, and accordingly decides that we need to eat so much. Here, the hypothalamus plays an important role, the ventromedial hypothalamus, leptin, ghrelin, cortisol, which comes from your adrenal gland that decides your stress levels. All of these come together to decide the homeostatic pathway. But the truth is that most of us eat for pleasure. We eat because we like to eat. We like the taste of food. This is where the reward pathway comes in. And the reason that this is so important is because evolutionarily, the brain does not take chances. Something as important as eating cannot be left to chance. We have to make sure that every species and every organism keeps looking for food. The only way to do this is to bribe itself, which is the bribe in the brain is called as dopamine. Every time the brain wants you to do something that is evolutionarily good, it rewards that action with dopamine. Dopamine goes and acts on an area in the limbic system called as nucleus accumbens. And nucleus accumbens is the area that is involved with pleasure, with feeling good. So if you bite into that cake or you bite into that pani puri, the pleasure that you get is because of dopamine hitting that nucleus accumbens spot. Unfortunately, this is also involved in addiction. So whenever you find yourself unable to stop eating, or you get that 2 a.m. craving for that cookie or that piece of cake in the ice in the fridge, the reason is that there is an addiction pathway getting activated with dopamine insisting on hitting that nucleus accumbens area. So these two pathways come together to decide as human beings whether we live to eat or we eat to live. The overview of the homeostatic and the hedonic pathways, when I showed you the picture of the cake, or when I described the cake to you, the smell, the sight, the taste, the imagination, the social context, all of this comes together to decide your personality, whether you like to eat something or not. So when you say that I like Chinese food, that has nothing to do with homeostasis. That has everything to do with your hedonic pathway. The hormones involved are opioids, dopamine, And this directly influences the cortex, your personality, your limbic system, that is your emotions, and your nucleus accumbens, which is your pleasure center. The homeostatic pathway has everything to do with energy depletion. It involves insulin and leptin, and this involves the hypothalamus and brainstem. All of this comes together to finally decide what kind of food you go out to eat, what kind of food you consume, and ultimately how you metabolize it. The overview of this whole system comes down to sensory cues and food thoughts, ultimately leading to the appetitive system. What makes you want to eat? What turns your attention? What controls your motivation? And finally, what controls your feeding behavior? Now, obesity is a vicious cycle. The more you eat, the more you want to eat. The reason for this is that when there is an energy imbalance, so you are eating more and expending energy less, it ultimately leads to more adipocytes, more weight gain, more leptin. Leptin is supposed to tell your brain to stop eating. But unfortunately, something called as leptin resistance comes into play, where the hypothalamus simply stops listening to leptin anymore. So now the hypothalamus thinks that there is not enough leptin. That means that you are not fully satiated. So that means that you should keep eating more and more. And so there is a release of neurotransmitters, and that cycle continues. We cannot talk of neuroscience of obesity without first talking about the neuroscience of cognition. The reason for this is that the most important power of the human brain is its ability to learn. When we start to learn anything, we are basically talking of neuroplasticity. So when two synapses come together to learn something new, the strength between those synapses keeps increasing. And this is neuroplasticity. We form new synapses and that connection keeps improving. The way this works is addition of newer receptors in the synapse. And one of the most important receptors that gets added is a receptor called as NMDA. Now, NMDA is one of the glutamate receptors. It reduces with age, and reducing NMDA receptors leads to memory loss and inability to learn new skills. The way NMDA works is that as you keep on learning, the reason we say practice makes man perfect is because as we keep on practicing, more and more NMDA receptors keep getting added and that synapse gets stronger. There is a Hebbian synapse, which is neurons that fire together, wire together. So the more you do two actions together, it forms a habit. Why is this important in obesity? One of the most important hormones in neuroplasticity is BDNF, which is brain-derived neurotrophic factor. And this is key in helping NMDA get inserted into the synapse. And leptin and ghrelin and all the gut hormones have an important role to play in BDNF production and BDNF utilization. So leptin elevates BDNF, so which means that leptin actually increases plasticity. Leptin helps you learn better. But when there is leptin resistance, which happens in obesity, the reverse actions happen. Leptin resistance is associated with impaired learning, poorer memory, and there is also a role in depression. Ghrelin also plays an important role. There is rapid reorganization of synaptic terminals in hypothalamus, and ghrelin also promotes LTP. So in obesity, when there is a mix-up or when there's an imbalance of the ghrelin-leptin ratio and there is leptin resistance, that has a direct effect in cognition. What is the brain-gut axis? It is a conversation from the gut to the brain and back. There is an effect of food on cognition. It starts even before you start to eat. The recollection of food alters emotional state of the brain. Ingestion can trigger insulin, GLP-1, it reaches hypothalamus, hippocampus, promotes synaptic plasticity. Lack of food can trigger ghrelin, which also supports synaptic plasticity. And this is one of the main reasons why fasting is recommended, because it increases ghrelin and it reduces leptin resistance. Insulin-like growth factor also has an important role to play. And vagus is the connection between gut to brain and back. Now, we have already covered cognition, emotions, hypothalamus, and gut hormones. One important aspect here is the HPA, that is hypothalamo-pituitary adrenal axis, and the immune system. This is the holy trinity of our human behavior. which is the connection between brain, gut, and the immune system. The reason that this is important is because these are the three gateways to the body. The brain deals with outside stimulus, gut deals with outside food, and the immune system deals with outside microbes. All of them take outside information, deal with it, and it trains us how to deal with our environment. All three have defense mechanisms, and it is the Army, Navy, and Air Force of our human body. Unfortunately, all three can fail, and if one can fail, the others will fail eventually, because one system cannot fail in isolation. Overstimulation of one causes overstimulation of the others. So overstimulation of the brain is what we call as stress or anxiety. That leads to overstimulation of the immune system, which is called as inflammation, and overstimulation of the gut, which leads to obesity. This is why obesity is so closely related to stress and inflammation, and the connection between all of this is what we call as metabolic syndrome, which leads to diabetes, hypertension, stroke, cardiovascular events. All of this comes under this paradigm. I hope that I've kept the conversation in time, and I hope that you all enjoyed it. Thank you so much for giving me this opportunity.
Thank you, Dr. Siddharth, for an insightful talk and breaking down the science. I hope that newer research will look into this basics and help us tackle this obesity pandemic. Thank you.
Thank you so much.
One question. Should I put it at the end or now?
If the question is to me, you can ask me right now.
Yes.
Yeah, right now, because that is.
Okay, Sid, it's a nice question, a nice talk. Everything made easy. How we can modify our leptin resistance? That is the key thing that perpetuates obesity.
Yes, absolutely. So deprivation of leptin is the only way, one of the main ways. So dieting has to be a key cornerstone in tackling leptin resistance. So the reason leptin resistance happens is because of overstimulation of the hypothalamus. So we have to reduce leptin, and the way to do this is through either through intermittent fasting or through reducing energy intake.
So it's all behavioral intervention.
Behavioral intervention plays a very important role. Yes.
Yes. Thank you. Thank you.
Thank you. Oh, thank you for sharing my YouTube channel. That's very kind.
Right. Just a comment here. Talk, Dr. Siddharth. I think for as dietitians, the takeaway is that it's not only about the calories and the carbohydrate and the protein counting. The numbers are important, but that's not the be all and end all for treatment for obesity. Behavioral management, in the absence of having pharmacological agents to manage leptin and ghrelin, I think is a very, very important that we must consider, and it needs to be a multidisciplinary approach for obesity management.
Yes, absolutely.
Absolutely. That was a wonderful session, Siddharth, as always. I'm just sharing the screen for everybody's benefit. He has an amazing channel on YouTube with almost 40,000 subscribers with neuroscience of, how to use boredom to your benefit, how to deal with guilt. Amazing sessions over there. Quite interesting. And for your pastime, and once, I've said this yesterday, if you see once, you will be hooked and you would want to, keep coming back. And
thank you for sharing the YouTube channel too. It looks nice and we should visit it. Yeah.
Thank you. So moving on to our next session. Thanks again, Siddharth. I would like to invite the next set of chairpersons if the organizer can. Yeah. Dr. Sanjay Kumar Agarwal, Professor and Head Department of Nephrology, AIIMS, New Delhi. Dr. Pankaj Hans, Head Department of Nephrology, Reuben Memorial Hospital, Patna. And Dr. Nazreen Hussain, Chairperson Dietetics, Nutrify Today. She's the member of National Executive Committee, Indian Dietetic Association, and founder of Director Freedom Wellness Management. I welcome you all, and I invite you to introduce our next speaker.
At the outset, I must thank Dr. Umesh Khanna and his team for inviting me to this wonderful session. Without wasting time, the next speaker is Dr. Amit Langote. He is a nephrologist and transplant physician in Apollo Hospital, Navi Mumbai. He has got awards of Angel Pin Award for his contribution to patient care at the Ottawa Hospital in Canada in 2015. And the topic which he is going to speak is the obesity and the kidney. I'm sure nephrologists, although do have understanding that how obesity affects kidney in various ways, starting from producing a glomerular disease to progression of kidney disease, and then affecting the donors, and a reverse effect in the dialysis population. But I'm sure Dr. Amit will cover and enlighten us on much more complexity of obesity related with the kidney disease. Dr. Amit, please.
Good morning, everybody. Thank you, Dr. Agarwal, sir, for the kind introduction. Thank you, Srnmcon, for this opportunity to talk on obesity and kidney disease. I just wanted to confirm if my slides are visible to everybody.
Yes, visible.
Okay. So I'm going to talk about obesity and kidney today, and I've taken a slightly different approach. Instead of just talking about clinical factors, but try to get into how the pathophysiology and biology of obesity and kidney disease. We know obesity is a raging pandemic now, and WHO defines obesity as BMI more than 30, and it is responsible for a staggering 4.5 million deaths prematurely every year. Just to get into context, this is about 4 times the number of people that have died in road accident, or 5 times the number of HIV/AIDS death in 2017. And yet, when somebody has been diagnosed with obesity, really there are no ears raised, there are no red flags, because it's such a passive, ongoing background silent killer that we are not really very worried if somebody is obese. Obesity also represents one side of the double burden of malnutrition, the other side being undernutrition. And nowadays there are more obese and overweight patients compared to undernourished patients, except in sub-Saharan Africa and Asia. And it is a rapidly growing at about the rate of 30% in developing countries compared to developed countries. So it is not something that can be really neglected. When you look at the number of deaths attributed to obesity, this is a 2017 data from Global Burden of Disease published in Lancet, we see that India is doing reasonably well compared to its neighbor China in terms of death. And obviously Europe and America are still doing bad, and they are worse, more affected than India. Having said that, if you look at these trajectories of United States deaths due to obesity and Western Europe, you see that they are beginning to flatten out. Whereas of concern is China and India, which we are on the ascent as compared to the world. So while we are definitely lower in terms of death, I'm sure there will be time when we would cross this trajectory and go beyond this. In China right now, the obesity-related kidney disease is probably overtaking even diabetic-related kidney disease. And in terms of deaths in India, obesity ranks among the first 10 causes of deaths, with 5.5 or rather 500,000 deaths every year. That's quite a lot of deaths. This is a cartoon depicting the various problems that one would see with obese patients, right from the brain to the toe, with gout, stroke, heart, and almost every organ that is involved, including the kidneys. And we know that obesity and metabolic syndromes are associated with cardiovascular risk factors like diabetes, hypertension, dyslipidemia, sleep apnea, hyperuricemia, and insulin resistance. And of note, diabetes and hypertension themselves can lead to kidney disease. And when associated with obesity and pandemic, they confer a higher risk of CKD in obese individuals. So let's look at how and to what extent lifestyle changes have affected epidemiology of kidney disease. We all know that reduction in agrarian diet and increase in calorie-dense processed industry food, along with reduction in physical activity, increased consumption of smoking, alcohol, and all such kind of lifestyle changes has led to increase in obesity and incidence of diabetes and hypertension. Each of these individually can lead to kidney disease. However, in addition, when you develop sleep apnea or cardiovascular diseases, this CKD progresses rapidly to renal fibrosis and end-stage renal disease. And all of these processes are influenced by genetic and environmental factors. We know that obesity is highly prevalent, and compared to that, kidney disease in obesity is not that prevalent. It affects only a percentage of population of obese people. So that proves that obesity itself is not a sufficient risk factor for kidney disease, and there is something else that triggers to the kidney disease. Possibly low nephron numbers may lead to predisposition to obesity-related kidney disease. And when you have low nephron numbers, there is glomerulomegaly, and there has to be an increase in single nephron GFR to meet the metabolic demands of the body. And for that to happen, there is some element of dilated afferent arteriole that leads to transmission of systemic hypertension, leading to impaired autoregulation within the glomerulus and sclerosis. Obesity also leads to capillary hypertrophy and increase in capillary diameter. As a result, the terminally differentiated podocytes density starts reducing, and there is less support to the capillary wall, and these gaps start forming, through which protein leak may happen over a period of time. Now, what is the evidence that we have for direct mechanistic link between obesity and kidney disease? Obesity primarily causes kidney disease by 3 different pathways. Obesity can cause obesity-related glomerulopathy. Obesity predisposes to stone diseases, and we know that in transplants it can cause poor renal graft life. Obesity in co-association with other comorbidities like diabetes and metabolic syndromes can lead to obese kidney diseases individually and in combination with them. But this factor of inflammation is a common link between obesity and CKD, and inflammation can lead to glomerular sclerosis and tubulointerstitial atrophy by releasing of pro-inflammatory hormones like angiotensin II via adipose tissue and the kidney, and these in turn will increase response of pro-inflammatory neurohormonal response like increase in interferon alpha, interleukins, and CD4 cells, which will be more than the anti-inflammatory FOXP3 CD4 cells. And all of that leads to systemic inflammation. And this inflammation leads to an interesting concept about fat intestine kidney axis. So when this inflammation happens, it leads to gut dysbiosis because this inflammation affects various organs. Normally, there is a tissue homeostasis maintained by a coordinated response between regulatory cells and bacteria, which is maintained through good function of the liver, kidney, adipose tissue, etc. However, when this hormone is disrupted, there is inflammation, and this inflammation leads to gut dysbiosis. Gut dysbiosis causes change in the gut microbiota, which leads then to systemic response of inflammation. And this systemic response of inflammation is mediated by increase in leptin, decrease in adiponectin, and inflammatory surge. And all of this inflammatory surge further leads to inflammation in the kidneys and damage in the kidneys. We also know that the adipose tissue itself can release adipose-derived factors along with the uremic milieu of a CKD, which causes the affection of the gut microbiota, which releases inflammatory cells like cytokines, inflammatory cells like dendritic cells and macrophages, which will then affect the kidney. The kidney, in turn, conversely, also when damaged, will release inflammatory cells, which will affect the adipose tissue and cause them to release adipose-derived factors, and this will perpetuate the cycle then. Adiponectin, also adipose tissue, when adipose tissue reduces adiponectin normally, but when inflammation happens, the adiponectin is less. This leads to downregulation of the adiponectin receptor, causing decrease in the AMPK, causing increase in inflammation, and thereby podocyte food process effacement, and as we described, the clinical effects of proteinuria, glomerulomegaly, etc., etc. Gut and kidney sodium balance is also an interesting concept to note. Sodium that is consumed is sensed by the G cells in the stomach, and they cause release of L-dopa and gastrin. These are then taken up by the amino acid transporters and cause stimulation of the gastrin receptor. L-dopa is converted to dopamine, and that both of them then will stimulate the gastrin and dopamine receptors, which will lead to natriuresis. Now in obesity, this axis is disrupted, and as a result of which there is sodium retention, hypertension, and acute kidney injury. Now to put all of this in a compact diagram, we discussed obesity leading to hypertension, obesity causing hyperfiltration, hyperperfusion injury, leading to hypertrophy, proteinuria, and a chronic kidney disease. But importantly, also insulin resistance, increase in visceral adiposity, and then the inflammatory responses like reduced adiponectin, increased leptin, increased adipose renin-angiotensin-aldosterone system like angiotensin 2, and all of them again will lead to kidney disease, finally leading to glomerular sclerosis and end-stage kidney disease. Now, what are the current and future therapies for obese patients with kidney disease? The diet interventions that are being talked about and discussed are high fiber diet, because high fiber diet can promote short chain fatty acid producing bacteria, which are apparently known to reduce inflammation and reduce thereby metabolic syndrome and CKD in preclinical studies in animal models. We presume and hope that probiotics also help reduce the inflammatory response and thereby the kidney damage associated with obesity. In terms of drugs, metformin is highly studied for its antifibrotic actions in models of renal disease. It also will improve metabolic control and thereby reduce kidney disease via diabetes and its effect on the kidney. The known drugs like angiotensin receptor blockers, SGLT2 inhibitors, and even HIF inhibitor activators are being investigated for their role in prevention of obesity-related glomerulopathy. In terms of surgery, bariatric surgery is definitely recommended for people who have exhausted all means of weight reduction, are not able to lose weight, and who meet a criteria of BMI more than 35 or 40, depending on the center and the thresholds. It is important to remember that people may gain weight back even after surgery unless you address holistically the issue of weight gain and obesity. Lastly, fecal microbiota transplantation is thought of as a way to address obesity-related glomerulopathy, because twin studies have shown that in twin, one of which is obese and one of which is not obese, they find that the difference has been the microbiota within them, and therefore transplanting a microbiota from a non-obese person to obese person may thereby reduce and affect inflammation in such a way that it may reduce obesity, and that is the hope and thought behind this treatment option. At the end, we cannot forget that in our busy practices, we hardly get time to talk about a holistic approach, and it is very easy to prescribe and advise of weight loss, but just exercising and diet sometimes does not lead to weight loss, because there are so many other factors which we do not know of, and hence it is necessary to have a multidisciplinary team that can help your patients lose weight. And always forget, prevention is the best treatment, and maybe it should start right in the childhood by preventing childhood obesity. There are certain knowledge gaps that remain in our understanding of the link between obesity and kidney disease, and I will just enumerate a few. We know of the obesity paradox, where obesity is associated with worse cardiovascular outcome in normal people, but somehow it is apparently causing better outcomes in dialysis patients. And we really don't know how that happens, except the inflammatory part, and maybe eating well reduces the malnutrition inflammation complex, and therefore maybe it helps. We need to identify factors that most strongly influence renal function in the setting of obesity. We do not know if it is the BMI, actual BMI, or there is a range of BMI that is more predisposed to obesity, and work needs to be done to understand that. We need to better understand the metabolic alterations that occur in the gut microbiota of patients with CKD, and the probiotics is a work in that regards. But unless we really know if it is a particular enterotype in CKD that is more predisposed versus others, that is a limitation currently there. And lastly, genetic contributions cannot be neglected. We know of obesity runs in families, But even if people stay different from the same family, they still end up being obese. So we do not know how that happens despite living differently and eating differently. So somewhere along, we need to understand our genetic response to calorie intake. Maybe that is what is altered, and that could help us identify high-risk patients and start preventive therapies in them very early. With that, I would end my talk, and happy to discuss any questions.
Thank you, Dr. Amit, for discussing the various pathogenic aspects. Before I hand over to carry forward to Dr. Pankaj and other chairperson, I just want to ask a question that if the obesity paradox is in the dialysis population, should one consciously try to make the patient obese during dialysis?
So that's a good question. So I can only answer what I try to do in my practice. And one thing that I've always believed is we in India are consuming very low protein compared to the Western world, as our diet is predominantly vegetarian. And for one, I have never asked my patients to stop eating anything once on dialysis, except salt, sugar, and water, which obviously needs to be controlled. And most of the times with good and adequate dialysis, I have rarely even needed too much of phosphate binders if they're able to take regular dialysis. The biggest hampering factor is inadequate dialysis, like once or twice, and then wanting to eat everything, which actually leads to more inflammation. And touchwood, I think personally, my experience has been the patients really do well if you allow them to eat, but make them understand that they need to increase the dialysis also to compensate for what they can eat. So I do believe that finding a little bit of chubby people in dialysis unit is really gets a smile on my face.
Yeah. Good to see. Okay, I will request Dr. Pankaj and Dr. Nazneen to take the session forward.
Dr. Amit, that was a fantastic lecture, and I think you very well elaborated on the fat intestine and the kidney axis. And yes, there is role of high fibers and probiotics, but like you rightly mentioned, the landscape of obesity today, we talk about 4 M's, and there are more than 40 factors which actually involve in obesity. So I think that's definitely a multidisciplinary team approach is required. And yes, during dialysis, slightly underweight patients, even when they come for diet, prescriptions do very well. So I completely endorse your point on that.
Thank you.
We don't have too many questions here as yet. Dr. Pankaj?
Dr. Pankaj, you are muted, please. Please unmute.
Hello, Dr. Amit.
Yes, sir.
I have a question to you. Yeah, my question is that nowadays we are seeing a lot of obese patients. Do you have any investigations so that we can monitor these patients, that whether they are going to develop FSGS or CKD later on or not? So which investigation we should go for monitoring such patients? And then number two, one more question in my mind is that we are seeing few transplant recipients who are too obese. Should we go for bariatric surgery in them or not?
Right. So I don't know if I touched, but poor graft function I mentioned as obesity causing poor graft function by inflammatory response modulations, and pro-inflammatory response is much more higher. And there is a downregulation of FOXP3 CD4 T cells. So that has been proposed as a role for organ rejection in obese patients. So if at least for transplant recipients, I think it will be worthwhile trying out all approaches before considering bariatric surgery before undergoing transplant, especially with BMIs more than 40, because that also starts them thinking that they cannot continue to be obese with the further ongoing steroids and other drugs that they will get, and also gets them to be a bit disciplined even before they get into the transplant phase. So certainly managing obesity and the inflammatory response pre-transplant would, I personally think, help in transplant recipients. With regards to any particular test to monitor them, I really don't know, because clinically we don't have anything except ongoing proteinuria. Having said that, obesity and in current era, obesity is also leading to earlier proteinurias, then later, like which happens with diabetic after 5 to 10 years. So clinically only proteinuria probably is something that we look at, but in terms of other tests like looking at angiotensin 2 levels and leptin levels and adiponectin levels, I don't think we have any validation as to how they are clinically helpful. I'm sure Dr. Agarwal sir may maybe have a comment on that.
No, I fully agree with you. As we are nearly coming to the end of session, I will just would like to comment on the global burden of disease. Say attributing cause of particular etiology in terms of a mortality and the daily in global burden disease is very, very complex. Their algorithm is such a complex thing that one need to really know that how they attribute, particularly like obesity, as a cause of mortality. It looks simple, but it's quite a complex process. With that, we are nearly completing our time. We will hand over session to the organizer. And thanks, organizer, for giving this opportunity to be part of this session.
Fantastic session, Dr. Amit, and thank you, organizers. Thank you, Dr. Umesh.
Thanks, everybody, for the speech.
Thank you, everyone. Thank you. There is one question. I think you addressed this, but Sukhada Bhate asks, what are your thoughts on obesity being protective for CKD-associated death? Then should we aim for weight loss or weight maintenance?
I think it was answered, right?
Yeah, it was answered. So moving to the next talk, it's a dietitian's perspective on obesity and kidney. For the next talk, I will invite my next set of chairpersons, Rishit Harwada, nephrologist from H&R Reliance Foundation Hospital, Mumbai, Radhika Milincha, registered dietitian, chief bariatric nutritionist, HOD Bariatric Nutrition Department, Lapro Obeso Center, Pune, Lilavati Hospital, and Hinduja Hospital, Mumbai, and Dr. Varun Bansal, consultant nephrologist, Karuna Hospital. As a practitioner myself, I use a lot of personal experience in guiding my patients. I've tried GM diet, keto diet, all sorts of diets, and I've managed to lose weight, but I don't know what to prescribe to my patients. And I would look forward to this session eagerly and try and hopefully learn a lot out of this. Thank you.
Can the chairperson introduce Caroline?
Thank you, Dr. Akash, for the kind introduction. At the outset, I would like to thank Dr. Umesh Khanna sir and the entire team of Srnmcon for organizing such a wonderful conference. So in the previous two lectures, we have seen Dr. Siddharth and Dr. Amit highlighting the science of obesity and the effect of obesity on kidney health. So in the next lecture, we have Dr. Caroline Remedios. She is an accredited practicing dietitian from Health Start and Dr. Mufi's Digestive Health Institute. She has received the first Nutrition Bariatric Guidelines Award. She published the first Nutrition Bariatric Guidelines and recipient of the IFSO APC Integrated Health Scholarship Award. She is also the course director for basic and advanced course in bariatric management. So over to Dr. Caroline Remedios. We look forward to hearing from you.
Hello and good morning, everybody. I will be talking about primarily how you manage patients post and pre-bariatric surgery, because that's my area of expertise. I hope you all can see my screen.
Yes, ma'am.
Yeah, perfect. Okay. So basically, Dr. Amit Langote already spoke about obesity and CKD, so I'm not going to go into that. But in practice, we've seen that bariatric surgery does help to improve metabolic syndrome and also to a large extent helps reduce comorbid conditions that enhance the progression of kidney disease. We've also seen that with bariatric surgery and weight loss, it also improves patients' chances of being on the kidney transplant list. And in obese transplant patients, it may also reduce the obesity risk factors that include sort of graft dysfunction. However, I must confess that Managing CKD patients post and pre-bariatric surgery is probably every nutritionist's nightmare, and we draw upon a lot of experience and clinical judgment to manage these patients. And until very recently, there haven't been guidelines to help us sort of navigate through with these patients. But there has been a recent set of guidelines, or rather a review paper that was published late last year, that sort of just gives you perspective in terms of how you can manage these patients. Starting from the pre-operative evaluation, I think is very important, number one, for us to get baseline biochemistry, because this will help us manage the nutritional status of patients, not only in the preoperative diet phase, but also help us manage their nutritional status post-operatively. It will help us manage and calculate calorie requirements so that we're not sort of looking at malnutrition or protein energy wasting. Very important, especially for dietitians in the field, to understand that we have to make sure we calculate weight, but make sure we record weight that is dry weight or edema-free weight, because that can be can make your calculations go askew. And though we don't really have a single strategy to assess the malnutrition in these patients, just the global subjective global assessment is probably good enough to understand where your patient stands in terms of malnutrition and wasting, even before getting them on for bariatric surgery. Before bariatric surgery, all patients are meant to undergo a compulsory diet in order to shrink the size of the liver, so that the surgery is easier, causes less complications, and also is easier for the surgeon to access the stomach. This diet primarily is a high protein diet, a liquid diet, and very low in calories. However, when you have a patient that is suffering from CKD, it is important to adjust your protein levels, and about 0.6 to 1 gram per kg ideal body weight is good enough to manage these patients preoperatively. And I think the important thing in this case is to avoid unnecessary restriction, or to be too restrictive, because that is again going to reduce your lean body mass. Potassium restriction only required if there is any sort of electrolyte imbalance, otherwise not to sort of be overly restrictive in that. Sodium restriction only in the case of edema, and working with your nephrologist to understand fluid restrictions if at all anything is required. Now, post-operatively, there are a few considerations as well. Please understand that post-bariatric surgery, intake, appetite drops drastically. The initial post-op phase is very difficult for patients to manage overall nutrition, because there's a lot of food aversions. There is a physical restriction of food intake because of the smaller stomach size. Appetite drops down drastically because of the changes in a lot of the hormones. And it takes patients at least a good 3 to 6 months to adjust to the new stomach and adjust to eating patterns and understanding what they can and cannot tolerate post bariatric surgery. Now, given that you have a patient that's already suffering from CKD, you want to make sure that you're managing their protein levels well enough, because all patients post-bariatric surgery are given a protein-forward diet. We do rely a lot on nutritional supplements, especially protein supplements, to manage their protein intake because of the drop in appetite and drop in intake as well. And most patients that do not have kidney disease also struggle to meet those requirements because of the nature of the surgery, and especially in the immediate post-op phase. And that's why we calculate their protein requirements at least from 1 to 1.5 grams per kg ideal body weight. And therefore, in patients that are clinically stable that are suffering from kidney disease, it is best not to over-restrict and manage at least about 0.8 to 1 gram per kg ideal body weight, primarily from high biological value proteins, and definitely rely on protein supplements to meet these requirements, because it's going to be very difficult to meet their protein requirements just via dietary intervention. Fluid intake again is very important and something that has to be taken very seriously because of in the immediate post-op phase, there is that mechanical limitation to take in liquids. A lot of patients in the early post-op phase experience what we know as water intolerance, or they don't like the taste of water, or because of the size of the stomach, they're not able to eat and drink at the same time. So water intake does get hampered drastically, and that could lead to dehydration. And in addition, there is also cases of vomiting and nausea in the initial post-op phase because they're getting used to the stomach, and that can also cause dehydration. And therefore very important to manage the fluid intake post-op, not only for patients suffering from CKD, but otherwise as well. So until and unless there is actual need for fluid restriction, make sure that your patients are getting at least about 1 to 1.5 liters of water a day, which might actually be quite a bit of a struggle for patients in the initial post-op phase, at least within the first month, because they can barely take about 30 to 40 to maximum about 80 ml at a time. So it has to be a constant reinforcement so that you don't reach a phase where your patient is dehydrated. Calcium and vitamin D, we do supplement all patients post bariatric surgery with calcium and vitamin D. Depending on the type of procedure, the dosage does change. So it would range from about 1,000 to 1,500 mg of calcium per day, from supplements, from food sources, everything together, and of course, even vitamin D3. Now, given patients that are suffering from CKD, they do have an increased risk of fractures. There's a decreased production and conversion of vitamin D to an active form, and also that hampers your calcium absorption. But we also have to make sure that we don't give them an excess of calcium in order to avoid hyperkalemia, and also to make sure there is no calcification, and therefore a slightly lower dose, maybe around 800 to 1,000 mg from all food sources would suffice. Most of our patients, whether they are suffering from CKD or not, do come in with extremely low vitamin D3 levels, and this we catch in the preoperative phase as well, when we check their baseline biochemistry. And most often than not, we have to sort of give them a very strong dose of vitamin D in order to boost up their levels. And given the fact that the patients suffering from CKD do have a higher risk of fractures, we would need to make sure that the vitamin D3 levels are at least around that 30 range, because we do see patients who come in with vitamin D levels with as low as 5 and 6, which is quite difficult to manage with only oral supplementation. So we do prescribe intramuscular injections as and when required, maybe on a fortnightly or on a monthly basis, in order to just boost that levels up, and then manage them with an oral vitamin D supplementation to keep those levels at an optimal rate throughout. Phosphate, until and unless it is really required, we don't have to add on another set of restrictions for patients suffering from CKD. And I think the easiest way to manage phosphate levels is to make sure that patients are avoiding any foods that are highly processed, avoiding foods that have too many food additives, because that sort of has a lot of your inorganic phosphate that gets absorbed and retained in the gut. And as far as possible, try and utilize phosphate binders in accordance with what your nephrologist would guide you with. Now, sodium again is restricted in most patients that are suffering from CKD, and the levels sort of remain the same, whether it's with bariatric surgery or after. If there is no overt cardiovascular disease, then less than 3 grams per day, and if there is some sort of a heart issue, then at least about less than 2 grams a day. Of course, keep a close watch on the electrolytes to make sure you're constantly having a look at the labs and the reports in order that you don't reach a stage of hyponatremia, and obviously look at your fluid intake as well at the same time. Now, potassium, again, until and unless you actually have a case where your potassium levels are extremely high, best to avoid excess restriction, because please understand, and again reiterating that post-bariatric surgery, very, very difficult for these patients to manage their food, to manage their nutrition because of the small size of the stomach. And even, as dietitians, sometimes we try to be overly careful and overly restrictive to manage levels. But please remember that even if your patient is consuming some, potassium-rich food, it will not be in quantities that would actually raise the potassium levels that high, because quantities are extremely low post-bariatric surgery. So, for example, to give you an idea, in the immediate post-op phase, patients can barely manage a couple of spoonfuls of food at a time. That does increase to at least about, a bowl full of food, in the first 2 to 3 months, and then they eventually manage to eat approximately 50 to 60% of their original intake. But in the early post-op phase, the diet intake is extremely restricted. More often than not, they have a lot of aversions to a lot of food. So you have to sort of play around to what they can manage, what they're tolerating, and sort of hold yourself back from being overly restrictive, especially when it comes to specific nutrients. Iron again is an important nutrient that we supplement all of our patients post-operatively, and the dosage ranges depending from surgery to surgery. Overall, you would give them about 40 to 60 mg of iron post-operatively, and this can continue for patients that are suffering from CKD as well. But most often than not, these might not actually help to keep those iron levels at an optimum level. And you probably would need to administer an IV iron injection to be able to get those levels to optimal levels. And this is something, again, that you would prescribe or sort of look at after consulting your nephrologist to see whether this patient does require an IV iron to manage their levels, because iron levels do get affected quite drastically, irrespective of the type of surgery, whether you're talking about a sleeve or your bypasses or your OAGD, because of obviously the lower intake of food, but also because of the reduced amount of hydrochloric acid, because you're either resecting part of the stomach or you're bypassing part of the stomach, your iron absorption does get affected. Specific salts of iron are recommended post-bariatric surgery, so you would look at giving either your chelated forms, or either your ferrous fumarate or your ferrous glycinate, and not the routine ferrous fumarate, because it doesn't get absorbed as efficiently post-surgery as it normally does. And unfortunately, most of the iron supplements available in the market are of your ferrous fumarate sort of variety. So it's important to also check what sort of iron is available in your supplement in order that your patient actually gets the most out of that supplement. Multivitamins are prescribed for all patients, again, post-bariatric surgery, and depending on the type of the surgery, we would prescribe either your routine multivitamins, maybe about 2 or 3 tablets a day, or if you have bariatric specific multivitamins, then you adjust the dose accordingly. Your multivitamins, calcium and iron are nutrients that you would start off in the immediate post-op phase, say about 1 month post-bariatric surgery, and continue them for at least 3 to 6 months post-op, depending on the surgery. However, most of your bypass procedures require supplementation for life. So it is very essential that even patients that are suffering from CKD are given multivitamin supplementation, but because there are chances of sort of accumulation of certain fat-soluble vitamins in patients suffering from CKD, it's important to check the amounts of at least your fat-soluble in your multivitamin formulation, so that you're not exceeding levels and risking yourself of toxicity. So vitamin A is something that you want to keep a watch out on. Vitamin C, again, is something that you want to check so that you're not sort of risking, formation of calcium oxalate stones. So make sure that you have a good history of your patients so that you know whether they are at a risk of developing stones, and then look at your multivitamin formulation to check that your vitamin C doesn't exceed the routine RDA for the population, so that you don't have another problem on hand. Follow-up for these patients probably are more the post-bariatric surgery. The follow-up routine is week to 10 days post-bariatric surgery, then at 1 month, and every 3 months until they complete a year, and then an annual follow-up is required post all types of bariatric surgery. However, in this special subset of patients, you would want to have more routine follow-ups, more close monitoring, make sure you're looking at their labs more routinely than you would any routine bariatric patient, because your levels could change quite frequently, especially in the immediate post-op phase. You want to make sure you're looking out for signs of dehydration, for edema, for malnutrition. So these special set of patients will require more of your attention post-op. So it's important to identify these patients in your pre-op phase so that you know that they will require more close follow-up and monitoring, especially in the immediate post-op phase. So at least for the first 3 months, they would require more close monitoring than routine bariatric patients. So in conclusion, we do know that bariatric surgery can help with managing metabolic syndrome, but we have to remember that this special subset of patients do have specific nutrient needs, and we have to keep in mind the type of surgery that has been done and manage these patients based on individualized lab reports and not just general understanding of bariatric surgery and bariatric nutrition. We have to make sure, especially as nutritionists, to avoid unnecessary and severe restriction in order to prevent malnutrition and prevent excess loss of lean body mass. Work closely with your patients, monitor them very, very closely. And please remember that in case of all bariatric surgery and bariatric management post-operatively and pre-operatively, it is a team effort. You do need a very strong multidisciplinary team approach. You obviously will require a surgeon, but work very closely with your nephrologist, and preferably a nephrologist that does have an understanding of bariatric and has treated bariatric patients before, because your nephrologist and the nutritionist will work very closely together to manage this special subset of patients. And lastly, we definitely need more sort of data, more sort of research out there to manage these patients in the long term. Thank you very much, and I hope I've kept time.
Yes. Thank you, Caroline, for the wonderful talk. I mean, you have focused on all the points very well, for the patients after bariatric surgery and even pre-operatively. One question I would like to ask you, of course, it's a nightmare for every nutritionist to deal with patient with a kidney disease and obesity, considering a lot of challenges and restrictions for a patient, because patient with obesity always comes with many other comorbidities apart from just kidney disease as well. So my question to you is, after bariatric surgery, when a patient with some kidney disease, there is a, we all know there are transition of phases from liquids to normal diet. So I think first 3 months are very crucial and critical while we manage, and when the, especially the patient is on liquid diet. So with your experience, can you just explain what are the challenges and how do you as a nutritionist overcome those challenges?
So I think the biggest challenge post-operatively is the first month, like you rightly said. They do seem to settle after that. And I think the first month of bariatric surgery for any patient is a challenge. So when you add on that patients do have kidney disease as well, it's all the more sort of difficult to manage. But I think the biggest thing to look at, especially for nutritionists working in the field, is to make sure that your patient is not dehydrated, because that is probably the biggest thing that you have to keep in mind. Also because it's very, very difficult for patients to manage their fluid intake post-operatively. Now, before the surgery, they're on a liquid diet, which is fairly easier to manage because their appetite is there. There's no physical sort of restriction for them to take in the kind of liquid. But post-operatively, the size of the stomach reduces drastically. So when you're talking about a sleeve, you're removing out about 2/3 of the stomach portion. We're talking about a bypass, you're pretty much left with a stomach which is no bigger than the size of your thumb. So, and also then immediately post-op surgery, there is edema, there is, that amount of pain, it takes them that amount of time to adjust. Most patients have what we call as water intolerance, so they don't like the taste of water. So you have to think of innovative ways that they can make up their fluid intake. So sometimes the most simplest thing is to, ice cold water works well for some reason. This change in temperature works very well. Just changing the flavor of the water, your flavor infusions or even liquids that have a little bit of flavor and not just plain water works very well. But I think now post-bariatric surgery, most patients are discharged, post-op day 1. If you do have a high-risk patient, a patient that has a CKD and you're worried about dehydration, there's no harm in keeping your patients in the hospital for another day or two, just to make sure that they don't go home and come back with a crisis situation. I would definitely see a patient as suffering from CKD maybe at least every week or every fortnight until I'm happy that the patient is managing their intake by themselves. If they're not able to come into the clinic, definitely at least keep a check on them, either on call or video call, but they will require extremely close monitoring. So dehydration probably is my biggest fear in that first month post-operatively, definitely.
Thank you so much. Any other questions?
Thank you, Caroline, for a wonderful lucid talk. I have a couple of questions. In patients who are not opting for a bariatric surgery, are there any specific diets that you advise to your patients with CKD?
For those, I send it to my colleagues because the patient that comes to me, and because we are a center that works primarily with bariatric patients, we do get those who have already done everything and then come to us as a last resort to help them. But if you have regular patients who are not undergoing bariatric surgery, I do refer them on to my colleagues that are much more, specialized in managing these patients.
One comment here. I think I totally agree with Caroline. Of course, if the patient is many a times we as a bariatric nutritionist become a primary contact to the patient when they come into or walk into the clinic, and at that time, we should be very much aware of the benefits of bariatric surgery over kidney disease, so that we can basically guide them towards a right therapy, what I can say. But if the patient is really not undergoing a bariatric surgery, I think a renal or a renal nutritionist would be the right person to guide them throughout. I totally agree with this point.
Rishit, your comments?
We can't hear you, Rishit.
Can't hear you. Rishit, can't hear you. So till Rishit finds his voice, Caroline, you've done a wonderful job. And I think the point which you raised about stones and the preponderance of stones in these patients who have bariatric surgery and in general obese people, and in the pandemic, the excess of vitamin C, vitamin D, etc., which is on board. Yes, vitamin D is very important, but I think we have seen sometimes the other end of it, the excessive vitamin D going on. Some of the CKD patients do not handle or tolerate vitamin D higher levels to that extent compared to the normal people. So very well elucidated about the role of vitamin C and stones, etc. Rishit, you found your voice?
Thanks very much.
No, we still can't hear him. I think that was a wonderful session, sir. We have to close this here. Right. I thank Dr. Varun Bansal, Dr. Rishit, both of whom we work with closely, friends and colleagues, interact on a daily basis. Thank you, Caroline, for such an amazing talk. We have Dr. Mufazzal Lakdawala here for our next talk, and I would like to invite the next set of chairpersons to introduce her. Unfortunately, we will not be joined by Dr. Jayalal. And Dr. Hemal Shah has, is stuck in an ICU. So I would invite Dr. Umesh Khanna to chair the current session and help us move forward with the proceedings. And I invite Dr. Ritika Samada. She's the regional head, Department of Clinical Nutrition and Dietetics, Max Super Specialty Hospital, Saket.
Thanks, Akash. Who would not want to chair a session of a star speaker or a rock star like Mofi? So it's my good luck that there are some absentees and I get a chance to, be a chairman for Mufi. So Mufazzal Lakdawala, as we all know, is the director of Department of General Surgery and Minimal Access Surgical Sciences at HN Reliance Foundation Hospital, Professor Emeritus of Nair Hospital, Honorary Surgeon to the Vice President of India. And apart from getting a lot of honorable awards, achievements, he is, He's done tremendous work during the COVID pandemic also. And, his work doesn't stop at just bariatric. He's been promoting a lot of work in obesity, has trained a lot of people in bariatric surgery, and many of them I have known personally. Some of them work in our area, and they've all been trained with Mufi. So it will be great to hear from Mufi on bariatric surgery in patients with CKD. Over to you. Is he online?
He was. He's just joining. He's just connecting.
He's in the attendee list, Avinash. Please add him.
Yes, sir. Yes, sir. He's connected.
I think he needs to be upgraded. I mean, this upgradation is not the right word. He should have straight walked into the first class in any flight.
Hello, sir.
Hi. Yeah.
Good morning, everybody.
Very good morning.
It's a kind of embarrassing introduction, sir, but I'll try and live up to a little bit of it at least. So I will just start off without wasting too much time. It's always such a pleasure to come back to Srnmcon, and thanks to Hemal and the organizers for inviting me for this talk. Well, chronic kidney disease, this is like preaching to the choir, but we all know at what stages of chronic kidney disease we have, from stage 1 to stage 5, where that leads to complete kidney failure. Well, if you look at it from grading in between the EGFR versus the creatinine clearance ratio and the urine albumin, again, there are various ranges that you can have DIGO classification. And what we do as bariatric surgeons, we try and stick to this kind of KDIGO classification to try and see how well we go from there. Well, chronic kidney disease has got various fathers and people from 60-year-old to tobacco use to family history. But what I'm most interested in is that obesity appears as the only modifiable risk factor when it comes to chronic kidney disease. Obesity has along with it and gets along with it a lot of comorbidities such as diabetes, high blood pressure, and various other things. So in this funnel, when we try and put it, it probably is the best option that we might have of treating chronic kidney disease and preventing any form of kidney disease from becoming chronic. Well, again, genetics and environmental factors, we can change the environmental factors, but we can't change our genes. Lifestyle is something that we can always do something about, and diet, physical activity, cigarette smoking, alcohol consumption, that's things we can avoid. In theory, in practical life, that really does not happen. India remains the second largest country with type 2 diabetics, and as obesity, we remain number 3 in the charts, in the world charts. So we have the cocktail that it takes. If our genes are leading us to that, then it just fires the gun, and then CKD numbers increasing from renal fibrosis to end-stage renal disease. It's all. So sustained weight loss is the only problem. It's very difficult to achieve, and hence is one of the most underutilized tools for preventing end-stage renal disease. Well, in a lean man, you have the liver with various things. The adipose tissue, kidneys are usually your waste excretion and blood pressure maintenance. Your gut is mainly for absorption and producing all those various hormones. What happens when you become obese? When you become obese, there is hyperfiltration, decreased permeability, and inflammation at the kidney level. And that is where all our problems start. Again, if you look at hyperfiltration, proteinuria and hyperfiltration, this is the progress by which it goes. Mechanisms of kidney injury in the setting of obesity are various. Okay, there is glomerular autoregulation, which might be impaired, and that leads to elevated systemic blood pressures, and that could be eventually transmitted to the glomerular capillaries, leading to eventual barotrauma, leading to further worsening of continuous damage because of barotrauma. Again, in India, we have seen that patients with a BMI of more than 40 are 7 times more likely to develop end-stage renal disease than those who are with normal weight. So there is definite interaction with the increased fatty levels that you have. We do know that obesity itself is a chronic inflammatory disease, and that eventually leads to a lot of inflammation, which eventually starts damaging the kidney more and more. So what is the positive association? Well, when we look at these forest plots and we look at end-stage renal disease, we have some degree of correlation, which kind of gives us some kind of obvious connotations to where we stand. If you look at, again, the Seuss paper, so all three papers looking at end-stage renal disease. The various other ones are looking at renal cell carcinoma and other things, kidney stones. But when we look at end-stage renal disease, there's a complete positive correlation when we go on the other side of the forest plot. Well, what happens post-bariatric surgery? Not only do we lose weight, bariatric surgery improves renal function in those with hyperfiltration. Like I said, one of the main causes of CKD in obesity is hyperfiltration. It improves renal outcomes in patients with established CKD as well. So in stage 1, stage 2, as well as stage 3, stage 4, we are seeing very, very good improvements. Gut hormone responses post-operatively are seen with gastric bypass mainly, but also with sleeve gastrectomy. And that contributes to beneficial effects of bariatric surgery. The improvements in CKD that we can achieve are control of blood pressure, maybe some degree of control of glycemia, but that's with the bariatric surgery, dyslipidemia, and decreased inflammation because of decreased obesity. So does bariatric surgery really prevent deterioration of, well, this paper from King kind of shows us when it looks at UACR, UPCR, and EGFR ratios. If you look at post-bariatric, 1 year post-op, you invariably kind of get, in the Roux-en-Y gastric bypass at least, you see some degrees of improvement vis-a-vis the UACR and the EGFR rates. Small, but yes, there is improvement. Now, there you have, so though it is not completely significant, if you see that there are small changes that happen 1 year post-operatively, both in the sleeve gastrectomy group, but more so in those with the Roux-en-Y gastric bypass group. In those with BMI below 40, there is a lesser degree of improvement as compared to those with BMI above 40, where there is statistically significant improvement that comes in. So to conclude, what this paper actually said is that in obese patients, bariatric surgery improves microalbuminuria and significantly decreases UACR and UPCR. And therefore, bariatric surgery should be considered early on in the treatment of those with renal problems with obesity. Well, this paper from Imad and his Imam Tahala and his group actually shows us one thing, that if you look at sleeve gastrectomy and Roux-en-Y gastric bypass, the Roux-en-Y gastric bypass has far better longer-term weight loss. The EGFR again seems to improve better with the Roux-en-Y gastric bypass. And if you put it on a time plot with weight loss and this, there are a few differences. So if you look at 3 years, even in CKD stages 3 and 4, there's improvement in the EGFR and therefore improvement in the overall CKD status. In this paper from Fisher, again, he says that though pediatric surgery showed declines in EGFR up to 3 years after surgery, changes in EGFR track poorly with these changes in BMI. And this study proves that there is the evidence that kidney-related benefits of pediatric surgery may be at least partly independent of weight loss. And therefore, it's not only weight loss, but there must be some other factors that do control it. And that's where you see the sleeve gastrectomy and the Roux-en-Y gastric bypass, and years relative to surgery, you see a dramatic improvement in EGFR along with the drop in BMI. Now, if you were to correlate it on an average time point with the hypothesis that the study is kidney-related benefits of pediatric surgery are weight-related or not, if you see with the Roux-en-Y gastric bypass, it does show that even at 3 years, there is significant improvement in the EGFR ratios. Now, this was a study showing 2144 patients and treatment with bariatric surgery. There was improvement in CKD risk categories in a large proportion of these patients, even up to 7 years. So that paper spoke about 3 years. This is even at 7 years. It shows that there is improvement. Improvement completely changes when it comes to moderate risk, low risk, and high risk and very high risk patients. This paper from Rana Abu Murad actually speaks about how it decreases albuminuria, decreases proteinuria, and thus changes GFR. And eventually, all bariatric surgery does is it changes those focal changes of glomerular sclerosis that happen in the kidney, and thus eventually land up improving. Right? So any kind of weight loss, be it exercise, be it medication, be it bariatric surgery, we do know that bariatric surgery probably has the best results, and therefore you see the maximum amount of change in eGFR post-bariatric surgery. Now, this is again a systematic review and meta-analysis from Kunli's group, and that has all these various papers that I spoke to you all about. And what it shows is that at a confidence interval of 95% in the forest plot, when you do post-surgery, you are seeing that most studies favor an improvement in the CKD status after sustained weight loss due to bariatric surgery. This is the forest plot comparing eGFR with body surface area. And again, if you see that it's completely skewed in favor of surgery as compared to pre-surgery. This is again comparing albuminuria, again in favor of surgery. And this is comparing albuminuria with proteinuria, again favoring surgery. So improvement in eGFR, glomerular filtration rate, improvement in albuminuria, and improvement in proteinuria all favors surgery. So to conclude, what they've said is that bariatric surgery could prevent further decline in renal function by reducing all these 3 things that we do know, and y'all would know better than me, that we need to decrease the proteinuria, we need to decrease the albuminuria, and improve glomerular filtration in obese patients, and thus delay the inevitable end-stage renal disease that progresses in most obese patients. Now, in this systematic review, which was published in Obesity Surgery, if you look at the forest plot, again, it favors surgery. And these are various publications and papers all proving the same thing. This is, again, GFR. Though in this study, that if you see the CKD group and compare it to the hyperfiltration group, they say that the CKD group might not have as much dramatic improvement as compared to the hyperfiltration group. And therefore, they say that the earlier you go in, that much better chance you have in terms of remission. And if you look at all studies, comparison of all studies over here, after bariatric surgery versus control before surgery, there is much more improvement after surgery in terms of proteinuria. So to conclude, again, the same thing decreases albuminuria and proteinuria. Now, microvascular, we do know that the kidneys get affected by micro and macrovascular changes. Now, microvascular changes, you do see that even over years with those patients with diabetes, there is an improvement in decreasing the nephropathy rates. So it decreases, this is Fisher study, again, it decreases microvascular disease. And then there's overall evidence that it improves even in terms of diabetes, not only obesity, but in those with obesity and diabetes, a combination of diabesity. So this was 3,015 patients that were put in, and bariatric surgery had positive effects on their kidney function and tended to decrease normal GFR in the early CKD and tended to improve in the later stages of CKD. So these are the creatinine values before and after surgery. Again, in Bilhas, this meta-analysis. GFR, again, before and after. Now, these are the various papers, if you look at the BMR and the improvements, you will see that weight loss was achieved by surgical intervention and improved all these various other things. These are the prospective trials now looking at improvements in creat clearance ratios, proteinuria, albuminuria, eGFR, and various studies. The only problem is the numbers are far lesser, and we are in the process of running a study which will have a far larger. So we've got a cohort of almost 250 patients to be far larger than any of these cohorts. And hopefully we should be able to publish our 1-year data very, very soon. So CKD with type 2 diabetes, well, Ricardo Cohen's paper observed that macroalbuminuria precedes at least 10 to 20 years before progressive microalbuminuria, and that's when you need to act at a much, much earlier level in terms of obesity. This is again comparing all various types of bariatric surgery. If you see that Roux-en-Y gastric bypass is probably the largest in terms of what they've done, and all these papers again did show that proteinuria, albuminuria was decreased. This is a systematic review with an analysis of more than 18,000 patients, again showing improvement of albumin to creat ratio and decrease in albuminuria. What happens to the microvascular complications? Again, nephropathy, post-bariatric surgery in all these randomized clinical trials, which are all level 1A evidence in the Stampede trial, in Milrone's trial, all showed that it kind of improved. Other microvascular like retinopathy and other things, it also improved nephropathy. There was a remission of nephropathy again seen in the early stages. Up to CKD4 stage, you can see a remission of nephropathy. So I would like to end by saying that obesity is a debilitating disease, but it also affects all the kidneys. And obesity comes along with it its partners like diabetes and hypertension that affect kidney worse off. Bariatric surgery is one tool which produces sustained weight loss, and there is maybe other effects with which the gut hormones change and may affect the renal functions in ways that we are not yet aware of. But decreasing albuminuria, decreasing proteinuria, and improving eGFR should be the short and long-term goal of any CKD patient, and that's what bariatric surgery gives. Thank you so much for a patient listening.
Well, thanks, Mufi, for really highlighting the importance of bariatric surgery in cases who cannot be managed by the usual care. Just want to ask you whether the BMI at which you offer bariatric surgery to somebody who doesn't have, say, diabetes or CKD, vis-a-vis somebody who already has started having proteinuria, is it different, or you use the same criteria to offer him bariatric surgery if he has proteinuria or if he doesn't have proteinuria?
So unfortunately, so far, we've not included that as one of the criteria for bariatric surgery. We are going on BMI specific criteria. However, the DSS2 study, which is the Diabetes Surgery 2 study, has actually said that patients with diabetes and proteinuria have to be prioritized for surgery at a much lower BMI, at 27.5 and above.
So actually the question is similar. Do you prevent comorbidities and the problems and complications at an earlier stage by going for prophylactic surgery where it is indicated, vis-a-vis once people have already suffered from the complications and then undergo obesity surgery? Are the results different, or I mean, is there any comparison? Is there any literature?
So I showed you some of the studies that showed that in the hyperfiltration group, which is the early stages, there's much, much better outcomes with sustained weight loss than in stages beyond CKD4, wherein we do believe that, yes, there will be some degree of benefit, but not enough to really prevent the rapid onset of end-stage renal disease.
Ritika?
So thank you so much, Dr. Lakshmanwala. Always pleasure hearing you. And of course, he had backed his talk with a lot of studies. Of course, I would just like to comment over here that yes, in our centers also we do a lot of diabetic, and as rightly said by the doctor, that yes, long-standing diabetes with proteinuria at a lower BMI would be probably suggested for a bariatric surgery. And yes, the reason is that weight loss would help in obviously the remission for diabetes, helping in blood pressure control. That obviously has a better outcome in the renal parameters for a longer duration of time. My question to you was that, the two sets of patients. One, of course, we're talking about diabetes with CKD, where we're talking about remission and probably, delaying the onset or progression of the renal problems. The other is, of course, we do get a set of patients who are ready for transplant but are overweight. And probably, yes, the answer is that you take them for surgery, get them to a better weight before they are actually taken. So those patients are ready for a transplant, but probably delayed because we want a better results post-transplant and the rejection of the graft is much less. What is your take on that? And do we have some kind of studies or probably some kind of data for such patients?
Yes, Ritika, unfortunately, I missed out on that part, and thank you for bringing that up. But yes, there is enough of studies now that have proven that conjoint liver and kidney transplants have been performed in patients. And unfortunately, the numbers are so less that we've not really been able to say whether you should do it concomitant, you should do weight loss prior, or you should do it post the transplant surgery. But now there are fewer and fewer studies coming up which have all shown that weight loss prior to a transplant, if a patient can wait for, let's say, 6 months, is definitely better because it makes the patient a better risk profile in terms of both liver as well as kidney transplants.
We've had around 4 to 5 cases where the patients have had undergone the bariatric surgery, waited for about 6 to 9 months before they were actually taken for the transplants, and 2-3 years they're doing quite well with us. So yes, that's there. Thank you so much, and thank you for having me as a chairman. It was lovely hearing to all of you, and especially I heard Carlene's. Another question was, of course, I would like to really, and of course, I think Carlene did point out about supplementation, that generally we have this notion that probably being a renal patient post-bariatric would need higher dose of supplementation, specifically in terms of calcium and iron, because we know for sure that renal patients and vitamin D, but I think we really don't go overboard, and we just try to give them the same kind of supplementation which we give to a normal bariatric patient. So that was highlighted by Carlene, and I totally agree on that. Thank you.
What about dosing of transplant drugs after bariatric surgery?
Sorry, I couldn't get.
So that's a good question. That's a good question. I'll take that, Ritika. So I was asking, Dr. Arun Shah was basically asking, what about the drugs that you have to give post-bariatric surgery? Does it cause any form of malabsorption, I believe? So you were trying to find that out. Most bariatric surgeries we do, so we bypass only the proximal, maybe meter or meter and a half of the shortcut if you're doing a gastric bypass as well. And if you see that it hardly affects absorption. In fact, we ourselves have done studies as well as world studies have shown tacrolimus levels which are more significant in proximal foregut absorption. It does not affect it. You don't have to worry about it. And most absorptions are normal, except if you do completely malabsorptive surgeries, wherein you're bypassing almost 2/3 of the shortcut, like the BPD or the SADI or the dual switch. That's the only time you should ask your bariatric surgeon to probably avoid those kind of procedures, because that might hamper your absorption.
Thank you.
Thank you. Thank you so much. Yeah. Akash?
That was an excellent session, sir. Thank you for gracing us. It was an honor to hear you talk. And we saw a lot of studies and absolutely updated session. And we thank you again for agreeing to come and speak to this. Thank you.
Thank you. Thank you very much.
So moving on to our next session, it's a little hatke topic, and who better to give that talk than Dr. Umesh Khanna. I will invite the next set of chairpersons, Dr. Jayakumar, M. Jayakumar, Professor of Nephrology and Associate Dean, Sri Ramachandran Institute of Higher Education and Research, Chennai, Dr. Jayaprakash Oza, consultant nephrologist, Apex Hospital, Varanasi, and Dr. Meena Mehta, associate professor, retired professor, former vice president of IDA Mumbai. Over to you.
Thank you very much. At the outset, I thank the organizing committee of Srnmcon 2021, especially Dr. Umesh Khanna for making it possible to take part in this conference. The topic today is topic for the session is oral hygiene and its role in systemic diseases. If you look back in the late 19th century, the theory of focal dental infection was a friend till early 20th century, and this sepsis was considered to cause inflammatory diseases such as arthritis and all that. Therapeutic edentulation was a common entity at that time. There was no benefit, and therefore the theory was discredited and largely ignored. Recent progress in classification and identification of oral microorganisms and realization that certain microorganisms are normal inhabitant of oral cavity has led to the assessment and the importance of oral infection. And therefore, it's increasingly clear that oral cavity can act as a site of origin for dissemination of pathogenic microorganisms to distant body sites, especially in immunocompromised individuals. Having poor oral health can put patients at risk for developing CAD, dementia, bronchitis, pneumonias, cancers, uncontrolled diabetes, and so on and so forth. To give this talk, we have Professor Umesh Khanna, the Director in Kidney Associates, Consultant Nephrologist, Asian Heart Institute, Corona Hospital, Suchak Hospital. And he's the founder chairman of Mumbai Kidney Foundation, trustee of Sapiens Health Foundation, secretary of Mumbai Nephrology Group, secretary of Amar Gandhi Foundation. Over to you, Dr. Umesh Khanna.
Well, if they will allow me to share the screen.
Yes, sir. You can.
Right.
You're on screen.
Yeah. So at the outset, let me say that I am as confused as you people are about what is this topic doing in an obesity symposium. Maybe like, yeah. So maybe like, vitamin D, we are trying to blame vitamin D for all diseases from common cold to cancer. Similarly, obesity, since we don't know any reason, we are trying to find different areas where obesity cause can be found. And this red colored slide is just a warning that oral cavity is as important, not just for kidneys, but for a lot of systemic disease. And honestly, ignoring oral health leaves a bad taste in the mouth. An apple a day keeps the doctor away, but poor oral health keeps everyone away. We are all familiar with it in occasional cases when we have people taking talks to close proximity. Whether it's the oral cavity, you look at the cause or an effect, both are important. Our mouth, as we know, is a window to the manifestations of systemic disease. And oral diseases, as pointed out by the chairperson, can lead to a variety of systemic illnesses. So like we are all trying to find some nexus or some axis, we have a mouth, body connection. And as pointed out by Dr. Jayakumar, the mouth-body connection is in a variety of ways, and I'll pick up one by one. The Surgeon General reports that at least 80% of American adults have gum disease, but the impact goes far beyond the mouth. As he said, it could lead to Alzheimer's, dementia, stroke, respiratory diseases. This is understandable, because it could, the oral hygiene could be probably one of the reasons. But then Jayakumar also pointed out, and very rightly so, that people with gum disease are twice as likely to die from heart attack. So this is the connection. as we were trying to find out why in obesity. It's a very simple connection, but being obese significantly increases the risk of periodontal disease, and it's always good to scare people about the effects of any disease, that it can lead to sexual and reproductive problems. Cancer, yes, as I said, men and women with a history of gum disease are 14% more likely to develop cancer than those with healthy gums. And of course, diabetes and bleeding gums increase your risk. Osteoporosis, again, studies have shown a significant connection between periodontal disease and osteoporosis, especially in women. Arthritis, again, was pointed out by Dr. Jaikumar. In fact, most of my initial remarks have been very rightly talked about by our chairperson. And so this slide actually points out that we have problems all around due to poor dental health. But did you know that adults with tooth loss may have a higher rate of even CKD? And if you look at this World Kidney Day poster, oral symptoms are observed in 90% of patients with kidney disease. And oral signs also of advanced renal disease, we have all seen. This talk is more towards, the internists, physicians, primary care physicians, dietitians, and some of the nephrologists might find it a little basic, but we see pallor in mucosa, we can see the breath, or we can feel the breath that smells like ammonia, stomatitis, and xerostomia again is a very important area, and I will dwell on it a little bit, but there are radiographic abnormalities and possibly delayed healing. So if you take the OPG, you will see that there is demineralization of bone, tooth mobility, socket sclerosis, calcifications, and all of it has some bearing on CKD. As pointed out by Dr. Jaikumar, oral infection or periodontitis can lead to cardiovascular disease. Specifically, one has to be scared of endocarditis, and a lot of cardiologists would probably ask you for prophylaxis to be given in patients with valvular disease if they undergo a dental procedure. So oral health related quality of life in adult patients with end-stage kidney disease undergoing renal replacement therapy. This systemic review was in BMC nephrology, and the oral health related quality of life generally suffers in patients with ESRD who are on renal replacement therapy. The common orofacial problems associated with CKD are in all aspects of the mouth, periodontium, oral mucosal lesions, the bone, cortical bone, the tongue lesions, and the salivary gland. And xerostomia would be very important, and we'll come to it a little later. We've seen this, we've discussed this, that there is a bad odor, metallic taste, and all that will help in reducing the food intake. Uremic stomatitis, enlarged salivary glands, which we know part of it could be due to hypoalbuminemia or hypoproteinemia, and decreased salivary flow. And you will see later on why this xerostomia or decreased salivary flow becomes a very important area. So the outcomes of poor oral health, as pointed out by our chairperson, is it acts as a source of inflammation. It could contribute to infectious diseases. And we know a lot of infections which can start from the oral cavity, specifically the fungi. And in transplant patients, we are very, very careful of fungal infections in the mouth. It can contribute to atherosclerotic complications. And most importantly, as I mentioned, various changes in the mouth can lead to protein energy wasting. And we'll see one by one all of it. Gingivitis and periodontitis are seen more frequently in end-stage renal disease patients, and we've all seen it. Repeated anticoagulation on dialysis predisposes these patients to gingival bleeding, and again can facilitate bacterial colonization. And periodontal disease has been reported to progress in severity across all segments: pre-dialysis, peritoneal dialysis, and hemodialysis. So oral cavity care is very important. Oral hygiene is extremely important if we need to prevent that. Periodontitis may act as a potential cause of local and systemic inflammation in CKD. So that much was for inflammation. What about infections? Periodontitis represents a potential source of episodes of bacteremia, especially in transplant patients. And a study showed that 32% of end-stage renal disease patients and 11%, if you compare, 11% of healthy controls had fungal hyphae through microscopy and buccal smears. So the incidence of fungal infections much higher in end-stage renal disease. We discussed in in passing about the contribution to atherosclerotic complications. So periodontitis exhibited dyslipidemia and dysglycemia in these patients. It may represent a risk factor for atherosclerosis and thromboembolic events. The treatment of these periodontitis infections can actually reduce the incidence of coronary heart disease and could be one of the preventive strategies. You must be wondering, how does oral cavity contribute to protein energy wasting? And we know that oral diseases contribute to it in a variety of ways, but most importantly, it's dryness, pain, bad taste, hardly any interest in eating, and this may lead to anorexia and nutrient deficiencies. But again, an important area which we miss sometimes is secondary hyperparathyroidism. And I think most practicing nephrologists have seen the bone cysts in the palate of patients who have been very badly managed hyperparathyroidism and with very, very high PTH. So parathyroidism can lead to loosening of teeth, bone changes, and so on. So a possible contribution of poor oral health in uremia will be mainly to reduce nutrient intake and protein energy wasting through different means, right from uremia, having psychological issues, poor oral hygiene, drugs, xerostomia, and so on. Now, this area is important, and we do not possibly pay adequate attention to the patients who cannot eat because of dryness. And we know for sure that uremic dryness is there everywhere. It's there on the skin, vagina, oral cavity. And much of it is caused by some of the drugs which we use, especially antiemetics, antihistaminics. Some of them are on antidepressants and some antihypertensive drugs, so especially the centrally acting ones. And these can reduce the salivary flow, creating conditions as xerostomia, which may ultimately affect both satiety and diminished nutrient intake in CKD patients, eventually leading to malnutrition. And this is the list of drugs, of which I think important for us is anticholinergics, antihypertensive, neurologically acting drugs, and antihistaminics. So this is known to all of you all, that when you have a renal disease or a dialysis patient or a transplant patient and he has to go to the dentist, fortunately most dentists ask for a certificate from the nephrologist for various reasons. For dialysis patients, you need to schedule his dialysis, you need to decide about heparinization, and therefore his dental work or treatment is important. From transplant point of view, it is important that he should be not put on drugs which could interfere, and so on. So another area of transplant which we must discuss as far as dental health is concerned is that all transplant patients, we all know, undergo dental health examination as part of kidney transplant evaluation process. Serious dental infections can delay the transplant, can even prevent it, and being, the approval for a kidney transplant is delayed, which of course eventually you get it, but one needs to be careful about oral health from that point of view. We know that immunosuppressants, antihypertensive drugs, many of them cause gum hypertrophy. And of course, transplant patients are very, very prone to fungal and other oral infections. So that's the connection between transplant and the oral cavity. So this is my last slide. And to summarize, as pointed out in the beginning itself by Dr. Jaykumar, that the mouth is a powerful diagnostic tool in the clinical assessment of systemic health. It's a mirror for either systemic disease or a mirror to the side effects of drugs. And we know gum hypertrophy with calcium blockers and CNIs and so on. So many systemic diseases, and we know about HIV, we know about diabetes, etc., but it includes chronic kidney disease and transplant. They will have oral manifestations. In fact, oral symptoms are observed in almost 90% of patients with kidney disease, and the coordination between a dentist and a nephrologist is very important. And the point which I stressed, I will summarize again, that drugs could be an important cause of oral signs and symptoms, especially xerostomia, gum hypertrophy, and dialysis patients need to coordinate with the nephrologist before the dental visit to avoid bleeding complications, the use of drugs, and altering the dialysis schedule. So ladies and gentlemen, look at your patients and explain to the patient that for heaven's sake, look after your mouth. You owe it to yourself. And more importantly, you owe it to people around you. Thank you. You're not audible. You're not audible, Jay Kumar. You're.
Yeah.
Yeah.
That's an excellent rendition about comprehensive talk on oral hygiene, how important it is for general prevention of inflammation anywhere else, and particularly with renal patients. In fact, dental health is so important that you have to brush teeth at least. Sugar diet, which is supposed to produce more acids and erode the enamel and produce plaques. So, during it is said that an oral procedure is being done, suppose a tooth extraction. Within seconds, you have bacteremia if you have a plaque. So we have to be very careful about it. Particularly, we face this in transplant patients. This oral sepsis very, very, very important for us. Thank you very much, Dr. Umesh. It's an excellent talk. Any questions?
I think comments from other chairperson, but we have just 2 to 3 minutes.
I am very happy that Umesh Khanna, chairman or running committee of renal nutrition and metabolism, had brought the topic. Topic is so important, but often less is spoken. It is ignored topic. But this session has brought this very important topic. So my comment is only one. The oral health is extremely important. Oral health can produce a lot of suspect disease already highlighted by the Jacobar and Umesh Khanna. So I have not put any question. All nephrologists, general physician, whatever disease may be there, they should look oral hygiene very carefully. Now the oral hygiene can also reflect suspect disease. So for transplant is concerned, patient on immunosuppression like cyclosporine, look at the oral cavity, the gum hypertrophy. You may not to go for the drug, but you need what is the cause of this gum hypertrophy. So oral health, dental examination, gum examination is extremely important. And again, congratulate Dr. Umesh Khanna, chairman of this conference, who brought this very least spoken topic and nicely covered. Thank you so much.
I want to ask the dietitian Meena about how much of this complaint about xerostomia, taste, etc., you find in your patients who are not eating, the CKD patients or the dialysis patients.
Basically, we come across very senior citizens.
Louder.
Whenever senior citizens are there, this is very common among them a lot. I hope I'm audible. Hello.
Yeah, to an extent, but yes.
Yeah. So basically, there we come across in our field also we see quite a few clients coming across, and with the drug, when you say rightly, whenever the drugs are being given to them, they come and definitely tell us it's dryness of mouth, how to gut the food. All these problems are there at the dietitian's desk definitely. And at the outset, I would just like to congratulate, as other fellow members also pointed out, this is the right kind of topic one needs to look thoroughly, because quite a few things are related. It's not, mouth is not only for aesthetic, it has a functional role also. So both the things are equally important, and it was pleasure to hear you, and thanks for enlightening us on this particular topic, and it's always pleasure to see all of you, and specifically I would just like to thank organizing committee, Dr. Khanna, Dr. Arun Shah, Dr. Akash, Ankit Modi, Dr. Bhalla, Dr. Anita Saxena, Gamrut Patel, and the total organizing committee for inviting me also here. Thank you.
At the end of the talk, my question remained that why was this put in the obesity symposium? And the only answer is probably the stomach is connected by the oral cavity, and eventually you put the food in the mouth for it to reach the stomach and you become obese. Maybe that's all. Thank you. Akash, take over.
Thank you, Chairperson. Thank you, sir. That was a pataka of a talk. And one of the benefits of virtual conference is that you are actually spared from the oral horror. so that is one benefit of a virtual conference. But yeah, amazing talk, sir. Moving forward with the next session, I would want to invite Ayan Day to take over the proceedings from here on. He'll be anchoring the sessions from now on. Ayan, why don't you introduce the chairpersons?
Thank you. You need a much needed break. So I'm Dr. Ayan Day, and it's an honor to invite the chairpersons, an elite chair we have of Dr. Professor Anita Saxena Madam from SGPGIMS Lucknow, Dr. Professor Anil K. Bhalla sir from Sir Gangaram Hospital, New Delhi, and Madam Jayashri Paranjpe, senior dietitian from BYL Nair Hospital. We are in for the treat, which is, I think, going to be gluten-free and dairy-free. Please take over, sir and ma'am.
Madam Anita Saxena, to introduce.
Well, it's a pleasure to introduce Dr. Clara Poddle. I've known her very well for the last 2 to 3 years now. It's been 3 years that we've been, interacting in the conferences, and I've been inviting her over. She's a consultant physician nephrologist, head of nephrology department, clinical director, Charak Memorial Hospital, Pokhara. She's actually not from Nepal, but she's settled in Nepal, and she's doing very well. And she's so I invite Dr. Clara Poddle to speak on gluten-free diet, dairy-free diet, and effect on gut microbiota and proteinuria. Dr. Clara.
Hello, good morning, everybody. Can you hear me properly?
Yeah.
All right. So I'd like to start screen sharing. Just a second. Okay, so I was asked to talk today about a gluten-free and dairy-free diet and the effect on proteinuria. So in 2015, in the Pediatric Research Journal, there was one article that has reviewed this topic and has found some interesting correlation with the gluten and dairy-free diets. So if we take from 1977, there was one study that has studied steroid-responsive nephrotic syndrome in children, 6 children. They put them on liquid elemental diet. And interestingly, 3 out of 6 patients, they went into complete remission. And later on, when they have reintroduced cow's milk, they have again showed some relapse, and they have again improved on a milk-free diet. And this was something very interesting at that time. Then later on, around 10 years later, there was another study which was looking at idiopathic nephrotic syndrome, and they have put 13 patients on oligo-antigenic diet for 10 days. And they have also found some improvement with this diet. In all 13 patients, proteinuria was significantly reduced. And they have also found that there was a history of allergy in 8 out of 13 patients. Then the next study on this was with cow milk protein, and they have taken 17 children with steroid-resistant nephrotic syndrome. They have excluded cow's milk from the diet, and 6 patients went into remission. And then later on, they had after remission, they have given them again the cow's milk, and they have again showed relapse. So this has clearly showed some correlation, however, not in all of the patients. Now, And the next study was on primary IgA nephropathy and the effect with the gluten-free diet. So in this study, 29 patients were put on gluten-free diet for at least 6 months. And they have found that IgA-containing circulating immune complexes levels were significantly decreased after 6 months on the gluten-free diet. And they have also checked IgA levels to the gluten antigens and the bovine and egg antigens. And they have found also that they were higher before unrestricted diet, and they have the levels were decreased after the gluten-free diet. And the mean levels of IgA to most of the dietary antigens have also decreased on a gluten-free diet, and the proteinuria level has also decreased. Now, all the previous studies were done in the 70s, 80s of the last century. And then for almost like 20, 25 years, there was not too much investigation done in this issue. And recently in 2018, there was one trial announced in which they wanted to put nephrotic syndrome children, steroid-resistant nephrotic syndrome children in a summer camp, put them on a gluten-free diet. And when this study became realized, they were able to enroll only 16 children, and 2 of them has showed reduction in the proteinuria. And so it was not like a breakthrough, something very impressive result. But I will just, in a few minutes, I will explain it more why. So if we check IgA nephropathy and the association with the gluten, then we found that from 1987, it was already described that in the IgA anti-gliadin antibodies, they have some association in the IgA nephropathy. And it is also known that gut-associated lymphatic tissue, it plays a major role in the development of IgA nephropathy, which was also shown in genome-wide association studies. So in a study in 1989, they have measured these IgA anti-gliadin antibodies in 45 IgA patients, 34 membranous patients, and 31 idiopathic nephrotic syndrome and membranous-proliferative glomerulonephritis patients. And they found that around 53% of IgA patients had these antibodies, and very less percent of the other nephrotic syndrome patients had these antibodies. So they have also proposed that this would be a good predictive blood test that could predict that this patient might have IgA nephropathy. So interestingly, in 2018, recently, there's a new thing that came up in a pilot study. They have tried medication, which is budesonide, which is entry controlled release, and it directly acts on the Peyer's patches, suppressing the gut-associated lymphatic tissue activity, and in IgA nephropathy patients. And they have found that with this medicine, there was a significant reduction in the proteinuria and the stabilization of the renal function. So this also proves that there is some relation between the gut and IgA nephropathy. Now let's go and talk about gluten-free diet. So this, what is this gluten-free diet and from where it came from? So if we check, for example, in the USA, what are the diet trends? That there was always some fashion in the diet, like low carb diet, and came the fat-free diet, and then from 2008 onwards, the gluten-free diet became very popular. And what we see in this, that initially it may be started by a scientist, but then later on it was picked up and marketed by the food industry. Because now if you say anything is written gluten-free, then people are much more likely to buy it. And the other thing is that there is always some culprit, like we say, okay, the carbohydrates are bad, so you have to eat low carbohydrate diet. Then came, okay, no, the fat is bad, so you have to eat the fat-free diet. And now came, okay, no, gluten is bad, causing all the problems in our lives, so you have to be gluten-free. But they are just too much superficial, because we just pick up one thing on the diet, and that may not be adequate. Now let's see, what is this gluten is about. So gluten is the main structural protein of the wheat, and it also comes in others like rye and barley. And the main proteins in that are the gliadins and the glutenins, which are a bit of toxic proteins. And if we see a gluten allergy is an immune-mediated response, it's an allergic reaction, which a few people will have. But if you see gluten intolerance, is just like inability to tolerate gluten, is also immune and also non-immune mediated. And gluten sensitivity can be a mixture of both of these. And we know only one disease which is directly induced by the gluten, that's a celiac disease, which is an autoimmune disease affecting the small intestine. And now they have also recognized there is also silent celiac disease, which means that the antibody testings will be negative, but the patients are reacting to the gluten. And what are the symptoms of gluten sensitivity? It can be very non-specific, like some GI symptoms, fatigues, depression, skin reactions, weight loss, autoimmune disorders, all kinds of autoimmune disorders, joint pains, and neuropathies. And basically, recently it was also proposed for the classification of these gluten-related disorders, autoimmune, allergic, and non-autoimmune. And in this one, lots of disorders come, especially in the autoimmune. We know celiac disease, gluten ataxia, dermatitis herpetiformis, and they can be all symptomatic or silent. And in the gluten sensitivity, well, which is very non-specific, and in the wheat allergy comes all the respiratory allergies, food allergies, contact urticaria, but they are the allergic types. Now, in 2009, Dr. Alessio Fasano has published one very interesting concept, which is known now today as leaky gut syndrome. So it proposed that there is a protein called zonulin, and the zonulin gets released when the gluten enters the gut. So in the enterocytes, zonulin gets released, and zonulin will open up the tight junctions in between the cells. And that's why what we are eating and what we have in our gut, and that includes non-digested or half-digested proteins and other nutrients, they can cross the barrier, and they can cause immune reaction, which in people who have the tendency for autoimmunity, it can induce autoimmune disease as well. And if we see what is zonulin, zonulin can be measured in the blood. It is actually a pre-haptoglobin 2. And this is the key biological effect of zonulin, is to open up the tight junctions. And what we see is that in most of the autoimmune diseases, we can measure high zonulin levels. And because of this, they have also tested one medication, which is a zonulin inhibitor, trying if it could help in the treatment of autoimmune diseases. And this is all under investigation currently. So today we have also talked about obesity. And that's why it's also interesting that they have also found that in obese patients, these zonulin levels are a bit higher, and they are nicely correlated with all the risk factors of the metabolic syndrome. And body mass index, weight to hip ratio, fasting insulin, triglyceride level. So there must be some connection, but we still can't see it very clearly. But if we talk only about gluten-free, dairy-free diet, then what we are looking at is just the tip of the iceberg, because the main thing is that what matters is more like the quality of the diet and not just one or two aspects of it. Most of the diet, we have lots of very popular diets, but most of them, they just focus on one type of macronutrient, like low protein diet or ketogenic diet or carbohydrate free diet. What we are picking up is just one macronutrient, and we are only focusing on the macronutrient. But if we would focus on the micronutrients and the quality of the diet, then we could realize that there is much more important, because all the plants, the vegetables and fruits, they contain all the vitamins, antioxidants, the phytonutrients, which our body needs. And if we don't give our body what the body needs, then we cannot achieve the good health. So if we see what are the triggers of the leaky gut syndrome, it's not only the gluten, it can be all types of other things like dietary proteins and all other toxins, hormones, stress. And if we see leaky gut could lead to food intolerances, immune abnormalities, and later an autoimmune condition, which means there is like a spectrum of diseases. So there is a new kind of trend, which is called the functional medicine. So if you see like you have a patient with lots of symptoms, but all of the blood tests are normal, all of the investigations are normal, then you would just label it, okay, it's a functional, like functional dyspepsia, functional pain, because we cannot really catch it, and the disease has not progressed as much that we could diagnose it as a specific disease. So that's why functional medicine started to investigate these and found that there are actually root causes for all of the diseases. And this functional medicine has a textbook, which can get us nearer to this. So for example, if we see autoimmune diseases, they have lots of factors where we could find the root causes for them. Before, we used to, in our medical books, we used to learn that autoimmune diseases are just like, we have no idea why they come. And the only thing what we can do with them is to suppress them with the immune suppression. But now there are more and more evidence that actually there are causes of these diseases. There can be root causes that can be found. And if we address all of these factors, we can even reverse the autoimmune disease without immunosuppression. And if we look at the factors, and one is genetics, which we already know. The other is the food and nutrition, which includes food intolerance, leaky gut, dysbiosis, and food additives, and especially deficiencies in the nutrition. If we look at the toxins, we have heavy metals, pesticides, plastics, electromagnetic fields, and then we can have infections. parasites, chronic sinusitis, dental infections, asymptomatic abscess, caries, root canal problems. And then we have to mention psychological and mental factors. So all these factors, they contribute to the autoimmune disease development. But to talk about these in more detail, I would need, I think, at least another 1 or 2 days of lecture, and I cannot do it in 20 minutes. But one thing is sure, that I have, when I have a patient with nephrotic syndrome, then I try to, or even briefly, I try to go through all of these and try to find if they have any occult infection. So I do a paranasal sinus screen, I do a dental screen, and I had many patients who came with a membranous nephropathy, and I found they had sinusitis. I cleared the sinusitis, and they went into remission. Another patient, I look in the mouth, and I see there are lots of bad tooth. So I said, go to the dentist, clean up your tooth, clean up your teeth. And after cleaning up the teeth, she went into remission, and she is still in remission without any immunosuppression. And the other heavy metals. In some patients, we found high mercury levels or high cadmium levels with membranous nephropathy. And when we have eliminated the source, they also went into remission. So it's not always that we have to jump with the immunosuppression. We can see a little bit if there is any other causes. And thank you very much.
Thank you, Dr. Clara, for excellent overview on this very practical topic. I have a question for you. As you said, that it is actually like iceberg. We have very few patients who are diagnosed, and most of the patients are subclinical, and we are not diagnosing them. And second is, in our routine practice, even in IgA nephropathy or nephrotics, we are hardly evaluating our patients for gluten sensitivity. So what is your recommendation on that?
Well, it's not that 100% of the autoimmune patients will have gluten sensitivity, and not 100% will have the dairy sensitivity. But many of them will have, because what we see is that most of the time, gluten and dairy, they are the most powerful sensitizers. Like they will create immune reaction. So if you just in all of your patients, if you just ask them to go gluten-free diet for some period, just to test if it makes any difference, and then it makes a sense.
What test do you recommend we should do for diagnosing gluten sensitivity?
Now, there are some tests like for the food intolerance. You can measure the IgG levels. So there in some places it might be available. I don't know about India, but I guess there might be some labs where it is available. So you can measure IgG level for the gluten, gliadin, and the milk protein like casein, and lots of other food that can have sensitivity. The thing is that once somebody has a leaky gut, then they can have sensitivity to all of the food that they usually take. So because in this part of the world, many people consume rice. I can also imagine that maybe in India or Nepal, maybe rice sensitivity may be even more than gluten sensitivity, because it depends on what people eat more. So if you eat something too much, too many times, then you can get intolerance to it.
Professor Anita, you will like to ask some question?
Yeah, no, I just like to comment that ever since I've met Clara, this thing has been in my mind, like elimination diets. I've been thinking about it, and whenever I see a patient with nephrotic syndrome, it comes to my mind, shall I do it? But then I look at the child and the mother, and I just can't, I can't even dare discuss this with them. So this is kind of a mental block. But then I feel that the kids are, or the nephrotic syndrome patients are going to benefit out of it. I do believe in it, but I don't have the courage to take the step in that direction.
But the main thing is what we should rather do is that autoimmune disease is connected to the leaky gut. That means that whatever we eat, it can trigger the immune reactions. So we should much more focus on healing the leaky gut, which is there is a specific diet with which you can heal the leaky gut, and to fix the bacteria in the gut. For that also you have to eat specific food like lots of vegetables. So we should rather much more focus on the quality of the diet. We should include much more living foods, less processed foods, and all. But these are all a little bit much more. It would take much more time to talk on all of these topics.
Thank you very much for wonderful talk. And with this, we close this session because already the time is over. Thank you very much.
Thank you so much, everyone. Thank you. It was a wonderful session. We really enjoyed and learned a lot from it. So the next is a panel discussion, which will also be very exciting. And it's a very relevant topic of are we being too restrictive? We had a lot of fun yesterday in the evening where Dr. Tushar Shah joked that if we are too restrictive, we don't live longer. We just feel like we are living longer. So it's a need of the hour to talk about it. And I welcome Dr. Umesh Khanna, sir, who needs no introduction. He's a director of Kidney Associates and a consultant nephrologist at Asian Heart Institute, Karina Hospital, Suchak Hospital. And to co-chair Dr. Zamurud Patel, ma'am, HOD, a chief dietitian at Global Hospitals, Mumbai, and the chapter convener of Indian Dietetics Association, Mumbai chapter. Session is all yours.
Thanks. I think Dr. Cam Kalantar very rightly put it up that the World Kidney Day tells us, how to live well on with kidney disease, and in which case it has become a patient-centric method of treating CKD, and which is why we thought it will be best to bring in patients also in the panel discussion. Otherwise, it becomes only nephrocentric, nephrology-centric, or a nutritionist sense. So we have a galaxy of speakers here, and let me introduce one by one. Dr. See, he's almost, he's not a doctor, but he's learned so much about nephrology now that it comes from my mouth. So Kamal Shah is a co-founder of NephroPlus Dialysis Centers, but here the introduction is basically he's almost 18 to 20 years having CKD, has gone through conservative treatment, transplant, peritoneal dialysis, and hemodialysis. So he's one of those experienced patients who has seen it all and who knows the ups and downs of each therapy. Let me also introduce my other patient, and both of them are my friends. Samir Haladi, who is the program director of Amar Gandhi Foundation, and we both are, a part of the Amar Gandhi Foundation. He is by profession a digital marketing strategist, and again, importantly, almost 17, 18, 19 years of handling his CKD, conservative management, dialysis, and now transplant. So again, an experienced person. Professor Anita Saxena, we all know, the professor of in the Department of Nephrology, SGPGI. Sana Saigira, we have again heard her and seen, and she's a renal dietitian at Dr. Kriplani's Kidney and Blood Pressure Clinic, and I've always found her extremely, intelligent answers and always to the point and very practical. The way Dr. Kriplani is also very practical. And Arvind Kanchi would be representing the nephrology community. He's a nephrologist and transplant physician, Bangalore, Sagar and Trustwell Hospitals. And we all know him through the great work he does through through the social media. So I think it's time. We have up to 1:30, and before that only we'll try and stop. And of course, Zamrud is there with me. And how can I do this conference or this panel discussion without Zamrud? So let me share the screen. Normally don't have in the panel discussion any slides, but this is basically to just keep the focus on the topics and we don't lose on these topics. So the first thing is, are we too restrictive with renal diets? And what are the effects on quality of life and lifestyles issues? Both these issues will be important from the patient's point of view. But let me tell you what all we are going to cover in this panel discussion. And if yes. So the discussion points will be the patient's perspective, identifying their issues. What are the effects on the, the frustrations, the depressions, and the issues of lifestyle and, quality of life. And then we'll go through the science behind restrictions. Why are the nephrologists and the nutritionists talking about restrictions of these items? And are there any Indian perspectives to it? Is there differences between the Western model and the Indian way of treating CKD, or our diets are different? And then, of course, the more important, because this is a science conference, so we'll talk about proteins, potassium, phosphorus, salt, fluids, calories, and what are the issues behind it. The problems of our kind of patients, why our Indian patients have different issues, and the ill effects of, anybody and everybody advising them, the non-dietitians advice, and so on. And of course, then what is the practical take home? How do you plan parties and get-togethers and outings and festivals? And what are the snacking options which these patients are missing? And eventually to conclude that it's not a one-size-fits-all template of the disease. So Samir, you are our opening batsman. And again, Kamal, both of you all have to handle this, the two aspects. What are the problems of diet which irritated you as a CKD patient?
So
Samir, Kamal, yes.
Yeah, as an opening batsman, let me first take guard. And
yes.
So my first experience as a dialysis patient was, as a CKD patient was pre-dialysis. So at that time, there were a lot of protein restrictions, and there were times when I was told not to even have, say, besan or that kind of a thing. So it was very difficult.
Yeah.
Okay. So it was very difficult to even avoid things like besan. Because it has protein, and yes, dal, for example, was very difficult because patla dal, when we are having rice, then dal, you need some taste. And I was a big eater. I think I still tend to be a big eater, and because of all of this, it became very difficult.
Okay.
Typically, even things like, say, chocolate. Okay. So chocolate is something. I guess everybody loves chocolate.
Yes.
And
I was about to tell you, you are not to be blamed for it. Everybody is a big lover.
Thanks for that. That makes me feel so much better. But yeah, there were a lot of restrictions. See, salt, for example, I could manage. I knew it was very critical for me. So I really cut down on my salt, and it really helped me a lot. Fruits is not something that typical middle class people would have on a daily basis. So again, that is something that I could do without. But to have a total ban on something like besan or patla dal was the worst thing that I could go through.
Yeah.
I guess pre-dialysis, that was it. On dialysis, I think I'm a vegetarian. So having so much of protein in a day became extremely difficult. Yes, I subsequently started having eggs, but even then, egg, and I'm a well-rounded personality, as you can see. So, and one egg white is just around 4 or 6 grams of protein. So to really have that kind of protein in a day is a big challenge, and especially when on dialysis you cannot have sprouts or any other source of protein because it is high potassium. So, that is where I found it difficult. Again, I always had a very active lifestyle. So I used to hike and I used to do photography. So there were times when without salt, I went for hikes, and there was a time I actually fainted on a hike.
Okay.
So then I tweaked my diet, and I sort of learned things all by myself and learned how to adjust the sodium controls on a dialysis machine, and carry salt with me, identify what are the symptoms of low salt vis-a-vis what are the symptoms of low sugar. So all of that happened later, but I think these kind of guidance would make a lot of difference.
Yeah, so you try to educate yourself. Kamal, are you there? I can't see you.
Yes, doctor, I'm there.
Yes. So was there any moment when you said, to hell with the nephrologists and the dietitians, I will eat what I want? So what are your thoughts on dietary problems as a patient?
Yeah,
does frustration come in sometimes?
Absolutely. I think it does. And that probably happens with most dialysis patients. I was told that you can have only as much water as you need to swallow your tablets. To that extent, the fluid restriction was put. But I think one major change in mindset that I would request nephrologists, dietitians, and so on is to give workarounds rather than restrictions, right? For example, like water, right? We know that dialysis patients need to restrict water to 1 liter. How about giving some ideas on how to restrict, like for example, have a spray bottle and or lime cubes.
So Kamal will come to the therapy, what to be done.
Sure,
but I just want to know right now what frustrated you. Yes.
Yeah. So blanket restrictions: drink only that much water, no fruits, milk and milk products should be restricted. And protein, my complaint was that I was told to have high protein, but almost every source of protein had high phosphorus or potassium. So how am I supposed to manage my protein intake when there are so many other things that will go up if I have that protein, right? So those kind of problems I had where I didn't have any guidance on how to manage. I was told that you need to restrict this, you need to restrict that, and as a result, what happens is so many things are restricted, you can start feeling depressed that what the hell is this life? I mean, why continue to live if there's so many restrictions that you can barely eat or drink what you want to, even things like water. Like, I mean, it's not alcohol, right? It's not whiskey that I'm having. They're not saying that have only this much whiskey. It's water. I mean, the thought that I had is restrict even water, something as basic as water. I mean, like, what the hell, that was the thought I had in the initial days.
Yeah. So we'll come out with a case, but this is not meant for people like Dr. Anita Saxena, Zamrud, Sana. They are the ones who are very knowledgeable about what should be given. But there is a whole community of dietitians who are actually practicing, and it's not that patients go only to corporate hospitals or teaching hospitals. And which is why I congratulate Anita and the Srnmcon for bringing out such conferences and meetings. So these are the people for whom this case actually is representative of as to the frustration of it. So 45-year-old female Mrs. Camila Fernandez underwent general health checkup for weakness and tiredness and was found to have a creatinine of 3.2 milligram per cc. Her urine routine showed trace albumin, rest of it was normal. Sonography typically showed small shrunken kidneys. She used to consume a lot of NSAIDs for chronic migraine. So no medals to diagnose this as clear-cut CKD. BP was just 130/80, no swelling, good urine output. Nobody would look at her and tell you she has CKD. BMI was 24, sugars, electrolytes, cholesterol, everything normal, calcium phosphate normal. And her nephrologist typically prescribed her soda bicarb, vitamins, and some advice regarding how to avoid nephrotoxic drugs and referred her to a dietitian. Now, dietitians, of course, they have been also taught a few things about, how to manage CKD, but that's in the general dietetics course, or, like how family physicians are given a general idea about nephrology, not specifically. So her GP referred her to his standard general dietitian. So this is the diet with both the GP and the dietitians typically got together and prescribed. They had a little idea that protein should be restricted, salt should be restricted, potassium should be restricted in CKD diet. So her non-veg was stopped. She was Camila Fernandez. So non-veg was stopped. She was allowed moong dal, tuar dal. 2 dals were allowed, and they were really kind enough to allow her 2 dals. Instead of chapati, she was asked to take rice, bhakri, and as part of protein restriction. All green leafy vegetables were stopped, and she was of course allowed to eat dudhi, turiya, gourd, tandi, etc. Fruits which we generally give it to sicker patients. And she was given 2 fruits, papaya and apple. Salads once a week was given, a chutti, holiday ke din, salads were allowed. And Obviously, no coconut water as part of potassium restriction. Her salt was reduced to just 2 grams and she was allowed 1 liter of fluid. I mean, she was given 1 liter of fluid restriction. Obviously, no fried food, bakery products, and no dietitian worth her salt will allow so much of bakery and things like that. So whoever took the name of dry fruits was given capital punishment in that house. So there's no question of giving dry fruit. She was asked to eat khakra as a snack, and whenever she felt hungry in between. And of course, she had to Google what a khakra is and how to eat on earth khakra. And she nearly choked reading her prescription. So Sana, again, I'm not seeing you. What's the problem? Sana is there?
Muted.
Yes, I'm there.
Yes.
I'm there, sir.
So we had to call experts to, modify this diet. And Sana, how would you treat Camila Fernandez?
Okay, thank you for the introduction, sir. Well, like you said, Camila Fernandez, when I listen to this, and stopping non-veg is like a crime for Camila Fernandez. So the first what you would do for her making a diet plan is take a recall, most importantly. So I'll sit and first understand what she's already been eating. I will not go into the basics of protein restriction and potassium. We all know that, I will just focus on what I would plan for Camila particularly. Okay. So now with the calories, of course, I would give it as per her requirement. And now coming to the proteins, I would understand her recall. Considering that her BMI is 24, I understand she's falling into a normal weight category. She's not overweight or underweight. Okay. So maybe 0.8 if I were to give, of which 50% will be from high biological value. Now the high biological value I will make sure comes from the non-veg source. So the only understanding that I will give her is how many grams of proteins is coming in 100 grams of non-veg. I will explain to her about the edible portion of non-veg, about the portion control for non-veg. I will not stop her non-veg, but of course the portion control will be explained depending upon her intake. That is with regard to proteins. Of course, eggs will be given, and the second class proteins, if she's not very keen, we will adjust more into non-veg. So depending upon her recall, we will finalize that. Coming to the potassium levels are normal. So we will not go into an aggressive restriction. But then again, she's Camila Fernandez. She must be adding coconut to all her curries, So I will just understand how much coconut she's adding to her curries and just calculate, because on an average, Indian diets are high potassium. If you're taking a lot of chapatis and all, so not about the exceeding limit, but then at least I will understand her intake of coconut in the coconut curries and see if I need to replace that or continue with that. Salt restriction, again, because she's a Goan Catholic or a Catholic, she must be having pav or breads for breakfast, So that is a strict no. All the liberalizations on one side, bakery on the other side, Salt restriction is something that I will explain it to her, that it is not because you are a renal patient. On the whole, WHO has recommended 5 grams of salt. Oh. So now when you fall into the renal category, it is a little more restrictive. So we will sit and work out. I will not give her upma poha for breakfast, that she'll faint there, if I do that to her. So we will come with options like pancakes or oats porridge, we will come to, generally it's a bargaining session when I have a diet counseling, some points I give, some points they give, and then we come and plan. Like if she wants to have a bread, then we work on sodium-free breads. I have recipes that they don't turn out that good. But if she's keen on dipping it in tea, those breads are hard when you make it without soda. But then if she will dip it in tea and have it, becomes soft. So if she's willing to do that, we continue with that. Or we make pancake with maida, or we make oats pancake. So there is where we figure out a bread. But with all the restrictions, I might not allow her to have bread daily. Everything else will be in moderation, because only the creatinine is high. Everything else looks good. There is no swelling. The urine output is good. So I will not put her on any fluid restrictions. The blood pressure is normal, but again, I will tell her, just because your blood pressure is normal, you can't take normal salt, That is where the notion comes, Sometimes they have low sodium levels and they start taking salt because they feel the sodium level is gone low. So there is where I will sit and I'll explain it to her that these are the points. Again, I will not put her on any phosphorus restrictions, but I will tell her that everything that is rich in protein is rich in phosphorus, I am not putting you on any, in case she does not come back to me for follow-up. She should know what is phosphorus, what is potassium, what is sodium. So when she moves out of my clinic, at least she is educated. So even if she does not come back, she will at least be keeping a track of these parameters. So maybe we might not be that restrictive to the patients if the parameters appear normal. But I feel educating the patient is very important, so that if we are in South Mumbai, if the patient is coming somewhere from the interior, they might not come back. But at least when they go to their general physician, they know that no, my phosphorus was normal 2 years back when I saw Sana. Now it has gone high. So let us look into that. So I feel I will educate the patient, but with regard to the diet, I'll be a little liberal because the parameters are not that high. So that will
be my. So I think a lot of people must have felt itna simple cheez hai. Why is Dr. Khanna brought it out? But I'm a family doctor in nephrology, and I work in the community where I see all kinds of diets being prescribed. And I thought there are a lot of general practitioners, physicians, and some of the community dietitians who must be listening to this or who would be listening to it. So let's put the
I would
dietary
just like
process.
to add
Yes.
one thing.
Yeah.
When you're talking of community dietitians, anybody who has a formal education in dietetics, when I say formal education, I'm referring to a BSc program. When they undergo, they are trained on renal nutrition.
Right.
You have a subject, but unfortunately, like how is it is in our country, people do 3 months, 6 months, 1 year online courses, sir, which is for 1 hour in 1 week, and they start practicing nutrition.
Absolutely.
So probably when these people may be able to do the wellness bit, but when it comes to specialized dietetics, they will be the ones who will not be able to guide patients well.
Absolutely. So we do have general practitioners also of that kind. So it's not restricted to only nutritionists. I mean, this is just for everybody.
Yes.
And it's nothing to talk ill about anybody. It's just that we need to educate everybody, which is what I was talking to Dr. Anita Saxena about. When we do these Srnmcons, why are we trying to include all of it? Because nephrology is not practiced only in corporate and PG, teaching hospitals, but also in the periphery. So I think we move on to the next aspect, and we are going to take all these together. So Arvind is there, and what is the science behind restricting proteins? Why do dietitians or nephrologists talk about restricting proteins? And more importantly, is it really needed? And of course, a lot of it is covered by some of the speakers earlier. And how do you advise your CKD non-dialysis patients about protein restriction? You are mute. You are on mute.
Thanks, Dr. Khanna, for including me in this debate. So nice of you. I would like to share some slides if you're okay with that. Can I?
So we have very little time, so I would be happy if 1 or 2 slides only.
Okay, fair enough. Other participant is sharing.
Nobody will be allowed to share more than 1 or 2 slides.
Fair enough.
So you will have to stop sharing so that Dr. Kanchi can share his slides.
Oh, so maybe Kanchi, it would be better if we just talk about.
Fair enough. Yeah, not an issue.
Yeah.
So basically, the idea of restricting protein in patients with kidney dysfunction obviously has come from Brenner's hypothesis. You're looking at trying to protect the kidney, trying to reduce the decay in GFR by giving less protein, less work for the kidney, and that is the basic premise behind it. But in the Indian context, quite frankly, in CKD patients, I would personally say that I would not stick to this sort of a diet. And why is that? That's because
there is some disturbance in the background. Can somebody mute if he is unmuted except Arvind? Yeah.
Okay. So basically, the diet from the Indian perspective, there are studies that show that despite, I think I hear the noise again, that despite protein restriction, the protein intake of the average Indian is between 0.8 milligram per kg to 1. So you are looking at an already restricted protein diet in most of the normal population. If you take vegetarians, you can decrease that by 0.1, and you are looking at a restricted diet already. Now, if you are looking at the amount of protein taken in by the average Indian, you're looking at cereals contributing to 50 to 60% of the protein. You're looking at non-vegetarian food contributing to about 7 to 10% of the protein. This is even in non-vegetarian people who take non-veg food probably 2 or 3 times a week, maybe more. Bulk of the protein content in most Indians come from cereals, come from milk and milk products. Only 7 to 10% comes from non-vegetarian food. So the question of restricting protein, especially in vegetarians, perhaps in non-vegetarians as well, is really besides the point. there is another aspect to this problem. The other aspect to this problem is that as you starve these patients, in the sense that you are now not going to give protein, you're going to reduce their phosphate, which is also has an effect on the protein intake, you are then getting to a stage where as this patient reaches dialysis, he is in malnutrition. He has protein energy wasting, and that is a really big problem, because you know very well that in dialysis patients, when you measure the serum albumin, that is the single most important indicator for mortality. And it's been shown in Indians, 68 to 80% of patients who enter dialysis are protein deficient. Now, if that is the situation you have, why are you restricting protein beforehand? Why do you need to restrict protein in patients in a population which is already taking a protein restricted diet?
Can I stop you, Arvind, here? Any of the nutrition experts tell us on your dietary recall, what is the kind of protein intake most people say? Arvind has probably quoted a figure of around 1 gram per kg. How much, Arvind, you said?
0.8 to 1 already in the normal population. I'm not talking
Anybody differs? Anybody differs?
No. So we had done a study where we tried to assess the nutritional status of normal people, and the mean that we had got was about 0.65. This was on a mixed diet, and that is what we had got. I'm talking of a mean, but if you're asking the range, it ranged from 0.5 to 1.1.
So Zamrud Patel is saying the whole country is on a CKD diet. Right. Okay. Anita, you wanted to say something? Yes, quickly.
Unmute, ma'am. Unmute.
Actually, Dr. D. K. Sinha from Kanpur has published a study which was done on controls as well as on medical doctors, right? And it's published in Journal of Renal Nutrition and Metabolism 2 years ago. And it has shown clearly that the average intake of protein is 0.6 grams per kg body weight per day. And it's not even 8. Even the healthy individuals are not able to get 0.8 grams of protein per day.
Right. So everybody is reinforcing.
Just a moment. Yeah. So my question to Sana is, when she says when the patient comes to her with 3.2 creatinine, she would like to start from she's not even diabetic. The patient is not diabetic. Patient is not hypertensive, nothing, no comorbidities, just come with a creatinine of 3.2. So why do you want to get into a hyperfiltration, the postprandial hyperfiltration state for the patient? Why don't you keep the patient on the same kind of protein that the patient was taking? You want to go beyond the normal intake, that is 0.6. You want to start from 0.8. I mean, I don't think we would want to burden the kidneys. They're not even used to 0.8 now, particularly with 3.2 creatinine. How can you think of giving 0.8 protein if the patient is not diabetic?
I think she said that she would do the dietary recall.
Recall. Because I heard Camilla, ma'am. If I would have heard Surendra Jain or someone, I would have said something else,
So, no, I think she said that we will do a dietary recall and then accordingly.
When I hear a shake, again, it differs. When I have a shake or a khan or Camilla, so that way it differs.
Correct. So I think the panel agrees that there will be the need for protein restriction in general theoretically, but the country is already on a CKD diet. So where is the need to alter the protein intake in a large majority of the people? We move on from proteins to phosphorus. So that's another area. We'll move on from protein, phosphorus, potassium, fluid, salt, etc. Phosphate, Anita, what do you think? We have a problem of, do we need to restrict phosphate in our diet? The kind of patients you come across? And then Arvind, you will have to give your comment.
I think, I'll give you our study. We've just finished a study on FGF23, clotho, vitamin D, and on hyperphosphatemia. And we found that even in CKD stage 1 and 2, the FGF3 levels, we know it's a phosphoric hormone, it goes up. Right. So what we did, I told my dietitian that you restrict phosphorus rich foods. So when we brought the phosphorus rich foods down, we found that the GFR went up within a year, and the phosphorus came down. FGF23 came down, clotho levels went up. So when we think of restricting phosphates, we say everything, the serum phosphorus is within normal ranges, so we shouldn't think. But looking at the results, what we are getting now, I think phosphorus restriction is important, but at the same time, if you're giving majority of phosphorus from plant-based proteins, it's not going to be absorbed completely. So it's only about 40% of what is going to be absorbed. Right. But yes, animal protein will have to, I think, should be restricted. The flesh part should be restricted. Yeah. I wouldn't want to restrict milk or egg. Egg is a very good friend of our CKD patients because the lowest phosphorus to protein ratio. So not that at all, but definitely when it comes to, I've been thinking about it. We've published we have 2 publications already. Third is also coming, that phosphorus restriction should be started right from stage 1. But it doesn't mean that the patient has to suffer. What Mr. Kamal said is something so very painful that, dal of thin consistency, that's what we hear in the OPD all the time. And it is so painful. And see, this is the reason SRNM, this was the thing that I wanted non-physician nephrologists to know, non-nephrologist physicians to know, that don't say zero protein and don't give them liquid dals. They give them something which will maintain their muscles. So this is the reason why I try to reach the physicians who are not nephrologists, just because the patient, when he comes to us, is oddly shattered, is totally badly psyched that he can't eat this, he can't eat this. This is, that particular doctor said no, and you were saying you do that. So this is the reason why SRNM is
yes,
important.
we are thankful. I think it was very important. Arvind, you mentioned about the Indian diet, even in non-vegetarians, is hardly non-vegetarian. So are you in your practice restricting phosphorus, or you are kind of allowing them normal food? Like what Samir and Kamal, if they come to you, you will allow them what kind of food?
I would allow them normal food. And here's the reasoning. The reasoning is that, yes, phosphate restriction is needed. Perhaps you're looking at the calcium phosphate product, you're looking at the PTH going up, you're looking at FGF. These are all numbers. What is phosphate restriction going to do? Phosphate restriction means you're going to restrict some form of protein again. If you start restricting protein, you're contributing to mortality. Has phosphate restriction or phosphate binders, have they ever shown a decrease in mortality in CKD or dialysis patients? The answer is actually no. There are 2 trials ongoing, randomized controlled trials, the high-low trial and the phosphate trial. Hopefully, they'll give us numbers. We have plenty of prospective trials. We have plenty of retrospective trials that have shown that phosphate restriction, phosphate binders, perhaps non-calcium phosphate binders are useful in reducing many of these numbers. But does it improve the important fact of mortality in these patients? And the answer is no. When that is the case, you are now going to restrict all these things, given that the patient is already on a low protein diet, a low phosphate diet, a low salt diet, a low water, and like our patients on dialysis say, they're going to get to eat nothing. So I would not restrict it I would not restrict vegetarian protein at all. Never.
So overall, in Indian context, what you are saying is that there is not a great need to go down to low phosphorus diets and maybe allow everything in moderation. If at all an occasional patient has phosphorus issues, we can use phosphate binders. Is that what your conclusion would be?
So the point is that if you're looking at colas and other food that contain additives, you would want to restrict those sort of phosphates.
Sure.
Obviously, if you're looking at protein food, you have to be a bit more careful in looking at that. Right. There's no doubt that a high phosphate level contributes to mortality. Sure. There's no doubt that a very low phosphate level contributes to mortality. The question is, does diet intervention plus phosphate binders reducing the phosphate level does that help mortality, reduce mortality? That is yet to be shown.
Right. We have 15 more minutes and we have come down to 2 problems. Protein restriction, not required to a great extent. Phosphorus restriction, not required to a great extent. I hope the 2 patients are satisfied that we are trying to be patient-centric rather than the figures or the value-centric. We move on to the fluid restriction part. And I think Yes.
Dr. Umesh, can I say something?
But 15 minutes and we have lots, so it'll have to be quick.
Matter.
Yeah.
Just a minute.
Yes.
See, protein restriction is not required because they're already on low protein. And even for a dialysis patient to reach 1 gram is, earlier on it was 1.2, last year it's come as 1. So 1.2 was really difficult for us to be able to, get the patient onto 1.2, but at least 1 was 0.8 and 1, something between that. What I'm trying to say is, I said phosphorus restriction is important. You just have to change the kind of vegetables the patient is taking.
Correct.
I'm not asking you to change to restrict protein at all.
Correct.
A lot of phosphorus comes from nuts, a lot of phosphorus comes from vegetables.
Right.
So that is the point, that my dietitian, she's just swapped the kind of the vegetables the patient was, and it showed the difference.
So you can
not that restricted protein at all. Never. That's not possible.
So you're saying other kinds of phosphorus should be reduced.
Can I just add that vegetarian protein?
I think the phosphorus debate can be taken on a separate level. We are now at fluid, unless we want to only stop at phosphorus, then otherwise. So I want to cover up almost all the points. But I think the point is well taken, that phosphorus restriction should be not at the cost of protein restriction, but at the cost of all other sources of phosphorus, which should be changed so that the patient has the benefit of it. So fluids, I think the 2 patients have already highlighted, is a big problem, and they are asking the dietitians to try and help them in how to manage fluid restriction. Sana, Zamrud, anybody can take it. Methods to handle fluid restriction, in short.
So in short, I will just say that when we are talking of fluid restriction, first thing is that we train our patients to, if they are non-diabetic, so you have these candies which are, fruit flavored candies that you get. You keep sucking on these candies, which quenches your thirst. Or probably even we have we have ice trays available today, which is with a mark of the ml that one cube would be making. So you can actually set those trays, so 5 ml per cube. So you can make that, and instead of drinking water, probably you can suck on these ice cubes, which could be flavored with a ginger juice drop, or lemon juice can be added, and that really helps the patient. Probably even for dialysis patient, many times we say that have thicker dals, have thicker curd, so that you can save on little fluid that can come. Or probably instead of adding milk, you use paneer. These are some practical things that we normally train our patients to do to save on the fluid.
Right. And some of the patients find their own ways of doing it, like how Samir and Kamal has done it. Potassium, this is what I call as a do dhari talwar. And, either way, we've had a couple of topics on why restricting vegetables, fruits, etc. may not be a great idea. And in many patients, except for a few in whom potassium is a big problem. So, so there is the good, the bad, and the ugly part of potassium, and we all know about it. And we need to, as Kamal says, go around it rather than, strictly restrict things. So Arvind, good part of giving potassium, why we should not be very strict with vegetable, salad, fruit restriction completely.
Well, obviously, the good part of restricted potassium is the fact that...
No. Good part of giving vegetables, salads, and fruit.
Yeah, good part of giving potassium would be that it has blood pressure lowering effect. We know that the DASH diet has a lot of potassium in it. Not only does it have a natriuretic effect, it has a renal, it has an adrenergic outflow decrease effect, and so it has a vascular tone effect as well. So definitely I would give more potassium in certain individuals. There is a beneficial effect in reducing stroke. This has been well brought out in trials. Some of these effects may actually be independent of blood pressure lowering.
Arvind, most of the noise is from your end, looks like.
No, it isn't.
Okay, fine.
I've got a very clean laptop.
Yes. Sorry.
Yeah.
Please go ahead.
Right. Bone homeostasis. If you look at giving potassium, bone homeostasis is quite important because food enriched in potassium actually gives you a base load. and that is quite important. And high potassium may actually have a direct effect on some of the bone metabolites. Kidney stone risk is decreased. I think you may have heard the talk yesterday, excellent talk on how potassium helps. A decreased progression of chronic kidney disease. There are a few papers that show bioavailability of phosphate is decreased when with plant protein, and when you give plant proteins more, that helps decrease progression of CKD. So there are a lot of effects of increased potassium in the diet that you would want to keep potassium high in the diet for most of the population, I'd say. In CKD, obviously, we're going to have to be a bit more careful, and
Actually, I wanted you on CKD only, basically. What advice would you give to your diet? So we go back to the dietitians. So let's take Sana first. Are you permitting salads and green leafy vegetables and occasional fruits in people? I don't know,
Yes,
in people whose potassiums are reasonable, and what level of potassium are you strict?
So when the potassium levels go above that is the checkpoint we follow at the clinic. It's Dr. Ashok planning. If it goes above 5.1, 5.2, that is the only point when we get very strict. Even at that point, we have never stopped the low potassium fruits, which are the CAP-CO fruits, because then the patient feels highly deprived. If we were to give salads at that point, when the potassium levels are very high, we give them leach salads or boiled salads. We are always coming up with solutions. Maybe leaching might not, and we explain it to the patient that is not making the diet potassium free. But then we are trying to give you a favorite food with potassium restriction. So if the patient wants to have curry, we will ask him to have rice flour curry. So that is how we manipulate only if the potassium level goes above 5.2, 5.2.
So unfortunately, a lot of patients will have potassium around 5.1, 5.2 CKD patients, especially many of them are on AS, ARBs, etc., and so on. So in which case, between green leafy vegetables, salads, and fruit, which one is more likely to be permitted by you?
Depending on the patient's choice, like I said, what you want.
So give a choice.
Green leafy vegetables, generally, I would prefer not to restrict. If the patient is agreeing, once a week, even with high potassium, we allow leached green leafy vegetables, slightly leaching the green leafy vegetables. And fruit is, at least the low potassium fruit should not be restricted at all, I feel, because then the patient is, if the patient is diabetic, already the patient is not having sweets, the patient is restricting other things, and then fruit gives them that satiety, the feeling, it makes them feel good. So the mid-morning fruit, at least we don't restrict even at the highest potassium level. We try to manipulate the rest of the diet, but try and squeeze in the fruit wherever we can. Only if the patient doesn't want it, we will not give it.
So Samir Haladi comes from Ratnagiri, and he has a mango farm in his place where he stays, and he's really upset about it.
I'm from Mangalore, but
it doesn't matter. 2 minutes ke liye Ratnagiri mein reh jana yaar. What is your problem? So anyway, is there a way we can move around it, so people who like such things, and like Punjabis, they will be mad at the fact that you are stopping dry fruits. Uske bigger life kya hai? What is the point in living? Yeah.
So sir, I'll just highlight over here. See the pattern of dry fruits, the way we eat. Normally we soak our dry fruits and we eat. Most of the people. So actually, when you're soaking, you're doing the leaching part. Yeah. And again, the portion size. If somebody tells me that when I have to ask in the recall how many grams or how much dry fruit you're eating, the answer is 5 badam bhigo ke khata hu, raat ko bhigota hu, subah khata hu. So you don't need to restrict that. Again, coming to that question of yours on Ratnagiri Hapus. Sir, if you see, we have the new version of our nutritive value book, the IFCT book. In that, now we have around more than, I think, 50 varieties of mangoes which are evaluated for the potassium content. And I don't know whether you heard of this Totapuri mango.
Yes.
Yes. So that
yeah, but
has
nobody
a lower.
Eats.
Yeah, but actually it has a lower content of potassium, and probably even Hapus, if you're controlling the portion size and you're giving, and if I'm doing my diet recall and I'm doing my calculation, probably if I'm able to balance it between, when I'm giving a 40 milliequivalents diet of potassium for a patient and I'm adding that half mango, if I'm adjusting in my requirement, I think the patient will be satisfied and will be able to do justice. Because I believe that if you go make the diet plan as per the patient's preference, there you really help the person, and that is what is a job of a nutritionist. Not writing no's, but we always prefer to write the do's. That's most important.
Excellent. So I think in your party which you are going to throw at the end of 2 questions, I think Totapuri might be around. So let's see. Anita, this question is important because some of the children have, a major issue about, how do they, at that age, they don't want these kind of restrictions. In your department, do you face issues of children, rebelling against these dietary problems, and what kind of issues?
See, when it comes to handling the children, we don't really get many pediatric patients in our department, but then we do have a little bit of experience. And then, as I said, with children, we do not like to restrict much. And as I said, even for when it came to nephrotic syndrome, straight away, I'm always thinking whether to go for it or not. But in CKD patients, definitely everything has to be according to their RDA. So you can't. But definitely, if the patient is moving towards hyperkalemia, then you would have to restrict fruits no matter what. And if the patient has, I think our kids are doing pretty well, so we don't really come across so much of a problem. But then they have to be counseled on how to avoid taking crisps and all. These are the things, the fast food. And then the only thing that I when I talk to the kid, and I just tell him that you be the leader, these things are not good for health, so you tell your friends not to take them, so that he thinks that, well, this is really, it is a very good, he can be a leader, he can bring about so that is, but I didn't think we tackled so many kids.
Yeah, but
here.
it's a good point you made, that counseling the child is important, and making him realize that
I always tell him, I always tell the mother that, look, if he follows what the dietitian is telling, and if he follows what I am telling, then on every such and such day you give him a reward. So they are rewarded. I tell my kids, my patients' mothers, that you must reward your child for behaving so nicely with you. I mean, not being so you have to handle the psyche of the child and the mother. So I think that is the way I do.
So Kamal, do you feel like eating बीच में biscuits, cake, pastries, ये dietitians को छुपा के side में बैठ के, is there a time when you want to cheat on them?
Absolutely. I love bakery products like a veg puff or a cake, and on a birthday, for example. But I kind of feel very scared when I'm about to eat it because of the diet restriction. But I would love to eat it.
So Sana, how do you handle people who are alone or do not have the luxury of having people to make specific snacks which we prescribe as dietitians? How do you handle these people?
So, like Dr. Anita Saxena said, even we have this reward days for adults. I tell them that Monday to Saturday, they've been dying to have a cake or a piece of pizza. You cannot say strictly, because this is a long-term disease. They'll be on this for a very long time. So we tell them, Monday to Saturday you follow the diet. Maybe on a Sunday you can have a small piece of cake or a small piece of pizza. Portion control is more important. This works for adults as well. Apart from this, we will have other options, like we will ask them to make on a weekend. Maybe they can make a roasted poha chivda or a roasted kurmura chivda or roasted jowar puffs. That way, or we come up with recipes like rice flour shakkar para, rice flour chutney. We have all the recipes written. Depending upon what the patient wants and how he wants, we come up with solutions. But then we do have certain cheat days, and sometimes we modify the cheat. Like if they really want to have the pizza, we look at the topping with paneer. We make the base with arrowroot, that way. So we formulate recipes for patients. We come up with ideas, so that way they don't feel deprived. But nevertheless, if they want to visit Domino's with their friends, maybe a youngster who is 21-year-old and is battling CKD, on a Sunday maybe, but then we educate them about portion control. Then we tell them that you can go, but portion control is very important. Don't have coke with it. So that way I have messages almost every Sunday, that I'm going to this place, I'm going to this place. Then I come up with ideas what they can have. If they're going to barbecue nation, I have ideas, like I'll just try and figure out what they can have there. You cannot always say a no. Then they feel then they have withdrawal symptoms. Then they don't trust in you.
So I think we are almost reaching the end of it, and therefore Zamrud is throwing a party for CKD patients, and all of us are supposed to barge in. Zamrud and Sana will make the menu. Sana will handle the kids whose birthday celebration is there, and Zamrud will handle the adults. I don't know Daru is allowed or not in that party, but we'll come to that later. Yesterday was a dry day. Today, I think it should be allowed. Zamrud and Sana, it's all yours. The stage is there for a party. Let's celebrate.
So, if you ask me, sir, I have really worked very closely with patients, and now I have started working very closely with caterers, because we realized that a lot of people need restrictions. So now probably we have started developing menus for parties. So you all are welcome. We normally work with these caterers, we give them the recipes. For example, as Sana was already highlighting, we get the pizza bases made, we get the toppings done. So probably, as we've already discussed about the protein restriction, we do not have to use much for Indian people, so we do use cotton cheese, or we use cheese for our pizzas. Again, we have a lot of roasted snacks that we are making today, and in the market, unfortunately, you do get roasted snacks, but that is not the minus the salt. But at least at Mumbai, if you approach a Cheda store, which is a chain of stores, and if you give your orders for a salt-free snack, because many times you don't need roasted snacks, you need the normal snacks, but only thing is the salt needs to be modified. Probably for most people, you can order these snacks today. So people who are staying separate, or matlab, who are staying alone, you have options today available, and you don't have to feel deprived. You can modify everything. It's very easy to modify. Only thing is, we need to understand what are the likings of our patient, and yesterday that was the reason of doing the regional diet menus.
Yes.
Region wise, we are very specific with our foods and spices. So if we are able to modify that as per the liking of the patient, I don't think we will have any patient cribbing, and we can always enjoy parties.
Yes, I think Sana, we are about to close, but this child has a birthday celebration, and the mother says, "Khali idli leke jao school mein." Can he?
Okay,
and all the other kids have taken cakes, pastries, etc. Abhi kya karne ka? What do you?
So at
Sana, you're muted.
At present, I'm already handling a kid. So the other day I was talking to him, and he's telling me, "Yeah, restriction." I said, first of all, get the kidney disease out of your head. You are a normal kid. Now tell me what you want. What you want to eat, and I will modify it. Everything from idli chili to paneer chili, everything, chicken chili, whatever you want to eat, I will modify it to you. I will minus the sauces and use the spices. I will minus the base and use arrowroot. Whatever, I will first make sure that the kid is not treated as a renal kid. It is very sad, to see kids being called as patients. So first, get it out of your head. He was so happy, and he said, "I want French fries." I said, "I'll go ahead. I will make that for you. I will leach the potatoes. I will do that for you. But tell me what you want to eat, and I will modify." That is the role of a dietitian, to modify the diet. That is where the talent comes in.
I think beautifully put in. I always said that Sana has that knack of, being practical and things like that. So I think I will not give the summary. If any of the patient wants to have one, half a minute to finish, because it was a patient-centric talk. So if you feel you want to add any points, both Kamal and Samir, as to what advice do you have for nutritionists and nephrologists about handling patient-centric diet? Otherwise, I think.
Yeah, can I come in here?
Yeah, please.
So I think the bottom line of this topic is give workarounds rather than blanket restrictions, like Sana just said. If they want to have, figure out, like even Coke, for example, right? I'm not saying that let them have 1 liter or 300 ml. Let them have 100 ml, restrict other things on that day till the next session, right? So workarounds is what should be given rather than blanket restrictions. That's all I would like to say.
Very good point. I think with that, we close, and first of all, I apologize being a little rough, and just basically because we wanted to cover up a lot of sessions, a lot of topics, so that the topic becomes relevant to whatever is given to me. And I must really thank. It's very difficult to be a panelist. It's easy to be a moderator. And thank you so much for so exceedingly well this whole topic has been covered. And I hope we've done justice to the topic. Thanks.
Thank you.
Thank you, sir. Excellent session.
Thank you all. Thank you very much for the session. Thank you.
Thank you.
So wonderful presentation.
It was great being part.
Great. We had real fun, sir, and very well conducted. So without any further ado, I'll move on to the next session. But please remember, now we again split into Hall A and Hall B. So Hall B, we will cover hemodialysis, and in Hall A, we will continue with the critical care symposium. So for the first talk, let me invite Dr. Arpita Rai Chaudhary ma'am. It's a privilege to invite her to chair the session. I've worked under her. She's an astute clinician, a wonderful teacher. She is the professor in the Department of Nephrology and Institute of Postgraduate Medical Education and Research, Kolkata. And Dr. Suratkal sir, a consultant nephrologist at Leelavati Hospital and Research Center. The session is all yours, ma'am. Please introduce the speaker and we can start.
Arpita can do the honors.
Good morning, everybody. Dr. Ratan Jha, who is a senior consultant nephrologist of Virinchi Hospital, Hyderabad, and a good clinical researcher. We all know him for a long time. Multiple times I have heard his talks in the national forums, and he is also a teacher of very high repute. So may I invite Dr. Jha for his deliberation.
Can I share my slide?
Sure, sir.
Is my slide visible now?
Yes, sir. Please put it on slides mode.
Am I audible?
Yes, sir. Please continue.
Good afternoon, everyone. It's an honor to be invited to talk on a very important topic, which was not been a focus in our day-to-day practice till long, and now we have realized that we need to be also looking at the aspects of nutritional care, and this topic being given has made me more enlightened how to look at the nutritional issues in the context of critical care nephrology. So my topic is nutritional evaluation of critically ill patients who have reduced renal function. It is very important to realize that the reported statistics of malnutrition in a hospital setting is very serious, that every third patient in a hospital or an ICU has some degree of malnutrition. Awareness among health professionals like me and many of us is quite poor, because most of us ignore this parameter in our treatment because of inadequate training in the past. There is a huge gap between our knowledge and the real practice of the ideas for nutritional care. We have less focus on dietary intervention and more on the medical interventions in patient care. Nutritional care in our day-to-day practice suffers from the lack of division of responsibilities between doctors, nurses, dietitians, who are not working often as a team in this context, and hence this forum is probably the right forum to at least bring awareness among the interactions between the different specialists who take care of such issues. It has been reported that patients in ICU are at very high risk of nutritional deficiencies. Every critically ill patient who stays in the ICU for more than 48 hours is considered to be at risk of malnutrition. It is said that patients who come to ICU in the beginning are having 1/3 of them are having some form of malnutrition, and if they are not focused so far nutrition is concerned, the remaining at least 1/3 of patient again develops this protein energy wasting by the time they leave ICU. That is, this problem is quite common in an ICU setting, and it has to be focused. Medical nutrition therapy there should be considered for all patients who are in the ICU, mainly for more than 48 hours. So as a clinician, when we look at the malnutrition in a patient who is in the ICU or in outside the ICU, we try to look at the patient as a type 1 malnutrition or type 2 malnutrition if they have any form of malnutrition. Type 1 malnutrition can be considered to be a kind of malnutrition where there is no inflammation or very mild inflammation, with malnutrition basically associated with starvation kind of situation, that is person eating less. While the type 2 malnutrition is a situation where patient has a lot of inflammation and comorbidities, which is difficult to treat, and it is the thing which is associated with high risk of mortalities if not properly addressed. So this is maybe a clinical setting to look at when we look at a patient for nutritional care. We look at it whether he has or she has a type 1 or type 2 malnutrition in a simple way. So when we look at the nutritional assessment, the aim of this assessment is to identify at-risk patient or malnourished patient so that we can reduce the complications which are associated with malnutrition, like increased incidence of sepsis, bed sore, the increased incidence of treatment failure, that is failure to wean the patient out of the ventilator early, poor wound healing, mortality related to arrhythmia, bleeding, and many multiple factors which contribute to mortality, increasing length of hospital stay because patients remain in the ICU because of hospital as well, because of ventilator requirement, and because of this, the healthcare costs. And that is the reason we need to focus on the nutritional assessment. So the goal of nutritional assessment as well as management is to prevent the basically protein energy wasting in ICU setting, to avoid complications and reduce or prevent mortality by improving wound healing in the surgical setting, improve the immune functions by appropriate diet, minimize inflammation by appropriate interventions, improve the antioxidant activity, the diet that are available, and based on these kind of consideration, we can improve in the endothelial function and increase cardiovascular mortality. And that is the basic goal of our nutritional assessment. So in this context, when you talk about nutritional care, it is a two-step process. The first step of nutritional care process is to do a screening. It is a nutritional screening, which is just like a QSOFA or quick SOFA that we commonly employ to assess whether a person requires hospitalization or ICU admission. So nutritional screening is the first line process to rapidly and accurately identify patients who require a more comprehensive nutritional assessment if that is so. And the tools for nutritional screening are listed in the slide. The commonest tool that is employed by all our dietitians in our hospital is nutritional risk scoring, the NRS scoring 2002. Though another kind of score is also possible to be employed, that is the malnutrition universal screening tool or MUST tool. 3 or 4 tools are mentioned just to complete that. The tools which are available in the literature, like nutritional risk index, geriatric nutritional risk index, many nutritional assessments, short form, and malnutrition screening tools. There are many other tools which are there, but for all practical purposes, when we are trying to screen a patient, the NRS 2002 is the commonest nutritional tool which is employed, followed by the MUST tool that we are going to discuss in the subsequent slide. So that was the first step of nutritional assessment, that is we try to nutritionally screen and decide which patient requires a detailed assessment by the nutritional assessment chart. The nutritional assessment detail is the second step of nutritional care, where we try to identify and quantify the specific nutritional problem. And the tools which have been developed to look at this nutritional assessment in detail are listed in the slide. That is subjective global assessment. Basically, it is utilized for hospitalized patient, and this is also utilized in the ICU care setting and is recommended by the Indian Indian Organization of the Critical Care, that this is the tool which can be employed in our day-to-day practice. There are other kinds of tools like patient-generated subjective global assessment and mini nutritional assessment for the elderly, but is hardly used. The other tools which are mentioned in the literature, other than this subjective global assessment, is a Nutric tool for the ICU patients. And in a dialysis setting, dialysis malnutrition scoring as well as malnutrition inflammation scoring has been also discussed, but they are all the research tools and which are not practically used. So coming to the important first screening tool that we talked about, the nutritional risk scoring 2002, which is employed in our hospital by our dietitian and maybe getting used in many other settings, is a simple tool to use, where we look at 2 parameters. One is the nutritional status, and other is the severity of disease which required hospitalization. And each parameter is given a score of 0, 1, 2, and 3. Like 0 is there is no nutritional abnormality. Mild one is the weight loss of less than 5%, or a BMI in the right range. Moderate or the score 2 is when we find that patient has a weight loss of more than 5 to 10% in 2 months' time, or a BMI between 25 to 18. And score 3 is the other extreme. Similarly, the severity of the disease is scored as 1, 2, and 3. For example, a patient of renal failure with chronic hemodialysis patient getting hospitalized will have a score of severity of disease at least 1. And if he's on ventilator and other things, his severity score will become 3. So this is how we try to look at it very cursorily to decide which kind of nutritional risk that patient is having. And any person who has more than 70 years, one more point is added. And based on this addition of this points for nutritional status, severity of disease, and age, person is categorized as a high risk or a low risk. Any person who has a scoring of 0 to 2 has to have a kind of assessment every week because he's a low risk patient. But any person in the risk category of 3 to 7 needs to have a detailed assessment that is basically the subjective global assessment. The other tool which can be used as a screening tool is shown in the slide. That is the MUST tool, which is a simple tool which can be also employed even in the OPD setting. That is step 1 and 2 and 3, where we look at the BMI, look at the weight loss in last 3 to 6 months, and look at his eating habits. That is either he is able to eat or not for last 5 days or more. And based on the points 1, 2, and 3, we try to add up to make a risk calculation. That is a low risk patient is one who has all the parameters in the good range. Medium risk is a person who has at least 1 point in all these 3 kind of steps. Or 2 is the situation where the person has more than 1 parameter abnormal. And persons are graded as low risk, where which requires a routine clinical care. A medium risk, where person has to be observed more closely. And the high risk, where person has to involve a dietitian to look at how to take care of his dietary risk. And this is also a kind of tool which is not only utilized in the ICU setting, but it can be utilized in the OPD setting, as even the nursing hospital in a small care settings. So that was about the screening tool. But when you try to look at the screening tool and decide to go for a next step of assessment, that is a person who is at high risk, these are the tools which are utilized for detailed nutritional assessment. The first concept of nutritional assessment is anthropometry and body composition. The commonest kind of parameter which is utilized for anthropometry is height, weight, and the body mass index. Other things in the anthropometry like skin fold thickness and mid-arm circumference is also utilized in certain settings, and particularly research setting and when you're doing a thesis work. DEXA, that is BIA, that is our total body nitrogen, ultrasound and CT are reported as a kind of tool to be utilized for body composition, but it is not a common tool that is used in day-to-day practice. Biochemical parameter is another kind of tool which is utilized for nutritional assessment, and the lab values, particularly of albumin or a pre-albumin, is utilized to decide which way the person has to be scored. In the clinical category of nutritional assessment, we look at the symptoms of particularly his food intake, the appetite, and the signs which could suggest the person has a kind of malnutrition, and the clinical stress points to decide which way to assess the symptomatology. We try to look at the dietary intake by the interview, recall, and many times if the person is stable in a chronic setting, we can collect the 24 hours urine to assess the urine and nitrogen appearance, because that gives an idea about the protein intake. And all these parameters are ultimately included in the SGA tool, that is the subjective global assessment tool, to come to a conclusion. And the urinary nitrogen appearance that we spoke is occasionally utilized to categorize the patient as a catabolic state, or trying to look at what is the amount of protein the person is taking. The complex or advanced methods of nutritional assessment is occasionally used in research settings, where we try to look at the body composition, like the neutron activation the tool, or DEXA scan, or the NMR spectroscopy, or bioimpedance the anthropometry, which is being utilized in certain advanced center to look at the body composition. So coming to the most common tool that is employed in all the settings where the nutritional assessment is done is the subjective global assessment, which employs at least 5 parameters in the history, that is the weight change, change in the dietary intake, change in the GI symptomatology, the functional capacity of the patient, the link between disease and nutritional requirement, which is basically stress factor, and looking at the physical examination, which are focused to nutritional deficiency, and patients are given a label of category A, B, or C. A means person is having a kind of is well nourished, or SGA A category is well nourished patient, SGA B category is moderately malnourished patient, and SGA C category is a severely malnourished patient. So A, B, and C are the usual abbreviations which are utilized, but occasionally these categories can be scored based on the score from that is from 1 to 10. We can put the scoring in all the categories, and a person who has 6 to 7 points in each category is category A, 3 to 5 points is category B, or 1 to 2 points is category C, and that is how either you can go a subjective way to look at A, B, and C, or slightly more objective ways to score the patient and categorize the patient as SGA A, B, and C. So all these factors are revolving around few common things that we commonly look at in our day-to-day practice. So what is the weight of the patient? Because it's very difficult to remember so many formulas which are already there in the textbook or which may be utilized. But I found that Broca's formula, which is there in our textbook of preventive and social medicine, quite handy, that we don't have to remember anything. Height in centimeter minus 100 is the expected or kind of weight for the patient if he's male, and 0.85% of that calculated figure should be for female. And that is the weight that we look at in all our patients to decide whether a person is underweight, overweight, or needs to be focused on that. There's a term called adjusted body weight. When we utilize this adjusted body weight, when we find that body weight is extreme, either too high or too low, particularly in dialysis patient, and then there we try to calculate the adjusted body weight by a kind of formula which is ideal body weight into 0.25 and observed minus ideal. So that was about the concept of weight that we normally utilize in our day-to-day practice. Then we try to look at the weight and height ratio, which is the commonest kind of anthropometric data for our analysis. And we analyze the person as mild nutrition, malnutrition, moderate malnutrition, and severe malnutrition based on the BMI, which is below 18.5. And any BMI above 23 is considered to be overweight, and more than 25 is obese. Underweight and overweight both are considered as malnutrition. The third thing that we can employ in a situation where we are not able to measure the height and weight in a patient, we can look at the mid-arm circumference, which is easy to measure, and it is said that any person who is a male and has a kind of mid upper arm circumference less than 23 is malnourished, and that will be corroborated by the BMI and other parameters. And female below 22 is a kind of centimeter is a kind of factor which is considered as malnutrition. So when we look at the weight, we try to calculate the weight based on the chronic weight loss or acute weight loss. The chronic weight loss is a weight loss over 6 months, while acute weight loss is the weight loss over 2 months or 2 weeks. And this is 5, 10, and more than 10 is the category of scale for mild, moderate, and severe kind of weight loss. So, but we need to understand that when I'm looking at this anthropometric data and the biochemical data, these markers have this limitation, particularly in kidney disease patients, like the albumin, pre-albumin cholesterol may be altered by inflammation. Similarly, the body weight can get altered because of the fluid overload. Anthropometric data like the muscle mass, etc., could be difficult to analyze in a person who is fluid overloaded. Energy expenditure formulas, which we will discuss in the subsequent slide, may not be valid in a very catabolic setting. SGA score, that is the subjective global assessment data, has not been fully validated in AKI, but it is the common kind of tool that is applied. And the body mass composition that we talked about, by looking at the bioimpedance analysis, CT, MRI, etc., are not been validated or not available. And hence, these kind of parameters are basically to give a talk, but not is easily employable. So in a ICU setting, we try to look at a patient from the nutrition standpoint into a moderate to severe malnutrition based on the phenotypic criteria that we talked about, the weight, body mass, and the muscle mass, and the other criteria of etiology based on his food intake and the disease inflammation. And then we categorize the patient as SGA A, B, or C. So in the context of acute kidney disease or chronic kidney disease in an ICU setting, if you find that one of the parameters in the biochemistry like albumin is below 3.8, or one of the parameters of anthropometry in the form of weight loss or body mass index is below the target range, below 23 BMI, or a person has a poor dietary intake in the form of less than 80% of the dietary protein intake or calorie intake, he or she is having a malnutrition. There is another kind of tool which is being talked about in the ICU setting in the research kind of this report, that NUCTIC scoring is basically a better tool in critically ill patient, which encompasses various variables like age, Apache score, SOFA, number of comorbidities, number of days in ICU, or interleukin 6. And based on this scoring, person can be categorized to have either a high score or low score. If IL-6 is available, we add. If IL-6 is not available, that is interleukin 6, we have a different kind of scoring. But this kind of scoring are not used in our ICU practice, because many of the parameters are not checked. Many of the parameters are dependent on the doctors, and maybe the nutrition may not have a kind of availability of those information. And hence, they employ still the SGA scoring even the ICU setting. So we categorize the patient as catabolic or non-catabolic from the clinical standpoint. A person who has infection, acidosis, or multi-organ failure is having a catabolic kind of ARF and will require more kind of care compared to non-catabolic patients like post-renal AKI or pre-renal AKI, which can be managed with the enteral nutrition. So we classify the patient as catabolic or non-catabolic based on the urea nitrogen appearance, and urea nitrogen appearance can be multiplied by 6.25 to get a protein that person is consuming, and NPCR is another way to look at the parameter. So patients with AKI are considered as mild, moderate, or severe renal failure and categorized into 5 to 10, more than 10 based on the UNA appearance. And we try to give a different kind of calorie intake as well as this amino acid intake and glucose. So when we look at calorie, we try to go by a simple calorie calculation of 25 into weight, but there are many kinds of gadgets which are available which can easily calculate how much is the calorie required for such patient. So nutritional requirement per ARF is shown in the slide that we at least have to focus on 20, 30 kilocalorie of energies, with appropriate carbohydrate and fat, and give at least minimum of 0.6 to 8 gram of protein. But in a patient who is on extracorporeal therapy requires higher protein. In contrast to the protein restriction and calorie restriction in patient on dialysis, we need to at least look at our patient who are in pre-dialysis phase, who are chronic. We give higher calories between 30 to 35 with the protein as is recommended by the various guidelines in the range of 0.6 to 8 in the pre-dialysis phase and 1.2 to 1.5 in the dialysis phase. So to conclude, when we are looking at the patients for analysis of nutritional parameters, we need to identify the patient who has risk by screening tools that we talked about, the NHS 2002 or a MUST tool. We need to assess the patient in detail if you find that person is at higher risk by a kind of subjective global assessment tool, or if possible, the Nutric tool in the ICU setting. We need to categorize the patient as a catabolic patient or a non-catabolic patient based on clinical profile and UNA. Give a nutritional diagnosis based on the patient as this SGA, ABC, AKI, and HRS. Suggest target and follow up periodically with oral, enteral, partial, parenteral nutrition or total parenteral nutrition with optimal energy and other components. Thank you.
Good talk, Dr. Jha, and finished in right time, I think. And one question to you, that when you look at a critically ill patient in ICU, I think you have recommended SGA rightly as the possible clinical screening process, by which you can, and regarding this catabolic and non-catabolic, it is very difficult to get urinary urea nitrogen because it is not regularly done in the clinical practice setting. Even in academic hospitals, it's rare to have that unless you run a project. Yes. So for critically ill patients, we always recommend enteral nutrition. What are the areas when you restrain enteral nutrition or refrain from enteral nutrition for a few days, or you always allow enteral nutrition?
This is a very valid question, because we are also trying to understand how to give the nutritional therapy. It is said that whenever a person can be given oral nutrition, that's the first line. If he cannot, you have to give enteral nutrition. If that is not meeting the goal, then we may have to go for parenteral nutrition. It is said that 80% of the target should be achievable in after 24 to 48 hours of ICU admission. And by 7 days, if we are not able to achieve the target, probably we have to go for a partial or total parenteral nutrition. TPN is a very complicated area, and which is usually done in a situation of multi-organ failure when person is on multiple kind of supports, and when the inotropic support is not permitting the patient to take the enteral feeding, that time probably we have to give a parenteral nutrition. That is the concept that we get.
Probably this is the answer. I also feel so, and do practice in clinical setting like that, that whenever the vasopressor goes too high, we refrain from the enteral nutrition, and when we can get down the vasopressor, probably we can again go back to enteral nutrition.
Yes.
Thanks, Dr. Jha. Probably time restriction is there. We have a lot of things to understand in this critical care area. I think in several sessions, we will be revealing those. Thank you all.
Thank you.
Ma'am, thank you, sir. It was a wonderful session, and taking it forward, we will now move on to the next lecture, which will be chaired by Dr. Deodat Chafekar sir, Director and Consultant Nephrologist, Supreme Kidney Care, Nashik, Professor of Medicine. Also co-chairing with him will be Dr. Mukesh Shetty, Nephrologist and Transplant Physician from Apex Kidney Care, Mumbai. Sir, the session is all yours.
Yeah. Good afternoon. Am I audible?
Yes, sir.
Yeah. After having looked at the nutritional assessment of a patient who is critically ill, I think it's time to talk about the management of a critically ill patient. And interestingly, there'll be two talks here. One would be the nephro perspective, and the other would be the intensivist perspective. So I guess that there is some difference in thinking as far as this particular aspect of management is concerned. And to take us through the nephro perspective of nutritional management of a critically ill patient with reduced kidney function is Dr. Rajshekhar Chakravarti, who's a Director of Nephrology at Star Hospitals, Hyderabad. And he's a very accomplished speaker, and he successfully organizes the AKI conference every year. And he's also a member of the AKI committee, faculty of ADQI, and the International Society of Nephrology. Over to you, Dr. Rajshekhar.
Thank you so much, sir, for those kind words. It is this is a topic which most of us are not very comfortable talking on. Whenever Dr. Umesh Khanna asks us to deliver a talk on a topic, we are sure he wants us to learn more about this topic. That is the reason he chooses us to discuss this topic. Can you see my screen?
Yes, you are visible.
Okay. So as my friend Dr. Jha shared with us, this is a complex situation. You see this particular patient who is in front of you. He was a young man of 32 years who came walking to the hospital with toxic fumes inhalation. Went on ventilator, went on CRRT, was on ECMO, and also had an endotoxin filter, as you can see. So this patient walked home after 2 weeks, coming off all the supports. So if somebody needs a success story like this, apart from our knowledge for dialyzing a patient or treating them in all the other aspects, nutritional management is also equally important. You see this patient post CABG, he is on a cycler peritoneal dialysis. So there can be various modalities of what you do to a patient when a patient comes under your care in the ICU. Our present knowledge is very clear. There are a lot of metabolic changes in AKI, which lead to increased resistance to anabolic signals and insulin, very high stress hyperglycemia, and increased levels of inflammatory mediators. Now, these contribute to a particular internal milieu, what we now understand as malnutrition, which is peculiar to a critical care patient with AKI. So we know what leads to this malnutrition, the premorbid conditions the patient has, severity of the disease, including the stage of AKI, and the process of care, what you and I do to the patient when the patient is in the hospital. We also know what it results in. We know that it results in very low serum albumin. We know it results in loss of weight, loss of body fat, increased mortality, increased hospitalizations, and also permanently changing the vasculature of the patient, even though there was only a single episode of AKI. So when you talk of malnutrition in kidney disease, we now know there is a significant component of inflammation and increased energy expenditure, stress hyperglycemia, and negative nitrogen balance. So all this together is now coined into a term called as protein energy wasting. So it is a term proposed to refer to the combination of negative metabolic consequences of acute loss of kidney disease on nutritional status. This is important understanding for you and me who are taking care of patients in the ICUs, because when a patient gets into the hospital or the ICU, the primary diagnosis could be a neurological reason or a gastrointestinal or an orthopedic reason. but the outcomes and the mortality are determined by whether this patient had AKI, and if he or she had AKI, the severity of AKI. The reason for this is what happens to the protoplasm with one episode of AKI. So this is a study which was looked at patients who had a single episode of AKI, followed up for 2 years. And during this time of 2 years, they behaved very differently. They died more often. They came back to hospital more often. They had more infections. So one episode of AKI changes the internal milieu. And we now know that there is a distant effect of AKI on all the other organs. And we also know what are those inflammatory mediators which actually change the other organ function. In other words, we know that when you have a patient with AKI, it is not a single organ disease, it's a multi-organ disease, and it continues to be so for a very long time after the AKI episode is over. And the present understanding is whatever we discuss now, the protein energy wasting syndrome is one of the main reasons for the internal inflammation and change in the internal milieu. My friend Dr. Jha spent some time on the details. So we have a definition for protein energy wasting, and it includes biochemical, body composition, and dietary intake. I don't want to go into the details for lack of time. So we understand now when you have a patient with acute kidney injury and a protein energy wasting, the comorbidities determine, they contribute to this. The critical care illness determine and contribute to this. And also the acute kidney injury by retention of uremic toxins and inflammatory mediators, fluid retention, gut edema, and of course, nutrient losses when the patient is on dialysis. So can we avoid protein energy wasting in AKI is the question. By our small discussion so far, we know the worsening nutritional status is a result of many mechanisms, inflammatory process and catabolic factors. It is not a direct effect of nutrient intake. So nutrition can only improve the protein and energy balance, possibly change the protein synthesis, but cannot suppress critical care illness-induced catabolism fully. So how do we approach diet in AKD in our patients? You have to look at the caloric intake, you have to look at the protein intake, salt and water, micronutrients, which includes vitamins and minerals, and also the renal minerals, which includes potassium and phosphorus. There was some discussion on this in the previous session. So how much calorie do we give? Though energy expenditure is higher during critical illness, but there is enough knowledge now and data to support underfeeding is not going to help your patient outcomes. Neither overfeeding is not going to help your patient outcomes. So how much calories do we give? So we need to know some idea about resting energy expenditure, and based on that, you want to give the calories. There have been a lot of data about, even from India, some elegant studies which talked about calculating what the patient needs vis-a-vis energy is concerned. But I should mention, most of us do not do this, though there is a strong data to say the gold standard is indirect calorimetry. I can give you several excuses why we would not do it in our patient bedside. Most of us are comfortable. Though the recommendations talk about indirect calorimetry, we are comfortable moving away from this formulae and going on to what is called as a weight-based consensus. In the absence of indirect calorimetry, the published predictive equation or simplistic weight-based equation of 25 to 30 kilocalories per kg per day can be used to determine the energy requirements. And that is what most of us do in our patients in a day-to-day basis. So we need to understand in the early time and the late time or late phase, the first 1 or 2 days, we call it as acute phase, early period, whereas 3 to 7 days, we call it as acute phase, late period. And after 7 days, we call it as a rehabilitating phase or a chronic phase. So in the first 1 or 2 days, it is suggested to give you hypocaloric nutrition in the early phase of illness, and then progressing slowly to 80 to 100% of the energy expenditure. So if you look at simple 25 to 30 calories per day, you can start off in the beginning with less, 20 to 25, and then go on from 25 to 30 kilocalories per kg per day. There is no evidence that caloric target should be different in AKI patients with or without RRT. But in patients with CRRT, please note, If you are using citrate, that can contribute to your calories. Similarly, I showed you a patient on PD, the dextrose can contribute to calories. So you need to take this into consideration. So this is a paper from Osterman, and we will go back to her every few slides. So the recommendation is in patients with AKI, start at 20 to 30 kilocalories per kg per day in the first 1 or 2 days, and then step up a little more. And there is no reason to have it any different from other ICU patients. So the level of evidence is 5, which is expert opinion without explicit critical appraisal. Most of the nutritional recommendations would be fitting into this. So let me show you the data from Renal study, which showed that among all the 1,456 patients who were in the study, when they looked at a stable caloric intake, this was achieved only 4 to 5 days after randomization. And the mean calorie intake daily was 11 kilocalories per kg per day. I'm talking of the best of the centers in the world, and this is what the facts were. So it is important for you and me to look at how much calories and protein we are giving to our patients. Coming to how much protein to give. Too much is not good, too less is not good. We already talked about it. And the main reason for this is when you think that you don't want much urea generation and give less protein, you actually end up generating more urea because you are breaking down the patient's muscle mass. Similarly, if you give more protein, you are again increasing the urea production. So there is some sort of a consensus, even if you look across all the recommendations from various societies, starting off at 1.2 and a maximum of 2 grams per kg per day. So if you look at the Aspen, they suggest protein of 1.2 to 2 grams per kg actual body weight per day, and no need to consider a special formulation unless electrolyte abnormalities are present in the patient. In those who are on a dialytic modality, the recommendations do talk of increasing the protein intake by 0.2 grams per kg per day. So what started off as 1.5 grams per kg could go up to 2, but categorically, there is no benefit of protein to be more than 2.5 grams per kg per day. The main thing that you and I should understand is protein should not be restricted in patients with renal insufficiency as a means to avoid delay in initiating dialysis therapy, because this has poor outcomes. Going back to Marley's recommendations, in patients with AKI, you can start off with 1.3 grams per kg per day. In critically ill patients, 1.5 grams per kg per day. Those who are on dialytic modality, this can be increased by supplementing another 0.2 grams per kg per day, maximum going up to 2 grams per kg per day. So again, looking at the renal study, which is again our nephro patients with kidney injury, the dietary protein intake daily was as low as 0.5 grams per kg per day. So this emphasizes to us, you and I should spend some time, just like you write a dialysis prescription, a nutritional prescription, interacting with the intensivist and the dietitian, ensure there is a default prescription of protein and a default prescription of calorie to your patients. What about vitamins and trace elements? Supplementing micronutrients during a RRT are important. This is again Marley's paper, Marley's group, which published it. And this is the rationale for this is at least 2 different studies. One is from Emory, which looked at 75 patients. They found loss or decrease in micronutrients in several of patients, especially if they were on dialysis. So in a way, to conclude, there is no single nutritional tool sensitive or specific enough to look at the non-nutritional factors influence in our patients, because they have many other things like inflammation and fluid overload. But one of the main things you and I need to go home today with an understanding is, you have a patient with AKI, it is the background comorbidities and the nutritional status which has brought that patient to you. There is a significant understanding. The earlier nutritional status, when a patient comes into ICU in front of you, they already are malnourished. And when you take this patient during the next 7 days of treatment of AKI in the ICU, what you do to this patient, including the calorie and protein intake, determines the outcomes not only short term, but also long term. I'm going to switch gears a little and talk about progression of AKI to CKD. And many of us now fully understand there is no episode of AKI which fully recovers, partly because we are not taking care of all the due processes, including nutrition, to these patients. If you look at the disease modifiers of AKI progression to CKD, one of the things which is important is the serum albumin of the patient determines the outcomes of recovery of the kidney. So if a serum albumin is very low during the process of care of AKI, or when you are dialyzing these patients, that is known to be an independent risk factor for kidney not recovering and going into a chronic kidney disease. Most of us now understand this model of progression to AKI to CKD, one insult, second insult, third insult, but it's the nutritional status pre-admission during the process of care that determines the outcomes to many of these people. At least there is a significant contribution of nutritional status to the outcomes. So we understand today AKI, then which is up to 7 days, AKD, which is up to 90 days, overlapping with onset of CKD. Most of our patients go on to this, and my single important job today would be to draw attention to the fact we need to give importance to nutrition as much as we give to antibiotics or dialytic prescription, because it determines the outcomes of our patients. Let me stop with just mentioning these are the Aspen guidelines in 2016, and I'll be repeating. All patients are at risk of malnutrition if they stay for more than 48 hours. Start enteral nutrition after initial stabilization unless there is a specific contraindication. Aim for 20 to 25 as a default prescription of calories, and 1.2 to 2 grams as a default prescription of protein in all our patients. In those who are on some form of replacement, renal replacement, consider another 0.2 grams per kg per day additional protein to be given. Do determine what is the micronutrients that have to be given to these patients. They do suggest avoiding enteral nutrition only if there is a hemodynamic compromise with stiff inotropic requirement is there. This is true with many other societies also. It will be almost like repeating the whole thing. So the take-home message would be, a patient comes to you, please have a default prescription on board as soon as the patient is there for the first 2 days, which can have a little hypocaloric supplements, but subsequently you need to go close to 80% or 100% of the energy expenditure. And protein have a default prescription which starts off at 1.2 to 1.3 but then goes on up to 2 grams. And if the patient is on RRT, you need to supplement another 0.2 grams per kg or so. Let me finish by just referring you to the papers. How to feed a patient with AKI. This is Marlis Osterman and ETNA. Most of you must have met both of them when you were in Hyderabad for AKI meetings. They are here every year, and they have done a beautiful job of putting up all the rationale and the recommendations one by one in patients with AKI and those with general ICU patients, including calories, protein, and vitamins and trace elements. This is the other paper, again from Marlis's unit. They looked at their patients over a period of 1 year and saw what was their micronutrient level in the blood and also in the dialysis effluent, and they concluded whether the patient is on RRT or not. You should be considering supplementing micronutrients to these patients, because all these ICU patients had a loss of B1, B6, B12, vitamin C, D, folate, selenium, zinc, copper, iron, carnitine, and many other things that they have prospectively looked at in these patients. This is a paper, nutrition support in critically ill patients with AKI, from our own cohort of patients. This is by Dr. Ramakrishnan's group in Chennai. Very crisp and very useful for day-to-day practice. And finally, this year, 2021, ESPEN guidelines on clinical nutrition, published in Clinical Nutrition, talk about entire list of do's and don'ts, which I think I can skip because it is more like what we have just discussed, including the term of protein allergy, malnutrition, different dialysis modalities, what happens to nutritional parameters. Only thing different would be they did talk about the futility of giving specific things, including omega-3 fatty acids. There is not enough evidence to support routine use of omega-3 polyunsaturated fatty acids in AKI, AKD, CKD, even with dialysis requirement. And similarly, they have asked us not to consider using glutamine, which is done in many of the units. So to conclude, if you have a critically ill patient, please look at the comorbidities, what is happening on that day. And the Marley's data clearly talks of 45% of people who come to you already have established malnutrition. Carefully look at what is the comorbidities and inflammation and the disease-related malnutrition, which can be already there, then which also sets in the minute you start the patient on any form of therapy. So keeping this in mind, you should consider a default prescription to be on board in your unit and then modify it over the next 24 to 48 hours. Thank you very much.
Thank you, Dr. Rajshekhar. That was a brilliant talk and it was very practical for all of us. Before I ask Dr. Mukesh to give his comments, just one or two practical points I want you to comment on. One is the volume. Most of the AKI patients, we struggle with the volume and we want to give adequate calories in a very, very low volume. And the second issue is about the severity of metabolic acidosis, because they also have lactic acidosis in addition to the uremic metabolic acidosis. So just your comments on that.
Thank you, sir. One, the volume, I think when we talk of a default prescription of nutrition, it has to be taken into account what is the demand on the patient for the next 24 hours and what is the capacity of the patient. And as you would have seen, the latest precision approach to RRT in the ICU from the ADQI also, they want each patient to be looked at individually on that day when you do your rounds or when the intensivist sees this patient in a demand capacity paradigm. Your patient may have 1.5 liters of urine output, but what you are planning for 24 hours, including the transfusions and all, may go up to 3 liters. So when your demand on the patient is going to be much higher than what the capacity of the patient, you need to consider an early start of RRT or any other modalities to remove the volume. So I would not restrict the volume to reduce any nutritional support because the patient's urine output is low. So one of the statements that I made, part of the guideline was never reduce protein intake because you want to delay dialysis. Similarly, I will not reduce the volume which I want to give my patient. And if the patient's capacity is not good enough to empty it from his body or her body, I would start a decongestive modality much earlier. So I think that goes without saying, whether it is volume or protein, you will not restrict just to delay a modality. As far as acidosis is concerned, the session before this did talk of what type of nutrients cause more acidosis. So I think we need to take the help of the nutritionist and plan in such a way that we don't cause additional acidosis. I am aware why you asked that question. There is a lot of data of late talking about the metabolic acidosis we cause when we prescribe something. I think we need to take that into context before prescribing it. Thank you very much.
Dr. Mukesh.
So I must say that a real complex topic has been simplified by Dr. Rajshekhar. And of course, when it comes as AKI or any of such heading, we normally talk about proteins, micronutrients, etc. I just wanted to ask Dr. Rajshekhar, what about the fat intake? Because they say that in critically ill patients, there is reduced fat clearance and decreased lipolysis. But the most calories are actually easily obtained by fat. So what should be our goal for the fat supplementation in critically ill patients?
So at least as far as the guidelines are concerned, there is no definite objection to lipid being used as a supplement, but most of them concentrate on the calories and the fat and the protein. Among the calories, you can always make sure that a part of it comes from your lipid formulations also. In the enteral nutrition, whenever we do give protein and calorie, I think many of us are comfortable adding some amount of fat to it. I should mention probably in the first 24 to 48 hours, you would avoid it because you are looking at not making the entire 100% energy expenditure. I don't want to go into the details of our understanding now about, we don't want autophagy to be and the mitochondria to be overburdened. So we may avoid the fat in the early 48 hours, but subsequently fat could be part of your caloric intake, and it may be a very good source also. Thank you.
Sir, this was an excellent session, very crisp take-home messages. And to take it further, to get an intensivist perspective, let me start the next session by requesting the chairpersons to join in. I have the pleasure of requesting Dr. Jayanta Datta to chair this session. He's a nephrologist from Narayana Multispecialty Hospital and Super Specialty Hospital from Howrah. Co-chairing him is Dr. Mangesh Tivaskar, consultant physician and diabetologist from Karuna Hospital, Mumbai. And we have Madam Salom Benjamin, who is a registered dietitian and nutritionist from Mumbai and former chief medical nutritionist and head of the Department of Dietetics at PN Medical College in Naya Hospital. Please introduce the speaker and we can start the next session. Thank you. Are any of the chairpersons?
Very good afternoon to all. If a nephrologist you would like to introduce, otherwise I would take on the session.
Then please take over.
Yes, we have our next session on nutritional management of critically ill patients with reduced kidney function, intensivist perspective. And we have speaker none other than Dr. Harish Chafle, consultant intensivist, chest physician, bronchoscopist, and sleep disorder specialist from Global Hospital, Mumbai. Over to you, Dr. Harish.
At the very outset, thank you very much, Srnmcon, for giving me this opportunity to speak today, as well as Madam Benjamin, for your kind words of introduction. Yeah. So we start.
Yes, sir.
Yeah. So nutritional management of critically ill patients with reduced kidney function. Since morning, we have been listening to so many nice perspectives, and I would give intensivist perspective about what should we do basically. So my flow of the talk would include just a brief about pathophysiology of renal disease. We all know evaluation of nutrition in renal diseases, CKD assessment of biochemical parameters. Then I would present two or three cases just to make the ball rolling. And then along with the cases, we should discuss about nutrition prescription in focus, nutrition requirements in AKI with or without renal replacement therapies, micronutrients and loss and replacement, and then route and type of nutrition, and definitely revisit the nutritional cases at the end of the talk so that we know what we have learned. So as we all know, renal damage and subsequent loss of renal functions profoundly affect the metabolism, nutritional requirements, as well as nutritional status of the patient. We see a lot of patients coming to OPD as well as indoor, where they are nutritionally very much depleted when they already have underlying kidney disease. Urine output decreases, resulting in accumulation of fluid and electrolytes in the blood. And few patients who are coming to you would be definitely edematous all over, and few would be excessively cachectic. That is what I can tell you. So retention of nitrogenous waste leads to uremia, and uremia can lead to uremic gastropathy and a lot of complications, and uremic gastritis, and the appetite goes down tremendously when it happens to the patient. Also, acidosis occurs because kidneys cannot excrete excess acid produced through normal metabolic process, and renal damage can result due to kidney disorders such as glomerulonephritis, polycystic kidney disease, obstructive kidney, and congenital kidney malformation. So these are stages I would not discuss. Whenever you are evaluating a patient of nutrition in CKD, so you definitely refer to a registered dietitian who need to assess the patient before we start off the nutritional assessment as well as management of the patient. Patient history, including medical, social, personal history, history of medication, supplements that are ongoing is very important, as well as to analyze the biochemical data and relevant laboratory values. Anthropometric measurements goes without saying, monitoring height, weight, body mass index, waist circumference, and weight change ratio. What are the weights in the previous dialysis session as well as what is the current ongoing weight? Nutritional history, including food intake, what are the habits, physical activity, exercise, food availability with the patient is also important. You might prescribe many things, but is it available with him? Can he make use of it? Psychosocial as well, economic issues impacting nutrition therapies, again, needs to be discussed. Physical examination findings are also important. So the formulation of renal diet is relatively complex compared to planning of other modified diets that we have seen in clinical practice. Diet components must be regulated as calorie content, protein, sodium, potassium, water, which is very, very important. Particularly potassium, magnesium, phosphorus, all these things are very important when dealing with the chronic kidney dissipation, and also calcium and phosphorus as there is renal osteodystrophy ongoing. So nutritional requirements in an ICU, if you see, the caloric requirements definitely would be indirect calorimetry would be a gold standard, but it's not available and not routinely prescribed or done. BS equation is what can help us in knowing the energy equivalent basically, and then it is the equation that has several values you need to put and then get your energy efficient. So protein by the nitrogen output equal to input. We know that we need to maintain a positive nitrogen balance in patients basically, and nitrogen balance is equal to total protein intake in grams upon 6.25 minus urinary nitrogen plus 4 grams. It is not valid in the presence of burns, fistula, wounds with high protein output as well as for the renal failure. So we need to correct for these. And nitrogen balance in AKI, urinary sodium grams per day, urinary urine nitrogen plus change in urea nitrogen pool. And this is the formula that gives you estimating catabolism, a possible tool for nutritional monitoring of patients with acute kidney. So nitrogen balance is definitely an essence whenever monitoring as well as prescribing anything. We know that the total nitrogen loss without dialysis and dialysis. So non-uric nitrogen, that is body weight into 0.031 or 2 gram, plus there are fecal losses, fecal volume into this thing. You can, as an average, you can take 2 grams. Plus during dialysis, there is a dialysate losses, and dialysate per gram per liter into dialysate total volume is what we can add to that. So total nitrogen assessment will be urinary nitrogen and plus fecal losses plus insensible losses. So calculation of catabolism degree, NB being the nitrogen balance, TNA being the total nitrogen appearance, and UNA being the urea nitrogen appearance. So these are the formulas that we need to apply and then get a balance. So to start off with, I will discuss this case of 18-year-old boy who was around 55 kg, previously healthy. Day 1 to 2, he had dengue with encephalopathy with oral bleed. So that's why he was kept NBM. Later on, he becomes bad, goes on ventilator. There is ARDS, gets intubated, ventilated, again remains NBM. Now there is a shock. So that's how vasopressors are on the table. Lactates being 14 started on CRRT within time. As far as sugars management was concerned, 25% dextrose at 20 ml per hour. So roughly around 500 kilocalories. And day 4, he becomes prone on ventilator, again remains NBM. Day 5, shock is better, but NORAD is down to 0.1 microgram per kg per minute. Lactates, they are coming down on CRRT. And there is negative balance achieved by CRRT. Patient made supine, still paralysis is stopped. And now serum ferritin of 1 lakh and LDH more than 10,000. Started on feeds 20 ml per hour with MVA opinion IV 41 since day 1. So day 6 to 10, patient showed improvement, ferritin down, platelets up, tracheostomy for weaning off from the ventilator. Feed started 80 cc per hour by day 8, calories 1800, protein 60 grams per day, and daily sled ongoing. Fluid balance 1.5 liters positive. Do you all think is the nutrition provided adequate in last 10 days of ICU stay? We'll discuss later on. Case 2, 66-year-old, 75 kg with diabetes, hypertension, CKD underlying. There is cervical myelopathy with restricted mobility since 6 months. Admitted outside for 14 days prior to transfer. Has a diabetic foot leading to a source for sepsis. Transport intubated, ventilated, HD catheter in dialyzed once in previous hospital for AKI with creat being 9.9 and acidotic. Day 1 to 7 is a course, septicemia, shock, encephalopathic again, edematous, HD catheter, ET secretions, wound all over they grew, Acinetobacter baumannii as is expected in such group of patients. Daily sled ongoing, albumin say 1.69 on admission. I would say albumin is a acute phase reactant. So definitely it is showing that part. Started on feeds NG 20, 40, 60, gradually increase on day 4 once the shock has reversed. Cholesterol, digoxin, antibiotic ongoing. Tracheostomy again, this patient also. Insulin infusion to keep the HGTs between 110 to 150. And calories around 2000 kilocalories per day. Protein 80 grams. MV and opinion daily 1 ampule. Day 8, positive by 9 liters discharge. Again, is the nutrition enough? Can we make any changes in the content is what I want to discuss later on. 34-year-old is my third case with 44 kg post-pancreatic necrosectomy, BMI less than 20, started on TPN, 60 cc per hour with calories of 1400 and amino acids of 50 grams. Essential elements IV ongoing, MVI opineuron, multiple drains around 5 with drain output of 1 liters daily. Day 4 has to be explored for suspected bowel perforation, and again, post-op developed septicemia, AKI, oliguric urine output being 25 to 30 cc per hour. Patient is in shock with creat of 2.5 and from 0.5, which was the pre-op creatinine. Has a massive blood loss intra post-op due to DIC. Stabilized on day 6, again TPN restarted at the same rate as patient went on sled on fluid could be adjusted. So critically ill patients with AKI and nutrition, AKI affects the fluid, electrolyte and acid-base balance, as we all know. Effect on protein, carbohydrate and lipid metabolism is a combined effect of AKI and the underlying illness. Macronutrients and micronutrients intake is also altered by RRT, and type of RRT that is chosen, as losses on RRT have to be factored in whenever you are prescribing or trying to adjust for nutrition of this patient. And ideally, every patient's energy requirement should be measured by indirect calorimetry, as I was telling in the beginning. But indirect calorimetry is not easily available as well as easily or widely available. And trials have not shown a distinctive advantages of indirect calorimetry. Nutrition guidelines still prescribes 25 to 30 kilocalories per kg for critically ill patients with warning to be not overfed. And we know that what can happen if you enter into an overfeeding or refeeding syndrome. So that's why we need to be very careful while refeeding a patient who's NBM since last 7 to 8 days. And so we need to start slow and build up gradually. Protein requirement varies from 0.8 to 1.5 grams per kg per day. Carbohydrates and lipids should provide around 75 to 80% of the total calories so that we can adjust for the nitrogen balance of the patient. Enteral route is preferred over parenteral. Definitely, whenever gut is ready, use the gut rather than parenteral. We know what can happen with parenteral nutrition. When there is no choice, we have to choose, but then it definitely adds a risk to a patient who is already septic. Time to initiate parenteral depends on the underlying nutrition status, and hemodynamic stability is a very, very important factor. Whenever the patient is on 2 vasopressors on a higher dose, you cannot feed the patient. We need to wait for him to stabilize, and then only we can start. Micronutrients need attention and needs depend on use of renal replacement therapy. As far as micronutrients, we all know electrolytes, vitamins, minerals, micronutrients requirements is poorly studied in AKI. Further, the effect of RRT on removal of mainly protein-bound trace elements are far from clearly defined. However, data shows that selenium, copper, zinc, and can be removed by convective as well as diffusive RRT. And levels of vitamin C, folic acid, thiamine are reduced due to losses on the circuit. And I think all these patients need supplement of these whenever they are on RRT. Thiamine loss is 1.5 times the daily provision. That is what all of us needs to know. Phosphorus and magnesium, definitely there is depletion likely on CRRT, need to be monitored and replaced whenever appropriate. Phosphorus containing fluids are now being manufactured for CRRT, wherein this phosphorus loss and other things can be managed. Glutamine, it's a conditional amino acid essential for cells with rapid turnover like enterocytes and cells in immune system. Definitely forms a part of the immune nutrition that needs to be considered. And glutamine losses is there on the RRT. In patients undergoing CRRT SLED, large losses of glutamine may occur, and here supplementing at dose of 0.2 grams per kg per day is what is recommended. This is still not being tested adequately in a bigger trial so that we can have that experience and start using in our clinical practice. In general, glutamine supplementation has been proven to be of no benefit in certain trials as well as certain, there's a confusion in this. So continuous renal replacement therapy, amino acid, trace metal and folate clearance in critically ill children is what was suggested in this pediatric study that was done by Michael Zappitelli. And they reported the first evaluation of the effect of CVVHD clearance of multiple nutrients in critically ill children. And they found that significant amino acid, folate, and some trace metal loss occurs by CVHD, which may impact on nutrition position of the patient. Abnormal protein metabolism in acute kidney injury is contributed by critical illness, and altered renal amino acid metabolism is manifested as protein malnutrition and negative nitrogen balance. We found that CVVHD amino acid losses equated to 10% of total amino acid intake, and this mammoth loss happens, and 70 to 20% of amino acids are provided by parenteral nutrition, even if you are supplementing. So you know you are supplementing less and there are losses ongoing. So nitrogen balance was negative, and despite protein provision of approximately 2 grams per kg per day, suggested that CVVHD losses contributed to worsening negative nitrogen balance, and that is what was reported in this paper. But not all is lost on RRT. The energy excess provided by citrate, lactate, and glucose in RRT solutions should be factored in patient cumulative energy balance to avoid overfeeding and hyperglycemia, because that also contributes. It's going on with the patients in the form of the citrate and lactate and glucose in RRT solutions. And recommended range of sugar is 110 to 150 milligrams per deciliter as per KID2 guidelines. As far as fluid balance is concerned, it's definitely a very, very tricky topic in patients with CKD, how much to give and how much not to give. Fluid balance is always crucial aspect of managing patients. Very often they are in overload before coming to you because the renal functions are not appropriate, and there is a definitely these patients when becomes hypovolemic, they get a tremendous third space loss and they become swollen from inside, even if they are intravascular. So there is relative intravascular depletion and hypovolemia in this patient, even if they are looking overloaded from upfront. So the challenge remains to provide nutrition in smallest possible volume. To control the volume as well as nutrition is definitely a challenge, and I face this problem in and out in my clinical practice. And we had a discussion with Zamrud daily about how much volume and how much she can provide from her end. That becomes a challenge. RRT sometimes is indicated to ease administration of adequate nutrition and avoid large positive balances, which is associated with higher mortality. So previously the concept was the bigger is better, basically. So people used to give more tidal volume. There were more fluid given to the patients and more calories were given. And now the concept is the lesser is the better. So low tidal volume and lesser volume of the fluid to be given to the patient. And that is how lower calories and other things are coming, and that is helping the patient. So time and route of feeding is definitely an important part. Early enteral nutrition is what is recommended as a route as per guidelines from ASPEN, ISPEN or Canadian, you take any guideline. Early TPN within 48 hours in case of enteral route cannot be established, is only an ASPEN recommendation. Other guidelines, they do not recommend that. ASPEN recommends it on day 8 in case of enteral, it cannot be established till now. This is not true for previously malnourished patients where early TPN is recommended, where you know that enteral plus parenteral you need to combine to achieve a goal of nutrition. So this was about management and nutrition in AKI and with renal replacement therapy. So you know that acute critical illness, stress, immobilization leads to anorexia, starvation. There is delayed start of nutrition therapy, as we discussed in our cases. There is insufficient nutrient intake from the patient side because of loss of appetite and inability to consume things. Low protein intake to delay RRT, estimation of nutritional needs, and acute kidney injury, metabolic acidosis. All these contribute to catabolism, lean body mass wasting, and there is protein energy wasting in the patients. And all these factors leads to inadequate delivery of proteins and calories, leads to protein energy depth, and again the same. And this protein energy wasting leads to increased mortality, increased morbidity, increased length of stay, and increased cost to the patient. So this is all we need to know, and we need to correct as soon as guidelines. And then these are the guidelines: ISPEN, ASPEN, KID2, and these are the recommendations by Grossley, and the route definitely enteral everybody will prefer, but then few patients need to combine the parenteral plus enteral, where you know that the goals are not met. Coming back to our cases which we discussed initially, previously healthy, he was not malnourished, acute illness, PN can wait for 5 to 7 days, 55 kg, calorie requirement 1375 to 1650 kilocalories per day. Protein requirement in this patient was 82 grams, so micronutrients added with thiamine, folic acid, vitamin C, glutamine essential elements were. So good fluid balance achieved as CRRT in initial phase. For case 2, he was an elderly with malnourished, already hospitalized for 14 days, septic shock and MODS. PN should have been initiated on day 1. Micronutrients and essential elements definitely require supplementation, and this was the prescription for him. 17 kg, so 1875 to 2250 calories. Proteins of 100 grams would be desired and targeted. Fluid balance detrimental to outcome, and most avoid hyperglycemia because he was already having source as diabetic food. So 4 weeks pancreatitis was the case 3rd, basically, which we discussed initially. Started on TPN and surgery on admission. So calorie, protein adequate as per guidelines. Glutamine, again, we are not sure. This is the ideal case for indirect calorimetry and nitrogen balance calculation. I thank you all for your kind listening. I'm open to questions if any from the audience.
Thank you, Dr. Ramesh, for that wonderful explanation. Though you are very fast, but I think you covered almost all the.
Yeah, I wanted to cover, so that's why I went very fast.
Yes, and beautifully narrated with the cases. So I think it is easy to understood. But still, every case is different, which we see in intensive care, and especially with AKI and other comorbidities existing, like pancreatitis or a surgery impending or a prior to surgery or pre-existing malnutrition is one of the very big problem we face the patients who come to ICU. And when we are not able to correct the right decision, what you have taken in the second case is the parental nutrition.
Yes.
So prophylactically, when we know that I'm not going to able to feed this patient, I must start on day one to salvage the patients. That is also one of the guidelines. And if the patient is on SLED or the dialysis, we can give interdialytic parental nutrition, and which also adds into the calorie and amino acids and fat, and which does save life, which is not very commonly seen, though we are a prime metro city Mumbai having a very good health practice. Very few intensivists and nephrologists will go for it. But I must thank you that you have really covered all the points. And if there are any questions, I don't see it in the chat box. Anybody from the, I think you were very clear, or maybe.
Okay. Yeah.
So thank you so much,
Thank
Dr.
you.
Harish.
Thank you, Benjamin. Thank you.
Yes.
Okay. Thank you, Srnmcon, again for giving me this opportunity. Thank you.
Thank you.
Thank you, sir. It was an excellent presentation. We got to learn a lot, and thank you for completing it on time. In fact, before time a bit.
Yeah.
That's amazing. For the next talk, Madam Salom will continue with us. We await Dr. Mangesh Tivaskar to join us. He's got busy right now. And when Dr. Rimita De joins, we will introduce her as well. But Madam, if you could just carry on with the next session, and we have requested the chairpersons to join whenever they are free.
Yeah, I think she's doing a good job, so Salom can continue.
Yes.
Excellent. Yes.
My name is Salome.
Salome.
Just to correct, yes.
Okay.
So,
Apologies, ma'am.
Yes. So the next speaker is speaking on practical prescription of feed, something very near to my heart because I've been practicing intensive care nutrition for all my life, like for 4 decades. And Vaidehi is one of my close friend and colleague. And I would like to introduce her for this session. She's the chief dietitian at Bhaktivedanta Hospital Research Institute. She's got few awards to her credit, diet consultant. She's with for Dr. Bharti Amte, and special appreciation by Dr. A.P.J. Abdul Kalam. And she's also a carrier of Legacy Award by Bhaktivedanta Hospital and the Institute. Special award as profession dietitian by Shiv Sena, that is your Meera Bhayandar, because this hospital is in the Bhayandar. And I would invite her to talk on practical prescription of feeds. Vaidehi, over to you. Your time starts now.
Thank you very much, madam, for the wonderful introduction, and very happy to know that you are my chairperson. Thank you.
Welcome.
Very good afternoon to one and all. I will just share my screen. 1 minute. Is it visible?
No, not yet.
No, ma'am.
Share the entire screen and then pick up the PowerPoint.
Is it visible now?
It is starting. Yes, please. Go to slideshow, Vaidehi. Yeah, you can start.
Okay. Today I'll be talking on practical prescription of the feeds, where I would cover what is the nutrition diagnosis and the prescription, the nutrition assessment of the patient. I won't go into detail because that has been already covered. Recognizing the nutritional requirements, again a bit of it, understanding the prognosis and accordingly taking the correct action, and planning of the feeds, delivery of the feeds, and obviously reassessment. So nutrition diagnosis is basically an extremely critical step in nutrition care process, where we understand a PES statement. Now, what is PES? It is one patient specific to one problem, that stands for P, one etiology, and based on assessment of signs and symptoms, that is S. So basically it has been designed by ADA, still the research is going on, but this actually helps a lot. For example, if an underweight patient admitted in the hospital, that is a problem. P, related to continued reduced intake of regular meals, that is etiology. resulting in less than, 500 calories less than RDA, or 30 grams proteins less than RDA, as per the evidenced by a BMI, which is around 20, which is a sign and symptom. So once we arrive at the nutrition diagnosis, we have to, as a dietitian, we have to go ahead with the nutritional prescription. So prescription, basically a diet, a general diet, where we have to take into consideration different nutrients, that is protein, macro and micronutrients, which are required for the optimal growth and tissue repair. But a therapeutic diet, where a diet intervention which is ordered by a healthcare practitioner, a nephrologist, as part of the treatment for clinical condition where the patient's nutritional status is altered and there is a decrease or increase in certain substances, like we have to make sure that we have to give low sodium or low potassium, sometimes high potassium, sometimes high protein, high calories, something like that. So when we talk about therapeutic diet, so we arrive at the conclusion that the patient's nutritional status is A, B, C. Mostly it is either B or C. Then we arrive at the prescription part. But before that, when from the nutritional assessment point of view, we have to understand how critical it is to intervene the patient nutritionally on day 1 within 24 hours of the patient's admission. In critical area, it is within 6 hours of the admission, provided it is not in the night. So putting everything into the practice is basically a comprehensive and routine assessment, which as per the NABH requirement happens within 6 to maximum 24 hours in the general wards, and where according to the National Kidney Foundation, this is about the patients who are hospitalized, where we take care of the assessment during this particular period. But for the patients who are regularly on dialysis, coming to the AKD, we have to make sure that, and we have started that in our hospital, the dietitian does go for the round, alternate day, covering all the 3 shifts of the dialysis patients, where the continuous reassessment of the patient is required, because malnutrition can lead to a poor prognosis. So I won't go into this. How is nutritional health checked? Okay. Now, when we arrive at what diet has to be prescribed, where there are so many restrictions on the pre-dialysis patients, there are increased requirements during the dialysis, phosphorus restriction, potassium, fluid, sodium restriction, limited selection of the fruits and vegetables, appetite is low. We have to look for the fiber and the micronutrients. So actually, what is left to eat is a big question mark. So nutritional therapy induces favorable metabolic changes, which prevents the signs and symptoms of renal insufficiency, where a stepwise approach or a simplified diet regimens usually are prescribed while taking into consideration not only the renal functioning of the patient, but the progression rate. The economic, psychological, and functional aspects also are something which are to be considered. Right selection of the formula feeds, and in order to allow efficacy and safety, the importance of monitoring, that is reassessment, is something which is required. Where the patients are on oral feed, where we have to understand, we have to make patient understand how much fluid is required. We can give them the goal that this is the dry weight goal, how much water is allowed, how much fluid is going in the IV, and accordingly we can specify it. Apart from that, if suppose patient is consuming, say, a mug of coffee in the morning as his breakfast portion, we can advise them, instead of having this, what can be replaced by a mug of coffee, so that we can take care of the intake of the concentration of the proteins and calories, and we can take care of the fluid requirement. So I can give you certain examples, like suppose a patient is on the oral, what prescription we consider in hospital is basically understanding the nutri shots, like a combination of some medical scientific formula which can be combined with little amount of fluid, which can be given as a filler. We can understand some millet, lentil, laddus kind of thing. If the potassium is under control and patient's appetite is less, we also do give 1 or 2 pieces of apple, so that if the taste gets changed, If abdominal bloating is there, we can think about some ajwain, hing or soft decoction that we do in our hospital. We have to prevent constipation. So understanding soluble fiber, which can be mixed with the food, so no water is required. Addition of MCTs for the calories, taste enhancers like lemon, ginger, black salt kind of thing. In case of RT feeds, the initiation, we have to make sure the golden hour, like as soon as the patient gets admitted, we have to understand how critical it is to have the nutritional intervention done. We can start with the scientific formula and can be followed with a combination of kitchen as well as scientific formula. And the most important thing, which madam also will agree with me, that involving relatives and motivational counseling of the patient is something which is the most important part of the nutrition prescription. Sometimes we do face the problems like suddenly the scientific formula which has been advised is discontinued by the consultant in our hospital. Does not happen normally, where we can directly discuss, the consultant and the dietitian can have the direct discussion and understand if at all there are prolonged hours of NBM, we can start the night feeding, or if at all anything has to be, if the patient is having some GI disturbances, what else better can be done for the patient, so that can be, we can arrive at the conclusion after the discussion. So purpose and scope is basically to understand that 80% of calories and other nutrient target can be achieved within the 24 hours. So first is the consultation, understanding from the consultant, open discussion, diet modification for the patient, assessment of the patient, progress notes where we have to be specific in writing in the file that how much exact water intake the patient is taking, fluid intake in terms of water, the fluid going through the diet and the fluid going through the IV. So these specifications we have advised, suppose 1800 calories per day, but actual intake of the patient is maybe around 1000 calories or maybe 800 calories if the patient is on oral feed. If on RT feed, we are able to achieve the 100% RDA. So all those points have to be regularly documented, discussed, modified, assessed, reassessed, and then obviously at the time of discharge, the patient should be that what we call as road to recovery in our hospital, where even post discharge, the patient's nutritional status has to be either maintained or improvised. Definitely, if scope is there, we can definitely improvise. But even post discharge, or the patient continues to come in the dialysis unit, then we have to make sure that nutritionally we are giving 360-degree care to the patients. So the suggestion is dietitians must in the patient care team to achieve the desired daily energy protein targets, not only the macro but also the micronutrient targets. Maintaining and or improving the patient's nutritional status is at most important. In fact, we have started doing the graphical system where on a day one, patient's nutritional or the patient's nutritional status is here, and at the time of discharge, where does patient reach? Also in terms of the nutritional content, like today 20% of RDA is achieved. Today was 0, maybe patient was NBM for whatever XYZ reason. Today we could achieve 100%. So that graphical presentation immediately at a glance gives us the understanding where do we stand. It is a first understanding for us that where do we stand and where we have to take the proper action. Also, when the consultant goes through the notes, it is a clear-cut understanding. Okay, we are arriving here. We, if at all any suggestions are there, we can have the open discussion kind of thing. So prescription is one part, but the documentation, which is extremely important, and the practical implementation. So all those things, if at all happens with a wonderful communication with the consultants, we are very lucky to have wonderful team of nephrologists in our hospital, Dr. Ankit Modi, Madam Zupe. So it's like a very uric acid is very high. Just do the needful. It doesn't need. It's absolutely practical approach, and it is in favor of the patient's benefit. And what is the dietitian's role? It is basically detection, which is extremely important. Detection of aggressive nutrition support at early stage with the aim to prevent refeeding or overfeeding, malnutrition, and thus aiding in reducing the overall ICU as well as the hospital stay. Thank you so much.
Thank you, Vaidehi, for that wonderful explanation of the feed. And we are in 21st century, and from 2011, Dr. Dan Handel said that we should not use any longer the word nutrition support. It's a nutrition therapy. So we are a medical nutrition therapist giving therapy with a goal and strategies for a definite outcome. So we are equally important in the team. As you said that the progression notes very important for the dietitian. In my long career, I have always taken round with the entire team, intensivist, nephrologist, if it's a treating surgeon or a medical consultant, then we are very good team and we discuss each case, then we don't go wrong on when to start, how much to start, and how do we avoid overfeeding, underfeeding, plus a treatment goes in line with all the entire team members. So that's a very good approach. I think all the dietitians must develop, and that is how we could achieve very good outcome. Also, most of our patients go walking out of the ICU, and this is the approach I think we need in this present era. So I don't think there are any questions. If there are any questions, we can take. Otherwise, I think we, Dr. Anybody has joined? Any other co-chair?
No, I think I saw Ruby sound around. Is she around?
She's for the next, yeah, she's for the next, I think.
Yeah, but she can comment on this if she wants to. There is some time available. Yeah, yeah.
Good afternoon, sir.
There you are.
Good afternoon, ma'am. And
good afternoon.
And very nice to hear Vaidehi after a very long time. And it's her practical experience what she shared. The right time, the right treatment, and the right choices that you make. Because that's the, you cannot experiment too much. If you've made the right choice, the treatment outcome varies. And nobody other than Salumi ma'am can, give the best of inputs. And I think it was a great talk by Vaidehi. Excellent presentation, very, very directly from your from bedside to practice. Thank you so much, Vaidehi.
Thank you. Zamrud, do you want to say anything?
Zamrud is around, yes.
Yes, sir, I'm there. So I think whether he has really touched upon most important points. Only at most of the corporate hospitals today, we are actually practicing scientific formulas than actually kitchen blends. So that is one thing. Yeah, that is one thing that I thought we should highlight. But actually, the work that Vaidehi is doing, she is actually trying to reach the patients' families and actually give them what is needed. So that's also a very good approach, Vaidehi. Thank you.
Any change for the small nursing homes where some critical ill patients are admitted, whether there is any difference in management in the critical care hospitals, big units, or teaching hospitals ke alawa, small nursing homes are there where all these ICU sick patients are admitted. Any change in the pattern of dietary prescription? You said you use...
Yes. Dr. Khanna, if I have to say, when I go to see in nursing homes, it's a real challenge. Most of them, they do not have a kitchen or even anything to mix the formula, even like a, like a pint or a whisker. We do not even have to mix the formula. So that is one big challenge. Plus, on a day-to-day basis, there is nobody to supervise or write a prescription or a case progression or assessment, reassessment on a regular interval is also not there. So it becomes very challenging in the nursing home where the dietitian services are not available, and they call on call, like people who are experienced, they sometimes call, but it is also very difficult for us to go daily and reassess the patient. We will write down, but there should be somebody at least at the junior level to continually assess, reassess, and modify the prescribed feed. If it's an RT feed, parenteral is out of question because they won't be able to handle it. So even if I have gone and prescribed interdialectic parenteral nutrition even in a big corporate hospital, but then I get a call after 24 hours, what next? So these are the challenges day to day what we face are in this area.
Fine. Thank you.
I think, ma'am, in in near future, what we can see, there's a high scope for dietetic assistants. Like if there is not an experienced dietitian who can, monitor continuously, if there is a junior dietitian or a dietetic assistant who can actually be a link between the treating staff and the visiting dietitian. That can also bring a big relief to these nursing homes and these small hospitals.
I would like to
That can fill the gap.
Sorry, I would like to mention one point. There's something called as nutrition nurse, who can be a rapport between the dietitian and the patient and the consultant. Where if Salome Madam agrees with me that if at all we can have some standard formula which can be immediately initiated as soon as patient gets admitted, and then she can be a one-point contact, which should work.
Yeah, very rightly said, Vaidhi. We do have, like, in a government hospital, we are not many dietitians. We do have a diet nurse in every ward. And then whatever we give a prescription at a bedside chart, that is being implemented by these nurses, because we will not be able to go it. So that can be also done at a nursing home level and a small institute also. Yes, very rightly said. Thank you.
Ayan, you are around?
Yes, yes, sir.
Yeah, so you should tell them about the 17th course which we are doing, where we are trying to get a nurse educator or a nurse
Very good.
coordinator,
Yes,
and that person will explain everything to the patient in nephrology, in intensive care, and then we can, give him or her, the nurse, ideas about renal nutrition also. So this is a bridge between the nephrologist and the patient, and that person is called a patient educator. So we are starting a course, a certificate course by Mumbai Kidney Foundation and Corep Trust, and Ayan is actually spearheading it. And 17th of October we are having this conference.
very good. Congratulations, sir. Very nice.
Thank you. And I'll just touch upon it for a couple of minutes that, as sir said, we need a nurse, a patient educator who navigates the patient through the various stages of CKD and in dialysis and transplant. So look forward to all of you being there on the 17th of October. We'll forward the brochure and all the other details. But this was an excellent session. Thank you so much for participating in it. And the discussion was amazing. Critical care and nephrology, when they come together, it's a real challenge for our patients. And we need a multidisciplinary team to work on our patients, because the margin of error is so less based on electrolytes, based on the phosphates, potassiums, the golden hour, as you said. And so this has been really, really great to listen to all of you. So with this, I close the previous session, and now we go on to the next session, which is equally important. There are a lot of myths around it. It's very relevant to our clinical practice, to all of us. And this is on immunity boosters and the kidney health. We'll discuss the good, bad, and the ugly. To chair this session, we have Madam Ruby Sound. We are very fortunate to have her with us. She's the dietitian at Eatwise Nutrition and Wellness Clinic in Mumbai. And to co-chair this session, we have Dr. Manisha Dasi, who is a consultant in the Department of Nephrology and Renal Transplant at Max Super Specialty Vaishali, Ghaziabad. The session is all yours. Please introduce the speaker and we can start this. Thank you.
At the outset, firstly, I would like to thank Dr. Umesh Khanna sir and my dear Zamrud ma'am for having me here. In fact, it is a need of the hour that we are bringing up new concepts like nurses and everything through Srnmcon. I think among the dietetics fraternity, Srnmcon is the most looked after program on renal nutrition, and lots to learn from each other. Thank you so much for organizing this entire program year after year. I've been hearing the session since morning, and we now come to another interesting, very, very important session. During COVID times, we've heard a lot about immunity boosters, and especially with the patients who are immunocompromised, especially those with CKD and other things. There's always a very thin line to decide whether the nutrient can be taken as an immunity booster or for the treatment. Among all the nutrient that we are talking about, which can enhance the immunity, we generally nowadays are talking about vitamin D, vitamin C, and many other nutritional supplements and herbs, which are a combination of these nutrients. Now, specifically about vitamin D, we know that, yes, vitamin D is frequently used in the patients, either to treat the secondary hyperparathyroidism or to prevent renal osteodystrophy. But specifically with related to its immunomodulatory effects, Today we have with us Dr. Keyur Dave. Dr. Dave is a senior consultant of nephrology at Jaslok Hospital, Mumbai, and his areas of expertise are andrology, clinical renal transplant, management of severe renal conditions, hemodialysis, peritoneal dialysis, and renal histopathology. Dr. Keyur Desai, we welcome you to talk on this very important topic of the role of vitamin T as an immunomodulator. We welcome you. Over to you, Dr. Dave.
Thank you very much, chairpersons. And I'm a part of Team Srmcon, and we're having a fantastic time organizing this conference. There are some certain really fantastic sessions on, and it's wonderful that everyone's learning so much. And coming over to the current session, which is about immunity boosters, and I would be starting on vitamin D. I'll just share my screen.
Sure, sir.
So is my screen visible?
Yes, sir.
Right. Okay. So, vitamin D remains an enigma. As Ravi Thadani famously puts it as, is it like a panacea, or is it much ado about nothing? Is it, it's a molecule which we seem to know a lot about, but yet at the end of it, we seem that we do not know a lot about vitamin D. It seems to be the answer of most of things that we know. But again, then, we kind of take it back that whether we really know everything about vitamin D. So sticking to the theme, since I come from Mumbai and the land of Bollywood, you will keep seeing these pictures which will keep coming into my presentation. So we start with the good bit of vitamin D. So let's start with a case. So this was, a 10-year-old boy. He's the shortest in his class. He has severe pain in his, right wrist while he has a fall while, he was playing, and then is found with a Colles fracture. He would often complain of body ache, pain in his limbs, was slow in his work, was inattentive in his class, would have constipation, severe abdominal pain while passing art schools. His parents would say that he would bedwet in the night despite being 10 years. And now he had undergone some surgery to correct his urine outflow obstruction when he was 5 years old. So basically there was some corrective surgery which was done. Now patient, when investigated, creatinine was found as 2.9, CBC hemoglobin was low, calcium was only 5, phosphorus was 9, albumin was 2.9, he was proteinuric with some UTI with pus cells of 15 to 20 in the urine. The kidneys were marginally small with an enlarged bladder and a thickened bladder. He was initially treated with cefixime, calcium supplements, hematinics, and lactulose. However, the complaints just persisted, and hence was sent to a nephrologist by the general practitioner. Now the nephrologist evaluated further. Vitamin D levels was only 2. PTH was 900. Stool for occult blood was negative. B12 was really low. So he was nutritionally deficient. Now the nephrologist put him on calcitriol, which is the activated vitamin D, and along with calcium carbonate, cinacalcet, which is a calcium mimetic, cinacobalamin, and soda bicarbonate. The patient got better. The pain constipation got better. The scholastic backwardness improved. In fact, the vitamin D levels came to about 35. The calcium levels was 9. The creatinine was 1.8. The bicarb was 20. Over a year, the child attained better growth and attained similar height like the other children in this class. Basically, what we're talking about is renal rickets. Now, as a nephrologist, I can vow and say that vitamin D definitely has a huge role to play when it comes to renal rickets, osteomalacia, CKD-associated osteomalacia, even vitamin D-related osteoporosis. So let's come to physiology of vitamin D. I don't want to make the discussion really theoretical, but we need to talk about normal physiology. So basically, the skin plays a part that gets exposed to UVB radiation. Specifically, the parameters that we're talking about is 290 to 350 nanometers. The pre-vitamin D3 gets converted, further to vitamin D. It's metabolized into, liver by the 25 hydroxylase enzyme. And in the circulation, we have enough 25 hydroxylase vitamin D. Now, this needs, various carrier molecules, and out of which the vitamin D binding protein and the albumin are the carrier molecules that we're talking about. Now, this gets, comes to the kidney. The kidney further, works on it, and we have the 1-hydroxylase enzyme working on it, and we have the activated 1,25-hydroxylase vitamin D, which has its interaction with the parathyroid hormone and the parathyroid glands. It works on the bones. It also helps in calcium absorption via the intestine. It prevents lesser calcium excretion, and further, the entire calcium, phosphorus, PTH, vitamin D homeostasis is maintained. Now we look at the graph. As and when the renal dysfunction increases, as the GFR reduces, further the activated vitamin D falls. If you look at the 25-hydroxy vitamin D, the curve more or less remains same. Very really interesting is as the GFR kind of falls down further, the vitamin D falls down further, but up to GFR of around 30, that's when the PTH starts rising, and up to a level of 25 hydroxylase vitamin D, the PTH has not risen. And you look at the 25-hydroxy vitamin D curve, the PTH has not risen further. Importance: lesser the GFR, definitely vitamin D supplementation, and the PTH is looked after. The guidelines also address this. So whenever we're looking at CKD stage 3, what the guidelines, the KDIGO guidelines emphasizes, we need to consider potassium, the phosphorus restriction, calcium and calcium supplementation, evaluate the vitamin D status and the PTH, and then treat accordingly. CKD4, interestingly, we know that all our dialysis patients need vitamin D, but the evidence is not very strong with respect to vitamin D. Why is it so? It's because we don't have enough randomized control trials to prove that vitamin D is actually, useful in dialysis patients. Now that sounds strange, but the fact is the observational studies are so strong that you do not have enough randomized control trials to prove that vitamin D is so, really helpful in dialysis patients. The maximum randomized control trials is with CKD stage 3 and CKD stage 4, where vitamin D supplementation has definitely found an excellent role, and we've kind of shown the effects. So these are the we most often use the cholecalciferol and the calcitriol. Now, along with the calcemic side effects, the good effects of vitamin D, we have better roles in cancer, the immune system, the cardiovascular system, the skin, the muscle weakness, the type 2 DM. So in fact, you name it and you have it when it comes to vitamin D and its usefulness. But is it as good as it's showing up? Let's look at the bad phase of vitamin D. Now, every possible trial, be it sepsis, be it inflammation, be it chronic disease, be it diabetes, be it anything, you name it, and vitamin D supposedly has a good role. But is vitamin D really that useful, or is it just $1 billion hoax or fake news? Now, I came across a study which they kind of evaluated vitamin D deficiency in India. Now, when you look at the figures here, you would find that everywhere, right from Kashmir to Kanyakumari to west to east of India, everyone is vitamin D deficient. Now, the definitions that they used was that 25 hydroxy levels of vitamin D below 20 was addressed as deficiency, 20 to 29 was insufficiency, more than 30 was sufficient. So if you kind of start evaluating, you might find that, everyone is vitamin D deficient. So, what is deficiency and why these levels have come up that way? Now, if you looked at my earlier graph, again, I come back to the same point. When they've done trials, the NEGM had published this trial where they actually found that 25 hydroxy D levels below 25 kind of increase the PTH levels. So you had a biochemical markers, and that's when you kind of type vitamin D deficiency at those levels. Now let's further understand whether vitamin, how does one come to vitamin D deficiency? Now 25 hydroxy vitamin D needs various carrier molecules, out of which the D binding protein, albumin, and the free form together kind of address the total 25 hydroxy D levels. Now, unfortunately, the tests that we have to evaluate, vitamin D kind of only considers the D-binding protein. Now, D-binding protein, interestingly, it's a negative acute phase reactant, and it's rapidly destroyed when you're looking at an inflammation. So the D-binding protein's half-life is also short. It's about 2 to 3 days. Now, when you're talking about vitamin D deficiency in sepsis or in inflammatory condition, possibly, what we're doing is we're just, calculating the vitamin D, which is bound to the D-binding protein. And because it's a negative acute phase reactant, we kind of measuring really low vitamin D levels, which they are not exactly, being there, because the albumin is responsible. And the moment that the inflammation is over, the vitamin D levels, automatically rise. And we kind of conclude that vitamin D is important for inflammatory conditions, which actually is not. Now, do we have evidence to that? We had animal experiments, and there are human studies which have done it. So they kind of found that they traced individuals where vitamin D binding protein deficiency existed. Now they found homozygous carriers, they found heterozygous carriers, and they found, completely normal individuals. What was interesting was people who had really low vitamin D binding protein, they showed that the vitamin D levels were really low. But did it make any difference to the calcium and the PTH? No, it did not make any difference to the calcium and the PTH levels. So possibly, we're comparing apples to oranges. We are not addressing the correct issue. Now, what also is we're relying totally on the Caucasian figures. We are not, making our own figures. It's possible that the blacks, the Caucasians and the Indians, we are intermediates, we may have different polymorphisms. And we may have different polymorphisms, which would be responsible for different D-binding protein levels in our case. And that's why the vitamin D levels, which would be normal, may, be different in our cases. So that's why possibly we are comparing apples to oranges. And that's why possibly, just based on the D levels, treating such, vitamin D levels may not be so important. Now, the ugly phase of, vitamin D. When we don't keep all this into consideration, we'll end up with the ugly phase of vitamin D. Now look at this case. A 70-year-old, was brought to the casualty with irritability, altered sensorium, loss of appetite. The creatinine was 10, the calcium was 15. Now her last follow-up with her doctor was 2 years back before the COVID epidemic started, and her creatinine was 2.1. She had not left her house in the COVID epidemic, and her last video consulted her family physician, who prescribed medicines to prevent COVID infection, which included vitamin D supplementation, because it was drilled into our minds that vitamin D would prevent sepsis, would prevent inflammation, and would help in COVID. If after taking these medications, the calcium level has risen. The vitamin D was found to be more than 200. The PTH was low. Patient had to be dialyzed. Patient was on hydration with Lasix and IV steroids. Gradually, patient's creatinine came down to 2.9, started passing good urine output, and was advised periodic calcium monitoring. But like all our patients, the patient was really scared about COVID. So, did not follow up. And then again developed, decreased urine output, irritability. Again, the calcium levels shot up. The creatinine went up to 8. The vitamin D levels were as high. And again, had to be hospitalized, dialyzed. And, gradually the calcium levels reduced. Patient was warned that is the vitamin D would periodically keep release, you keep coming into a blood circulation, the calcium levels would shoot up, and that really requires calcium, monitoring. Similarly, after 3 subsequent hospitalizations with hypercalcemia treatment, eventually patient has settled with creatinine, coming down to 2.3 over 9 months. The ugly phase of vitamin D is intoxication in, unmonitored use of vitamin D. Ultimately, it leads to hypercalcemia and the hypercalcemia related side effects. How do we treat hypercalcemia? We need IV hydration, zolantonic acid, steroids, we need calcitonin, we need calcimimetics, and in secondary hyperparathyroidism, even parathyroidectomy. So what do we, take home from this current discussion? And I want to give a huge credit to, Ravi Thadani on he is an Indian practicing in USA, and he seems to know a little more about vitamin D than a lot of us. Now, what do we take home from this discussion? Every routine measurement of vitamin D in an absolutely normal individual is actually not warranted. There is no particular evidence where vitamin D less than 20 is actually associated with high cardiovascular disease. It's only in patients with renal disease, in liver disease, where actual supplementation of vitamin D has found to have some particular use, or has shown a lot of benefit. So, do we really have vitamin D deficiency? Because there can be quantitative difference in D binding protein. There can be qualitative difference in D binding protein that may actually, show that may show as vitamin D deficiency, whereas the patient may not really be vitamin D deficient. So before coming on to, vitamin D deficiency and, treating it, let's evaluate the calcium status, the PTH status, the bone status, and let us, really understand whether the patient really wants vitamin D supplementation, and then only give it rather than blindly following the curve. That's my take on it. Thank you very much.
Thank you very much, Dr. Kaur. That was a very balanced presentation, I would say. I'm especially in agreement with your ugly part of the role of vitamin D in health, because I feel that the most common cause of iatrogenic or accidental hypercalcemia in elderly age group is vitamin D toxicity. As far as patients with chronic kidney disease are concerned, I would want to know from you, is there any specific role of measuring 125 hydroxy vitamin D instead of 25 hydroxy vitamin D in evaluating vitamin deficiency? Is that any more helpful? That's first question. And the second question is, what is the role of vitamin D supplementation in kidney transplant recipients or patients who are on immunosuppression?
Thank you so much for the question. Now, coming to the first question, the role of measuring the activated vitamin D. Now, honestly, vitamin D, if we have an activated vitamin D which could be measured really easily, that would be really helpful. Because the problem with measuring activated vitamin D is that the T half is just so small that when it comes to a regular collection and it reaching the laboratory, some amount of vitamin D, maybe miscalculated, and it may not be very, very accurate. If we have a particular setup where it goes to the lab within seconds or minutes, it may be really helpful and a good guide. But again, this may not be available to everyone. So coming back to the same points, let's not be general. Let's look at the PTH levels. Let's look at the calcium levels, especially in, when we're talking about CKD stage 3, CKD stage 4, CKD stage 5. Let's really establish, real vitamin D deficiency, because most centers would still measure the 25 hydroxy vitamin D. And rather than blindly treating the vitamin, the 25 hydroxy, we kind of look at the entire biochemical parameters and then look at it. Coming to your second question regarding the renal transplants. Now, renal transplant patient population, again, is a subset where, they have medications where, that may lead to osteoporosis, like the steroids, like the tacrolimus and the cyclosporin. And vitamin D supplementation in such a patient would be again important, taking into consideration the baseline calcium values and the PTH values. Again, a lot of patients may have just undergone transplant from a stage of dialysis. They may be, hypocalcemic. So yes, evaluating the biochemical parameters well, and then vitamin D supplementation in such a patient, especially the activated vitamin D form with regular checks on calcium, would definitely have a role in renal transplant patients.
Thank you very much, Dr. Kaur. That was so kind of you. Are there any other questions from the audience? Do we have any more questions?
No, I think
yeah.
there aren't any questions, right? So we close on time, and thank you, Manisha. Thank you, Ruby. And of course, thanks, Keyur, for this wonderful, the good, the bad, the ugly, along with the filmy style of presentation. And that's what is expected from Keyur. Thank you.
Yeah,
Okay, we
truly
move on
excellent.
to...
Okay, sir. Thank you.
We now move on to the next session, and on the immunity boosters. I think even more than vitamin D, it was vitamin C which was in vogue along with vitamin D. So the good, the bad, the ugly of vitamin C. We have the chairpersons, Dr. Siddhini Vishwanath, a friend of mine who is adjunct professor at the Manipal University, member secretary ethics committee, Manipal Hospital, Bangalore and is the head of Department of Nephrology at the Manipal. And Ms. Rita Patil, who is the Associate Professor, Maniben Nanavati Women's College, Mumbai. So the chairpersons will introduce the speaker. The speaker is Smriti Sinha, who is an anchor for the 2 days. She's done a great job. Over to Vishwanath and Rita Patil.
Thank you, sir. Thank you very much. At the outset, I'd like to thank Dr. Umesh Khanna for the invitation, and I congratulate for their wonderful organization and being on time, which is very important. I like the timer what you have kept. I think it is keeping everybody on toes. Dr. Smriti Sinha, she is a consultant nephrologist and transplant physician at Sarvodaya Hospital, Faridabad. She has many achievements and awards to her credit, including FAS and membership. And she has wide experience in interventional nephrology and having performed many tunneled catheters and of course biopsies and even acute peritoneal dialysis, which has become very, very rare nowadays. My other chairperson has any comments, madam? Anything?
I'm looking forward to this session, and I'm sure it's going to be a very interesting one because vitamin C has always been, particularly in the COVID times, it has been extremely controversial for its immunity. So let's hear our speaker.
Yeah, before she starts, I must say that Mumbai's loss has been Delhi's gain, and Smriti was a Mumbaikar till now, and we are really going to miss her, and of course Delhi will be much richer.
Thank you so much, sir. Thank you everyone for that kind introduction. Dr. Keyur Dave has already spoken about vitamin D. As my consultants used to say, my endocrinologists during our MD times, every decade seems to have a vitamin which is in vogue. It seems to be vitamin C in the last decade. There are a lot of studies have come up. Vitamin C seemed to have existed before that when we talk about evidences, but COVID has brought it back. It's back in limelight. So just a minute. Sorry, yeah. So vitamin deficiency diseases used to be enormous burden of suffering worldwide, but slowly we discovered each vitamin, and replacing those vitamins have reduced the particular deficient diseases like vitamin D deficiencies and vitamin C deficiency, which is scurvy, to minimal number of people. Now we see these deficiencies only in small number of people who primarily have unbalanced diets or malabsorption syndromes or abnormal losses, which is important for us because our dialysis patients fall in that group, or uncommon genetic defects. In 1990, it was widely believed that if you supplement vitamin, it might even cure cancer or now even cardiovascular diseases. But sadly, all the RCTs and meta-analysis that have happened subsequently have been quite disappointing. However, also they're easily available as supplements, and pharmacy in India is not very difficult. I mean, we can easily buy supplements off the counter, and people tend to self-dose. Higher doses of these vitamins actually can lead to harm. So we'll see more about that. Ascorbic acid, this is the most famous study which happened in 1975, and the most commonly used indication for this is actually common cold. But if you actually see the study, even in this, there was very little or marginal benefit that ascorbic acid actually gave to patients with common cold. So what does vitamin C do in our body? Vitamin C is very important for a number of processes, especially in your immunity related processes. Maybe that's why it became so famous during COVID. Firstly, it helps with collagen formation, which is going to lead to better wound healing and lesser bleeding. It's an immunomodulator as well as an anti-inflammatory drug. It decreases your hypoxia-inducible factor, decreases DNA methylation, histone methylation. All of these are involved during the process of inflammation, oxidative stress. It also increases your carnitine, catecholamines, and other hormones. All of them are involved during sepsis and inflammation. So vitamin C deficiency is actually more common than we think. There was a study which was done in India in 2011, which showed that an alarming number of 73.9% people from North and 45% people from South were actually deficient in vitamin C. So why does vitamin C deficiency happen? Normally, body can store vitamin C for 3 to 4 years, but in especially our CKD patients who have poor intake because of appetite, anorexia, altered taste. They have huge dietary restrictions, specifically citrus fruits and other kind of fruits are restricted in general. There is loss of vitamin C during dialysis. 50% of vitamin C levels, there's a decrease of 50% of vitamin C level with every dialysis session. Uremia alters its metabolic pathways, and polypharmacy, especially your antacids, can lead to interference with gut absorption. So let's look at the good and not so good. This is the KDOQI guideline, which recently came out in 2020. What it says about vitamin C is that in adults with CKD 1 to 5 or post-transplantation who are at risk of vitamin C deficiency, it is reasonable to consider supplementation to meet the recommended intake of 90 mg per day for men and 75 mg for women. It also analyzed a number of studies which has been done around vitamin C, especially in your dialysis and other CKD patients. What it found was, yes, vitamin C is deficient in our patients. About 40% patients of CKD are deficient. But the studies, which were 5 RCTs and a few case control studies, they did not show any difference in quality of life, mortality, hospitalization in dialysis patients when vitamin C supplementation was given blindly. These studies did not measure the baseline vitamin C level. They were just given in fixed doses like 500 mg after every dialysis session or 250 mg, and they found supplementations did not actually improve the quality of life. Other things that vitamin C it was studied for was the nutritional status. It showed that your pre-albumin and your albumin levels did not change. It's commonly and famously known as an antioxidant and is used in non-inflammatory states. It did not decrease the CRP levels either. However, it was also noted that when you give it at high doses like 200 or 250 mg or more, 3 times weekly, that is in dialysis patients, there is an accumulation of oxalate and other toxic metabolites, which can lead to potential toxicity. The one part where vitamin C is commonly associated is its use in anemia and CKD. This part was not covered in KDOQI. I have individually analyzed this. What vitamin C does is that it's basically a reducing agent. So it decreases your ferric form to a Fe2 plus form, and it improves the mobilization of iron from the stores into the blood, where it can then be used for hemoglobin formation. So it is useful in states of wherein we have high ferritin levels. So there's increased tissue stores of iron in the body, but there's a decreased utilization. So it can be used sometimes as an adjunct to EPO or iron therapy. And like we've already discussed, vitamin C deficiency is common in our patients. So let's look at some studies. Does it really help? These studies all came out in early 2000s to like 2015. This was one of the first studies. It compared giving vitamin C 3 times a week to patients, and they were analyzed against the placebo group at the end of 6 months. And what they found was that patients who have high ferritin levels at baseline, if you gave them vitamin C 500 mg 3 times a week, it led to a significant decrease in your EPO dose requirement and improvement in your TSATs. And this was specifically for patients with high ferritin level. This was another study. Patients who had moderate iron stores, in the sense they were normoferritinemic, but their stores were between 100 to 500 microgram per liter. It was seen that even in these patients, if you gave vitamin C supplementation, these were all IV vitamin C, there was a significant improvement in the iron profile and decrease in ferritin levels. So furthering these, people try to even compare oral vitamin C instead of IV vitamin C. And however, this was one small study. It was done only on about 30 patients. What they found was that oral and IV both don't work in improving your iron profile. And in fact, there is an accumulation of oxalate in blood. However, in the 3 months of follow-up in this study, there was no toxicity because of oxalate, which is basically your cardiac toxicity or stone formation. But this is only a 3-month follow-up and again, a small study. So the problem with vitamin C is that most of the studies are extremely small. The RCTs have a sample size of 30 to 60 or maximum 100 patients, and they all have mixed results. So the cat is still out of the bag for this particular indication. we might be able to use it in patients who have very high EPO requirements, very high ferritin levels, can't give anything else. But there are newer therapies now coming in. This is just a cheaper modality which might be used in some settings. The another thing that vitamin C, like we spoke about COVID, there are a lot of trials of vitamin C, a lot of interest of vitamin C around sepsis. So this is one of the largest studies which was published recently in sepsis. This is sepsis with patients and in patients of sepsis with ARDS. This was published recently in 2020 in Nutrients. Sorry, ironically, this was actually a negative study, the Citrus ALI study. They had some 43 outcome parameters, of which SOFA score was the main parameter. And grossly, if you use high dose vitamin C, that is at 50 mg per kg, the SOFA scores didn't improve much. But there was a post hoc analysis, and in which they analyzed that of the 43, the four most common indicators, that is your ICU free days, your hospital free days, your mortality, and your ventilator free days. Among these three of them, it was significantly, three of the parameters significantly improved actually with vitamin C administration. There was actually an 81% decrease in the mortality, which is a handsome decrease. So there might be a lot of, because we are commonly associated with sepsis, as AKI occurs in 50% patients, RRT is needed in 20%, there might be a lot of vitamin C, which is now going to be used in the future in ICU, especially in septic patients. So we need to know what is the metabolism of vitamin C. Like I spoke about, in single intermittent dialysis session, it reduces by 50%. The rate of reduction is actually even higher when we are talking about CRRT, because there is consumption-related substantial oxidative stress because of the extracorporeal circuit, which can lead to more consumption of vitamin C and lesser plasma levels. So a supplementation of as high as 2 to 6 grams per day might be required in patients who are septic and or on CRRT. The other model where vitamin C has been studied a lot is drug-induced AKI. This primarily came from animal studies, which show that oxidative damage and apoptotic injury is the key underlying mechanism for acute tubular necrosis. These were the initial few rat models and rat studies where they saw that if you gave vitamin C in patients along with cisplatin and colistin, which are known and commonly used nephrotoxic drugs, actually your rate of ATN. Actually, they did a biopsy study of these rats later on, and they thought that the ATN was much lesser if you gave vitamin C along with these drugs. But did it translate clinically? This is one of the only few positive study actually, which showed that colistin, when used for acute kidney, colistin is associated with acute kidney injury. In fact, it's associated in as high as 44% patients who have received it for sepsis. And if you give ascorbic acid simultaneously along with colistin, it might actually reduce your chances of AKI. The p-value was less than 0.05, as you can see. But other studies did not support it. Again, like I've said, most of the studies on ascorbic acid are small size studies. This is one study where the sample size was only 30 patients, and they used urinary NGAL as a method for detecting AKI. And what they found was that there was no nephroprotective effect. So most of the studies, in fact, actually, apart from the one I've spoken about earlier, have been negative in drug-induced AKIs. Let's get to the ugly part. So what are the potential side effects when we are giving vitamin C? Everyone thinks it's a water-soluble vitamin. You give it in high doses, it comes out of the kidney. That is not true for our patients because, again, it is metabolized in the body and it forms oxalic acid. So kidney stones is a real risk factor with use of high vitamin C levels, doses. In fact, given at very high doses, sometimes it can act as a pro-oxidant and can worsen the oxidative stress. It is a reducing agent. It can lead to hemolysis in G6PD patients, and it can also lead to incorrect glucose readings from fingerstick glucose meters. Secondary oxalosis is a real risk factor with this, especially in patients who have a GFR of less than 30. Normal vitamin C ascorbic acid levels of more than 100 micromole in blood is what is associated with secondary oxalosis. Lesser levels are actually needed for erythropoiesis and wound healing and for the deficiency improving effects of it. So going above a certain level and overdosing vitamin C actually can lead to side effects. Maintaining it in the median level of 30 to 70 will give you all the benefits. Hemodialysis, when patients are on hemodialysis, and especially if high flux dialyzers are used, it actually decreases the plasma oxalate levels by 71%. And it also reduces your vitamin C levels. So they are dialyzable. This is a recent study which has come out in JASN. In all the previous studies which did monitor, and even in KDOKI, it has been mentioned that oxalate levels did increase, but whether it translated to a clinically significant mortality, we didn't know. But this has now been proven. JASN recently published an article which showed that in dialysis patients, if you have increased oxalic acid levels, then this actually leads to higher mortality and higher level of cardiac deaths. Oxalate stones, we've already spoken about how vitamin C can lead to oxalic acid. Because of time constraint, I'm just going to skip through this really fast. This was a study which actually showed that the vitamin C supplementation is a risk factor mainly for males. This is 11-year follow-up, and this is a very large study of 45,000 men which were done. And vitamin C supplementation at more than 1 gram per day actually leads to increased chances of calcium oxalate stones in males. So the take-home message is that CKD patients are at high risk of vitamin C deficiency, especially a dialysis patient. Initiation and cessation of vitamin C supplementation, as well as supplementing dosage, should take into account the individual's nutritional status, dietary intake, comorbid conditions, and dialysis modality. Malabsorption or disease of an inflammatory nature, patients who have these are more prone. So yes, please go ahead and supplement them. It might improve erythropoiesis, but always make sure that you look out for oxalate toxicity, especially if you're supplementing at high levels of more than 500 mg per day. There is an emerging role in sepsis. It's an antioxidant, and lipid profile should be monitored in these patients. And the role in drug-induced AKI is not yet established. Thank you.
Thank you, Smriti. That was a very, very crisp presentation, I must say.
Thank you.
I had a question actually while you were discussing this. The studies that you quoted, were they the ones which had used dietary vitamin C in any of them, or they were all of pharmacological supplementation?
Ma'am, these studies for pharmacological supplementation. Yeah.
Because I would just say that probably dietary vitamin C may not behave so harshly for patients, for CKD patients. And what you said was very, very right. When they are given too much of it, definitely the oxalate problem would be there. So that would probably happen only with supplementation of vitamin C, but not with the dietary vitamin C. What we have to remember is that dietary vitamin C is definitely going to help the patients, even for the little erythropoiesis that it may contribute to. Because you know that CKD patients really have a problem with that, and anemia, once it starts, is going to be difficult to control for them. But that was a very nice presentation, because even for dietitians who feel that vitamin C should be given as rampantly as possible, we have to be very cautious to know that we might be in, risking stone formation as well. So thanks a lot. I haven't seen the chat if we have any questions.
I think I'll want to know from Vishwanath his inputs on oxalates and vitamin C, especially in the COVID era. Whichever kidney biopsies have been done where people have received a lot of IV vitamin C has shown even in the biopsy oxalate crystals. So have you come across any literature or patients of oxalate problems?
Not directly, sir. In fact, as you mentioned, many of our patients, even before you write vitamin C, they're already on vitamin C. There is this famous combination of C plus available. They're already there. They send you a picture saying, can I take this? Sometimes it will be difficult for me to answer for our CKD patients and transplant patients, saying, can I take this? If they say, sometimes I keep silent, I won't tell anything. So unless they insist, I tell them you take for a few days and stop. And we have one physician who routinely writes for all patients who come with sepsis. Probably for short time, it is okay. For long time, as mentioned by Dr. Smriti, I would be a little concerned about secondary oxalosis and oxalate absorption.
True. So stones.
We have had a couple of COVID and AKIs, but fortunately, we haven't seen oxalate crystals in those. Most of it were TMA, AKI, and AIN like picture. Definitely, I would be wary about using too much of vitamin C. I have a question for Dr. Smriti. In fact, as Dr. Rita mentioned, we saw a lot of vitamin C data coming up in 2003 and 2000 era, and then after that it slowly went off, maybe because people were worried about side effects. Can we use in somebody who is not responding to erythropoietin or has resistant anemia, if we can help them for a short time? What are your thoughts on that?
Yes, sir. So, like you mentioned, most of the data that came out in 2003 were all smaller studies. And then because maybe EPO, iron, and then the entire conversation went to HIF inhibitors later on, vitamin C has been left behind. But because it's a cheap drug, it's cost effective, and our patients are deficient, I would suggest in patients who are hyperferritinemic and are on high doses of EPO, we might give a short trial of vitamin C, maybe for like 2 months or 3 months, and see the response to it.
Any thoughts of anemia in transplant patients, vitamin C helping, or any side effects of vitamin C in transplant patients?
Sir, again, GFR patients who have a low GFR around 45, 30, chances of oxalosis is always there. So we might, especially if there are males and they're susceptible, or their primary disease was renal calculi, in that case, I think we should be a little wary. But we can, sir, again, the dosing is the main thing. If you keep it below 250 mg per day, I think we can give it a try for a short period. The most side effects that we saw were above 250 mg per day, and the recommendation is around 70 to 90 mg. So maybe around 100 to 150, we can give them a try.
Thanks, Smriti. Great talk. Thanks, Vishwanath and Rita Patil, for your comments and chairing the session. And I was doing locum for Ian Day. Is he around as an anchor, or I will continue?
Yes, sir, I am around.
Oh, good. So
thank you. So excellent talk, Dr. Smriti. Thank you. And vitamin C has crept into our prescription, and if we are brave enough to stop it, and if a patient even has a little bit like worsening of bloating, then be sure you will be held responsible. So it's that stage that we have left with. We now come to the last part of this very important session, and it's a very, very relevant talk as well on herbal medicines and gym supplements. So to chair this session, I would request Dr. Srijit Parmeshwaran sir to come on board. He needs no introduction. He's a professor at JIPMER Pondicherry, and he established the Department of Nephrology there. And along with him, I request Mrs. Sugata Bhatte, registered dietitian, IDA India, and ex-registered dietitian of HCPC. Please welcome.
Good afternoon, everyone. Thank you, everyone, for having me in this program. I would not delay the session. I'm happy to introduce my good friend Sanjeev from Chennai. He's the head of department of nephrology at Savita Medical College, and he's quite active on social media, be it nephrology as well as nephrology education as well as COVID-related information. He's part of the nephrology social media collective as well. If you have anything more to add, Ms. Sugata, you can please do so before.
Yeah. Thank you so much, sir. I'll also not take too much time. I would first like to thank the team at Srnmcon for having such wonderful topics and very relevant topics to today's time. After two different talks on vitamin D and vitamin C, we've understood that supplements, we understand that, okay, with the right dosage, they might be useful, but if you go over and above, it might not be useful, it might cause harm. But the patient, when they come to you, in order to avoid medication, in order to avoid, lifetime dialysis, they will try every possible alternative medicine, alternative therapy that will be available in the market. And they do not have that information of the right dosage, etc. So it's a very relevant topic, and I look forward to listening to Dr. Sanjeev Nair on nephrotoxic effect of herbal medicines and gym supplements. Thank you so much.
Thank you. I'm just going to try and share my slides here.
Both Srijit and Sanjeev are from Tamil Nadu, the heart of whatever Siddha medicine or the herbal medicines, and we are looking forward to hearing your thoughts on the immunomodulators used. If I'm not mistaken, officially the government of Tamil Nadu had given, at least to my son when he's studying, he suffered from COVID, he was officially given that whatever medicine Siddha. Not able to share?
I am not really sure if I'm sharing. Am I sharing now?
No, you're not. No.
Yeah, you are right, sir. In the sense, not only in Tamil Nadu, Pondicherry government as well.
Yeah.
Some of these Siddha preparations were while he is trying to share his slide.
Yes, I know.
This was being widely distributed even through medical colleges, and it is
Yes.
not public thing. In fact, I can share you when my wife had the H1, H5N1. We stay in the Jimma campus. The primary health center, which is attached to state government, they came home and said that both me as well as my wife should take.
Yes, yes, yes. You take the name again. I'm trying to pronounce it. Kudinir, right?
Yeah, like there are multiple Kudinir. Kudinir basically means a liquid preparation. I'm also trying to recollect the names of that. There are actually multiple preparations of Siddha, which comes with the suffix of Kudinir.
No, what amazed me was it was officially being given by the government of Tamil Nadu to the patients. Sanjeev is not able to. Let me ask my technical team to help you. You have sent the slides?
You are muted.
He has not been made the co-host. If we can make him the co-host, he'll be able to share the screen.
He can, ma'am.
Yeah.
Sir, just open your slide first.
All right, slides open.
And now open your Zoom.
Zoom is also open.
Now click on that green button, share screen.
Share screen.
Yeah, done.
Now just click on your PPT.
Click on the PPT.
PPT.
Yeah, okay. Has that worked?
I don't know what happens after you share screen.
Any windows popping up?
I'm asking. They're asking me for opening up the system preferences, and for some reason,
I think you'll have to restart the whole process again.
I'm calling you on WhatsApp video. Please answer. Show me the screen.
I'm really sorry for this. This should not have been.
No, it's okay.
If you are using Mac,
go
to the system preference and unlock from that.
Yes, that's what I'm trying to do. I am trying to. For some reason,
Mac is a big problem. The problem is Mac.
We'll have a debate on that later on. But for now,
even it took me like 10 minutes to set my Mac, and I was like, why
Yes.
do I have a Mac?
Yeah.
You have to unlock from the system preference.
yeah, I am trying to do exactly that. And for some reason,
So you can just mail me.
Is it possible to mail the slides?
Yeah, I'll do that straight away.
Yeah.
I'm still figuring.
Yeah.
Well, we can continue the debate of Mac if people are keen on.
Tapping the mail ID in chat box.
What is the maximum dose of vitamin C that you've seen prescribed?
1 gram 8 hourly, I think.
So I've seen 3.6 plus 15. So 5 grams per day is what I've seen.
Yeah, in the market, sir, we have 5-gram supplements available. There's some which are even up to 10 grams also. But they come from an unregulated market, so we got to be very careful.
Meanwhile, I was just looking up the name of the Kudinir.
Kudinir, yes.
Kabasura Kudinir.
Yes. Come again.
Kabasura.
Kabasura, yes. So my son religiously took it because he was a first-year resident there. So he was forced to. He was admitted for asymptomatic COVID because he was in the same college. So Kabasura
Kudinir is one, and then another one is Nilavembu.
Nilavembu.
Yeah, these are the two most popular things. Everywhere it's distributed in public places by the politicians, and it is distributed to inpatients in hospitals. It is distributed for prophylaxis for COVID also. It seems to be one drug for everything which has fever associated with it, be it dengue. They give it for dengue fever. They have been giving it for dengue fever for a few years, it seems. And when H1N1 came, they were giving this. The thing is, it's not the problem. I will tell you is not only with this. This has become like a common remedy, and everybody takes it. But there are other preparations also. I would say practically everybody with kidney disease now goes and takes something or the other. Okay, some of them tell us, some of them don't tell us.
So it's a keynote presentation.
I'm just sending you the PPT as well.
So are you all seeing in Pondicherry a higher incidence of herbal medicine induced acute kidney injury?
Yeah, acute kidney injury. In fact, there is a case series of membranous nephropathy which we have published in KI reports 2 years back. Proven biopsy proven membranous with the serum and urine assay of mercury also done. Some of them had sky high levels of mercury. That is one which is clearly demonstrable. And we know the association. And two of them were our own nursing staff, nurses who took it for asthma. Siddha medicine they took for asthma. And AKI and all we do, but the problem is most of the time like Gopalakrishnan sir is sharing his message in the group in the chat. Swasakalpa name he has
Shwasakalpa.
Shwasakalpa, yeah, that
Membranous
is the one our nurses were taking.
Gopal Krishna is around. Okay. Nilamambu Kudinir.
So I have the talk. Do you want
right.
me to present?
Yeah, if you could just start off the slides. I've wasted time as it is of everybody and we're late as it is. So let's just start off.
So we are 5 minutes late.
I am very aware, sir, and I'll try and finish as soon as possible.
By now you know me, so.
Yeah, I know you stop me off.
Everyone knows you before, sir, not now.
Can you see the screen?
Yeah.
Let's start. Yeah.
All right. So thank you so much to the organizers. Apologies for the delay, and we'll start off straight away. Akash.
Yep.
All right. So the thing is, plants have always been used for their medicinal value. Off the top of our head, most of us can list out digitalis or quinine or artemisinin, which are used. Which are plant-based drugs which we use for treatment of common ailments. But there are more than 120 drugs which are developed from plant-based chemicals. And I use the word developed because there is a good manufacturing practice involved. These compounds are tested and isolated. The active metabolite is isolated. Then there is a process of testing for safety as well as efficacy and independent regulation before they are approved for human consumption. But most natural herbal remedies are often concoctions with multiple herbs, sometimes some adjuvants to make the concoction palatable or stabilize them. And they are dispensed by native healers or unlicensed practitioners. So the issue is that there is no safety efficacy testing for the natural remedies. But these are the mainstay of medical care in a lot of developing countries, especially in sub-Saharan Africa. About 60% of the primary healthcare is natural and herbal medicines. And in China, from where the whole concept originated, as well as in most of rural India, as well as many parts of urban India, where we have our own alternative forms of medicine. Increasingly, these drugs are also being used in the developed world, that should be developed world, as weight loss pills or dietary supplements, and now, especially post-COVID, immune boosters. So the global turnover for the natural remedies is estimated somewhere about 85 billion and captures about 20% of the market. Next slide, Akash. So the problem that we see as conventional medical doctors is that our drugs are tested and therefore have proven side effects, and that is an issue. Next slide. And that is an issue for most of our patients. So why do they use herbal medicines? They identify our drugs as having too many side effects and then prefer drugs which are supposed to be natural and that is automatically considered safe. Many of them also want to take ownership of their own health and use these medications as supplements to what we are prescribing. And one of the other things is that these are not even considered medicines quite often. They're considered, because they're considered supplements and immune boosters, they're taken long-term and at whatever dose the patient thinks that he or she needs. So that's another problem. Next slide. So why do the herbal medicines cause nephrotoxicity? Can you click for me, Akash? The toxicity of these medicines have been well described for a long period of time. And they cause toxicity sometimes because we don't know whether the herb that we are taking is toxic. Sometimes there is a misidentification of something of a herb, and that is substituted for something that is harmless. And this is something that has happened with aristolochic acid, which we will come to. There is often deliberate or inadvertent contamination of conventional drugs with toxic chemicals. There can be potentiation of the toxic effect of a conventional drug because of its co-use with a herb. Now, this happens with green tea and grape juice, which are very well known CYP3A4 inhibitors, or something like ginkgo biloba, which is a well-known CYP3A4 inducer. You can also have it rarely by using consuming meat which is already from an animal which is grazed on toxic plants. Hemlock is a common example. It causes respiratory depression as well as renal toxicity and rhabdomyolysis. Next slide, Akash. So, like we said before, some of these compounds or their active metabolites can be directly nephrotoxic. There can also be toxicity because of the addition of either adulterants or additives to stabilize the concoction while manufacturing the product. And there can be interaction with other concomitantly administered drugs. There are drugs which also cause diuresis, rhabdomyolysis, or nephrolithiasis, and thereby alter the body homeostasis, and that can cause nephrotoxicity. Next slide, Akash. So the thing is, because there is a lack of pharmacovigilance, we don't know the exact incidence and prevalence of herbal nephrotoxicity because it is mostly a self-volunteered information and we have to ask for it. Next slide. So coming to this case report, we have a 33-year-old dancer who was previously well. She was brought to the ER with a history of painless hematuria, reduction in urinary output, and was associated with both pedal edema as well as facial puffiness of 10 days duration. She came with a history of consuming Chinese herbal tea, which she had said she was taking for general system cleansing and with the additional benefit of weight loss. So she was taking this for 5 days prior to the onset of these symptoms. She had no other previous history, no dysuria or trauma, or no previous hematuria, but there was a history of vomiting and hiccups. Now, and when she presented, she was acutely ill, pale, with anasarca, with stable vitals. Next slide. The investigation showed a urine with 1+ proteinuria and 3+ blood. RFTs were significantly elevated. Potassium and bicarb was okayish. So this patient was started on hemodialysis, and she had to continue 4 to 5 sessions of hemodialysis before she started to recover. Finally, she had a complete recovery, but this is one of those cases. So the mainstay of what is considered herbal medicine toxicity is the Chinese herbal medicine, and they have two main components of nephrotoxicity: aristolochic acid and alkaloids. Aristolochic acid are a family of carcinogenic, mutagenic, and nephrotoxic phytochemicals, and alkaloids are nitrogen-containing organic compounds which are derived from multiple plant species. The kidney is the usual route of excretion of both these compounds, and because of the high flow rate as well as the large endothelial surface of the kidney, a large amount of the toxin is delivered to the renal parenchyma, and in a setting of dehydration, the active tubular transport will ensure that the medulla sees a high concentration of these toxic compounds. And the nephrotoxicity associated with these medications include acute kidney injury, chronic kidney disease, nephrolithiasis, rhabdomyolysis, Fanconi syndrome, as well as urothelial carcinoma. So aristolochic acid is the most well described of these compounds, and its toxic component was known from the late 50s to 60s. It is found in the roots, stem, leaves, and fruits of plants in the Aristolochia and Asarum genera. And the clinical features are usually insidious of a progressive decline in renal function that is either incidentally picked up or the patient presents directly in end-stage kidney failure. There is evidence of proximal tubular dysfunction with some glycosuria, sometimes even other a full-blown Fanconi syndrome. The proteinuria is not significant, therefore the patient does not have much edema. There is some hypertension. Severe anemia disproportionate to the degree of renal function is common. Patients have present with contracted kidneys and rarely have urothelial malignancies as well. Once these patients progress, they generally end up in end-stage kidney disease. There is no known treatment for aristolochic acid nephropathy. Steroids and RAS inhibition have been tried without much success. This brings us to Balkan endemic nephropathy, which has a lot of striking similarities with the aristolochic acid nephropathy. Now, this is endemic to the Danube River basin, so Croatia, Serbia, Bulgaria, that area. And patients similarly have a chronic interstitial nephritis kind of picture, which is insidious. And when they looked at the early parts of why this happens, wheat contaminated, flour contaminated with aristolochic acid was mentioned, but there were other hypotheses which was followed. One of the main was something called ochratoxin, and heavy metal poisoning and insecticide poisons were also considered. But a 2007 paper published in JASN, I think, sort of established the causality of aristolochic acid for Balkan endemic nephropathy by demonstrating the presence of DNA which was bound to aristolochic acid metabolites in the renal tissue of these patients who have Balkan endemic nephropathy. So, but one of the big differences between the two is that patients with Balkan endemic nephropathy progress much slower to ESRD. And one of the reasons for this is possibly that in aristolochic acid nephropathy, there is a consumption of a large amount of the toxic compound within a short period of time, as opposed to a much smaller rate of consumption in the Balkan region. And genetics also probably plays a part. Next slide. So the method of injury for these patients is nephrotoxicity, which is because of increased mitochondrial permeability. These patients have tubular cell apoptosis, and that is mediated by decreased expression of EGF and VEGF. In tumorigenesis, like we said before, the AA metabolites bind to the DNA, and that bound compound sort of increases the expression of HRAS and P53 overexpression, and that affects the cell cycle regeneration process in these patients. Next slide. So this is, I think, the a sort of miniaturized list of the more frequently mentioned herbs which can cause, and there's pages and pages of this available for those of you who want to go out and check what else is there. I picked Salix daphnoides on purpose because willow bark, as it is commonly known, is used as an analgesic, and the toxic compound is salicylate, and which is another compound which we have isolated in conventional medicine from Salix alba. But when used directly from the bark, it causes renal papillary necrosis. Chaparral is a home remedy for gas, cramps, and common cold, and its continued use is known to cause renal cell carcinoma. Licorice, we all know, can cause hypokalemic nephropathy, acute hypokalemia, rhabdomyolysis, and AKA also. Yohimbe is known to cause a SLE-like syndrome. Rhubarb causes chronic interstitial nephritis, and this is something that we see quite a lot in South India. Oduvan poisoning, which is a kind of leaf which is used by a lot of people here to self-abort and suicides, and it is known to cause AKI, which is extremely difficult to treat. Patients usually end up dying. Next slide. So with that, we'll sort of move to, yes, all right. There is also the fruits. I'd like to mention cranberry and star fruit here because those are taken not for as herbal medication. They are usually just consumed normally, and in excess can cause obstructive nephropathy. And we all know that our own alternative forms of medicine can be contaminated with lead, mercury, or arsenal and cause chronic interstitial nephritis. This brings me to the second half of this talk, which is the gym supplements. And the question is whether we can, Akash, next slide, whether we can muscle up without natural. Akash, hello? Yeah, whether we can muscle up naturally without the supplements that we're using. And that's actually an interesting question because as we speak, my brother's trying to end up looking like this without much success, without the benefits of all the supplementation. Next slide. So we have another case to put. This was a patient who presented to us about a couple of years back. He's a 29-year-old male who was obviously building his body on a high protein diet. He was taking anabolic steroids with some other unknown supplements, and albuterol tablets, which he was taking for two specific reasons. Apparently, albuterol decreases the degree of respiratory distress at the end of workout, as well as allows you to build up your muscle faster. So he presented with azotemia, which was very high, required dialysis on a biopsy because it showed global sclerosis, and is currently awaiting a renal transplant. Next slide.
Sir, we are almost reaching.
Yeah, I'm done. So these are the common supplements that are in vogue. And the next slide, the main one that we need to talk about is anabolic steroids, which cause three types of injuries. One is FSGS, which is associated with long-term use, and that is mediated by multiple channels of injury, RAS activation being one. It also causes increased endothelin production, reactive nitrous oxygen products, and triggers an inflammatory cascade. So unless the steroids are discontinued, these patients progress to chronic disease. Bile acid nephropathy is seen in the context of cholestatic liver disease. It improves with improving jaundice. And renal artery thrombosis, there's only one case report, and that patient ended up requiring nephrectomy. And that's again a direct effect of the steroids on hemostasis and increased platelets as well as platelet activation. The other toxic supplements are creatinine monohydrate. There is only case reports. One RCT did not show any risk. Multivitamins, vitamin D is the male culprit, and this veterinary dose of vitamin D is upwards of million units, which they use. The energy drink, which is associated with AKI, is Red Bull, 2 to 3 times daily for weeks together. Branch chain amino acids do not seem to cause problems except in animal studies, and whey protein is safe even at 1.6 to 2 grams per kg per day if you're physically active. Next slide. I think that'll be my last slide. Yeah. So herbal medications are not without side effects and should be part of a differential diagnosis for a wide variety of renal injury patterns. In the absence of pharmacovigilance, a high index of suspicion will aid diagnosis in these patients. Traditional Indian alternative medications may be contaminated with heavy metals, resulting in kidney and liver disease. Gym supplements should ideally be taken only under professional medical guidance, and the indiscriminate abuse of supplements can lead to kidney disease. Thank you.
Thank you, Sanjeev. That was a nice overview of the currently available literature on this thing. I just want to make 2 points because we are short of time, and I would like to know your response to that. So, in fact, we had done, there's a paper which came in CJASN, which is part of our ICKD national cohort, where we have around 5,000 patients being followed up. And we did a study on the prescription pattern and found that around 23% of the CKD patients, in fact, reported taking herbal medicines. Okay, so my guess is that this is actually much more than what is reported. What we see in our actual practice is much more, and this is basically underreported. The underlying problem seems to be more systematic in India because of this Ayush law which has come in, which has exempted. This seems to be a worldwide problem, and it is there in India also, where all these drugs are exempted from the rigorous checks and balances which regulatory control the modern medicine pharmaceutical subjected. So neither they are the quality control for their manufacturing practices are not rigorous. There is no need for them to report adverse reactions on the drug farm preparation itself. Neither the composition is usually supplements they are being marketed. So my question is, what do you see is the solution? Because this is a very systematic, officially propagated, officially promoted, and for the lay person, this gives the misgiving that because this is exempted, it gives the impression that this is safe. It is taken for granted that this is safe. That is why the law doesn't mandate it to be tested. Whereas we know that it is the other way around. We have enough and more evidence. So that is one. The other thing is we have not really, unlike the studies which you have quoted, most of the preparations, we don't know actually what are there are too many preparations, and we really don't know what is the composition and what is the health impact of these things. There seems to be a total lack of scientific study on that aspect also. So what do you see the solution to this problem, the real life problem we are having?
So two things. One is obviously there will need to be a greater law which will bring about greater regulatory oversight about these drugs. But more importantly, I think we need to have kind of lab access to be able to prove causality for some of the things that we are seeing. I routinely have cases where they present with acute interstitial nephritis or chronic interstitial nephritis due to a compound that they have, but I'm not able to test it and prove causality in any way because of access to labs which can do that for us. I think that's one of the things that we need to sort of demand and make sure it happens.
What do you tell your patients when they ask you that? Sorry, I think we are out of time.
Yes, sir. I'm sorry. Thank you so much, sir. We can talk so much about this. This is such a relevant topic.
Absolutely fine. Thank you, everyone.
Yes, sir. But thank you so much. We now move on to the next session, which is also very, very relevant, very important in our CKD management. And we'll deal with phosphorus, uric acid, and lipids in CKD. Are we clear or still confused? To chair the next session, we have with us Dr. Sunil Prakash sir, who is a senior director and head of the Department of Nephrology at BLK Super Specialty Hospital. And we have Dr. Pradeep Salgia, senior consultant, nephrologist and kidney transplant physician from Choitram Hospital, Indore. And to give the talk is Dr. Arvind Majumdar, who is my mentor, who is the reason why I joined nephrology. Sirs, please start the session.
Hi, good afternoon, everybody. We have Dr. Argya Majumdar, who is a high special training in nephrology. He's a director and head of nephrology from AMRI Hospital. He's head of Department of Medicine at AMRI Dakoria, present Indian Society of Nephrology, East Zone. And we all know that's a very difficult topic because it's a nephrologist dilemma. I mean, it's very difficult. The phosphorus level has to be controlled to right level, and it's all the nephrologists find it's very difficult. And now for this, we have Dr. Majumdar. I would request him to present his talk.
There seems to be some technical issue with Dr. Majumdar joining. We are trying to sort that from our end. Let's just wait for a couple of minutes. But would love to have your insights on this till the time he joins. Back on the modalities.
So what are your thoughts? So why don't we start the discussion till the time Dr. Majumdar joins us? How do you approach? What are your targets to managing hyperphosphatemia and CKDs?
If you're asking me, I would say the target for hyperphosphatemia non-dialysis patient, I would keep the phosphorus close to 4.5. While for dialysis patient, I can go up to 5.5. But again, as we know that each milligram rise in phosphorus, there is a significant increase in mortality. So at any case, I mean, keeping close to 5.5, less than 5.5 in dialysis and close to 4.5 non-dialysis patient is a safe target range.
Correct. I think Dr. Majumdar is here, so we can probably initiate the talk and then move forward the discussion after the talk. Tech team is, yeah.
Hello. Good afternoon. Can you hear me?
Yes, we can hear you.
Yes, we can.
I'll share screen. But it's not just 1 minute. Okay, good afternoon. Can you see the screen?
Yes, sir.
Yes, sir.
Yeah. Just enlarge it. That's it.
Enlarge it, yeah.
The slideshow, sir.
Slideshow.
Yeah.
Perfect.
Is that okay? Right.
Yeah, perfect, perfect.
Fine. So today I'll be talking on hyperphosphatemia in CKD. Now, if we look at the causes of CKD, we can see a very important cause is reduced glomerular filtration rate, that is acute kidney injury or chronic kidney disease. Now, why is hyperphosphatemia important in CKD? Now, hyperphosphatemia is associated with significant pathophysiology in CKD. This contributes to the high rate of mortality in these patients. And actually, the risk of death in CKD due to cardiovascular events is more than the risk of surviving and needing RRT. The propensity of CKD patients to develop heterotopic mineralization of soft tissues, including the vasculature, is a very important component of the cardiovascular risk. And hyperphosphatemia has been directly linked with vascular calcification. And it is also an independent cardiovascular risk factor in CKD. Now, there are multiple studies, the ERIC study and the Framingham study, which all show that higher phosphorus is associated with cardiovascular events and mortality. Now, let's have a look at the phosphorus balance. Now, intake of food. This is an American diet, so which sort of includes the intake of phosphorus about 1200 milligram per day. In Indian diets, it's lesser, about 800 milligram per day. And of that, 400 milligram is excreted in the feces and 950 milligram absorbed into the body. And this is in a interchangeable pool. The blood component just comprises less than 1%. So 1% of the phosphorus is free in the circulation. And an important reservoir of the phosphorus is the bone. And there is osteoblastic activity, and there is formation about 300 milligram phosphorus, which is deposited in the bone, and about 300 milligram resorption daily, which maintains the balance. And this phosphorus comes into the phosphorus pool. And about 800 milligram of the phosphorus is excreted in the urine. Now, what happens in CKD is this excretion in the urine decreases to, say, 650 milligram per day. And we are restricting phosphate in the diet. So say the intake has decreased from 1200 to 1000. And of this 300 milligram is excreted in the feces. So still about 750 milligram is absorbed into the interchangeable pool. And in CKD, a change which occurs is resorption from the bone increases and deposit in the reservoir of the bone decreases to about 100 milligram per day. So therefore, the body develops a new reservoir for the phosphorus, and that is the soft tissues, including the blood vessels, where about 200 mg of the phosphorus may get deposited. Now, if you look at the regulation of phosphorus balance in CKD, first of all, we know that in CKD, the vitamin D activation is less, so there is less calcitriol, and this increases the calcium absorption from the gut. The phosphorus absorption remains the same, and the decreased serum calcium stimulates the parathyroid gland to secrete PTH. This increases the reabsorption of calcium and calcitriol synthesis, but decreases phosphorus reabsorption. Also, excretion in the kidney is decreased. So therefore, we get an increase of serum phosphorus. To deal with this is the molecule FGF23. Now, actually, FGF23 release is not increased, but FGF23 itself is excreted in the urine. So therefore, with the ongoing CKD, FGF23 levels increase, and that is the phosphatonin, and it tries to compensate for the decrease in GFR by increasing the phosphorus excretion through the kidneys. Now, I told you there's a new reservoir, and that is the deposit of phosphorus in the blood vessels. This vascular calcification increases the vessel stiffness, and this results in increase of pulse wave velocity, increased pulse pressure, and we know the disastrous effects of coronary calcification, that is decreased coronary perfusion and also left ventricular hypertrophy. This leads to various cardiac disease events like coronary artery disease and heart failure. So therefore, after understanding the background, so phosphorus balance and its alteration in CKD and why it predisposes to cardiovascular disease, we know that why it is important to control phosphorus. And the KDOKI practice guidelines have already laid down that in CKD stage 3 and 4, the phosphorus should be maintained in the normal level, that is between 2.7 and 4.6. And in stage 5 CKD to about 3.5 to 5.5. And you know the intact PTH levels in CKDs 3 and 4 should be 35 to 70 and 70 to 110. However, in CKD stage 5 on dialysis, they should be maintained at a slightly higher level of 150 to 300. The KDOKI guideline recommends that the phosphorus intake should be less than 1 gram per day. And it suggests that limiting dietary phosphate intake is important. No exact cutoff is provided in the guidelines. And as phosphorus intake is linked very closely to protein intake, it suggests limiting protein intake to 0.8 gram per kg per day in patients with GFR less than 30 ml per minute. And suggests definitely to avoid high protein intake more than 1.3 gram per kg per day in patients at risk for CKD progression. And consultation of patients complicated by differences in the dietary phosphate content, as I explained, between the Western diets and say the Indian diets, difference in phosphate bioavailability, which I'll deal with in a second, and no clear listing of phosphate additives in the food. Now, this is one of the main reasons for increasing phosphate content of the food. Now, what are the sources of phosphate in the diet? One is natural phosphates, which are contained in raw or unprocessed foods, the phosphates added to foods during food processing, and the phosphates in dietary supplements and medications. The bioavailability of the phosphate from the food depends first of all on the processing of food, because processing of food, I told you, adds phosphate to the food, and of course the protein intake, because higher the protein intake, so more intake of red meat, etc., you know, that increases the phosphate intake. And also the form of phosphate is very important. That phosphate in the form of non-vegetarian diets, that in the meat and fish, you know, that is more bioavailable, that is taken up more by the body than the other forms in vegetarian diets. And therefore, dietary education is one of the pillars of management of phosphates in CKD. Animal and plant-based foods contain the organic form of phosphate. Food additives contain the inorganic phosphate. and we should explain these to the patients. Now, about 40 to 60% of the animal phosphate is absorbed. Like I said, while plant-based phosphates are less absorbed, about 20 to 50%, because they contain phytates, and which is less absorbable. Now, dietary education about the best food choices are very important, and one must stress on homemade foods, as processed foods and addition of additives will only increase the phosphate content of the food. Now, this is a chart which you probably cannot see well, but this just includes the phosphate content of various proteins, and this is available on the net. So you can check what is the phosphate content of various foods, and as we can see that some of the foods like sunflower seeds contain a high phosphate per gram of protein, sort of 53.7, whereas there are other foods like cottage cheese, which has only 11 gram of phosphate per protein. So the percentage of phosphate per gram of protein also varies from food to food, and that is important when we consider dietary education. Now, the KDIGO guidelines in patients with CKD 3A to 5D, including those on dialysis, suggests that the phosphate lowering treatment should be based on progressively or persistently elevated serum phosphate. And in patients, this is the new guideline, and it is reasonable that the choice of phosphate binder takes into account the CKD stage, presence or absence of other components of CKD MBD, concomitant therapies, and the side effect profile. So that's what the KDIGO tells us. Now, what are the phosphate binders which are available for us? So all these agents bind the phosphate which is there in the diet in the gut and prevents its absorption. So firstly, we have the calcium containing phosphorus binders. That's the calcium carbonate and calcium acetate. Next, calcium citrate was a binder, but it's no longer used today because it has been shown to increase absorption of aluminium. And for the same reason, aluminium hydroxide, which was also a potent phosphate binder, is no longer in use now, because absorption of aluminium in CKD will cause aluminium toxicity, cause anemia and bone disease. Other phosphate binders are sevelamer, lanthanum, nicotinamide, ferric iron-containing phosphate binders, ferric citrate and sucroferric oxyhydroxide, and a new phosphate binder called tenapanor. I'll just touch on the binders. General principles is that for all phosphate buffers, the lowest dose that is effective should be used. If calcium-containing phosphate buffers are selected, the total dose of elemental calcium should not exceed 2000 milligram per day. And the amount of elemental calcium contained in the phosphate binder should not exceed 1500 milligram per day. So these are the general guidelines. And of course, that the binder should be taken with meals. And that is something we have to dim into the patients. So first, coming to sevelamer, which is one of the most promising phosphate binders. There are two forms available, sevelamer hydrochloride and sevelamer carbonate. These are non-absorbable cationic polymers that bind phosphate through ion exchange. The conventional dosing is 3 times a day with meals. Sevelamer hydrochloride may cause metabolic acidosis, and therefore now the carbonate form is preferred. Now, sevelamer has the advantage that it has some pleiotropic effects. It reduces cholesterol and thereby has action on reducing atherosclerosis. Also has been shown to reduce uric acid and improves endothelial dysfunction. So therefore, it is very beneficial to prevent cardiovascular disease in CKD. Lanthanum is a rare earth metal that is effective in lowering phosphate levels in dialysis and non-dialysis CKD. And compared to the other calcium containing phosphate binders, efficacy is good in suppressing PTH. An additional benefit of lanthanum may be reduced daily tablet burden. And another advantage, it is chewed rather than swallowed whole. Can I have just 2 minutes, please? There are no significant side effects reported in dialysis patients. Now, calcium-containing binders, a calcium carbonate or calcium acetate, which is more efficient, these binders, of course, may lead to extraskeletal calcium phosphate deposition if the product exceeds 50. Now, we have the iron-containing phosphate binders with sucroferric oxyhydroxide and ferric citrate. This is effective in reducing serum phosphate concentration as the same effect as the other phosphate binders, and it also serves the dual purpose by increasing the serum iron, transferring saturation ferritin, and thereby improving anemia management. The dose is 2 tabs after meals of ferric citrate. Nicotinamide may lower phosphate levels by reducing GI phosphate absorption. A randomized placebo-controlled crossover trial in 33 patients found that niacinamide significantly lower phosphate levels. This was published in CJSON. Tenapanor is a new phosphate binder. It's an inhibitor of intestinal sodium-hydrogen exchanger 3, and that was developed to treat irritable bowel syndrome with constipation, but also shown to lower phosphorus by blocking its paracellular transport from the intestinal lumen. In a phase 3 randomized double-blind trial, the safety and efficacy of oral tenapanor was studied in 209 patients. At 8 weeks, tenapanor significantly reduced serum phosphate compared with placebo by the following figures at 3, 10, and 30 milligram twice daily doses. This was a dose-finding study. Adverse effects were limited to a modest increase in stool frequency.
The last 30 seconds. I'm sorry to interrupt.
Arya, can we summarize?
Yeah, I'll just close with the Indian study. This is the Indian study which gives us an Indian perspective. This is a review article, and that highlights the cost differences, which is very important in India. Here, calcium carbonate is the cheapest, whereas you can see sevelamer, others are more expensive. So we have to, according to profile of the patient, we may have to choose the phosphate binders. And particularly, we can choose calcium-containing phosphate binder, which is cheaper when the patient has hypocalcemia. Whereas when the patient has hypocalcemia, we can opt for sevelamer and the non-calcium binding phosphate binder. So therefore, the take-home message is hyperphosphatemia is common in CKD, and it may lead to vascular calcification and is an independent cause of cardiovascular mortality, which kills most of the patients on dialysis. Dietary education is the key. Non-calcium containing phosphate binders are preferable, but of course we have to match the cost of the phosphate binders with the profile of the patient. Iron containing phosphate binders are promising as they serve a dual purpose of decreasing phosphate and also helping in anemia management. So that may be a promising thing in future. Thank you.
Would request Pradeep to close the session with his remarks.
Yeah, I would say that so many phosphate binders are available now, but still, if we see into clinical practice, we'll find large number of patients still have got a higher phosphate levels. Probably we should look into a number of other factors also, that apart from that, whether they are taking it properly, all the phosphate binders or not. And secondly, the dialysis prescription also need to be prescribed, because despite all these things, we still don't achieve the target level of the phosphorus in not quite number of our patients. I hope this experience must be shared by other nephrologists as well. So with this, I thank Dr. Agya, who gave a good and detailed talk on the hyperphosphatemia in CKD. Thank you, Dr. Agya. Thank you.
Thank you, Dr. Argya and the chairpersons. We'll now move on to the next session. I would like to introduce Dr. Arvind Kalla. He's consultant nephrologist and director, Krishna Super Speciality Hospital, and Dr. Praveen Kumar Etta, consultant nephrologist, Virinchi Hospital, Hyderabad. We will now, the session will be on hyperuricemia and CKD, and I will invite the chairpersons to introduce the speaker.
Hi. My sincere thanks and congratulations to Dr. Khanna and Srnmcon team for organizing such a meticulously planned academic feast. Hyperuricemia, yes, definitely. I'll first introduce Dr. Gopalakrishnan. He's Director and Professor, Institute of Nephrology, Madras Medical College. He is having so many publications, chapters, awards, chairman, and is advisory committee member of Prime Minister's National Dialysis Program. Without taking time, I invite Dr. Gopalakrishnan, please.
Very good afternoon. Thanks very much, Professor Umesh Khanna and his team for organizing such a wonderful academic feast and inviting me to be part of it. The topic for today's discussion is hyperuricemia in chronic kidney disease, a contentious issue. There are a lot of uncertainties about this topic. This title may sound very simple, but actually it is a very difficult and contentious issue where there are so many unresolved questions remain. For instance, the definition of hyperuricemia is uncertain. There's a lot of debate going on because of the wide variation in the serum uric acid level in the population. We don't know at which point it becomes a disease. That's number one. Number two, the popularly accepted consensus for the cutoff value of serum uric acid for definition of hyperuricemia is based on uric acid solubility point at physiological temperature and pH, namely 6.8 milligram per deciliter. But as you all know, the level of uric acid should be slightly lower in women because estrogen is uricosuric. Having said that, with a special reference to chronic kidney disease, we all know there is a very high prevalence of hyperuricemia, mostly asymptomatic hyperuricemia in CKD, according to one series, from stages 1 to 3 as high as 40%, and stage 4 and 5 as high as 70% of the patients of CKD have hyperuricemia. Uric acid has got important physiological roles. The two important ones are, it is one of the mechanisms of elimination of nitrogenous base from the body. And two, it is a potent antioxidant. You'll be surprised to know that more than 50% of serum's free radical scavenging is done by uric acid. Actually, it has got a dual role. It is a friend as well as a foe. In extracellular uric acid, it confers endothelial cytoprotection. It is important for endothelial health. In fact, compared to all other animal species, the human species, the Homo sapiens, we are lacking the enzyme uricase, which causes degradation of uric acid. This mutation, thereby resulting in disappearance of the uricase enzyme, occurred as a kind of an evolutionary advantage so that Homo sapiens can have higher level of uric acid that is important for sustaining endothelial health. It is of such a great importance, the physiological role of uric acid. But the same uric acid, when it is there inside the cell, it behaves like a villain. It is a pro-oxidant. It enhances the production of free radicals. And it initiates a host of pro-inflammatory cascades. And also it causes immune activation. It enhances the action of CD8 cells and so on. So this is the uric acid paradox. Can uric acid injure kidney? It seems to be so, at least in animal experiments. It can cause direct toxicity to the crystal, that is direct toxicity to the kidneys. And we have to analyze the nephrotoxicity of uric acid and two broad mechanisms. One is the crystal effect and the non-crystal effect. Whatever I'm describing is a non-crystal effect of uric acid on the kidney. It can directly impair the kidney function. Also, it can cause exacerbation of factors which affect the kidney, like hypertension. There are many observational studies. They link hyperuricemia with hypertension, increasing blood pressure. It causes renal vasoconstriction and inflicts endothelial dysfunction, causes activation of renin, upregulation of angiotensin II, thereby promoting the proliferation of vascular smooth muscle cells. And particularly at the glomerular level, it causes pre-glomerular vasculopathy and pro-inflammatory signaling, and ultimately that can result in interstitial inflammation. All these are observed in animal experiments. As well as there were many population-based controls, cohort studies and observational studies, which showed a graded association between the serum uric acid level and development of CKD. This prompted many investigators to investigate further and to establish this causal relationship between hyperuricemia and the chronic kidney disease. The famous MDRD study, modification of diet and renal study cohort, in which about 838 patients with CKD 3 and 4, when they were followed up for a decade, there was a positive association between uric acid level and cardiovascular and overall mortality. But mind you, there was no relationship with kidney failure. So this kind of conflicting reports are there even in observational studies. But you know, to confirm this association, we had to go ahead with randomized controlled trial. I'll talk about that in a short while. How about hyperuricemia and dialysis patients? Again, it is very highly prevalent. Very interestingly, uric acid is easily dialysable in hemodialysis. So the levels of uric acid in hemodialysis, there are multiple determinants. It all depends on the timing of your estimation in the serum. Soon after dialysis, it will be very low and so on. And also among hemodialysis patients, the inverse relationship between uric acid level and the cardiovascular mortality has been identified. Whereas in CAPD, there is lesser clearance of uric acid. And in CAPD, the relationship between hyperuricemia and the cardiac mortality and overall mortality is not consistent. There are varying reports. Fine. I was talking about the RCTs, the randomized control trial, which are the only research tool, which can, with certainty, prove a relationship between a potentially injurious agent and the causation of a disease. Let me highlight on two important RCTs on this particular question recently published. The one, serum urate lowering with allopurinol in kidney function in type 1 diabetes. This is called PEARL trial, prevention of early renal loss trial. This is the infographics. It is a multi-center, double-blinded, randomized controlled trial. 530 patients with type 1 diabetes and mild to moderate diabetic kidney disease. They were included in this, and they were randomized to allopurinol group versus a placebo group. The primary endpoint was the mean iohexol-based GFR. It is a measured GFR, not an estimated GFR, after 3-year follow-up. As you can see here, the allopurinol had no clinically meaningful beneficial effect on the kidney outcome. So further elaborating on this trial, the primary outcome, as I well said, iohexol-based GFR after 3 years. Secondary outcomes, iohexol-based GFR time trajectory, the slope of decline in GFR. eGFR based on CKD-AP formula at 4 months, doubling of serum creatinine and progression to ESRD, urine albumin excretion rate after 3 years, and finally, fatal or non-fatal cardiovascular events. There are many strengths of this particular trial. Let me elaborate on that. The study population was highly suitable. Why I say that? These study subjects had a rate of decline of GFR to the tune of about 2.5 ml per minute per year, meaning this is a vulnerable group for rapid progression of CKD. So ideal group where an intervention has to be studied. That's number one. And there was an 80% power of the study to detect a clinically meaningful treatment effect. And the study population showed a very high adherence to trial intervention. There was a sustained reduction of 36% in uric acid level in the allopurinol group till the end of this trial. As well as, the more importantly, the other co-founders, the glycemic status, blood pressure profile, and the RAS inhibition were balanced between the groups at baseline as well as throughout the entire trial. So these are the strength of this trial. So we have to take the results with a lot of respect. As you can see here, this panel, the left-hand side panel shows there was a sustained reduction in serum uric acid level by 36% in the allopurinol group. So the drug was very effective. The down column shows there was no significant difference in iohexol-based eGFR. So it is a negative based GFR. So it is a negative study. Let me go to the second RCT, effect of allopurinol on the progression of chronic kidney disease. The first one was in type 1 diabetes, but this is general. This is called CKD fixed trial, RCT, stages 3 and 4 CKD patients without history of gout, The inclusion criteria, EGFR decrease at least 3 ml per minute per 1.73 square meter in the preceding year. And 1:1 randomization between the groups, between allopurinol and placebo group. The primary outcome was change in EGFR from randomization to week 104. That is 2 years. And here the GFR was estimated GFR based on CKDAP formula. And the drug was effective in reducing the serum uric acid in the allopurinol group to the tune of about 2.7 milligram per deciliter. But as you can see here, by the end of 2 years, it did not slow the decline in EGFR as compared to the placebo. So a second RCT, it was a negative trial. So where do we stand? So these are the secondary outcomes of this CKD fixed trial. 40% decline in EGFR, and end-stage kidney disease, death from any cause, fatal or non-fatal cardiovascular event, hospitalization for any cause. All these were, there was no significant difference. Let me talk about one more study. There is a Korean cohort study. It was again a prospective cohort study of 2,402 patients. They were classified into quartiles on the basis of serum uric acid level. And the composite renal outcome was need for dialysis or transplantation, doubling of serum creatinine from baseline. The important findings are the risk of progression to renal failure increased by 28% for each 1 milligram per deciliter increase from baseline. So it is a very important point. But the propensity score matching analysis to study the effect of uric acid lowering therapy, it failed to show any renal protection offered by either allopurinol or febuxostat. So this is no CKD trial. And finally, one more trial using febuxostat, that is FEATHER trial, asymptomatic hyperuricemia, application of febuxostat. Randomized control trial, 462 patients with stage 3 CKD with asymptomatic hyperuricemia, febuxostat versus placebo, follow-up for about 108 weeks, that is 2 years plus. Unfortunately, febuxostat did not mitigate CKD progression in stage 3 CKD patients. And finally, very interesting observation. This is for something called Mendelian randomization. What is this? The Mendelian randomization is a very novel concept in the sense that there are large data sets are available, like ARI, cardiovascular health study trial, and so on. There's a huge databases available. And just analyzing the 26 important single nucleotide variations of the genes which have an impact on the uric acid level, whether there is any association between the prevalence of this genetic risk score based on these genetic single nucleotide variations resulting in hyperuricemia and CKD. It's a kind of a bird's eye view. This study also failed to show kind of association between the increased uric acid level resulting in genetic mutations and the CKD. And finally, so this is another important study that showed it's a multicentric, double-blinded, randomized trial. The patients with gout who were on febuxostat versus allopurinol. Median follow-up was 32 months. The purpose of this study was to compare the effectiveness of febuxostat with allopurinol in handling hyperuricemia in gout. It has got nothing to do with the kidney failure. But look at the findings. The all-cause and cardiovascular mortality were higher in the febuxostat group than the allopurinol group. It is a bit disturbing. After this, there is a lot of discussion about the cardiovascular safety of febuxostat. But I went through this trial. It's not very decisive. It is not coming out with a very clear-cut statement linking febuxostat with cardiovascular morbidity, mortality. But it has stirred up a lot of interest. This is important in the sense that when we apply medications to bring down the serum uric acid level, without known benefit, without definite effect of that, the agent which we are using should be absolutely safe. So I think in future, there will be more studies on febuxostat cardiovascular safety. So as of now, there is no definitive evidence for beneficial role of uric acid lowering therapy in retarding CKD progression. This is my final statement. And I take this opportunity to invite you all for the 51st Annual Conference of Indian Society of Nephrology to be held at Chennai. I happen to be the organizing secretary. Please block your states. Thank you very much.
Thank you, Dr. Gopalakrishnan, for this excellent and comprehensive coverage of this topic. We all have witnessed uric acid from gout era to this modifiable risk factor, uric acid. My question to Dr. Gopalakrishnan, is there any study which shows duration of hyperuricemia associated with complications or CKD?
There is no study that has really analyzed the duration of hyperuricemia with chronic kidney disease. There are many observational studies, population-based cohort studies, and many uncontrolled studies which have linked hyperuricemia with incident CKD and prevalence of CKD. That was the basis for further RCTs, but unfortunately, no RCT could prove that. But coming to your point, I mean, there is no study that clearly has analyzed the duration of hyperuricemia.
And once you start this Fabuxstat oblique allopurinol, for how long you used to give it?
So actually, I used to give very widely on this, but after going through all these RCTs and recently, I am a bit discouraged to use it first in the first instance. It's a very difficult question to answer. First of all, whether we have to use it or not, that is a question. And particularly allopurinol, it causes, agranulocytosis and leukopenia. So I make it a point, those who are on allopurinol, at least periodically, like once in 3 months or so, whenever they come up for follow-up, it is mandated to look at the WBC count. There are many instances I have heard about and I myself have come across allopurinol associated leukopenia resulting in septicemia and so on. And again, allopurinol requires dose modification in CKD, but that problem is not there with Fabuxstat.
The house is open.
Excellent session, sir. Thank you for that extensive coverage of the topic, and thank you for the chairpersons for conducting the session. I don't think there are any questions for Sir's talk. So if in the interest of time, I think we'll move on to the next session and the speaker.
Thank you very much. I thank the chairpersons and the organizers.
Thank you, sir. For my next session, I will invite Dr. Garima Agarwal, consultant nephrologist and renal transplant specialist, Columbia Asian Manipal Hospitals, Bangalore, Karnataka, and Dr. Wahid Khan, senior consultant and head of department, Brahmananda Multi-Speciality Hospital, Jamshedpur, for the talk on lipids and CKD by Dr. Virani. I would invite the chairpersons to introduce the speaker.
Hello, everyone. I'm Dr. Garima. At the outset, as everyone, I have to thank Dr. Umesh and Dr. Akash for such a brilliantly organized conference. I've been enjoying it the last 2 days. It's been a pleasure, and how it's working like clockwork. Is the co-chair here?
Yeah.
So would you like to introduce the speaker?
Yeah, thank you. Thanks a lot. Thanks a lot. That's really indeed, you're right. It's a indeed pleasure to attend this session also, and it's really a new thing to have such a vast, big conference on the nutrition and related issues. Zahir is a well-known nephrologist in Mumbai, and fortunately, we were together in our academics time. He's a consultant nephrologist in Global Hospital in Mumbai with multiple honorable awards and achievements he has been associated with. And he will be speaking on the lipids in CKD. Zahir, can you please start? Zahir?
Yeah, I'm right here. Thank you, Dr. Khan and Dr. Agarwal. Can you hear me loud and clear?
Yeah, you're clear.
So thank you for this invite. And, Dr. Umesh Khanna and the organizing committee had asked me to keep it short and brief, so we actually can have a discussion instead of a sort of a didactic lecture. So lipids and chronic kidney disease, there is much to be said, and there's very little data to basically elaborate. So basically, chronic kidney disease is associated with an increased cardiovascular disease and obviously increased cardiovascular mortality. And way back in the Lancet in 2011, actually chronic kidney disease patients, men with a creatinine of more than 1.7 and women with a creatinine of 1.5 were put on simvastatin and ezetimibe. And this showed a major decrease in all cardiovascular events across the board. And basically for patients with chronic kidney disease, there is an estimated 19% reduction in major atherosclerotic events per 39 milligram per deciliter reduction in LDL cholesterol. So this first slide basically tells you that every chronic kidney disease patient should be on statins or some sort of cholesterol lowering agent. But is that true? Is that the rule of thumb? So we'll go forward and look at that part of it. So you have to assess the lipid status in patients with chronic kidney disease, and a very basic assessment would be the total cholesterol, the LDL cholesterol, the HDL cholesterol, and triglycerides. Now, there is a term known as shoot and forget. So in chronic kidney disease, actually, they start statins according to the guidelines, and then they just forget monitoring it. Unlike in other atherosclerotic diseases with ischemic heart disease, where you keep monitoring it. So that was a shoot and forget attitude, which was proposed for chronic kidney disease. Now, what are the medical conditions? What are the medical conditions which actually lead to the causes of dyslipidemia and chronic kidney disease? So there are various. As you all know, nephrotic syndrome is one of the common causes of hypercholesterolemia. There is a history of alcohol consumption, hypothyroid state, liver disease, and diabetes. Along with our medications, especially the ones which we use after transplant in the form of corticosteroids, cyclosporin, and sirolimus. So once you start a statin or any anti-dyslipidemic agent, one has to make sure that he is not on another drug which could cause drug-drug interactions. Now, this slide actually is very busy, and it just tells you that there is no rule of thumb in how the lipid status will look in nephrology. Okay, so the triglycerides are high in hemodialysis patients, nephrotic syndrome patients, and peritoneal dialysis patients, while in stages 1 to 4, they might be even normal. As you can see, the pattern varies across the board. One thing I would like to bring to your notice is the LDL cholesterol. All the guidelines are based on reduction of LDL cholesterol. And as we go further down this presentation, you will see that the LDL cholesterol is not as elevated in chronic kidney disease patients as it is in other patients. So do we need another marker which will be more accurate to tell us what the lipid status or the dyslipidemic milieu of chronic kidney disease is? And there has been a proposition to use lipoprotein A, which you can see in this slide, which is elevated in all forms of chronic kidney disease. So this is the latest European guidelines, and what do they categorize as very high-risk patients for cardiovascular events? So severe CKD with a GFR of less than 30 mils per minute per 1.73 meters square is a very high-risk factor for atherosclerotic disease. Now, why is this important? Because the goals of low-density lipoprotein cholesterol are different according to your risk. So remember that if you have a GFR of less than 30 mils per minute per 1.73 meters square, your actual goal of LDL cholesterol is less than 55 milligram per deciliter and a reduction of 50%. So if you do not, if you want to achieve the maximum benefit of a dyslipidemic agent, this is what your goal would be for a very high-risk patient. On the other hand, if it is just a high-risk patient, which is moderate chronic kidney disease, which should be your eGFRs of between 30 to 59 mils per minute per 1.73 meters square, you still have to reduce the LDL cholesterol by 50%, but your LDL cholesterol goal is around 70. So for the very high risk, it's 55. For the high risk, it is around 70. Now, why would you remeasure lipids, in a chronic kidney disease patient? One is to know for compliance, because our patients, I have been listening to the last few talks, and our patients are on phosphate binders, calcium supplements. Whether you want to use allopurinol or febuxostat is still a debate. They'll be on multiple antihypertensive agents. They'll be on iron supplements, B12 supplements. So there will be a lot of pills to be taken. So one is to ensure there is compliance. Also, you need to whether you want to reevaluate the 10-year cardiovascular disease risk in patients less than 50 years. And to determine the goals, because of the last two slides which I showed you, the goals vary. So just giving a statin might not help you achieve that goal. So maybe one needs to remeasure lipids. There is no data telling you how often to measure it. So I cannot answer that question. So a randomized control trial may need to be done to tell you how often the lipids need to be remeasured in chronic kidney disease patients specifically. So as this is a dietary conference, we have to involve our dietitians. And the first thing that comes up is therapeutic lifestyle changes of patients with chronic kidney disease. Whenever I see a dyslipidemic patient with chronic kidney disease, I just ask them to go see my dietitian, which is Dr. Zamrud, because it's impossible to answer all these questions and to make a diet which contains all these factors. So basically, you have to consult your dietitian who's a specialist in renal nutrition. So the other thing that you have to also explain to them is the importance of body weight. So as you can see that you have to make sure that the obesity is controlled. And there was a lovely seminar on obesity this morning, which also elaborated how obesity and chronic kidney disease go hand in hand. So these are the factors which need to be looked at when one is also treating dyslipidemia. It's not only statins. You know, a patient comes to your clinic with a high LDL cholesterol, is the beginning and the end is not giving them a statin. One has to look at the other lifestyle modifications, dietary changes that can be done. Also physical activity. There is a lot of stress on physical activity, even in our hemodialysis patients. Multiple trials showing how cycling during dialysis is helped. So obviously one needs to do at least 3 to 4 times a week, 30 minutes periods of moderate physical activity. Obviously, one has to keep in mind if there is an underlying ischemic heart disease and how much stress a person can take. But a gradual increase in the physical activity will definitely help. Will also help in reducing the weight. Will also help in controlling the blood sugars and the blood pressure. So the benefits of this are various. Also, habits and smoking cessation is one thing that one has to definitely stop if one is dyslipidemic. Alcohol in moderation. I don't know whether there's something as alcohol in moderation, but there are various guidelines which one can go through, how many glasses of each individual alcohol containing drink one can take. So what do the guidelines say? So basically statin treatment in chronic kidney disease, but not on renal replacement therapy. If they are between the ages of 18 to 49 and they have chronic kidney disease, if they are one of the following risk factors, one should be on a statin. So obviously if they have an ischemic heart disease, they have diabetes mellitus, they have a prior ischemic stroke, or if the 10-year incidence of coronary death or non-fatal MI is more than 10%. So there are scores for which you can calculate the last point. But if any of our patients between 18 to 49 who are chronic kidney disease have the first 3 risk factors, they should be on a statin. So, sorry. So statin treatment in patients above the age of 50 years and a GFR of less than 60 and who are not on dialysis or kidney transplant, one should treat with a statin or a statin ezetimibe combination. One can start with a statin, and if the lipids, if the LDL cholesterol does not decrease, then one can consider an ezetimibe. If the age is less than 50, but the GFR is more than, sorry, that slide. If the age is less than 50, with that slide is it's got the age wrong there. Sorry, apologies. So if the age is more than 50, then one has to treat with a statin. So statin treatment in dialysis patients, dialysis dependent CKD should not be initiated on a statin or statin ezetimibe treatment. Statin or statin ezetimibe treatment should not necessarily be discontinued among existing users when dialysis treatment is initiated. So why was this? So when the trials were conducted in dialysis patients who were started on statins, they did not find any mortality or cardiovascular benefit. Also, they found that the tolerance to statins was much lower in dialysis patients compared to the general chronic kidney disease population. So if one is on a statin before he's initiated on dialysis, then one can continue. But if one is initiated straight on dialysis and has no other cardiovascular, I mean, if he has an ischemic heart disease or he has had a previous stroke or he's had a PTCA, obviously he's going to be put on a statin for that. But just like I showed you in the last slide, where I said that all patients above the age of 50 with a GFR of less than 60 should be treated with a statin, that rule does not apply if the patient is otherwise healthy and is only on dialysis and has no other coronary cardiovascular risk factors. So statin treatment in kidney transplant patients, everybody should do a fasting lipid level on an annual basis. Treatment targets are same as the general population. It reduces the primary and secondary cardiovascular risk. And one thing one has to remember, as I mentioned right in the beginning, that simvastatin has interactions with cyclosporin and CCBs. So one has to choose one statin with care. So this is one slide which I thought says it all. Basically where you should start statins and where you shouldn't start statins. So in microalbuminuria, without any other risk factors, there is no role of statins to decrease the microalbuminuria. Chronic kidney disease stage 1 to 4, yes, you have to start statins. Nephrotic syndrome, the evidence is unclear, but most of the time, if it is something like a minimal change disease, they do respond to steroids and the lipid profile normalizes on its own. Dialysis patients, one should not initiate, and renal transplant patients, that's an absolute yes. So what happens if you can't use a statin? So various other tricks have been tried, like in all other things, like your multiple phosphate binders, you have multiple things to get down the lipids. So fish oil for CKD and dyslipidemia, there was no clear benefit to the use of fish oil supplements in CKD. And therefore, at present, it cannot be recommended for the treatment of dyslipidemia. Bile acid resins, again, the use in CKD is limited. There is not much data. Although there are no theoretical concerns regarding the use in ESRD, there is no data to address safety or efficacy. So again, none of the guidelines recommend the use of bile acid resins for the treatment of CKD and dyslipidemia. Niacin, as alluded by the previous speaker, has also been used for hyperphosphatemia. And one thought that whether it could be used for both hyperphosphatemia and dyslipidemia, but it has a very potent side effect of flushing, which makes the patients very uncomfortable. So with the newer phosphate binding agents and better lipid lowering agents, niacin is not found any favor. And it basically combining it with statin also did not find any benefit in the cardiovascular outcome. So also that drug cannot be recommended for CKD and dyslipidemia. Now, hypertriglyceridemia. The first thing is always going to be lifestyle changes and loss of weight, exercise, dietary changes. The second step would be statins. You are always wary of using fibrates in phenofibrates in chronic kidney disease because of the high risk of rhabdomyolysis. So very few indications to use phenofibrates, and also to be used with great care. And those are only if you have a hypertriglyceridemia induced pancreatitis. So at present, it's lifestyle changes, dietary modifications, and statins. So doses of statins in adults with CKD, as you can see, there is some amount of dose modification which is recommended. And atorvastatin is the safest statin, basically, if you want to use along with simvastatin. Rosuvastatin has fallen out of favor because it was found to cause some amount of tubular dysfunction and also found to progress chronic kidney disease in certain trials. So atorvastatin or simvastatin would be your drug of choice. So non-statin treatments, as you can see, as I already mentioned to you, niacin, gemfibrocil, fenofibrate, ezetimibe, bile acid binding resin, and fish oils. This is a slide which I'd be happy to share with the group if they need it. It basically tells you the dose adjustments and how to use it with cyclosporin. And I've already alluded to the fact that fenofibrate should not be used in stage 4 and stage 5 CKD. So this is a new drug, and basically it has found safety in chronic kidney disease patients. It is known as alirocumab. It's a fully human monoclonal antibody to PSCK9. So PSCK9 actually promotes the degradation of the LDL receptors, thereby diminishing the clearance of LDL from the circulation. If this drug basically binds to the PSCK9, it will help prevent the receptors will not get degraded, and therefore the LDL cholesterol will be cleared from the circulation. This has been tried in chronic kidney disease patients, and basically there was no signal of any worse side effects than in the other groups. The main side effect, as you can see in the last slide, was basically local injection site reactions. It's not available to the best of my knowledge in our country, but it's something to look out for. There is another drug which is available, which is known as cholesterol ester transfer protein inhibitors. This basically helps increase the HDL cholesterol, but it increases the HDL cholesterol, but it was not found to have any reductions in cardiovascular mortality. So it has basically fallen out of favor. There are also newer drugs which are RNA-based drugs, which basically act in the liver and help reduce the cholesterol levels, but that's beyond the preview of this discussion. So what do we know? In chronic kidney disease, there's dysregulation of the lipid metabolism, and it results in increased levels of triglyceride and oxidized lipoproteins and reduced levels of HDL cholesterol. The LDL might be normal or elevated. the response of statins in CKD diminishes in the later stages of CKD and in dialysis patients. So we need to look for other therapeutic targets apart from LDL cholesterol. Thank you.
Thank you, Dr. Zahir. That was a great talk, very crisp. You kind of summarized all the literature for us into workable clinical pearls. I do have a few questions before the co-chair asks. I had one question for you. You know, in the transplant patients, we have this peculiar picture where they have a very high triglyceride, and the LDL is actually normal and the HDL is low. And sometimes they start fibrates, somebody told them or something. So what's your opinion on fibrates in transplant patients, or say CKD, stable CKDs, because they usually come with a high triglyceride, you know?
So when I was going through the literature, most of the literature still says that statin should be your first choice of therapy. And it is actually triglycerides only above the range of 500, which are actually known to cause problems like pancreatitis and all. So with lifestyle modifications, weight loss and statins, most of the times we get away with just statins and dietary modifications and loss of weight and physical exercise. In the odd case where we have used, though the guidelines say we have used gem fibrosis very occasionally when we've seen hypertriglyceridemia induced pancreatitis. In fact, in one of our cases, we had to go ahead and do plasmapheresis also, because that is another way to get down the triglycerides quickly.
Right, right. The other question I had is, I was very interested when this topic was given to me as a chair, because a few months ago we had a patient who was started on a very high dose of statins post an angio, an MI episode. And along with other factors, he was a stable CKD3. He came to us with an AKI due to rhabdomyolysis because of the very high dose, as you had just shown that according to GFR, we need to reduce the statin dose. And I was wondering what's the right time? Should we restart the statin? Should we not give it at all? Should we look at the alternatives you mentioned? Any comment on this? Like sometimes rarely reported statin-induced rhabdo, you know?
Right. So again, I would say that one would look at what the indication is, and I would confer with my cardiology colleagues. If it's a fresh PTCA where he needs to give the statin, once the rhabdo subsides, I would start at a very minimally low dose and then keep monitoring the CPK. There are some people who recommend a change of statin from rosuvastatin to atorvastatin, but I have no personal experience in that. People feel that if you change the type of statin that you're using, it might benefit. But as far as I know, you can restart it, and you have to start it at a much lower dose.
Okay, thank you. I actually was stopping the cardio, so it's a lesson for me too.
No, I think Zahir clearly mentioned that depending on the indication. So if it's a fresh PTCA,
it was, yes.
We do start, and I see maybe once in 6 months one statin-induced rhabdo. It's not very uncommon, and I think as he rightly said, occasionally you can try shifting, and of course Rosua is going to be anyways not dose by dose. You can't have atorvastatin and rosuvastatin same. It's almost half of atorva. So shifting from one statin to the other would be one of the options, and very, very small dose. Be careful of the hypothyroids who have a little higher tendency towards statin-induced rhabdomyolysis.
Right.
They've also said to check the vitamin D levels. If the statin causes a lot of muscular pain, one should look at the vitamin D as well. Sorry, I'm just interrupting you.
So a lot of them may not come with frank rhabdo, but may start with all these aches and pains. And if you don't do their CPK levels in the beginning, of course, many of them may have still a reasonably normal level of CPK and yet eventually go into rhabdomyolysis. So you need to have your antennas really high up. Yeah.
Right, right.
Thank you, Zahir. Thank you for doing, and it was a really very informative and juicy, lucrative talk. Thank you, ma'am. And
no, we still have Sukhada. I think Sukhada had raised her hands up.
Yeah, do you have a question from the audience?
Yeah, I think Sukhada had raised her hand up.
That was an error. That was an error.
Doesn't matter now, since you have committed an error, you will have to ask something or give your comments on how you manage lipids in these situations. Sorry, I think you didn't get a chance last time. Also, I think we had to quickly wind up the session. So if you have any comments, please go ahead. No problem.
Not an issue, sir. Excellent conference and very well timed. Really happy with the entire organization.
No, honestly, I wasn't fishing for a compliment, but doesn't matter. Thank you.
So,
Compliments are always welcome, no, sir?
Yeah.
सर के साथ काम करना है तो be ready to kind of gain 2 or 3 inches because वो constant टांग खींचते रहते हैं. So
That's okay.
accepted. So yeah, so it's the Hall B session is also finished. People are joining Hall A now, and we thank you, chairpersons, and thank you,
Thank you.
Dr.
Thanks a
Zahid,
lot.
for giving us a brilliant session.
Thank
we
you.
now move forward to the next thing on hand, which is the debate. Two very two amazing speakers, extremely knowledgeable, who will be coming up and kind of talking about a topic which will have a lot of people will have strong feelings about. I'll invite the chairpersons, Dr. K.S. Nayak and Dr. Amit Gupta. We've introduced them before, but I'll introduce them again. Dr. Nayak is the Chief Nephrologist, Department of Nephrology, Virinchi Hospital at Hyderabad. Dr. Amit Gupta, Director and Head, Department of Nephrology, Renal Transplant, Apollo Medic Super Speciality Hospital, Lucknow. I'll request the elite chair to introduce our two speakers and to begin the proceedings. Thank you.
Mike, you can go ahead.
Yeah, this is, I think, this has become a regular item in every nutrition meeting, keto analogs for and against. So let's wait for the talks, Amit, to pass the verdict. We have two excellent speakers. I wouldn't call them young. They are quite erudite, quite experienced. Vinath Bhargav, he's consultant nephrologist. I think he's a PGI product, SGPGI product, presently at Sir Gangaram Hospital, New Delhi. And Edwin is probably one of the masters. So he's going to have a tough task taking on Vinath Bhargav. He's professor and head nephrology, Government Stanley Medical College, Chennai. I just everyone knows what a fantastic teacher he is, and I just saw yesterday the photograph of one of his students getting the gold medal. So we really look forward to this debate, and me and Amit, the old guys, will pass the verdict either in favor or against.
We won't pass the verdict. The audience will pass the verdict. And incidentally, Vinant is actually an alumni of Gangaram Hospital, Sir Gangaram Hospital. He has trained at Sir Gangaram, and he is actually has a Mumbai connection. He's done probably his MD from Mumbai. So, am I right, Vinant?
Yes, sir, absolutely.
Okay.
We'll find out vada pav khata hai ki nahi.
Okay.
Yeah, let's start with Vinant then. Yeah.
Yeah. Thank you, sir. Thank you, Dr. Amit, sir. Thank you, Dr. Nayak, sir, for the introduction. I'll just do my screen sharing and then we can start, sir.
Debates are the most interesting, and so hopefully it'll be a fiery one.
Is my screen visible?
Yeah, go ahead.
So thank you. At the outset, I'd like to thank the organizers and the committee for inviting me to debate on this very interesting topic, which is a very common topic. And I also like to thank my stars to be born in an era where I can actually argue for this, because my moderators, unfortunately, might be a little biased with the kind of publications and the kind of data they have generated over the last few years. So without wasting too much time, let me just tell you that I'm going to be debating in favor of use of keto analogs. And I'm going to be going through my presentation in the following manner. I'm going to be discussing about what is keto analog very briefly, what are the renal survival benefits, what are the dialysis prevention benefits, what is the mortality benefit, what is the economic benefit versus any form of renal replacement therapy, and in the end, is it a patient's choice prescription? So we all know that in the conservative management of CKD, since time immemorial, we've been taught that the high protein diet is what starts the vicious cycle, which causes glomerular hypertension, increase in glomerular pressure, and causes damage to glomerular structure. Hence, we always advocate the use of low protein diet in patients with CKD to preserve the renal function, as well as to improve the proteinuria, albuminuria, and to delay the initiation of uremic symptoms. It has also been shown to improve metabolic profile, and seriously, there has been absolutely no reason for not recommending the use of a low protein diet in the past few years, despite the large scale study, which was the MDRD study. So, but now I'm faced with a little nutritional dilemma. If I restrict the protein in my diet, then it's going to cause malnutrition in my patients. It's going to deteriorate the quality of life and also worsen the symptoms of chronic kidney disease. So I come to you with this molecule, which is keto analog, which is nothing but a keto and hydroxy analog, in which there is transamination of the non-essential amino acids, and it's converted into an essential amino acids. And so we will have a patient which will have less of nitrogen and less of urea into the blood with equal nutrition. Without wasting much time, let me just run through the major studies. And the most important study which I could find was the one from Liliana Ganiata from Hungary. She's published in 2016 in the Journal of American Society of Nephrology, in which she has published this randomized controlled trial in which she included 207 non-diabetic CKD stage 4 and 5 patients. And the intervention group in this study was a vegetarian, very low protein diet, which was supplemented with a keto analog. And this was compared to a low protein diet group. The primary endpoint was the renal replacement therapy initiation and a reduction of more than 50% of baseline eGFR. And so from here, I can confess that from this trial, we know very clearly that the keto analog can be used as a good supplement for nutrition because the BMI remained normal, as well as there was no change in the serum albumin at the end of the study group in patients who were given supplemental very low protein diet. And also, there was lower percentage of patients in the keto diet group which reached the primary endpoint, that was dialysis or experiencing ESRD or a 50% reduction in creatinine, 50% reduction in creatinine. Also, the serum urea significantly decreased only in the keto diet group, as well as the serum bicarbonate, which is found to be increased in patients on the keto diet group. There was favorable data for increasing calcium as well as reduction of phosphate in the keto diet arm. And the most surprising thing was that you needed only 3 patients to actually prove the advantage of using this drug as compared to when you look at statins or antibiotics, which have been used in the past to show the superiority and treating patients. So this group then further went on in 2019 to publish in the nephrology NDT, nephrology dialysis and transplantation, where they assessed the 5-year survival data. And they found that the 5-year survival was superior in patients who were on supplemented very low protein diet, and also the requirement for renal replacement therapy, that is, the kidney survival was much better, and the renal replacement therapy was much lower in patients with supplemented very low protein diet group. So it could be concluded that keto diet could safely postpone dialysis in compliant and carefully monitored patients. The next study was a 10-year study involving nearly 1,500 patients in Taiwan, in patients who were anemic and had advanced CKD, and they were treated with low protein diet group, and then they were started on keto acid supplementation, and the risk for ESRD as well as all-cause mortality was analyzed. And here also, the data analysis has confirmed that keto analog supplementation is associated with lower risk of long-term dialysis and the composite outcomes when daily dose is at least 5.5 tablets. And this was independent of age, sex, and other comorbidities. Another data comes from Thailand. This was published again in 2018, where they analyzed the low protein diet as well as the supplemented very low protein diet group and did a 12-month follow-up. And they have also shown that the reduction in GFR was much slower in patients with the very low protein diet group with supplemented keto analogs. And also the protein urea was shown to be much better. That is, there was somehow a regression in protein urea in this particular group. So it could be safely said that very low protein diet plus a keto analog treatment is associated with greater preservation of renal function in stage 3 and 4 CKD. Cooper, she in 2019 has very convincingly published this review article in the Nutrients 2019, where she has said that when you supplement a patient with keto analogs with very low protein diet, you have very favorable outcomes on the metabolic parameters, particularly metabolic acidosis, insulin resistance, and also a good effect on the bone metabolism. And this chiefly occurs because of much better use of amino acids, as well as an anabolic effect of these molecules and these amino acids on the body muscle. With this, I move on to the chief Indian studies. The first study was published in 2018 by the SGPGI group. It was a very innovative study which looked at patients in stage 1 to 3 CKD, and they looked at the effect of combined therapy of very low protein diet with keto analogs, and they looked at the renal function of these patients. And also what was very innovative was to look at the compliance to this kind of a very low protein diet group. And the group 1, that's the group in which you had, you saw the GFR was getting better in patients who were supplemented with keto analogs, as well as the creatinine declined in patients who were given keto analogs in the supplemented group. At the end of the study, the serum albumin levels were maintained in the intervention group, and the hemoglobin levels increased, as well as the serum calcium increased in the intervention group. Though the authors have confessed that most of these patients, they were counseled only once, and most of them did not adhere to the proteins restriction when they were given keto analogs. But that brings us to the concept that most of our Indian patients might not even adhere to the protein restriction. And still you have this data which tells us that most of these patients, you could see that there were the decline in renal functions and improvement in GFR, or maybe slowing down the GFR was seen even in these patients when you supplement them with keto analogs. The next was Dr. Sunil Prakash and his group. They published in 2004 when they studied 34 adult CKD patients, and they randomized them to receive either low protein diet with placebo or a very low protein diet with the keto analog. And they followed them up for 9 months. And they also noticed that in the keto analog group, there was better preservation of GFR and maintenance of BMI, which was a very important concept as compared to low protein diet plus placebo group. This is unpublished yet data which was selected by the American Society of Nephrology from my center, that is Srnmcon Hospital, in which we studied the effect of keto analogs and a protein restricted diet in patients of CKD stage 4 and 5, divided them into 2 different groups. One was the low protein diet and the other was a supplemented very low protein diet, and looked at them over a period of a year and analyzed different parameters. So we found that in the intervention group, there was an increase in hemoglobin, protein, serum albumin. The HDL levels were better. There was reduction in serum phosphorus as well as the total cholesterol. And what is interesting again was that there was a significant difference in the mid-arm circumference and tricep skin fold thickness in the group which did not receive any supplementation. And also there was a decrease in GFR, which was much rapid in the group 1 patient, which were not supplemented as compared to group 2 patients. So it could be safely said that supplementing patients on very low protein diet group with keto analogs has a beneficial effect on slowing down the rate of decline of renal function and helps to maintain the nutritional status of the patient. With this, I come to the next study, which is by Professor Nayak himself, and I know he would like this study. This was published in 2014 on nearly 180 adult pre-dialysis patients who were CKD stage 3 and 4, and he assessed them for a period of a year. This is an interesting study because keto analogs were given to both the groups. The group which was on very low protein diet got more liberal keto analogs. And can you see my slides, the next one?
Yeah, no, not yet.
Yeah, okay, sorry. So will I be given grace for this 30 seconds?
Yeah, go ahead.
Thank you, sir. So over here, we can see very clearly that when you look at both the groups, there has been a substantial increase and substantial improvement in creatinine clearance, as well as the blood urea and nutritional parameters, as well as the subjective global analysis. So that means if you have supplementation with keto analogs, irrespective of whether it's a very low protein diet or a low protein diet, you will have some kind of an outcome. When we look at the diabetic CKD patients, again, this is the data that I took out from analysis done in Mexico, published in 2009 on 200 CKD patients, where they divided patients into diabetic and non-diabetic group and look at them at short-term observation of 6 months and 2 years longer. And look, this is what they found out, that in diabetic patients, supplementation of keto acids actually improves the uremia as well as the diabetes control. And so it can be concluded that a low protein diet, when it's supplemented with keto acid, improves the insulin sensitivity in diabetic kidney patients, and in long term does not worsen the nutritional status and preserves the body composition. So what are the recommendations? The recommendation data comes, the most initial data, which was substantial and which was used by all of us, came in 2009 by this group when they published in Journal of Renal Nutrition, when they said that when you start with CKD stage 3, it's good to do protein restriction, but you should add a tablet of keto analog. And then came the Indian CKD guideline work group in December 2013 that suggested that essential amino acids and keto acid supplementation in diet may be used for prevention of progression of chronic kidney disease. But the recent recommendations come from the 2020 update from the KDOQI guidelines, which say very clearly that in metabolically stable patients, these are patients who are non-diabetic, to reduce the risk for ESRD or death and improve the quality of life, you are suggested to give a very low protein diet along with supplementation of keto acids or keto analogs. However, in patients who are diabetics, the data still for KDOQI says that the recommendation is to just keep them on a low protein diet, and we should be having some more consensus on this maybe in the next guidelines. To summarize, so when you have keto analogs, when you combine them with a protein restricted diet, there is definite reduction of uremic symptoms, amelioration of metabolic acidosis, there's better calcium and phosphorus metabolism. Obviously, then there is lesser renal osteodystrophy, there's reduction of proteinuria, improvement in glucose metabolism, insulin sensitivity, and improvement of disturbed lipid profile. And in turn, all of this will actually be beneficial to your patients by slowing down the GFR deterioration and results in later initiation of dialysis. In my last few slides, I would like to bring to you to notice, look at the global prevalence of chronic kidney disease in India. It seems to be pretty high as compared to the rest of the world. And when you look at this paper, which was published by Dr. Umesh Khanna, it's a formidable cost when you put a patient onto dialysis, either for the patient or for the economy themselves. And when you look at the cost analysis here, it looks very convincing over here that when you look at the cost analysis and look at keto analogs, it costs only 8,000 rupees a month as compared to the cost of hemodialysis, peritoneal dialysis, or transplantation, considering the cost of therapy. So in the end, I'd like to wrap up by saying that what does my average Indian kidney patient in the hospital want from me when he comes to me in the OPD? He only wants one thing from me when he's progressing in CKD. He wants the why for kidney problem. And I suggest that maybe after this presentation, my moderators would agree that maybe I would like to add a keto analog. And thank you very much. So I would like to conclude by saying that winners focus on winning while losers focus on winners. So maybe keto analog here is the winner at the end. Thank you very much.
Yeah, Amit, you want to ask Edwin to start?
Oh, I think what we'll do is that we'll ask Edwin to start, and then we'll give Vinant 1 minute to rebut if he has any.
Yeah, that's fair enough. Yeah, I think so. Edwin, go ahead, please.
Good evening, respected chairpersons. Thank the organizing team for including this debate. Vinant is extremely smart guy, not only in his looks, but also today he has made sure that he has quoted the papers of both the judges and also the organizing committee chairperson. So I have to wage a lone battle myself against keto analogs. So let me start. I acknowledge the help I received from Dr. Sukanya Govindan, my colleague, in preparation of this talk. So I shall begin by saying keto analogs, not yet for CKD. So the points to debate here are CKD patients eligible? Which groups benefit from delaying dialysis? Does it achieve hard outcomes? A very low protein diet and keto acids are a dietitians trained to do this? And the pill load and cost, does it outweigh the benefits? So we know a low protein diet is 0.6 gram per kg per day, and a VLPD is 0.3 to 0.4 with a nitrogen-free keto analogs. This keto acid gets converted to corresponding amino acids by transamination. So how does it work has been extensively dealt with by Vinant. So it's used in place of amino acids without excess nitrogen burden. Excess nitrogen from urea and CKD is utilized in this conversion. So mostly they contain 4 keto acids, leucine, isoleucine, valine, and phenylalanine, wine hydroxy acid, and 4 amino acids essential in CKD. Calcium content in the keto acids helps in correcting the mineral bone defects. However, a deficit in calories or essential amino acids can, however, produce negative nitrogen balance and cachexia. So the apparent benefits are clear that there has been a decrease, improvement in mineral bone disease, increase in EPO sensitivity, increase in insulin sensitivity, etc. So the apparent benefits again, probably when started in CKD 3 to 5, decrease in the protein load and hyperfiltration in kidneys, decrease in the acid load on kidneys, improves calcium deficit and reduces the phosphorus load. Protein degradation in the gut produces the peak acyl sulfate, indoxyl sulfate, trimethyl amino oxide uremic toxins, and the decreased uremic symptom load delays the need for dialysis. So the apparent benefits are again clear in these studies. However, the beneficial effects disappear when keto acids are started a little late, at eGFR of less than 18 mils per minute. And this is the 2020 KDOKI update on nutrition, where it mentions that in patients who are metabolically active with CKD 3 to 5, protein restrictions with or without keto acids to reduce end-stage kidney disease and improve quality of life. But look at the strength of the recommendation. It is only a 2C recommendation. And however, look at CKD patients not on dialysis and with diabetes. It says it's reasonable to prescribe under close clinical supervision a dietary protein intake of 0.6 to 0.8 to maintain a stable nutritional status and optimize glycemic control, however, which remains an opinion. So are patients eligible? So keto acids are advocated for metabolically stable adult patients, CKD 3 to 5, absence of any active inflammatory or infectious disease, no hospitalization within 2 weeks, absence of poorly controlled diabetes and catabolic diseases such as cancer, absence of antibiotics or immunosuppressive medications, and absence of significant short-term loss of body weight. The major cause of CKD in India, as seen in the CKD registry, as also Dr. Agarwal's study, shows that 25% of patients CKD have diabetes, and the incidence is likely to be more due to lack of universal screening. Poor glycemic control is often encountered, and all these patients are not ideal candidates for keto acid-based therapy. In healthy CKD patients, providing a sufficient energy intake, about 30 kilocalories per kg, protein intake can be safely decreased to about 0.5 to 0.6. So keto acid supplementation usually requires taking a very low protein diet, which might be a nightmare in our patients, especially when unsupervised. So most Indian patients with CKD have insufficient energy intake. Protein energy wasting is quite common, and they are prone to infections. So the focus here in our patients should be on energy intake. So are our patients eligible? Once again, coming to this question, maybe they should be prescribed to those with good appetite, good nutritional status, and slowly progressive CKD at early stage 1, 2, 3. Maybe prescribed at 4 and 5 if the appetite and nutritional status are good. However, most of our patients get diagnosed at a very late stage. 50% are detected at GFR of less than 15 mils. Protein energy wasting is very common even in early CKD, and majority of patients are already on a low protein vegetarian diet. So who will benefit? Probably elderly patients in whom dialysis might not be associated with improved survival. Slowly progressive CKD when initiated in early stages. Does it achieve all hard outcomes? Studies indicate benefit, of course, in preserving eGFR, better phosphate and BP control, improved insulin sensitivity, no lowering of serum albumin or weight loss, and results achieved in a trial setting supervised by renal dietitians and monitored by adherents. But is replication of this possible in real life remains to be answered. Coming to our dietitians, very few dietitians are available and fewer renal dietitians. So they are not trained to give a diet plan or meal plan with very low protein diet. There is failure of therapy and non-compliance. So most of us double up as dietitians, and hence there's a reluctance to prescribe a very low protein diet and risk of increased protein burden when not followed with the very low protein regimes. Coming to the pill load and cost. Recommended dose is 1 capsule per 5 kg of body weight. So a 50 kg patient has to take something like 10 tablets per day. The cost of 10 tablets varies between different brands to 360 rupees per day. And the per capita income in our country works up to only 370 rupees per day. So similar benefits can be achieved with predominantly vegetarian low protein diet, which also works out cheaper. So to sum up, let me look at the eligible criteria in a very small group of carefully selected patients, as included in many studies, including India. No overwhelming comorbidities like diabetes or infection. Slowly progressive CKD, early stages of CKD, no protein energy wasting, under the supervision of trained renal dietitian, increased pill load and increased cost of therapy. So keto analogs, in my opinion, is a luxury which few patients can afford, can be instituted in only a small subset of patients in our setting to attain intended benefit. Thank you very much for the patient listening.
Amit, how do you want to take it now? We give Vinant.
We'll give a minute to Vinant to make a point, and also a minute finally to Edwin if he wants to make any counterpoint.
Thank you, sir. Thank you, Dr. Edwin. Thank you, Professor Edwin, sir. We've been learning through you since many, many years now. And your presentation was absolutely amazing, first of all. But there are a few points here which I would say that, though I agree with the fact that you were stressing more and more on metabolically stable patients, but we have convincing data now. I have been, because of shortage of time, I was not able to present the data in the diabetic CKD patients, in which they have compared patients who are either on low protein diet, very low protein diet with keto analogs, and have found that keto analog supplementation has always helped most of these patients to even overcome the inflammatory stress in the body. So I would take it the other way around, that inflammation, though may be a contraindication as per the related KDOKI guidelines, the guidelines are basically based on studies which are, just before the guidelines are formulated, and a common consensus is taken. So I would still feel that keto analogs, though it has still a long way to go for patients on CKD, and they still have to come up with a lot of convincing data. But as of now, the literature supports the use of keto analogs in patients who are either diabetic, non-diabetic, especially so in the Indian subpopulation, which seems to be so malnourished and needs more of essential amino acids, especially the ones without the nitrogenous component, so that it not become uremic, considering the fact that there are so many cities, so many townships now still existing in India.
Sorry, Vinant, can I ask you? You have to answer the last point that Edwin mentioned, that he says that you could achieve the same results with a low protein vegetarian diet instead of giving the expensive keto analogs. Would you like to take up that point? Essentially that's his argument, that for giving a keto analog you have to have very low protein diet, which is difficult to monitor. And he's saying that you can achieve the same results with just a vegetarian low protein diet. So
Yes,
what is your answer to that?
Yes, so the answer to that comes from the study from Kalantar, which has been published in NEGM in 2017, in which he has very clearly said that the concept of low protein diet, not supplemented, is not as beneficial as when you supplement keto analogs along with either a low protein diet or with a very low protein diet. So there's substantial.
What you're saying is that you would like to give a low protein diet supplemented with keto analogs, or are you saying that you would insist on the patient to have very low protein diet and then supplement with keto analogs?
Yes, sir. So I would actually, from the data that's available and from the current practices that are done, from the guidelines that are coming to us, I would like to say that it would be supplemented very low protein diet. So that is very low protein diet along with the keto analog, because that's the that's the best data that we have right now to support the use of a keto analog.
Let me intervene and for the benefit, this is not a biased opinion, but to both the speakers, additional information, personal communication with Al Pikisler, the 2020 KDOKI guidelines had a hard stop of including RCTs and other studies up till 2016. Any study that was published in late 2016 was not included. So the Liliana Garniata, incidentally from Romania, Vinant, not from, you said somewhere else, Hungary. No, she's not Hungarian. She's from Romania. Her study was not included in that. And Al Pikisler says that if that study and the subsequent studies would have been included, the conclusions would have been far more stronger towards keto analog. This is a very unbiased opinion, number one. Number two, the cost of therapy you have calculated is for SVLPD and one tablet for 5 kgs. There is a possibility, and equally effective is one tablet for every 10 kgs, which comes to half the cost. These are two things I would like to bring to your opinion. Third thing is the MDRD study in the United States has totally prevented the nephrologist from using keto analog even now, though the KDOKI guidelines came from there. That they still cannot do studies. Neither can they have data supporting ketone loss. Most of the studies are coming from Europe, the randomized control trial. So this is in the proper setting. I would like to both the speakers to know this.
I think we should give
Can I make a small comment?
chance.
Yeah, can I make a small comment? The best part of today's debate is we have two debaters among the speakers, and we have two debaters amongst the moderators also. They are also.
Let's give Edwin the right to rebut.
Yes. Edwin, go ahead.
Good evening, sir. Yes, it's well agreed that one has to use it in the appropriate patients and appropriate circumstances. For me, working in a large public hospital which caters mainly to patients on a low socioeconomic strata, it becomes extremely difficult for us to prescribe this and also to follow. As such, most of our patients are on a very low protein diet. And we are all worried about costs. As you know that any new nephrology product that comes in, first thing that most of us would, in addition to looking at the scientific evidence, we'd always look at the cost. So how many years are we going to continue this ketone? Because the enormous cost involved. If you're going to start it at, let's say, somebody you pick up at stage 2 and continue till stage 5, and suppose this takes about 10 or 15 years, that amount of money, I think, even if he had progressed to CKD5, he could have had a transplant.
So, Edwin, you are actually arguing against your own supposition that ketone analogs are not effective. You're saying 10 years you can keep a patient in stage 3 on ketone analogs. That's what you're saying.
No. If that is the argument, that if you're going to initiate it at that stage and say benefits are going to be there, how many years are you going to keep them on this ketone?
I think it costs about 20 to 25% of the cost of dialysis.
Edwin, I think what you should emphasize more is that unless it's given the proper dosage, it's not going to be effective. And the dosage that most of us in India are using are homeopathic doses because of the cost involved. So I think the point that I think Vinant has to answer that unless this medicine is used in the proper dosage, I mean, whether it will be effective at a dosage, what Nayak was trying to say is 10 milligrams per kilogram. 10 milligrams per kilo rather than using it at one tablet at 10 kg per weight, rather than using it at one tablet at 5 kg, which is the actual recommended dosage. So there are data to suggest that whether it will be as effective as it has been quoted in other studies, where it has been used at dose of one tablet at 5 kg per weight.
Yes. I mean, Arvind has raised his hand. Yes.
Yeah. Sorry.
Yeah, just to find out, I think you people have already discussed this. There are studies that have shown that beyond the entry to dialysis, those who have been on very low protein diets have actually got problems with increased mortality. So if you see the MDRD and other trials, those who from a very low protein diet, who are also on keto analogs for that matter, who go on to start dialysis, the rate of death within the next 15 months after starting dialysis is double that of those who are not on a very low protein diet. So how are you going to substantiate very low protein diets when the mortality on dialysis increases in these patients? Has anybody else looked at the mortality in these patients?
Yeah, that particular study, the lead author was Vandana Menon, and one of the co-authors. All the study, this entire MDRD study was done from Tufts University, where incidentally the AJKD head office, the office of AJKD is there, and one of the reviewers was, there was a conflict of interest, and the follow-up that you are talking of was actually based on data they got from the social security card. It was not a scientific analysis, it was data they got from the social security card, which is like giving a scientific opinion on such an important matter by using the Aadhaar card. This has been criticized by all the leading proponents of keto analogs, from Teplan to Fook to all these people from Europe, and not a single rebuttal has come from The
Nag, you have
agency
to be unbiased. You're
The way
judge.
to rebut
No, no.
that would be to have a trial which says that on this very low protein diet with the keto analogs, the mortality is not higher after you start dialysis. Perhaps a trial in that sort of category may help rebut that. Otherwise, we will still be looking at that data and saying, my God, we need to be careful.
Can I request the chairperson or the moderators rather to close this debate, because as Vinant mentioned that every Srnmcon we can continue to debate this. And
Edwin still has a point to make. I think he hasn't got a chance to reply.
Okay. Edwin, you have the
No,
last.
it's only the cost that and the number of years the patient has to be on the drug that one has to be concerned about. For the most affordable ones and the ones who can be very carefully monitored, and you need to have a little high-tech dietitians to really prescribe this and advise the patient on this. So in a select population, it may be really useful, but at what cost? How many of us are going to offer this to all our patients that we see in the outpatient department, especially the poor socioeconomic strata and the ones who are already on a low protein diet? So that's the question.
Honorable moderators, am I permitted to just make one last comment?
Oh, sure. Quick one.
Thank you, sir. So this is going to be a quick one. So this is regarding the cost of therapy plus the number of tablets that have to be taken. So the data actually comes from Taiwan, which says that these people look almost like us. They have a low body mass index like we have, and they've used tablets, minimum 5.5 tablets per day. So that's about maybe 6 tablets. We use 6 tablets over here. So we could probably do a trial here which says, like Dr. Edwin Fernando is saying, that Professor Fernando wants to
The
say.
major problem, Vinant, if I can just butt in, is that the pill burden is in patients with chronic illnesses is normal.
It's already high.
You have phosphate binders, you have your antihypertensive drugs, and you have other things that you give to your patients. So the compliance to these medicines is again something that one will suspect, because A is the number pill burden and 2 is the cost of therapy. So unless we are able to sort of ascertain whether our patients are able to take those medicines, even though there has been some data which suggests that this is beneficial from various Indian centers as well as abroad, I think this will be open to still.
I agree with the Amit that the deficiencies that we have do not justify that keto analogs do not work. If we don't train our dietitians properly, if we don't counsel our patients properly, if we don't select our patients properly, then keto analogs do not work. That means we are deficient, not keto analogs, Edwin. I feel it should be used correctly and it works, because our experience has been that we have saved money, and if used in the correct dosage in the right patient, it works.
Like you should have been speaking instead of Vinant.
That's why I said.
No. I have to tell the truth because definitely none of them knew that Liliana Garniata's study was not included in the 2020 guidelines.
Requesting the moderators to close.
Okay, to wind up. I think it's time to wind up. I think the debate was very interesting, and both the speakers, I must congratulate both the speakers for making the session lively. And I must thank Dr. Nayak for even making it livelier.
No, I should thank Edwin for having the courage to take keto analogs head on. I really respect that. I think so. Thank you.
Thank you, sir. Thank you very much.
Thank you.
Thank you, both the speakers and the chairpersons, for this amazing debate. A lot of people have already commented. It's an amazing, they're really enjoying the debate. It's not over yet. We have the quiz coming up, and we'll be declaring the winner of the poster at the end of the quiz as well. I request all the delegates and the attendees and the faculty to join the quiz. The link will be flashed at the bottom right if you're attending from the platform. For the attendees,
I have to attend one board meeting now.
to conduct the quiz, I invite Dr. Divya Bajpai, Associate Professor from KEM Hospital. There's a lot of noise going on in the background.
I think somebody hasn't muted his, all those who are not going to speak can mute. And before.
So your voice kind of went away in between.
Yeah, I just wanted to announce that Dr. Alan Almeida from the Corep Trust of Madam Acharya has announced these prizes of 15,000, 10,000 and 5,000. So I thought I must put it on record that it's Dr. Alan Almeida's, rather, he's the trustee of the Corep Trust, the trust which was formed by Madam Acharya. Me, Alan and Bharat are the trustees of it. So the whole thing is, the prizes will be given by the Corep Trust. Thank you.
Thank you, sir. I would like to invite Dr. Divya Bajpai to conduct the quiz. Everyone knows her. She's the associate professor from KM Hospital and St. GS Medical Mumbai. She can be called, I can safely call her the Derek O'Brien of nephrology quizzes. And her quizzes with ISN have been amazing, and I've been truly honored to have been a part of you and for having got the opportunity to work with her. And I invite you, Divya, to kind of take this session forward. And
Yeah, thank you so much, Akash. And I must congratulate you and Umesh Khanna sir for such a wonderful conference and so much for being so much punctual on time. So as we come to the end of this amazing academic feast, it's now time to remember what we have learned throughout these 2 days. And in the process of doing that, we'll also have this opportunity of earning some very, very cool cash prizes. So it's a win-win situation. So can I request Avinash to share the screen, and we'll start with the rules of the quizzes first.
Divya, let's give 2 or 3 minutes because it's a new link that they've come from.
Yes.
Let's give them 2 to 3 minutes. And,
yes. In the meantime, can I go ahead with the rules?
Yeah, sure.
Yeah. So everyone will have to register because it's a quiz. It has to go on a different platform. It's a StreamGo platform. You have to register from the registration desk. You can just click on the link below and you will be taken to the StreamGo platform. Once you have done that, once the quiz begins, this will look something like this. The question will be there in front of you with 4 options. This quiz contains 20 questions. All of them are MCQ based with 4 options each and only 1 correct option. Each question is allotted a 30-second time to answer. We will be reading only the stem of the question, after which the options will be displayed. We will not be reading the options. Once the options are displayed, the timer will start. You will have 30 seconds. At the end of 30 seconds, the question will be blocked from the back end and we will be displaying the answer with explanation. To make it more interesting and little more competitive, we have also kept negative marking here. So every correct answer will be awarded 4 marks and there will be a -1 negative marking for every incorrect answer. So it is +4 -1. And still, if we have a tie, because this conference has so much of attendance and we hope everyone joins the quiz, and it's also open for each and everyone, including trainees and dietitians and physicians, and everyone is welcome. So if we still have a tie, the tiebreaker will be the time to answer the question. So it is also important for you to remember that you have 30 seconds, but the faster you ask, the higher you will be scoring. So keep these 2 things in mind. One is negative marking and one is fastest finger first. Also a request that do not post your answers in the chat box. Do not type the answer like option A or B. They will not be counted. You have to click the answer on your screen. Only then it will be automatically submitted and it will be counted. So they were the rules. I hope they are clear. We will wait for a few more minutes for everyone to join.
The tech team needs to give us a go ahead once there are enough attendees. So is the tech team there?
Yes, sir.
Siddharth can.
So the faculty is asking whether the same link which they are in right now, it would be valid for the quiz.
So I have put it on the chat box. The quiz link. The faculty can also join the quiz.
They have to click the link which reads https://webinar365.in/quiz.
Okay.
And they'll be taken directly to the
chat box right now.
All right.
Any queries regarding the, such they're simple, but the quiz rules, are there any queries? So best wishes for everyone.
I think we wait for a minute and then we start, I think.
Yeah, maybe people will take about a minute or two more to join. Yeah.
So someone has asked on the WhatsApp group that once they have logged in, what is to be clicked? So nothing is to be clicked now. Once the quiz starts, there will be questions and options displayed. Then you can click and select the options.
Ma'am, so far 104 attendees have joined.
I think we can start.
Okay, so I'm starting right now.
So here's the first question. Mr. SK is a 45-year-old male with CKD stage 4 and uncontrolled hypertension. He started on sodium bicarbonate tablet, which he is consuming 3 grams per day. How much sodium is he getting through these tablets? And your options are and the time is up. And the correct answer for this question is option number B, that is 36 milliequivalent. It is pretty easy to calculate. Each gram of soda bicarb tablet, as it is commercially available, provides 11.9 milliequivalent each of sodium and bicarbonate. So if we round it up to around 12, 3 grams will be providing 36 milliequivalent. This should be remembered when we prescribe lots of soda bicarb to someone who's supposed to be on a sodium restricted diet. Over to Akash for the next question.
Thank you. Can you please display the next question? Rohan is a 14-year-old boy on maintenance dialysis and he's having anemia. He's not tolerating oral iron supplements and he's apprehensive in taking IV iron. Which of the following IV preparations can be administered via dialysis?
Akash, you are muted somehow.
Sorry. Ferric pyrophosphate citrate is the right answer. It is a water-soluble iron salt which can be administered via the dialysate to supply iron directly to cancer. This was a 9-month placebo-controlled double-blind multi-center randomized control trial, which wherein FPC was delivered via dialysate, and it significantly reduced the dose of ESA that was needed and the amount of IV iron that was needed. So that is the correct answer for that question. Let's move on to the next question, and I think Divya can take that up.
The next question, please. So all of the following suggest functional iron deficiency, except you have to select which does not suggest functional iron deficiency. And your time starts now. And the time is up. And the correct answer for this question is option number D, that is serum ferritin less than 200 milligrams per ml. We should always remember that functional iron deficiency is a state when there is inadequate iron supply to meet the demand, despite having normal or abundant iron stores. So iron stores are adequate, but they are not reaching the bone marrow for formation of hemoglobin. This is specifically characterized by a low serum ferritin level, which is the only test which can differentiate between functional and absolute iron deficiency. Also to remember that hepcidin levels are usually low in absolute iron deficiency. They are normal to high in functional iron deficiency. Moving on to the next question.
So Jaya is troubled by recurrent bouts of colic. She is found to have calcium oxalate kidney stones, and all of the following are measures which will be helpful to her, except let's display the options. Time is up. Let's display the answers. So restricting diet, we attended a wonderful session yesterday, and sodium restriction is one of the most important things that you do to control, to reduce stone risk. So that is definitely not the answer. Restricting dietary calcium intake is not generally recommended unless it is excessive and can be maintained between 800 to 1000 milligrams per day. In fact, decrease in free intestinal calcium can lead to increased absorption of dietary oxalate and enhanced oxalate excretion. The free intestinal calcium can bind the oxalate and get excreted. So reducing the calcium intake is not recommended, not warranted. Supersaturation of urine with respect to calcium oxalate and an enhanced tendency to stone formation occurs because of increased oxalate excretion in urine in presence of low calcium supplementation. I think we can move on to the next question. Divya can take that.
So your question number 5 is, all of the following statements regarding smoking are true except, and the options are and time is up. The correct answer for this question is option number C. Nicotine containing e-cigarettes rarely cause increase in heart rate. Please show the answer. So nicotine containing e-cigarettes do not contain tar or carbon monoxide. That way they are little beneficial, but they do contain nicotine, which gets converted into cotinine, which is a substrate, and it causes increase in heart rate. It is also interesting to note that habitual smokers can often have lower blood pressures than non-smokers, which might be related to a generally lower body weight compared to the non-smokers, and also because of the vasodilatory effects of cotinine, which is the major metabolite of nicotine. Also, the other two options, that's option number A and D, are correct. That's heavy smoking can cause nodular glomerulosclerosis, and it can also cause increased proteinuria. Over to Akash for the next question.
Which of the following combination of electrolyte disturbances can be seen in a chronic alcohol use disorder? Read the question carefully. The time is up, and we can move on to the explanation. The correct answer is A. Alcohol disorder is associated with a high anion gap metabolic acidosis due to the decrease in insulin glucagon ratio, which leads to keto acid formation. It also causes increase in lactic acid production, and it can also cause hyperchloremic non-gap metabolic acidosis due to loss of bicarb, which may be seen in due to loss of keto acids in urine. Occasionally, metabolic alkalosis is also seen when it causes severe gastritis and recurrent vomiting. Respiratory alkalosis may be seen in patients who are withdrawing, or in chronic liver disease who are in pain and sepsis. Common other metabolic derangements which are seen are alcohol-induced urinary loss of phosphate, which leads to hypophosphatemia. A lot of other mechanisms by which it causes hypophosphatemia, hypomagnesemia, and hypocalcemia. So a lot of electrolyte imbalances which may be seen. The correct combination in the option is option A, and I will ask Divya to take up with the next question.
Which of the following statements is true about sarcopenia in CKD? And your options are, options please. Can we have the timer back on the screen? So we need the timer back.
Timer is up.
Okay, the time is up. The correct answer for this question is option A, that is sarcopenia and protein energy malnutrition share the common etiological factors. As you can see here below this Venn diagram, common etiological factors like inflammation, aging, insufficient energy and nutrient intake, they're common for both of them, and also they share common outcomes like low quality of life, increased fractures, and other morbidity and mortality. It is important to note that the other options like severe sarcopenia, where not only the muscle strength is low, but also you have to document a low performance of the muscles, and also muscle protein degradation is related sarcopenia. So all the other options are wrong, and the correct answer is option A. Over to Akash for the next question.
Thank you. According to current evidence, which of the statements related to protein intake in CKD is incorrect? Can we see the options? The time is up, and I believe we should move to the explanation. So the correct answer is A. In CKD population, dialysis population, daily protein intake of less than 1 gram is definitely wrong, and the protein intake can be increased to 1.2 to 1.5 grams per kg per day. The other options in diabetics, yes, the protein intake should be restricted to less than 0.8. This third option, which was high protein intake more than 1.3, is associated with risk of progression. The last option, there is limited evidence still, but we had a detailed talk on this. Plant-based protein is what is to be tried in CKD, which helps in retarding the progression. Moving on to the next question, and Divya will take that up.
Thank you, Akash. Question number 9 for you is, Mrs. A.S. is a 45-year-old lady whom you are counseling for initiation of dialysis. You explained to her various modalities of renal replacement therapy, but she has also done her Google research and she is worried about protein loss in CAPD. So how much protein is approximately lost in a stable CAPD patient every day due to peritoneal dialysis? And your options are and the time is up. The correct answer for this question is option number B. The loss of serum proteins in stable CAPD patients is up to 5 grams in every 24 hours, out of which 4 gram is albumin and 1 gram is other proteins, which include transferrin, immunoglobulins, complement factors, beta-2 microglobulin, and alpha-2 microglobulin. There are studies which have correlated peritoneal albumin and protein losses to outcomes in peritoneal dialysis patients, and they have not found any correlation with those. So this is something which we should be counseling all our PD patients. Over to Akash for the next question. Unmute yourself, Akash.
A very easy and short question for me. Choose the incorrect statement. The time is up. Yes. So this should have been a relatively easy question. Proteins should not be restricted in patients with AKI to attenuate urea generation and dialysis requirements. It is shown that protein restriction is in fact associated with greater risk of mortality. Protein energy wasting is quite common in incident patients with AKI, and both the guidelines, which is KDIGO and ASPEN, agree that proteins should not be restricted, and enteral proteins are always preferred over parenteral nutrition. And so all the other three options were wrong. The correct answer is B. They should not be restricted. Correct. Let's move on to the next question.
And the question number 11 is, as per the recent KDIGO guidelines, all of the following measures retard the progression of CKD except. Options are and the time is up. The correct answer for this question is option number C, that is lower serum uric acid less than 7 in dialysis patients does not help in retarding the progression of CKD as per the KDIGO guidelines. They say that there is insufficient evidence to support or refute the use of agents to lower serum uric acid for progression of CKD. All the other options, which included control of blood pressure, control of HbA1c levels, and physical activity to achieve a healthy weight and smoking cessation, have positively shown to retard the progression of CKD. Over to the next question.
In children with CKD, guidelines suggest all except, let's see the options. Thank you. The correct answer is that in children with CKD, there is no evidence that a low protein diet slows the progression of disease. There is a concern that such a diet may impair growth. BP lowering medicines have to be started once the BP remains more than 90th percentile for persistently, and the target is usually to bring it less than 50%. And ACRBs can be used, should be used. And we suggest that children with CKD, in fact, be given a daily diet containing at least 100% of the reference intake for the age, height, and weight, and for protein based upon age and gender.
Next question, please. And question number 13 is, all of the following statements about vitamin C therapy are correct except. And the time is up. The correct answer for this question is option number D. Vitamin C levels can be reduced up to 50% after a single hemodialysis session, obviously because this is a water-soluble vitamin and it is removed on dialysis. Hence, the patients on hemodialysis can frequently develop vitamin C deficiency if their intake is poor. All the other options, which included that large doses of vitamin C can cause a false negative stool Guaiac test. Also, it can cause diarrhea, abdominal bloating. These are correct. And also, there's an association between vitamin C intake and oxalate kidney stones, and it is specifically true for men more than women. Over to Akash for the next question.
6 more to go. This is question number 14. So chronic untreated metabolic acidosis in CKD can lead to all of the following complications, except which one? Can I see the options? Can we move on to the next slide? The correct answer is B. Metabolic acidosis worsens the CKD MBD. It promotes the development of secondary hyperparathyroidism. So that's not the option. The last option is reduces respiratory reserve. That is also correct. It promotes insulin resistance, and it does not increase the sodium potassium ATPase activity. It reduces it, and which could further impair the myocardial contractility and promotes to development of repeated attacks of congestive heart failure.
And your next question is, all of the following drugs can be used to treat metabolic acidosis except, and your options are, this is actually an easy giveaway. And the time's up. The answer for this question is option number A, that is calcium gluconate. Because as we all know, sodium citrate, calcium acetate, and calcium carbonate can all be used to treat acidosis because they get converted into bicarb in the body. But that is not true with gluconate. It can actually cause acidosis. Over to Akash for the next question.
Methoxy polyethylene glycol epoetin beta, popularly the Mircera injection, should be avoided in all of the following patients except, can we see the options now? Let's move on to the answer. So the answer is C. In end-stage kidney disease with the hemoglobin of 8.6 with decompensated liver disease, erythropoietin stimulating agents can be used. This question was mainly to address the coexistence of cancer. There is no history of cancer. We can probably consider it to with low risk factors. There is no contraindication. We can use it when there is active diagnosis of cancer. If there is severe anemia, we treat it with blood transfusion. And prior to erythropoietin stimulating agents, we evaluate for other correctable causes. And even when you have to start it, we start with a lower HB target of 10 grams per deciliter. And please place special emphasis on carefully monitoring for and preventing thromboembolic events. If there has been a past history of cancer, and if the cancer is considered cured, then consider continuing conservative treatment and for hemoglobin target. The cancer is not cured. There are follow goals which are same as for active cancer. The other options, that diabetic with a high risk of stroke, I would first correct the iron deficiency and look for other causes before proceeding with giving a long-acting ESA. And the last option was with a transferrin saturation of less than 20%. I would first correct the iron deficiency anemia before jumping and starting Mersera. So the correct answer by exclusion as well as by selection would be answer C, that there is no contraindication for it to be used with decompensated liver disease.
Thank you, Akash. And here comes the 17th question. 4 more questions between you and your cash prize. Which of the following is false about parenteral nutrition use in a patient with acute kidney injury? And the options are: pick up the false statement. The time is up, and the correct answer here is the option number D, which says that the selenium should be restricted in patients on CRRT, which is wrong, because CRRT causes double the loss of selenium, which is usually lost from the body in health. Hence, the usual intake is 100, and so we should be supplementing more than 200 micrograms of selenium every day in any patient who is on renal replacement therapy. All the other options were correct, which says that parenteral nutrition aims at reducing hypercatabolic state. That is the most important role of parenteral nutrition in these critically ill patients. Parenteral nutrition should also include lipid emulsions with a triglyceride dose of 1 gram per kg body weight. And while doing this, hypertriglyceridemia is a complication and we should be doing regular monitoring. Also, administration of L-carnitine is justified when the patient is malnourished and critically ill. Over to Akash for the next question.
Thank you. In a patient with Cushing's disease, presenting with restlessness and confusion, which of the following electrolyte abnormalities is most expected to be seen? Cushing's disease, which is the commonest electrolyte abnormality, presenting with restlessness and confusion. Can we see the options? Can we see the answer? The answer is A. The easiest way to have reached the answer would have been to see the bicarb. All the other options, the bicarb was less. So it was basically patients, the other 3 options at metabolic acidosis, which is not seen in Cushing's. In Cushing's, there is a decreased renal conversion of cortisol to cortisone by 11 beta hydroxysteroid dehydrogenase type 2, allowing for cortisol to exert mineralocorticoid effects, which leads to hypokalemic alkalosis, which is associated with normo or hypernatremia and hyperchloremia, which may result in disorientation, encephalopathy, coma, and even death. So the correct answer here is A, hypernatremia, sodium of 154, hypokalemia, potassium of 3.2, and increased bicarb of around 30.
The next question. So this is question number 19, just 2 more to go. Joy is a 9-year-old boy and is diagnosed with idiopathic hyperoxaluria. He's a kid, he wants to eat everything. So you have to tell that all of the following dietary items need to be restricted for him except. And time's up. The correct answer for this question is option number B, that is cheese and yogurt. As you can see on this little table in your screen, all the other options had very, very high oxalate content. So obviously they are to be restricted. However, calcium-rich foods like cheese and yogurt should be actually recommended or promoted because calcium naturally binds to the oxalate, and eating this calcium-rich food will help him binding the oxalate in the GI tract and excreting of calcium oxalate through stools rather than urine. Over to Akash for the next question.
This is the last question. Buckle up, guys. 4+ if you get it correct. You have completed diet counseling for a patient with hypertension and CKD. Which statement by the patient will cause concern? Please show the options to me.
This again should be a giveaway after attending the whole Srnmcon. Like everything comes to end to this question.
So I believe the answer is actually self-explanatory. This was an easy one, and we just wanted to end at a good note. Bread and mayo are hidden sources of sodium and should definitely be avoided. All the other options, a lot of them were Mediterranean in diet and would have been okay to take by the patient. So the concerning statement was that he will continue to have bread and mayo. Thank you, Divya, for coordinating and coming up with this amazing quiz. And I would ask you to continue, let you to continue the session. Yeah. So till the time our backend team comes up with the winners and with the with the details, I now request the tech team to show the posters that have been submitted this time. We'll just go through the list of posters that were on display and then declare the winning poster. So we had total of 15 posters that were submitted, from all parts of the country. And they are still available on the platform for anybody who would wish to go and take a look at the research on display. And let's declare the winning entry, and we will invite the winning author to come and present her research for 5 minutes. Can we see the winning entry? Avinash? Yes. So the winning entry was from Savita Medical College by Indumati Ilango, Dr. Nair, Sanjeev Nair's team. And it was on nutritional assessment and post-hemodialysis recovery time. The scientific team found this to be an extremely important paper because it dealt with an important quality of life measure. And, it's something which is important to our patients. And, I would let Indumati take it from here and present the thought behind the paper and what I mean, the methods and results in short. Indumati, over to you.
Good evening, sir. Hello, sir. Could you hear me?
Indumati, congratulations. Your voice is not very clear. Can you speak a little loudly?
Yes, sir. Thank you, sir. Thank you so much, sir. Sir, good evening to one and all. I first like to thank everyone, everyone for giving me an opportunity to present in this conference. And I especially like to thank my professors, Dr. Karthikeyan and Sanjeev sir, for guiding me through this. And my research is about nutritional assessment and post-dialysis recovery time. So the answer to the question, simple question, is how long does it take to recover from a dialysis section? So it denotes the dialysis recovery time, which is an independent predictor of health-related quality of a life outcome in hemodialysis patient. And malnutrition in hemodialysis patient is associated with increased mortality. And our study mainly saw the association between the nutritional status as well as the appetite of the hemodialysis patient with the post-dialysis recovery time. It is an observational study. 100 hemodialysis patients attending dialysis in Savita Medical College were included in the study, and the duration of dialysis should be more than 3 months, and the age of the patients included in the study was more than 18 years. Patients with active infection, cancer, dialysis, dementia were excluded from the study. The nutritional status of the patient was assessed using subjective global assessment scale. And the appetite status of the patient is through the CNAT scale, that is Council Nutritional Assessment Questionnaire. And the mean dialysis recovery time of continuous 3 dialysis section was calculated, and it was compared with the nutritional and appetite status of the patient. So around 50% of our study population fall under our having a dialysis recovery time of more than 6 hours. And coming to the basic demographic and clinical parameters of our study population, the mean age was around 50 years, and 74% of the study population were male, and the mean dialysis recovery time was 10.4 hours, and the serum albumin was 3.7, and around 38% were diabetic, and 83% of the population were hypertensive. And the result was that the around 25% of our study group fall into severely malnourished group, and 20% fall into well nourished, and around 55% of the patients were moderately malnourished. It was seen that patients with a higher severity of malnourishment was having an higher dialysis recovery time, and it was significant. And the patients with severely malnourished were having a dialysis recovery time of around 1,327 minutes, that is coming around 22 hours. And also patients with a higher risk of anorexia had a higher dialysis recovery time, around 1,617 minutes, when compared to patients with no risk of anorexia. And also the patients with severe malnourished patients were having a low serum albumin level. So the study concluded, the conclusion was that patients, hemodialysis patients with poor nutritional status and also poor appetite had an longer dialysis recovery time, which in turn affected the well-being of the hemodialysis patient.
Unmute so please.
Congratulations, Indumati, once again. And if Dr. Khanna is there, I would invite him to, congratulate you and declare the prize for the best paper.
Why would I not be there? I mean, you always reserve the best for the end. I mean, my enthusiasm hasn't been reduced. In fact, with all of y'all around, it's really great. So thanks for that excellent quiz. It was really enjoyable. And I did not participate. I entered, but then I thought people might feel I know the answers. So, I mean, that's being confident that I'm going to win the... But anyway, congratulations, Indu Elango, and you deserve the first prize. And there is only one prize, right, Akash?
There's only one, and we've kept a cash prize of 11,000 rupees for the best paper.
Yes.
So
we are trying to assure you that you will get it. When is a little question mark, but as early as possible, as they write ASAP. We'll send it across. We'll have to find the ways and means. We'll probably send net banking transfer. Something we'll do it to sure.
Thank you, but you should go ahead and publish the paper and not just end it with not here.
Talia,
Yes,
yes.
sir. Thank you,
sir. Are we ready with the quiz results, tech team, or we still have a few minutes? Is the tech team there?
Sir, just within 2 minutes. Within 2 minutes.
So in the meanwhile, Dr. Khanna has asked me to present the vote of thanks. So I believe that he would be the right person. But I consider this a very important honor and privilege to thank everyone for this memorable occasion. And thank you, Dr. Khanna, for giving me this opportunity to present my vote of thanks. I hereby thank the President and the Secretary and the Vice President of the Society of Renal Nutrition and Metabolism for giving us the opportunity to host this year's conference. Srnmcon 2021, Dr. Anil Bhalla, Dr. Anita Saxena, Dr. Georgie Ibrahim, Dr. T.S. Rana, for allowing us and giving us this opportunity. I thank all the chairpersons, all the speakers for having given such excellent talks and sessions. It's truly enriched our the conference and has been truly an amazing academic fest. I would like to thank the organizing team, Dr. Arun Shah, the co-chairperson, Dr. Ankit Modi, co-secretary, Dr. Keyur Dave, Dr. Himal Shah, the scientific committee, Dr. Amit Gupta, Dr. Mayuri Trivedi, Dr. Zahir Virani, Dr. Rajesh Kumar. I apologize if I'm missing out on anyone. I would like to thank the sponsors, the chief sponsors, Laranon and Septalist, for having supported this endeavor. Thank you, MCure, Dr. Reddy's, Abbott, Steadfast, and all our friends who helped us, Intas for having helped us with the quiz. I thank Divya for giving us her guidance and inputs in making the conduct of the quiz go seamlessly. Last but not the least, I would like to thank Dr. Umesh Khanna. He's been the rock star. He's been the the backbone of the show right from the day of conception. He's taken everybody along. Not once have I seen lose a school or temper or patience. There have been many hiccups or speed breakers, but he's always found a way to get the best out of everyone. That's the quality of a true leader, actually. And he's always put the interests of his juniors in front of his own. And I'm really lucky to have gotten this opportunity and this honor to have worked with him on this conference. And then he's been a guiding light and force, not just in nephrology or in practice, but in life also. Thank you, sir, for this amazing opportunity. And
so we have started a mutual admiration society, and I think I cannot but thank Akash for making this whole conference possible. Without his help, I would be clueless. And yes, I would probably give some ideas, but the main work has been done by him and Zamrud. So
I forgot very important people.
No. So don't worry. Zamrud cannot be forgotten. There is no way you can forget Zamrud. So Zamrud has been, parallel with the nephrologists on one side. The IDA management is all by Zamrud, and she has been a force, always was. And I mean, I know her from so many years. For every meeting of mine, if there is even a small element of nutrition in it, Zamrud would be there for all my guidance. And whenever I need any help, she's there. Zamrud, you want to say a few words?
Sir, I just want to thank you very much for having us. And indeed, I have been receiving from last 2 days a lot of messages. We really look forward to working and generating more renal nutritionists. A lot of interest has been evoked by this conference in a lot of nutritionists. In fact, I have more than 1,000 people who have registered with the renal SIG group of ours who want to actually start learning renal nutrition.
So count me also as one of the participants. I would also want to learn a bit more on renal nutrition. Anyway, I think the results are ready, but Dr. Bhalla is there, and I think I must thank him as the president for having faith in the Mumbai team to allow us to do this conference. It was really a learning experience, and it was fun. I mean, let me say, I don't do anything if I'm not enjoying, and I really enjoyed doing it.
Yes, before you declare the results, let me again comment, in fact, the feedback. One, Akash, you forgot to mention the meeting and more, the platform.
Yes.
That's what I was just going to add.
Yeah, the technical aspect was
the technical
flawless.
Support was excellent.
And one before
Girish,
Dr. Bhalla
Zia.
says, before that Bhalla says, the person who made me go to meetings and more was Dr. Anil Bhalla. He had blind faith in them.
Yes.
And I must say that I could not have chosen a better person for managing this conference. Girish and his entire team, Avnish ko to bahut tang kiya, ek aad baar gussa bhi kiya.
Sabika, Girish, Zia, Avnish, Avinash, Manas, everybody.
Yes.
And Avi
Great
has
technical platform.
Yes.
रात को 11-12 बजे कॉल करो, सुबह 6 बजे कॉल करो. Avnish was always
excellent
there
sport.
for recording the talks and everyone.
And I will just like to say a few words that it was an exemplary teamwork. Exemplary teamwork, and Dr. Umesh Khanna is an excellent organizer and very good team leader. He takes along everybody. You will not find a single person, whether it is a nutritionist, whether it is a some faculty member, or even a DNB student or DM student. Everybody will feel happy and satisfied with working with him. That is the quality this man has brought.
Thank you,
And
Dr.
you are fortunate to working with such a person.
Absolutely,
and it was a flawless meeting. We can give 10 out of 10 marks actually.
Thank you so much. Thank you, everybody.
Because the time management was perfect. And not only perfect, without annoying anybody, he didn't annoy anybody. He didn't abruptly stop any session. And the best part he had God gifted is that he has excellent source of this sense of humor. And in that humor manner, he can control the things. And Jamrood is anyway, she is the part of us only.
Yeah, pillar.
The pillar. And you have taken this society to a different level. The future organizers will really work very hard to match your performance. And I congratulate you, the whole team. I will not name, already Akash has named all of them, but I thought that the meeting and more requires a special mention.
Yes, of course. We forgot about it.
Yes. It was a part, but I missed out. I'm sorry, sir.
So we are doing 3 more meetings with them.
Correct.
Yes, even without knowing that this is going to be that successful, all because of Dr. Anil Bhalla's recommendation.
No, that shows the faith you have got in me.
We forgot 3 important partners, sir, our academic partners: IDA, Dr. Jagmeet Madan, IMA, API. We forgot to thank
Mumbai Nephrology Group,
ISN. We thank for all your for partnering with us and for giving us this opportunity to bring the conference to the masses. Thank you once again, everyone.
Thank you once. I think the results are ready.
Yes. Thank you, Dr. Bhalla. Dr. Bhalla, will you do the honors to declare the results?
Yes, Dr. Bhalla has to do it.
Sure. So, how many winners are there? 3?
3 winners.
3.
Okay. The 3rd winner has already been declared.
This is the 3rd winner, Dr. Kevin T. John Capiari. Dr. Kevin.
Can we show this next person?
Second is Dr. Srinidhi HC. If they are here, if the winners are here, they can just be there for just small short comment. And first is Dr. Arpit Gupta.
Wow.
Let us have the virtual clapping, please.
Clapping. Akash, how will we transfer the money? You'll have to find.
We'll get in touch with them. We'll get in touch.
All three of them have scored 20 out of 20. It's just a matter of time, the fastest figure first, but all 3 of them have the same score, 20 out of 20.
Was copying allowed?
To check if they are sitting together.
So, congratulations to all the winners. And 20 out of 20 is really a very good score. Some of the questions were difficult, were not easy, but still 20 out of 20.
But there were some which was easy because even I could answer.
So I think the whole organizing team requires now relaxation. And please go and relax today. And really, it has been a wonderful event.
As they say, all good things have to come to an end. And I think we will now close the session. Thank you so much, all of you all, for being a part of it.
Thank you. It was wonderful seeing all of you. Dr. Bhalla, it was so, it felt really nice to see you again after 2 years. So looking forward to future meetings when we can meet in person.
Sure.
Thank you. Bye.
Thank you all. Thank you.